Hello everyone. Uh, so this is Dr. Govind Rai Garg. Hello, good morning. Good morning, Dhananjay, Aishwarya, Chandra, Medvik, etc. Alines, Dr. Gulati, Aishwarya, Hermoine, Thipesh, Unknown, Asif. So we have plenty of students here. So nice to see you all. So first of all, very happy new year to all of you. Am I audible? Am I visible clearly? Good morning. Good morning. Happy new year. So how are your preparations going on? हाँ, प्रणय पाकिस्तान से आ गए। पाकिस्तान से तो आपको पता ना, हार लग के ही आए थे। तो today's lecture is also going on YouTube live also. So let me see the इधर कर दो यार possibly। हो जाएगा ये बड़ा, बस ठीक है। चल, डॉक्टर सुहास, नीरज, रंजन, मोहम्मद, इरफान, नित्या, राहुल, वेदांत। सो हेलो एंड हैप्पी न्यू ईयर टू ऑल ऑफ यू। तो सर जल्दी से 15 क्वेश्चन लीक कर दो। हाँ सक्षम में, अगर वो लीक कर दिए तो भी आंसर नहीं कर पाओगे बेटा। बोले सो डू नॉट रिलाई ऑन दीज थिंग्स, सो जस्ट ट्राई टू डू दी स्टडीज। नॉर्मल पढ़ाई करो, एवरेज पढ़ाई करो, सो दैट विल बी गुड एनफ। ओके, सो डू नॉट लुक फॉर शॉर्टकट्स। बिगेस्ट मिस्टेक मोस्ट ऑफ द स्टूडेंट्स डू इज दे विल ट्राई टू लुक फॉर शॉर्टकट्स, तो एग्जाम में नॉर्मल चीजें भी रह जाती हैं। ओके, चलिए, we do not have too much time, so we are around 4 hours for completing pharmacology, so let's do quickly। so I have got presbyopia, तो पास का चश्मा लग गया है, and now I have to see two screens, one for YouTube and one for uh, uh, our Zoom session। so हाँ, I'm not getting old, नहीं, I have gotten old। चलिए, so let's start। So we will change the sequence little bit. We'll start with the antimicrobial agents, antibiotics. So antibiotics we broadly divide into two parts. They may be cidal. Cidal means which kill the organism. Cidal which kill the organism, and static which stop the growth of the organism. Now, they are normally same in a immunocompetent person. The person having normal immunity, the drugs are equivalent. But if a person has low immunity, we have to give only cytal drug. So if there is bacterial infection in a patient with low immunity, we have to use a cytal drug. Static drug is not reliable. Now, which drugs are cytal drugs? You can easily remember. Cytal drugs we remember as बेवफा। हमें पता है कि बेवफा जो होती है वो मार डालेगी, है ना। बेवफा मार डालती है, तो बेवफा ड्रग्स आर साइडल ड्रग्स। सो बीई स्टैंड फॉर बीटा लैक्टम्स, वीए स्टैंड फॉर वैंकोमाइसिन, F is fluoroquinolones, drugs whose name end with floxacin, ciprofloxacin like drugs, and A for aminoglycosides like gentamicin, tobramycin, natilmycin, amikacin like drugs. Clear? So these are the important cytal drugs, whereas most other drugs are static drugs. Clear? So that is cytal and static classification. Now we will divide the antimicrobials according to their mechanism of action. And first and the most important mechanism of action is drugs inhibiting cell wall synthesis. And these drugs you can remember as firmly bind to bacterial cell wall. Firmly bind to bacterial cell wall, the drugs which bind to cell wall. So F is phosphomycin, phosphomycin. BI is beta lactams. BAC is bacitracin. C is cycloserine, and VA is vancomycin. So these are the important cell wall inhibitors. Among them, phosphomycin, it is used for UTI, but a special thing is it is single dose treatment of UTI. Most of the antibiotics are given in a course for 3 to 5 days, but phosphomycin special thing, it's a single dose. Single dose. Cycloserine is used mainly for tuberculosis, TB, And the major side effect of cycloserine is psychosis. Psychosis, the name says if we remove the L, it becomes cycloserine. Cycloserine means psychosis causing drug. Okay. So beta-lactam and vancomycin we will discuss in little detail. So starting with the beta-lactam antibiotics first. Beta-lactams. Beta-lactams are divided into 4 type of drugs. One are called penicillins. All of them have beta-lactam ring. Second are cephalosporins. Third are carbapenems. And fourth are monobactams. These are the 4 type of beta-lactam antibiotics we have. Penicillin, cephalosporin, carbapenem, and monobactams. So we'll discuss them one by one, starting with the penicillins. Now, penicillins, the most important question asked, which is penicillinase resistant penicillins? Penicillins can be broken by an enzyme called as penicillinase or beta-lactamase, but some drugs are resistant to them. Those are called penicillinase resistant penicillins, and these we remember as condom drugs. Condom drugs. So C for cloxacillin, O for oxacillin, N for nafcillin, D for dicloxacillin, and M for methicillin. O we have already covered. So these are penicillinase resistant penicillins. And you can remember, just like condom protect from pregnancy, so condom drugs protect from penicillinase. Clear? So these are penicillinase resistant penicillins. The second question asks, which are the oral penicillins? Which penicillins can be given orally? And these you can remember from the mnemonic vodka. We know we drink vodka. Vodka ko oral lete hain. Vodka injection is not required. So vodka drugs also are oral drugs. They can be given orally. So V for penicillin V. O is oxacillin. D is dicloxacillin. K is cloxacillin. And A is ampicillin and amoxicillin. Ampicillin and amoxicillin. So these are the important points about penicillins which are asked, which are penicillinase resistant and which are effective orally. Clear? The question can be asked as a mix also. Which oral penicillin is penicillinase resistant? Which oral penicillin is penicillinase resistant? So you can see that oxacillin, cloxacillin here, oxacillin, cloxacillin, dicloxacillin here. So these are oral penicillins which can be given. Oxacillin and cloxacillin, these are oral penicillins which are penicillinase resistant. Okay. Then coming to cephalosporins. Now cephalosporins, there are many generations of cephalosporin from first to fifth generation of cephalosporins. But important problem is the name of all of them start from ceph. So how to remember which is which generation? So we have a very good mnemonic to remember them. So any cephalosporin which start from cepha. Ceph is common, but if there is A after that, A is the first letter, so it will be first generation. Any drug starting from cepha like cefazolin, cefalexin, cefadroxil, cefalothin, cefaloridin. So A means first generation. Now if A is not there, next, we will see whether the name of the drug contain pi or not. So as we commonly say in Hindi, char pi. So pi means char. Char means 4. So fourth generation drug with pi in the name. Cefepime, cefpirom are fourth generation. Cefepime and cefpirom are fourth generation. Now if pi is also not there, then we will see role. Role. If role is there in the name or not. So like today's young generation, commonly we write the word ROFL, rolling on the floor laughing. So ROFL, F means fifth generation. So fifth generation, if the name contains a role like ceftibiprole, ceftaroline. If role is there, it is fifth generation. Now, if role is also not there, we will see how the name is ending. If the name end with any of these 3, me, 1 or 10, because we are writing 3 things, me, 1, 10, so it will be third generation. Third generation. So me like cefixime, cefotaxime, ceftriaxone, cefodoxime, ceftazidime. 1 means cefoperazone, ceftriaxone, and 10 means ceftibutane. So if it is me 110, it will be third generation, and any remaining, that will be second generation. Any remaining will be second generation. Yeah, this is the gross mnemonic. Now you need to remember 2 exceptions in these mnemonics. One is cefuroxime, which is ending with me, but it is not third generation. And second is cefaclor, which is starting with A, but not third generation, first generation. Clear? So these are the two exceptions you need to remember, and both the exceptions are in the second generation. Exceptions सारी second generation में आएंगी. Okay, so you can remember the generations. Clear? So I have not written one drug in this. Quickly tell me. कौन सी थी? Forgot. So leave it. So you can remember the different generations from this mnemonic. Okay. सीफा जुलिन वगैरह तो है सब इसमें. ठीक. चलिए. So remember, सीफा is first generation. If it is pi, fourth generation, roll, fifth generation, me, 110, third generation, and all other will be second generation. Okay. Chalo. Now moving to next, which is carbapenems. Carbapenems. Carbapenems, their name end with penem. So first drug in this group was imipen. But imipenem was broken down in the kidney, so it became inactive. So imipenem, the kidney produce an enzyme called as dehydropeptidase. Dehydropeptidase. It breaks imipenem. So when we give imipenem, it is broken by dehydropeptidase. If we give it alone, it is useless. So what we do, we give imipenem with an inhibitor of this enzyme. And the drug inhibiting this enzyme is cilastatin. So imipenem is always given with cilastatin, otherwise it is useless. Now what is important about imipenem to remember? It has very broad spectrum. Very broad spectrum means it is effective against most of the gram-positive, gram-negative, as well as anaerobic bacteria. So it has very broad spectrum. Gram-positive, negative, as well as anaerobic bacteria are included. The major side effect of this drug is seizures. Imipenem, the main side effect is seizures. Imipenem, the major side effect is seizures. So after imipenem, we made many more carbapenems like meropenem. The name of all of them will end with penem. So we have meropenem, atrapenem, doripenem, and ferropenem. So these are also carbapenems. The properties are same. That means they are also broad spectrum. They can also cause seizures. But important differences. Number one, they do not require cilastatin. They are not broken in the kidney, so they do not require cilastatin. And number two, they have lesser risk of seizures as compared to imipenem. The risk of seizures is lesser. So imipenem has highest risk of seizures. Others have lower risk of seizures. And among the carbapenems, the only carbapenem among these which can be given orally is ferropenem. Ferropenem is the only oral carbapenem. Only oral carbapenem is ferropenem. So the name says LARO, Laro. So it is ferro. Ferro is equal to Laro. Okay? So laropenem is oral. Ferropenem is oral. Clear? So that is about carbapenems. Then moving to the last drug, monobactam. The only drug in this category is agtrione. Agtrione. It has two properties which are totally opposite to penicillins. So unlike penicillins, penicillins are mainly for gram-positive. It is only for gram-negative. Only gram-negative bacteria, not effective against any gram-positive bacteria. Second, penicillins were causing allergy. This do not show cross allergy with beta-lactams. Do not show cross allergy. So when penicillins came to know that a drug has come in our group which has totally opposite properties. We are causing allergy, they are not causing. We are for gram-positive, they are not for gram-positive. So they went to this drug and asked, Aji tera naam to bata. So that's why we kept the name as agtrione. Clear? So Aji tera naam to bata. Agtrionum, it is a monobactam which is only for gram-negative and which do not show cross allergy. Clear? So be very careful. Both these properties should be there. Okay? If they ask in the exam gram-positive, do not mark agtrionum. It is only for gram-negative bacteria. Okay? Chat is disconnected in YouTube. Let's see. Tarun? You disconnect over here. So that is about the first group of drugs. That means beta-lactams. Then second one is vancomycin. Vancomycin has lot of limitations. Number one, vancomycin cannot be given oral. It is not effective orally because it is not absorbed by GIT. Number two, vancomycin, whenever we give IV, it causes release of histamine, which can lead to vasodilation and person will appear red. That's why it is known as red man syndrome. Vancomycin can cause red man syndrome. Red man syndrome. Then vancomycin is nephrotoxic and ototoxic. Two major side effects, nephrotoxic and ototoxic. And we will discuss later on also one area where you need to remember not effective. Vancomycin is not for any gram-negative bacteria, including Pseudomonas. So that is the MCQ asked, which drug is not effective against Pseudomonas? The answer is vancomycin. Vancomycin is not for Pseudomonas, any gram-negative bacteria in fact. So vancomycin is only for gram-positive bacteria. Then what is important thing is vancomycin, what is the use of vancomycin? Vancomycin is a drug of choice for MRS, methicillin-resistant staph aureus. It is drug of choice. Second, it is also drug of choice for enterococcal endocarditis. Enterococcal endocarditis in patient with penicillin allergy. Normally, for enterococcal endocarditis, we use penicillins. But if there is penicillin allergy, we can use vancomycin. So can we use aztreonam in this patient who is having penicillin allergy? Can we use aztreonam? Yes or no? The answer is no, because it is enterococcus. Enterococcus is gram positive. Aztreonam is only for gram negative. Clear? Second, it can be used, not the drug of choice, can be used for pseudomembranous colitis. Vancomycin can be used for pseudomembranous colitis. Clear? So these are the important points regarding the vancomycin also. So that means we have completed the topic of drugs inhibiting cell wall synthesis. Cell wall synthesis. Okay? Chal. Moving to the second mechanisms, drug inhibiting protein synthesis. Now, bacterial ribosomes, they are of two types. We have 30S ribosome and 50S ribosome. So some drugs, they bind to 30S, some drugs bind to 50S. So how to remember? You can remember bind at 30 and cell at 50. So जैसे मैं बनिया हूं तो मैं तो बनियों वाली बातें करूंगा कि 30 पे खरीद के 50 में बेच दो. क्लियर? तो बाय एट 30 एंड सेल एट 50. तो बाय एट 30 means A means aminoglycosides, T means tetracyclines. They bind to 30S ribosome. Aminoglycosides and tetracyclines bind to 30S ribosome. Whereas other drugs, cell you can write as S for cell or C for cell. Both the mnemonics will work. So cell S means streptograms. Streptograms. C means chloramphenicol. Chloramphenicol. E means erythromycin. Not only erythromycin, but all thromycins. Clarithrol, azithro, all of the thromycins. L for linezolid and L for lincosamides. So these bind to 50S. Or simply remember, lincosamide example is clindamycin. Lincosamide is a group, example of drug is clindamycin. So you can remember just this by add. Aminoglycoside and tetracycline bind to 30S, all other bind to 50S. Aminoglycoside, tetracycline bind to 30S, all other drugs bind to 50S. Yeah, so we'll quickly discuss these drugs, the important MCQs which are asked. So starting with aminoglycosides. Examples of aminoglycosides like, we have drugs like gentamicin, streptomycin, amikacin. These are aminoglycosides. The important point about aminoglycosides to remember, they are injectable drugs. They are not effective oral. They are injectable drugs. Aminoglycosides are the only cidal drug among protein synthesis inhibitors. Remember, Bebuffa contains A for aminoglycosides. Only cidal drugs among the protein synthesis inhibitors. Now coming to special points about aminoglycosides, they are mainly for gram-negative bacteria. Mainly for gram-negative bacteria except Salmonella. This is the MCQ asked, which drug is not effective against enteric fever, typhoid fever? The answer is aminoglycosides, not for Salmonella. Second, they require oxygen for entry in the bacteria. So if a bacteria do not use oxygen, they cannot enter, they will become ineffective. So that means second question asked, where they are not effective, it is for anaerobic bacteria. So aminoglycosides are not effective in two type of bacteria. One is Salmonella, second is anaerobic bacteria. Then aminoglycosides have three main side effects. They are nephrotoxic, they are ototoxic, and they can cause neuromuscular blockade. Aminoglycosides are nephrotoxic, ototoxic, and they can cause neuromuscular blockade. And lastly, aminoglycosides are teratogen. They can cause hearing loss in the baby. Aminoglycoside can cause hearing loss in the baby, so they are contraindicated. So among the antibiotics, which antibiotics are contraindicated in pregnancy? Which antibiotics are contraindicated in pregnancy? So you can remember in pregnancy, female is already fat. So fat is contraindicated. Fat is contraindicated. F means fluoroquinolones because they cause cartilage and tendon damage. Cartilage and tendon damage. A for aminoglycosides because they are A for auditory toxic. That means hearing loss is there. And T for tetracycline. T for teeth and bone problems. Teeth and bone problems will occur in the newborn baby. That's why they are contraindicated. So fat is contraindicated in pregnancy. And what is the drug of choice among the antibiotics in pregnancy, which are safe in pregnancy? The answer is paracetamol. Paracetamol is safe. We know penicillins, cephalosporins, and macrolides are safe. Penicillin, cephalosporins, and macrolides are safe. Penicillin, cephalosporin, macrolides are safe. Clear? So that is important about aminoglycosides. Clear? Then coming to tetracycline. Any drug whose name ended with cycline is tetracycline. So drugs like doxycycline, minocycline, any drug ending with cycline is a tetracycline. Now, what are the important point about tetracyclines to remember? Tetracyclines are a drug of choice for rickettsial infections. So that is the only important question which is asked repeatedly again and again. Tetracyclines are drug of choice for rickettsia. So you should know what are the important rickettsial infections. Rickettsial के examples पता होने चाहिए आपको. कौन से rickettsial infections होते हैं जल्दी से बता दो. We have many types of typhus like epidemic typhus, endemic typhus, scrub typhus. बहुत तरह के typhus होते हैं and many types of fever like Q fever, Rocky Mountain spotted fever. Clear? So drug of choice for most of the typhus, most of fevers which are caused by rickets. Rickettsia. Tetracyclines are drug of choice for rickettsial infection. Another important question, they will try to confuse you. They will give a feature of scrub typhus and then they will give what is the drug of choice. And in the option, they will give doxycycline with ceftriaxone, doxycycline with azithromycin, doxycycline alone. The answer is alone. Doxycycline alone is enough for rickettsial infection. No other drug is required with doxycycline. Okay, only doxycycline is enough. Do not get confused. No? Then coming to macrolides. Macrolides are the drugs whose name end with thromycin, like erythromycin, clarithromycin, azithromycin. Thromycins are the macrolides. Thromycins are the macrolides. Macrolides are drug of choice for CLAP. So you cannot forget this because every year one question is asked from this mnemonic, CLAP. So C for chancroid. Chancroid. C for Corynebacterium. Corynebacterium causes diphtheria. Yes. So chancroid and Corynebacterium. L for Legionella. Legionnaire's pneumonia or Legionella. A for atypical pneumonia. Atypical pneumonia. And P for pertussis. Whooping cough. So macrolides are drug of choice for CLAP. So you must remember, you cannot forget this because every year question is asked on these. Macrolides are drug of choice for chancroid. Corynebacterium means diphtheria. Legionella means Legionnaire's pneumonia. Atypical pneumonia caused by Mycoplasma, chlamydia, etc. And pertussis, that means whooping cough. So macrolides are drug of choice. That is the most important thing to remember. Then most of the macrolides, yes, name is written in Russian. I think Sneha. No, I don't. I'm not able to understand completely. Clear. So Macrolides are enzyme inhibitors. Most of the macrolides, they are enzyme inhibitors. Yeah. Then moving to linezolid. But a special thing to remember about linezolid is a drug of choice for VRSA pneumonia. When the pneumonia is caused by vancomycin-resistant staph aureus, the drug of choice is linezolid. And now linezolid is approved in treatment of tuberculosis also. Now it is approved in treatment of tuberculosis also. Now, what is most important thing? Linezolid, the side effect is peripheral neuropathy. Linezolid can cause peripheral neuropathy. Peripheral neuropathy can be caused by linezolid. The side effect is peripheral neuropathy. Clear? Then last drug is clindamycin. Clindamycin is a drug of choice for lung abscess and brain abscess. Lung abscess and brain abscess, particularly caused by anaerobic bacteria. This clindamycin is drug of choice. Clindamycin is drug of choice for lung and brain abscess caused by anaerobic bacteria. Clear? So these are the important points regarding the drugs inhibiting protein synthesis. Clear? So we completed the second mechanism, drugs inhibiting protein synthesis. Then moving to third, drugs inhibiting DNA gyrase. DNA gyrase is required for uncoiling of DNA so that replication can occur. The drug inhibiting them are fluoroquinolones. Fluoroquinolones means their name end with floxacin. We have plenty of floxacins like ciprofloxacin, ofloxacin, levofloxacin, norfloxacin. So many floxacins are there. Now, what are the important point about floxacins to remember? Fluoroquinolones, they are effective orally. Fluoroquinolones are oral drugs, and these are also cidal. Remember, Bevafa contains F means fluoroquinol. They are also cidal. And what is special is they are effective for both gram-positive as well as gram-negative bacteria. Effective against both positive as well as negative bacteria. That means they are effective even against MRSA and even against Pseudomonas. So positive and negative both are covered. Now, what is the important thing? Fluoroquinolones are commonly used for UTI, commonly used for urinary tract infections. But the question asked is, which fluoroquinolones are not effective for UTI? Now, if a fluoroquinolone do not go to kidney, it will not go to urine. So it will not be effective. So which fluoroquinolones do not go to urine is PMT. PMT. PMT stand for p-floxacin, moxifloxacin, and trovafloxacin. These three drugs, they are not effective for UTI. They will not be effective in UTI. Second, because they are not going to kidney, so they are safe in renal failure. Safe in renal failure. So that is the MCQ asked, which fluoroquinolone can be safely used in patient with renal failure. So remember, अगर किडनी फेल हो जाए तो भी पीएमटी तो दे सकते हो ना. So the NEET UG exam which is called nowadays, at our time it was called as PMT ना. तो what we commonly say कि अगर किडनी फेल होगी तो भी पीएमटी देने से कोई नहीं रोक सकता है ना, तो पीएमटी तो दे सकते हैं. But problem is these are contraindicated in liver failure. Obviously, if a drug is not excreted by kidney, it must be metabolized by liver. So these are contraindicated in liver failure. Clear? So they are not for UTI. They are safe in renal failure, but contraindicated in liver failure. So PMT is the mnemonic for these three MCQs. In तीन MCQs का mnemonic है PMT. Clear? Now, second important thing about fluoroquinolones to remember, some fluoroquinolones are called as respiratory fluoroquinolones. Now, why respiratory fluoroquinolones? Because they can kill any bacteria causing respiratory tract infection, like gram-positive bacteria, including Streptococcus, Staphylococcus, Pneumococcus, which are causing respiratory tract infection. They can kill gram-negative bacteria also, like Klebsiella, Pseudomonas, which are causing respiratory tract infection. They can also kill the atypical bacteria causing respiratory tract infection, like Mycoplasma, Chlamydia, etc. And they can even kill Mycobacterium tuberculosis. So they are effective against all organisms causing respiratory tract infection. That's why we say, oh my God, oh my God. So these are oh my God fluoroquinolones. O means ofloxacin, M means moxifloxacin, G means getifloxacin. And one drug which is similar to ofloxacin is levofloxacin. Levofloxacin is longer acting ofloxacin. So these four drugs, oh my God, these are respiratory fluoroquinolones. Respiratory fluoroquinolones. And we discussed already, fluoroquinolones are contraindicated in pregnancy. Why they are contraindicated? Because they can cause cartilage and tendon problems. Cartilage and tendon problems. So they are contraindicated in pregnancy. Fluoroquinolones are contraindicated in pregnancy. The major side effect of fluoroquinolones is seizures. Fluoroquinolones can cause seizures. Earlier we discussed imipenem can cause seizures. Now we discussed fluoroquinolones can cause seizures. Clear? So that is about third mechanism, DNA gyrase inhibitors. Then moving to the fourth, drug affecting the metabolism. Metabolism inhibitor. And the main drug in this category is cotrimoxazole. Cotrimoxazole, the name says it is a combination. It is a combination of two drugs. CO means combination of TRIM. TRIM stands for trimethoprim. Trimethoprim with oxazole. Oxazole means sulfamethoxazole. So it is a combination of TRIM with oxazole. The name is co-trimoxazole. Combination of trimethoprim with sulfamethoxazole is co-trimoxazole. Now, important question asked, what is the ratio of these two in the co-trimoxazole tablet? In the tablet, they are present in a ratio of 1:5. Remember, S look like 5, so it is 5. Clear? And S is a longer name, so it is more. Second, what ratio we require in the blood is actually 1:20. So read carefully where they are asking the ratio, whether in the tablet or in the blood. In the tablet, it is 1:5. In the blood, it is 1:20. Okay. Now, second important question asked is where they are used. Cotrimoxazole is a drug of choice for Punjab National Bank, PNB. Drug of choice for Punjab National Bank. So P for pneumocystis, N for nocardia, and B for Burkholderia cepacia. Burkholderia cepacia. So they are drug of choice for Punjab National Bank. Pneumocystis, nocardia, and Burkholderia cepacia. Pneumocystis, nocardia, Burkholderia cepacia. Clear? So that is about cotrimoxazole. So fourth mechanism, metabolism inhibitors. Now moving to the most important thing. Normally everyone says we need to remember drug of choice. We need to remember which drug is effective against which bacteria. But I tell in different manner. I say instead of remembering so many drugs which are effective against one bacteria, remember which drug is not effective, because the MCQ commonly asks all drugs are effective against Pseudomonas except. All are effective against MRSA except. Clear? So I will tell in this manner not effective. So for Pseudomonas, many drugs are effective, but which is not effective? Vancomycin. Vancomycin is only for gram-positive bacteria. Similarly, for MRSA, many drugs are effective, but which drugs are not effective? Beta-lactams. Beta-lactams. Penicillin, cephalosporin, carbapenem, they are not effective. For anaerobic bacteria, we already discussed aminoglycosides like gentamicin, amikacin are not effective. Similarly, for enteric fever, salmonella, aminoglycosides are not effective. Mycoplasma, it is a bacteria without a cell wall. So any drug which inhibits cell wall synthesis will be useless. So cell wall inhibitors like beta-lactams and vancomycin both are useless in case of mycoplasma. And Candida krusei is the only candida where fluconazole is not effective. Fluconazole is a drug of choice for all other candida species, but it is not for krusei. Okay? Then we can quickly discuss drug of choice also. For Pseudomonas, the drug of choice is most जिद्दी cephalosporin, जो सबसे ज्यादा जिद्दी है, ceftazidime. Ceftazidime is जिद्दी, and usually it is given in combination with amikacin. Then for MRSA, drug of choice is vancomycin. Well, no, vancomycin is drug of choice for MRSA. For anaerobic bacteria, if it is lung or brain abscess, we will use clindamycin. Clindamycin for lung and brain abscess. Whereas anaerobic bacteria causing GIT infections, the drug of choice is metronidazole. Metronidazole is drug of choice for GI infection caused by anaerobic bacteria. Then enteric fever, drug of choice is ceftriaxone. Ceftriaxone is drug of choice for enteric fever. Mycoplasma, drug of choice is azithromycin. Azithromycin. Candida cruzi, drug of choice is amphotericin B. Amphotericin B is a drug of choice for Candida cruzi. Most other Candida, it will be fluconazole. Clear? So not effective is very important to remember. Okay. So that is important about the non-specific antimicrobial drugs. Okay. Great. Chale. Now we'll discuss some specific diseases, starting with the most important one, which is malaria, caused by Plasmodium. Now, if there is two main species, we have Vivax and Falciparum. If there is uncomplicated malaria, which is caused by Vivax or Falciparum. So if it is caused by Vivax, the drug of choice is chloroquine. CH means chloroquine. Chloroquine is the drug of choice for Plasmodium vivax malaria. Whereas chloroquine is ineffective in falciparum in most cases. So for falciparum malaria, drug of choice is ACT, artemisinin based combination therapy. Artemisinin based combination therapy. मेरी वीडियो को ऊपर साइड ले लो. Is it interfering with any place? नहीं. तो फिर क्यों ऊपर लेना भाई? क्या करना चाह रहे हो? पढ़ाई कर लो, पढ़ाई का टाइम है, फालतू के काम मत करो अभी. ठीक है, चलो. So coming back, Vivax malaria, drug of choice is chloroquine. Falciparum malaria, drug of choice is artemisinin-based combination therapy. Okay. Now, what is the main difference between Vivax and Falciparum? Two main differences between Vivax and Falciparum. Quick little clinical difference. Vivax and Falciparum में clinical difference क्या होते हैं? Vivax malaria is usually mild. Falciparum cause complicated malaria. Complications are caused by falciparum, severe malaria, cerebral malaria, all caused by falciparum. Vivax is usually mild to moderate, not severe. But Vivax parasite, it can relapse. Vivax malaria, there is relapse because it contains hypnozoite, whereas falciparum never relapses. Falciparum में hypnozoite नहीं होते, तो falciparum do not relapse. Falciparum do not relapse. So uncomplicated malaria caused by Vivax, answer is chloroquine. Falciparum is ACT. But because there is relapse, we need to kill hypnozoites also. So in case of Vivax malaria, we need to give primaquine. So chloroquine with primaquine. Primaquine is to kill the hypnozoites to prevent relapse. Okay? Then if it is complicated malaria, always answer is intravenous artesunate. It is the most effective drug. So IV artesunate is a drug of choice for complicated malaria. Okay? And killing the hypnozoite to prevent the relapse is called as radical cure. When the radical cure is done by primaquine. And primaquine is given for 14 days for radical cure. For radical cure, primaquine is given for 14 days. Okay? So that is about treatment of malaria in a person who is not first trimester pregnancy. Everywhere else we will use this. Okay? Now, if there is first trimester, the important thing to remember, two drugs are avoided in pregnancy. One is primaquine. Primaquine is contraindicated in all the trimesters. Second is ACT is contraindicated in first trimester. We avoid ACT in first trimester. Clear? Rest everything will remain same. So chloroquine will remain same chloroquine. But primaquine we will not add because primaquine is contraindicated. ACT we will change to quinine. Instead of ACT we will give quinine. Q is quinine. Yeah? IV artesunate will remain same everywhere because it is severe malaria. We are understanding, we are caring about mother more. Okay? Radical cure we will never do in pregnancy because only drug for radical cure is primaquine and primaquine is contraindicated in pregnancy. Okay. Now, if it is second or third trimester, everything else will remain same, just like without pregnancy. Only difference is because it is pregnancy, so we will not give primaquine. Primaquine remove कर देंगे, second and third trimester, everything else will remain same. Is it clear? So let's quickly revise because this is important. एक बार बिना टेबल देखे try to answer the question because that is important. Clear? भाई सबटाइटल कैसे ऑफ करते हैं मुझे नहीं पता. सेटिंग्स सबटाइटल ऑफ कर देना यार. Now without looking at the table, try to answer because these are important. Okay? Drug of choice for Plasmodium vivax malaria is chloroquine plus primaquine. Okay? But in pregnancy, we will not give primaquine. So first trimester, second trimester, third trimester, it will be chloroquine only. Falciparum malaria, drug of choice is ACT. बट इन फर्स्ट ट्राइमेस्टर वी विल गिव क्विनी. रेस्ट एवरीवेयर सेकंड या थर्ड में एसीटी ही रहेगा. ठीक है. कॉम्प्लिकेटेड मलेरिया एवरीवेयर आईवी आर्टिसोनेट. कॉम्प्लिकेटेड मलेरिया आईवी आर्टिसोनेट एवरीवेयर. Clear? And radical cure, we use primaquine for 14 days. Clear? So that is the treatment of malaria. Now quickly discuss what is ACT. ACT is artemisinin based combination therapy. Artemisinin based combination therapy. We have two type of ACT. One is artesunate plus sulfadoxine pyrimethamine, and second is artemether plus lumefantrine. Now this ACT, artesunate sulfadoxine pyrimethamine, it is given all over India. All over India. Whereas artemether lumefantrine is used mainly in northeastern states because there the parasite is resistant to sulfadoxine pyrimethamine. So you can remember that from the mnemonic NEEL. नॉर्थ ईस्ट स्टेट में आर्टिमिथर प्लस ल्यूमिफेंट्रिन. आर्टिमिथर प्लस ल्यूमिफेंट्रिन. बाकी सारे इंडिया में एएसपी. आर्टिसोनेट प्लस सल्फाडॉक्सिन पायरिमिथर. Everywhere else we have ASP, but in northeastern states we have artemether plus lumefantrine. Artemether plus lumefantrine. नीला से याद कर लो, जैसे मर्जी याद कर लो. नीला. ठीक. नीला is also good. ठीक. Okay. चलिए. Primaquine we already discussed. Primaquine is drug of choice for radical cure of Plasmodium vivax malaria. Radical cure of vivax malaria. Primaquine, apart from that, it can kill gametes of all species. Kill gametes of all species of Plasmodium. For radical cure, it is given for 14 days. Whereas for killing the gametes, single dose. One dose can kill the gametes, but for radical cure, it need to be given for 14 days. And what is important, you need to remember it is contraindicated in 3 special situations. Pregnancy, which trimester it is contraindicated? Which trimester? Pregnancy के कौन से trimester में? All trimesters. Contraindicated in all trimesters. Second, it is contraindicated in infants, that means less than 1 year old baby. And third, it is contraindicated in patient with G6PD deficiency. So 3 important contraindications of primaquine need to be remembered. Radical cure of vivax, it is drug of choice, and it can also kill gametes of all these species. Okay, so that is about malaria. Done. Then moving to the most important disease, which is tuberculosis. Can you please give indications for prophylaxis? But a prophylaxis given when a person is coming from the endemic area. अगर endemic area से आदमी आता है, endemic area में जाता है, sorry, तो we need to give prophylaxis, that is for travelers. Travelers में prophylaxis करते हैं. So prophylaxis, although have not been asked long time, prophylaxis, if the person plan to stay there for less than 6 weeks, or the person plan to stay there for more than 6 weeks. If the person plan for less than 6 weeks, we will use doxycycline. More than 6 weeks, we will use mefloquine for prophylaxis. Clear? That is for prophylaxis. Update on treatment of malaria in pregnancy, safe in all trimesters, including first trimester, chloroquine, artesunate, quinine. Yes, Harshik tak it's all right, but still the treatment will remain same. We will prefer chloroquine only. Artesunate is not preferred in first trimester unless it is a severe malaria. Severe malaria में prefer नहीं करते. हम prefer करते हैं. चलिए, coming to tuberculosis, first line drugs for TB. We all know first line drugs are H, R, Z and E. H, R, Z and E. And one of the second line drug is S. I hope I don't need to write the names of them. Clear? H is isoniazid, R is rifampicin, Z is pyrazinamide, E is ethambutol, S is streptomycin. Clear? So first of all, we'll make a table here only. Out of these, which drugs are cidal, which are static? Only static drug is ethambutol. Ethambutol is static. All other drugs are cidal. Isoniazid, rifampicin, pyrazinamide, streptomycin, all are cidal. Then second, which is effective against which type of bacteria? Remember, isoniazid, rifampicin, and ethambutol are effective against both intra and extracellular bacteria, whereas pyrazinamide is only for intracellular bacteria and streptomycin is only for extracellular bacteria. Then third, which is hepatotoxic? Which drug cause liver damage? Isoniazid, rifampicin are hepatotoxic. Pyrazinamide, maximum hepatotoxic. But ethambutol and streptomycin do not cause liver damage. Ethambutol and streptomycin liver damage नहीं करता. Okay. And lastly, safety in pregnancy. Isoniazid is safe. Isoniazid rifampicin is safe. Ethambutol is safe. Pyrazinamide is avoided. Usually considered safe, but avoid करते हैं फिर भी. Streptomycin is absolutely contraindicated. Contraindicated in pregnancy. Contraindicated in pregnancy. And lastly, special points. What are the special points you need to remember? Isoniazid is one of the ship drugs. Ship drugs, I hope all of you remember. Ship drugs are for? Yes, all ship drugs are metabolized by acetylation, and ship drugs can cause SLE. They are metabolized by acetylation, they can cause SLE. Ship stand for sulfonamide, hydralazine, isoniazid, and procainamide. So these drugs, they are metabolized by acetylation and they can cause SLE. Acetylation and SLE. Clear? So ship drug, acetylation and SLE. Second, isoniazid can cause neuropathy, mostly peripheral neuropathy, but in overdose it can cause seizures also. So isoniazid can also cause seizures, and peripheral neuropathy and seizure occur due to deficiency of vitamin B6. Vitamin B6 deficiency lead to seizures and peripheral neuropathy. Seizures and peripheral neuropathy. Okay, hepatotoxicity तो हमने पढ़ लिया इधर. Now, rifampicin, special point to remember, rifampicin is always given empty stomach. Rifampicin is always given empty stomach. Empty stomach देते हैं हमेशा. Second, rifampicin is a powerful enzyme inducer which can lead to lot of drug interaction. Enzyme inducer and lot of drug interactions are there. And lastly, rifampicin, it can also result in orange colored urine. Three main points to remember. Given empty stomach, enzyme inducer and orange colored urine. Pregnancy में कौन सा anti-TB drug avoid किया जाता है? Isoniazid, rifampicin, pyrazinamide, streptomycin. बेटा avoid अगर ये ऑप्शन में है तो streptomycin तो obviously आंसर होगा. If streptomycin is not in the option, then mark pyrazinamide. ठीक है? अगर streptomycin ऑप्शन में ना हो तो pyrazinamide मार्क करते हैं. Okay. Now, pyrazinamide, the main side effect is hyperuricemia. Pyrazinamide cause gout, hyperuricemia. Pyrazinamide cause gout. Ethambutol, E for eye problems. It cause optic neuropathy leading to red-green color blindness. Optic neuropathy leading to red-green color blindness. Ethambutol, optic neuropathy. And streptomycin is nephrotoxic and ototoxic. Streptomycin is nephro and ototoxic. Clear? So these are the important points regarding the first line drugs HR, ZE and S. Yes, ethambutol का characteristic side effect है optic neuropathy, E for eye problem. Now coming to second line drugs. Second line drugs पहले कर लेते हैं, फिर हम बाद में mechanisms पे चलेंगे. Second line antitubercular drugs. In second line drugs, you need to remember about some important points. First, second line drugs include some of the injections and fluoroquinolones. Injections like streptomycin, kanamycin, capreomycin, amikacin, and fluoroquinolones. Oh my God, love wala. Okay, same fluoroquinolone. Ofloxacin, moxifloxacin, gatifloxacin, levofloxacin. So this is second line drugs which are cidal. They kill the bacteria. Second line cidal drugs are injectable and fluoroquinolones. Then second line static drugs. These include cycloserine, ethionamide, and PAS, para-amino-salicylic acid. Cycloserine, ethionamide, and PAS. The important MCQ was cycloserine cause psychosis. We discussed psychoserine. Ethionamide, it cause, and both of them cause hypothyroidism. So which second line antitubercular drug cause hypothyroidism? The answer will be ethionamide or PAS. One drug which is not used nowadays is thioacetazone. Thioacetazone was used. Now it is rarely used, and even then it was contraindicated in patient with HIV. HIV के लोगों में पहले contraindicated थी. ठीक, अब तो देते नहीं है इसको. Then we have some drugs, second line drugs, which are used for other indications. but now approved in TB. They are already available for other indications, but now approved in TB. These include clofazimine and linezolid. Clofazimine and linezolid. Clofazimine cause skin pigmentation, brown pigmentation of skin plus dryness of skin. Just give the feeling that coffee is spilled on the skin. So when coffee is spilled on the skin, it become dry and it become brown colored. So brown colored pigmentation with dryness caused by clofazimine. Dryness is called as ichthyosis. Yes, the word used for dryness is ichthyosis. Then linezolid we already discussed cause peripheral neuropathy. Linezolid cause peripheral neuropathy as a side effect. Linezolid cause peripheral neuropathy as a side effect. Then moving to totally new drugs in tuberculosis. Totally new drugs in tuberculosis. These include bedaquiline, delamenide, and pretomenide. Bedaquiline, delamenide, pretomenide. These are totally new drugs in tuberculosis. So bedaquiline act by inhibiting mycobacterial ATP synthesis. तो बेसिकली बेटाकुलिन देने से बैक्टीरिया में एनर्जी नहीं बचेगी तो बेड पे लेट जाएगा. बेड पे लेटाने वाली दवाई इज बेटाकुलिन. देन डेलामेनाइड प्रेटोमेनाइड दे आर नेम सेइंग MAIN. So they are mycolic acid inhibitors. Mycolic acid inhibitors. Delamenide and pretomenide are mycolic acid inhibitors, and all the three drugs side effect is QT prolongation. All three drugs can cause QT prolongation in ECG. Clear? All three drugs cause QT prolongation. Okay. Chali. Now coming to treatment of TB. So first of all, mechanism of isoniazid and rifampicin. Isoniazid. Isoniazid is metabolized to form activated compound. Isoniazid is inactive. So first of all, it is activated. And this is activated by an enzyme called as catalase peroxidase. Catalase peroxidase enzyme is present in the bacteria which will activate it. And the gene which form this enzyme is CAT gene. Now, when it is activated, it will inhibit the mycolic acid synthesis. Inhibit the mycolic acid synthesis. So, question asked, which mutation cause isoniazid resistance? It is CAT G. CAT G mutation cause isoniazid resistance. Then rifampicin, it acts by inhibiting RNA polymerase. RNA polymerase. And this is formed by a gene called as RPOB. So if there is a mutation in RPOB, it causes rifampicin resistance. So rifampicin resistance is due to mutation of RPOB gene, whereas isoniazid resistance occurs due to mutation in CAT G gene, CAT G mutation. Okay, so that is about mechanisms of isoniazid and rifampicin. Now quickly moving to, yes, INHA, but that is less common, beta, Tanuj. Now coming to treatment of tuberculosis. Treatment of tuberculosis in every patient now is 2HRZT plus 4HRE. 2HRZT plus 4HRE. Now, some of you will be saying the new treatment guidelines have come. They are just the new guidelines, but still the drug of choice is same. ठीक है, अगर ट्रीटमेंट ऑफ चॉइस पूछे तो यही है. द न्यू इज अल्टरनेटिव 4 month स्ट्रेटेजी. ठीक है, ये तो 6 महीने की हो गई. सो न्यू ट्रीटमेंट गाइडलाइंस आर फॉर 4 months, but they are not the drug of choice. The drug of choice is still this 2HRZD plus 4HR. 2HRZD plus 4HR ही मार्क करना है आप कहीं भी है. Now drug resistant TB, you need to remember which, when we will say multi drug resistant TB, when we say pre-XDR and when we say XDR. That is important. Classification is important. MDR TB when it is resistant to H plus R, isoniazid and rifampicin. Pre-XDR is when is H plus R plus fluoroquinolones. And when it is resistant to H plus R plus fluoroquinolone, that means pre-XDR plus resistance to any one of bedaquiline or linezolid, then we say it is XDR. Bedaquiline or linezolid, any one of the two, then it is called as XDR. So you need to remember this definition, because on drug resistant TB mainly question asked is on definition. Definition में पूछते हैं. Okay? Pregnancy में भी same है बेटा. Okay? So some people still use the older regime, but guidelines say same treatment. Is it clear? It's okay. आफ्टर इंटेंसिव फेज यूजली वी स्टॉप पायराजिनामाइड, पायराजिनामाइड को बंद कर देते हैं। तो HRZD है ना, 2 महीने का इंटेंसिव फेज है, उसका जेड नहीं है तो पायराजिनामाइड को बंद कर दिया। ओके, चल। नाउ कमिंग टू इंपॉर्टेंट साइड इफेक्ट्स ऑफ एंटीट्यूबुलर ड्रग्स। एक्सटेंसिव में क्या डिफरेंस होगा बेटा? एक्सटेंसिव यही तो है, एक्सडीआर इज एक्सटेंसिव ड्रग रेजिस्ट, एक्सटेंसिव ड्रग रेजिस्ट। क्लियर, चल। Non-tubercular use of rifampicin. Rifampicin has plenty of users but not used. Rifampicin is effective against gram-positive also, gram-negative also. Rifampicin is effective against MRSA, effective against Pseudomonas, effective against Brucella. Plenty of organisms it is effective, but we normally do not use it. Okay, chalo. Now coming to ATR, adverse effect. Isoniazid, two important side effects. One, it is hepatotoxic. Second, it causes pyridoxine deficiency, which can lead to peripheral neuropathy or seizures. Rifampicin, the main side effect is hepatotoxicity and orange colored urine. Orange colored urine. Pyrazinamide cause hyperuricemia apart from hepatotoxicity. Ethambutol E for eye problems. Optic neuropathy leading to red-green color blindness. Red-green color blindness. Streptomycin is nephrotoxic, ototoxic, and cause neuromuscular blockage. Ethionamide cause hypothyroidism. All three cause QT prolongation. QT prolongation. Clear? So these are the important adverse effect of anti-tubercular drugs. Okay. Just linezolid add कर लो, peripheral neuropathy. Linezolid, peripheral neuropathy. Peripheral neuropathy. बेटा लिखा तो है हाइपरयूरिसीमिया एंड क्लासिकली एसोसिएटेड विद पायराजिनामाइड हो जाएगा। ठीक है, चलिए। देन मूविंग टू लेप्रेसी। लेप्रेसी में दे आस्क द डोजेस, लेप्रेसी ट्रीटमेंट दे आस्क द डोजेस। सो लेप्रेसी द ट्रीटमेंट इज सेम फॉर पॉसिबैसिलरी एंड मल्टीबैसिलरी लेप्रेसी. What is the treatment? Treatment is we give rifampicin 600 milligram once a month and clofazimine 300 milligram once a month. 2 tablets in front of the doctor, that is called supervised. Then rest of the tablet to take home. Clofazimine 50 milligram and dapsone 100 milligram. Person will take daily. At home means unsupervised. And this will be continued for 12 months in multibacillary and 6 months in possibacillary. The treatment is same, otherwise duration is different. Okay. So that doses are important. Doses are asked in the exam. Doses are asked in the exam. Okay. Check. Then coming to HIV. So in HIV, the treatment is, drug of choice for HIV is TLD. TLD. T for tenofovir. Tenofovir. L for lamivudine. And D for dolutegravir. This is most preferred nowadays. If this person do not want to give, we can give TLE. T and L are same. E for efavirenz. Efavirenz. Both are considered first line drugs. So first line drugs for HIV are TLD or TLE. TLD or TLE regimes, they are drug of choice for HIV. Drug of choice for HIV. Okay? Then coming to side effect of anti-HIV drugs, they are very important. Side effect, zidovudine. Zidovudine cause bone marrow suppression. So the name says, अगर जिद करते हैं बच्चे, बहुत ज्यादा जिद करते हैं तो पेरेंट्स हड्डियां तोड़ देते, तो बोन मैरो सप्रेशन हो गया। अबाकाविर, अब्बा को पता लगा आप क्या कर रहे हो तो उनको एमआई हो जाएगा। ठीक है। जैलसिटाबिन, तो जैलसिटाबिन कॉज मुंह जल जाता है, एप्थस अल्सर्स इन द माउथ। M-tricitabine cause tree-like pigmentation on hand and soul. Tree-like pigmentation. दादी को पैनक्रेटाइटिस हो गया तो डाइडानोसिन कॉज पैनक्रेटाइटिस, दादी को पैनक्रेटाइटिस हो गया। स्टेबुडिन कॉज पेरिफेरल न्यूरोपैथी, रिमेंबर्ड एज पीएनएस, पेरिफेरल नर्वस सिस्टम। तो पेरिफेरल न्यूरोपैथी बाय स्टेबुडिन, पेरिफेरल न्यूरोपैथी बाय स्टेबुडिन। ईफाविरेंस खाने से वियर्ड बिहेव करेगा, पर्सन विल बिहेव वियर्ड, so there is altered mental status, altered mental status, altered mental status। नेविरापिन पीने से लिवर खराब हो जाता है, हेपेटोटॉक्सिसिटी। नेविरापिन कॉज हेपेटोटॉक्सिसिटी। hepatotoxicity, and all the navirs, any drug ending with the navirs cause metabolic problems. Metabolic problems are called as lipodystrophy syndrome. So there will be hyperglycemia, hyperlipidemia, all these features will be there. So navirs, they cause lipodystrophy syndrome. Clear? So that is important about adverse effect of anti-HIV drugs. Beta, you can tell Ajat Jat, you can, Ajat Jat is asking the question after reading the everything. Please answer the question yourself. कौन करेगा बेटा विविड ड्रीम और सीएनएस साइड इफेक्ट्स? किसको खाने के बाद वियर्ड बिहेव करेगा आदमी? ईफा विरेंस, ठीक है ना? तो यू कैन आंसर योरसेल्फ। ओके, चलिए। Now, which drugs are effective against both HIV and hepatitis B? These are remembered as LET. Let us treat hepatitis. But what is difference to remember? It is lamivudine, it is tenofovir. These are same, but this drug is emtricitabine. तो आपको क्या ध्यान रखना है? What you need to remember is effective against both HIV and hepatitis B. Okay? But that does not mean if we want to treat hepatitis B, we will give all three. For treatment of hepatitis B, any one out of the three is given. Clear? For hepatitis B, give any one, not all three. But for HIV, we will give all three. HIV में तीनों देते हैं, ठीक है? Whereas for treatment of HIV, any one is given out of these. Okay? Usually the drug of choice is tenofovir. Drug of choice for hepatitis B virus is tenofovir. It is clear? Any one is given for hepatitis B, but the question is which anti-HIV drug can be used in hepatitis B? Answer is lamivudine, emtricitabine, and tenofovir. I hope the concept is clear now. इसमें कोई कंफ्यूज तो नहीं होगा ना? बेटा HIV की ट्रीटमेंट में तीनों दवाइयां एक साथ देते हैं जो LET कहते हैं, बट हेपेटाइटिस बी में इन तीन में से कोई भी एक देनी है, एनी वन आउट ऑफ दी थ्री, ठीक है? सो एनी वन आउट ऑफ दी थ्री, सो lamivudine, emtricitabine, tenofovir, they are effective against hepatitis B also. Okay, चलिए. Then if there is HIV with TB, first of all, do not start the treatment together. If we start the treatment together, it lead to immune reconstitution inflammatory syndrome. अगर एक साथ ट्रीटमेंट स्टार्ट कर दी तो आइरिस हो जाएगा. सो बेसिकली द सिम्टम विल वर्सन. सिंपल लैंग्वेज है, सिम्टम विल वर्सन. सो व्हाट टू डू? स्टार्ट ATT फर्स्ट एंड आफ्टर 2 to 6 weeks स्टार्ट एंटी रेट्रोवायरल थेरेपी. टीबी की ट्रीटमेंट पहले स्टार्ट कर दो, 2 से 6 हफ्ते बाद, डिपेंडिंग अपॉन हाउ सीवियर द टीबी इज. अगर माइल्ड टीबी है तो 2 हफ्ते बाद, अगर सीवियर टीबी है तो 6 हफ्ते बाद स्टार्ट ART. क्लियर? Second, rifampicin is enzyme inducer. How to change different drugs when we are using rifampicin with HIV treatment? So if the person is taking the treatment TLE, अगर TLE की ट्रीटमेंट ले रहा है तो we will rearrange it, it become LET. So we will say let it continue. Let it continue means no change. These drugs do not interact with rifampicin. Rifampicin इनका metabolism increase नहीं करता, so we will continue. Second, if the person was taking TLD, तो we already discussed TL से तो इंटरेक्ट करता ही नहीं है, so D को डबल कर दो, डबल दी डोज ऑफ D. डोलूटिग्राविर की डोज को डबल कर दो. एंड इफ द पर्सन इज टेकिंग TL प्लस प्रोटीएज इनहिबिटर, then change to rifabutin. Rifampicin should not be used with protease inhibitors. Change to rifabutin. Change to rifabutin. Clear? So that is important about the anti-HIV drugs. Okay. Vertical transmission, everyone knows. Vertical transmission. If the mother is taking effective therapy, then give only nevirapine to baby. Only nevirapine. If mother is not taking effective therapy, then give zidovudine plus nevirapine to baby. Clear? So basically it is to baby. If mother is taking effective therapy, only nevirapine, not taking zidovudine plus nevirapine, duration just remember 6 weeks. Do not get confused कब 6 है कब 12 है, just remember 6 weeks. ठीक है? और हर एग्जाम के हर क्वेश्चन में 6 वीक पे आंसर हो जाएगा आपका. ठीक है? Just remember 6 weeks. Okay. 6 months नहीं है बेटा, 6 weeks. ठीक है, 6 weeks. Okay, चलिए. Then quickly discussing the drug of choice for different type of infections. Herpes simplex 1, herpes simplex 2, varicella zoster, that means chicken pox, herpes zoster. Last slide, ले लो screenshot. चलिए. The drug of choice for herpes viruses, acyclovir. Acyclovir is drug of choice for herpes viruses. Cytomegalovirus, cytomegalovirus drug of choice is Jancyclovir. Jancyclovir. Cryptococcal meningitis, cryptococcal meningitis, amphotericin B plus 5-flucytosine. This is important to remember. Amphotericin B with 5-flucytosine, drug of choice for cryptococcal meningitis. Mucormycosis, only amphotericin B. Amphotericin B. MRSA, vancomycin. Pseudomonas, we already discussed, ceftazidime plus amikacin. Ceftazidime plus amikacin, Pseudomonas. Amoebiasis, metronidazole, any drug ending with nidazole, metronidazole, tinidazole, secnidazole, nidazoles. Bacterial vaginosis, again nidazoles. Metronidazole group of drugs are drug of choice for metronidazole group of. See, bird flu and swine flu, the drug of choice are oseltamivir type of drugs. Oseltamivir. Oseltamivir, it act by inhibiting which enzyme? Neuraminidase. These are neuraminidase inhibitors. Oseltamivir like drugs are neuraminidase inhibitors, drug of choice for bird flu and swine flu. Clear? Note down this. Bacterial vaginosis. So they may not give directly the name bacterial vaginosis. So they will give hints like clue cells are present. Clue cells are present. There is secretion from the vagina. Vaginal secretions are there. Amsel criteria are positive. Amsel criteria are positive. Whiff test is positive. So whenever any of these is given, means it is bacterial vaginosis. Bacterial vaginosis. Clear? The drug of choice for bacterial vaginosis are metronidazole or tinidazole. They are drug of choice. Metronidazole or tinidazole like drugs are drug of choice. But if we cannot use them, then we can use clindamycin. Clindamycin is alternative. Metronidazole like drugs are drug of choice. Clindamycin is alternative. Yes, frothy discharge is there. Clear? Metronidazole, tinidazole are used and clindamycin is alternative. Clear? Sure. Then quickly revising 3 antibiotics we discussed that cause seizures. जल्दी से नाम बता दो. 3 antibiotics causing seizures. Imipenem, very good. Imipenem. Second, all fluoroquinolones and isoniazid. The important drugs which can cause seizures: imipenem, fluoroquinolones, and isoniazid. Imipenem, fluoroquinolones, and isoniazid. Clear? So that completes our first topic, that is antimicrobial agents. Okay. So we have taken a little longer time for antimicrobial, but it's okay. Important topic. Now we will move to the second topic, which is central nervous system. We'll start with Parkinsonism. We know Parkinsonism occurred due to deficiency of dopamine, but it is mainly occurred because there is imbalance between dopamine and acetylcholine. So dopamine decreases, acetylcholine remain normal. So the balance is shifted. So if we want to treat, so 2 type of therapy. One, we can increase dopamine, or second, we can decrease acetyl. So 2 type of drugs we can use in Parkinsonism, either increase dopamine or decrease acetylcholine. Increase dopamine or increase dopamine or decrease acetylcholine. Clear? So these are the 2 type of drugs we can use. Now, which drugs increase dopamine? So we can give levodopa. Levodopa, that will increase dopamine. It will form dopamine. But levodopa, we want entry in the brain. We do not want levodopa to form dopamine outside the brain. So we always give levodopa with carbidopa. Carbidopa is peripheral dopa decarboxylase inhibitor. Peripheral dopa decarboxylase inhibitor. Levodopa is given always with carbidopa. Carbidopa. Now, levodopa is most effective therapy for Parkinson's. most effective therapy for Parkinsonism is levodopa-carbidopa combination. Right? Then second, we can give drug releasing dopamine. Dopamine can come down. So that is done by amantadine. 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 It can release dopamine. And amantadine, it is special point is amantadine has additional NMDA receptor blocking property. It also has NMDA receptor blocking property. And its major side effect is livedo reticularis. It can cause livedo reticularis. Skin pigmentation known as livedo reticularis. Yes, ankle edema also. MAO-B inhibitor, we can stop the metabolism of dopamine. If dopamine is not broken, level will increase. The drug inhibiting MAO-B is salazilin. Salazilin is MAO-B inhibitor. Similarly, another enzyme which breaks dopamine is COMT, and the drug inhibiting COMT are capones. Any drug whose name end with capo. One capone we use is entacapone. One we do not use now is tolcapone. Tolcapone. Clear? Then drug can stimulate dopamine receptors. The action will increase. Drug stimulating dopamine receptors are pramipexole and ropinirole. Pramipexole and ropinirole are dopamine agonists. These are now the drug of choice for drug of choice for Parkinsonism. These are drug of choice for Parkinsonism, pramipexole and ropinirole. Pramipexole, ropinirole are drug of choice. So these are drugs which increase dopaminergic activity. But all these drugs, they are useless in drug-induced Parkinsonism. Remember, Parkinsonism can be caused when we block dopamine receptor. Schizophrenia, it occurs due to excessive dopamine. So when we treat schizophrenia, we will block dopamine receptors. And when we block dopamine receptor, Parkinsonism occurs. Clear? So which drugs can cause Parkinsonism? These are D2 blocker. Any drug blocking D2 can cause Parkinsonism. So those are drug-induced Parkinsonism. Drug-induced Parkinsonism. Remember, for drug-induced Parkinsonism, we cannot increase dopamine because receptors are already blocked. So we have to give anticholinergics. So anticholinergic drugs, they are drug of choice for drug-induced Parkinsonism. Drug-induced Parkinsonism, drug of choice are anticholinergics. And anticholinergic drugs, the main drug we use is benhexole. Benhexole. The other name of this is trihexyphenidyl. Trihexyphenidyl. Benhexole or trihexyphenidyl. So you can remember that from park your Benz. So drug-induced Parkinsonism, park your Benz. So benhexole, benztropine, they are drug of choice for drug-induced Parkinsonism. Now, if benhexole-like drugs are not given in the option, if they are not given in the option, then we can use promethazine. So promethazine is an alternative drug for drug-induced Parkinsonism. ड्रग इंड्यूस पार्किंसोनिज्म में नॉर्मली बेंजैक्सोल देते हैं, अगर ऑप्शन में ना हो तो प्रोमेथाजिन मार्क कर देना. बेटा लिखा दो एंटीकोलिनर्जिक. बेंजैक्सोल इज एंटीकोलिनर्जिक. एंटीकोलिनर्जिक. ठीक, तो बैलेंस विल बी रिस्टोर्ड बेसिकली. ओके, चल. देन मूविंग टू विच न्यूरोट्रांसमीटर इंबैलेंस अकर इन पार्किंसोनिज्म. बेटा अभी शुरू से कहानी सुना रहे हैं, रामायण में शुरू से पढ़ता आ रहा हूं. आजाद जाट, अच्छा आई थिंक आजाद जाट इज जस्ट प्लेइंग गेम्स विद मी, है ना. डोंट प्ले गेम्स विद माय हार्ट. ओके, चलिए. नेक्स्ट, मूविंग टू लिथियम. वी नो लिथियम इज अ ड्रग ऑफ चॉइस फॉर बाइपोलर डिसऑर्डर. ड्रग ऑफ चॉइस फॉर बाइपोलर डिसऑर्डर. In fact, this is the only drug used in bipolar disorder which can decrease the risk of suicide. No other drug in bipolar disorder can decrease the risk of suicides. The only drug which can decrease the risk of suicide is lithium. Now, lithium is very, very important. Pharmacokinetics of lithium, it is given by oral route, which has 100% bioavailability. Half-life of lithium is 24 hours. And it is given usually BD or TDS, twice or thrice a day, because of narrow therapeutic index. So because it has narrow therapeutic index, so we need to do therapeutic drug monitoring. Monitoring of therapeutic plasma concentration is required. So plasma concentration for acute mania we require is 0.8 to 1.2. Whereas for prophylaxis or for bipolar disorder, we want 0.5 to 0.8 milliequivalent per liter. Milliequivalent per liter. The question is when to check plasma level. When to check? It is 12 hours after last dose. 12 hours after last dose. So we are checking the trough level, lowest level. So lowest level is present 12 hours after last dose. Then important interactions, two important interactions, one fasting, second thiazides. Fasting and thiazides, they will decrease sodium from the body. So when sodium is less in the body, kidney will try to conserve sodium. So sodium and lithium look same to kidney. So kidney will start conserving lithium also. So that can lead to toxicity. So toxicity can occur. Why toxicity occur? Because kidney will help in more reabsorption of lithium. More reabsorption that lead to toxicity. How we will come to know that there is toxicity? So if that symptom is present, we will say it is lithium toxicity. So what is that? Diarrhea, ataxia, and tinnitus. So diarrhea, ataxia, and tinnitus are symptoms of lithium toxicity. Diarrhea, ataxia, tinnitus. That toxicity. And what is the treatment of lithium toxicity? There is no antidote for lithium. So the treatment is usually hemodialysis. Apart from symptomatic treatment, if severe, we can do dialysis. Dialysis is the treatment. And lithium is teratogenic. It can cause Epstein's anomaly. Lithium can cause Epstein's anomaly, box-shaped heart. Epstein's anomaly caused by lithium. Clear? Then the side effects of lithium, we remember from lithium. Side effects of lithium are written in the lithium itself. Leukocytes increase, that means leukocytosis. Tremors. Fine tremors are the most common side effect of lithium therapy. H is hypothyroidism. Hypothyroidism. IU is increased urine, that means diabetes insipidus. And M is mothers. Expectant mothers means pregnancy it is contraindicated because of Epstein's anomaly. Lithium can cause Epstein's anomaly, so avoided in pregnancy. Clear? So these are the important points regarding lithium. Lithium is the most important drug. You cannot skip it. सबसे important दवाई lithium. Okay. Now quickly tell me which benzodiazepines are safe in liver failure. Lot of benzodiazepines are safe. Lot means lorazepam, oxazepam, and temazepam. Look, lorazepam, oxazepam, temazepam, they are safe in liver failure. Safe in liver failure. So lot of benzodiazepines are safe in liver failure. And quickly tell me what is the antidote for benzodiazepine overdose? What is the antidote for benzodiazepine overdose? Benzodiazepine, the name end with peen, तो पीने के मजे को नील कर देता है. द नेम इज फ्लू मजे नील. पीने के मजे को नील करने वाली दवाई फ्लू मजे नील इज एंटीडोट फॉर बेंजोडाइजेपिन. Benzodiazepine antidote is फ्लू मजे नील. Okay. Then moving to antipsychotic drugs. We already discussed psychosis occur due to excessive dopamine. So the typical drugs are those which act by blocking the dopamine receptors. So D2 blockers, they are typical antipsychotic drugs. Whereas atypical are those which block 5-HT2 receptors. If a drug block D2, it is typical. If a drug block 5-HT2, it is atypical. Clear? So mechanism I have written here. So typical drugs are D2 blockers. Atypical drugs are 5-HT2 blockers. Now what are the properties? If we block D2 receptor, so the main advantage of blocking D2 receptor is we can control the positive symptoms. So person aggressiveness, hallucination, delirium, all these we can control by D2 blockers, positive symptoms. But D2 blockade in the brain can lead to two type of problems. One, extrapyramidal symptoms. Excessive blockade of D2 can lead to extrapyramidal symptoms. And second, it can lead to hyperprolactinemia. Dopamine is decreasing prolactin. When we block, prolactin increases. On the other hand, atypical drugs which are 5-HT2 blockers, they can control both positive and negative symptoms. Typical drug cannot control negative symptoms. Atypical can control negative symptoms also. They do not cause EPS or hyperprolactinemia because they are not blocking dopamine. So EPS and hyperprolactinemia is rare. But the major problem of these is metabolic side effects. Metabolic side effects, hyperglycemia, hyperlipidemia, insulin resistance, weight gain, all of these can occur. Yeah? Weight gain can be caused by all. Remember, weight gain is caused by all, typical as well as atypical, because weight gain can also be caused by H1 blockade. They are all having H1 blocking property. Okay? But these cause all metabolic side effects, not only weight gain. They can cause hyperglycemia, hyperlipidemia, insulin resistance, all these can occur. Okay. The question asked is, first of all, name of the drugs. Here, the main drugs you need to remember is haloperidol, flufenazine, and chlorpromazine. Haloperidol, flufenazine, and chlorpromazine. These are the main typical drugs. Then atypical drugs, these include drugs ending with pin or dan. Drugs ending with pin or drugs ending with dan. Pin like we have clozapine or olanzapine, quetiapine, acinapine. Many pins are there. Similarly, dan like risperidone, paliperidone, ziprasidone, lurasidone. Many dans are there. So drugs ending with pin or dan are typical drugs, atypical drugs, and one more drug which do not end with pin or dan is aripiprazole. 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 So pin and dan and aripiprazole. And I hope everyone remember शिप्रा आंटी. सबको शिप्रा आंटी पता है ना? शिप्रा आंटी है ना? तो शिप्रा आंटी, अरे शिप्रा का तो वेट ही गेन नहीं हो रहा, तो एरिपाइपराजोल एंड जिप्रासिडोन दे डू नॉट कॉज वेट गेन. Aripiprazole and ziprasidone, they do not cause weight gain. Aripiprazole and ziprasidone do not cause weight gain. Aripiprazole, ziprasidone do not cause weight gain. Clear? Now coming to special point about these drugs. First of all, extrapyramidal symptoms. There are 5 types of extrapyramidal symptoms: dystonia, akathisia, Parkinsonism, neuroleptic malignant syndrome, tardive dyskinesia. And first of all, the question asked how to identify. So you all know the name says dystonia. There will be altered tone. So the neck will be shifted toward one side, or the tongue will be going up, eyes may be going up. So there is movement of muscle spasm is there. Akathisia, person cannot stay still. Person keep on moving here and there. Person's legs will keep on moving. So person is having restlessness, do not stay still. Parkinsonism, we all know, triad of tremor, rigidity, bradykinesia. Tremor, rigidity, and bradykinesia. Then neuroleptic malignant syndrome characterized by high-grade fever with muscle spasms. High-grade fever with muscle spasms. And tardive dyskinesia is characterized by rabbit syndrome. Rabbit syndrome. So there will be movement of lips like a rabbit. Okay? So you can remember this. Clinically, you can identify. Now coming to special points, muscular dystonia is the earliest EPS to appear. Earliest EPS to appear. Whereas tardive dyskinesia is very late to appear. Very, very late to appear. It appears after many years. Many years. Clear? Now coming to treatment that is asked. For dystonia, drug of choice is benjhexol. If benjaxol is not given in the option, mark promethazine. Wherever benjaxol is there, alternative is promethazine. Akathisia, drug of choice is propranolol. Propranolol. If it is not given, you can give benjaxol. Parkinsonism, drug of choice is benjaxol. If not given, promethazine. Neuroleptic malignant syndrome, drug of choice is dentrol. Again, not given, you can mark benjaxol. Benjaxol. And tardive dyskinesia, drug of choice is valbenazine. Valbenazine. Valbenazine is drug of choice for tardive dyskinesia. Remember, for valbenazine, this tardive dyskinesia, benjhexol is contraindicated. The only EPS where benjaxol cannot be given is tardive dyskinesia. Only EPS where benjaxol cannot be given is tardive dyskinesia. Clear? So that is about extrapyramidal symptom. Very, very important among antipsychotic drugs. Clear? Now coming to special point about aripiprazole. Aripiprazole is known as dopamine serotonin stabilizer. So it has action of both the typical as well as atypical dopamine serotonin stabilizer. So what it do in dopamine? It is D2 partial agonist, not agonist, not antagonist. It is partial agonist. Along with that, it is 5-HT2 antagonist. So it will stabilize dopamine and serotonin level. Dopamine serotonin stabilizer. Okay? And what is the special point? शिप्रांटी तो याद ही है. अरे शिप्रा का तो वेट गेन नहीं हो रहा. That means it cause minimum metabolic side effects. Minimum metabolic side effects including weight gain. So no weight gain. So that is special about aripiprazole. Okay. देन क्लोजापिन तो सबको याद ही होगा, क्लोजापिन सबको याद होगा ना। क्लोजापिन जो करिए कि क्लोज अप, जब हम क्लोज आएंगे तो कहेगी कि मैं तुम्हें बर्बाद कर दूं। ठीक, तो कैसे बर्बाद करती है? तो पहले आप मदहोशी में खो जाते हो, सो दैट रिजल्ट इन सिडेशन। सिडेशन इज द मोस्ट कॉमन साइड इफेक्ट ऑफ क्लोजापिन। मोस्ट कॉमन साइड इफेक्ट इज सिडेशन। देन इसको देख के आपके मुंह से पानी निकलने लग जाएगा, सो साइलोरिया। साइलोरिया, वेट पिल्लो सिंड्रोम, वेट पिल्लो सिंड्रोम। फिर उसको देख के आपको दौरे पड़ना शुरू हो जाएंगे, सीजर्स। सीजर्स, आपके ब्लड के सेल आपको धोखा दे जाएंगे, ए ग्रेनुलोसाइटोसिस, ए ग्रेनुलोसाइटोसिस, ए ग्रेनुलोसाइटोसिस। देन उसको देख के दिल में दर्द भी होगा, मायोकार्डाइटिस, मायोकार्डाइटिस, मायोकार्डाइटिस। एंड लास्टली, वो इतनी मीठी है, सबसे ज्यादा मीठी है तो शुगर ही बढ़ जाएगी, सो मैक्सिमम मेटाबॉलिक साइड इफेक्ट्स, मैक्सिमम मेटाबॉलिक साइड इफेक्ट्स। So clozapine, these are all problem with clozapine. But clozapine is highly effective. So it is a drug of choice for treatment resistant schizophrenia. If schizophrenia cannot be treated by any other drugs, then we use clozapine. Otherwise, we will not, because there are so many side effects. So many side effects. So we do not prefer, except when it cannot be treated by other drugs. Okay. So that is important about clozapine. Clozapine. Okay. So that is about the antipsychotic also. Now moving to anti-epileptic drugs. So important anti-epileptic drugs, their user side effects we have mentioned. Valproate. Valproate is a drug of choice for Gamla. Everyone remember Gamla? Valproate is drug of choice for Gamla, GTCS, generalized tonic-clonic seizures, absence seizures, myoclonic seizures, Lennox-Gastaut syndrome, Lennox-Gastaut syndrome, and atonic seizures. So valproate is a drug of choice for Gamla. Major side effect, valproate can cause pancreatitis, liver damage, hepatotoxicity, and it can also lead to polycystic ovarian disease. Gender specific side effect is PCOD. Special point, what is the antidote for valproate hepatotoxicity? L-carnitine. L-carnitine is antidote for valproate hepatotoxicity. L-carnitine is antidote. Okay. Then carbamazepine. Carbamazepine is mainly used for focal seizures. Focal seizures. It is drug of choice. Drug of choice for focal seizures. And second, it is drug of choice for trigeminal neuralgia. Drug of choice for trigeminal neuralgia. So focal seizures and trigeminal neuralgia, drug of choice is carbamazepine. Adverse effect of carbamazepine are 4A's. 4A's are the side effects. So first A is allergy. Any drug can cause allergy. Second A, which is the asked in the exam, is ADH. It causes a release of ADH from the posterior pituitary, which lead to dilutional hyponatremia. ADH will retain water, sodium become diluted, hyponatremia occurs. Then third A is aplastic anemia. Aplastic anemia. And fourth A is auto-induction of metabolism. It will induce its own metabolism. Auto-induction of metabolism. But among them, the only MCQ point is hyponatremia. Release ADH, which lead to hyponatremia. Hyponatremia. Then special point to remember, it is contraindicated in absence and myoclonic seizures. In absence and myoclonic seizures, carbamazepine is contraindicated. Coming to phenytoin. Phenytoin is again used for focal seizures and GTCS. Used for focal seizures and GTCS. Yes, carbamazepine, oxcarbazepine cause more hyponatremia. Oxcarbazepine cause more hyponatremia. Now, focal and GTCS, phenytoin is used. Adverse effect phenytoin, everyone knows. Hot Malika. I hope I don't need to revise. इसको तो याद नहीं करना ना. हॉट मलिका तो दिल में भी बैठ गई होगी ना. तो हॉट मलिका. So we have hirsutism, hypertrophy of gums, osteomalacia, teratogenicity, megaloblastic anemia, arrhythmias, lymph node enlargement, insulin deficiency, vitamin K deficiency, and ataxia nystagmus vertigo. Ataxia nystagmus vertigo. Clear? Hot Malika, everyone knows. Now, what is special point? Again, phenytoin is contraindicated in absence and myoclonic seizures. So carbamazepine and phenytoin are contraindicated in absence and myoclonic seizures. Now lamotrigine again used for focal seizures and GTCS. But main important to remember side effect, it can cause Stevens-Johnson syndrome. Stevens-Johnson syndrome characterized by skin rash. And special point, always start with the dose. Start low dose. So we will look for the rash. If the person is not having rash, then we will increase dose. Otherwise, we will not. Clear? So lamotrigine always start with low dose. And second, L means least teratogenic drug. Minimum teratogenic anti-epileptic drug is lamotrigine. Okay? Now lorazepam is a drug of choice for status epilepticus. Status epilepticus कब बोलेंगे? When it is present continuously for more than 5 minutes. When the seizures do not stop for more than 5 minutes, it is called as status epilepticus. Drug of choice is lorazepam. Lorazepam is a drug of choice. And lorazepam is safe in liver failure. Remember we discussed a lot of drugs are safe in liver failure. L means lorazepam. Safe in liver failure. Then vigabatrin. Vigabatrin is used for infantile spasms. Infantile spasms. Particularly if there is infantile spasm with tuberous sclerosis. Normally for infantile spasm, it is ACTH. But if there is infantile spasm with the tuberous sclerosis, it is vigabatrin. And vigabatrin, the mechanism says it is GABA transaminase inhibitor. The name says it is a GABA transaminase inhibitor. GABA transaminase inhibitor. And VI means visual field contraction. The main side effect is visual field contraction. Visual field contraction. Okay? It causes visual field contraction. And infantile spasm, everyone knows, it's seen in less than 1 year baby, infantile, and plus characterized by salam seizures, and on ECG there, EEG there is hypsarrhythmia. Hypsarrhythmia, also known as which syndrome? West syndrome. Also known as West syndrome. Clear? I hope you all know about that. Okay. Then moving to antidepressant drugs. Antidepressant drug, the most important group are SSRI, selective serotonin reuptake inhibitor. And SSRIs are drug of choice for depression. Not only depression, they are drug of choice for obsessive compulsive disorder, drug of choice for phobia, drug of choice for bulimia, and drug of choice for post-traumatic stress disorder. Everywhere drug of choice are SSRIs. SSRIs are drug of choice for not only depression, but other conditions also. The main side effect of SSRI is sexual side effects. Major side effect is sexual side effects like delayed ejaculation and an orgasm. Delayed ejaculation and an orgasm. These are the main side effect of SSRIs. Okay? Nausea is most common. Like GAD side effect common with everyone. Just GAD also they are drug of choice. Generalized anxiety disorder also drug of choice. Okay? Now which are the drugs? I hope you remember Sasuri. Sasuri paracetamol से flu extinct. Sasuri, that means SSRI paracetamol से flu extinct. So para means paroxetine. Sita means citalopram. Se means sertraline. Flu means fluoxetine and fluvoxam. And E means escitalopram. Paracetamol से flu extinct. Clear? So that is about SSRIs. Then SNRI, only one thing you need to remember the name. The name is venlafaxine. Only SNRI, serotonin noradrenaline reuptake inhibitor, you need to remember is venlafaxine. Then TCAs, examples of TCAs, drugs ending with pramine or triptyline. Pramine like imipramine, clomipramine, desipramine. Triptyline like amitriptyline, nortriptyline. Pramines and triptylines are TCAs. The most important point about triptylines is to remember about their toxicity. TCAs cause side effects. Toxicity. So what is the toxicity of TCAs? TCS toxicity is characterized by seizures, characterized by Dhatura type of symptoms. All anticholinergic symptoms are there. Dhatura. Dhatura stand for, they have strong anticholinergic property. So we have dilated pupil, delirium, dry mouth, hyperthermia, agitation, tachycardia, urinary retention, and accommodation lost. Accommodation lost. I hope Dhatura everyone remembers. Clear? Symptoms of Dhatura are there. Clear? So dryness, delirium, dilated pupil, hyperthermia, agitation, tachycardia, urinary retention, and loss of accommodation. Clear? So Dhatura symptoms are there. Apart from that, there will be metabolic acidosis, and metabolic acidosis precipitate arrhythmias. So all these are features of uh, TCA poisoning, and the drug of choice for TCA poisoning is sodium bicarbonate. Sodium bicarbonate is a drug of choice for TCA. TCA poisoning drug of choice is T for tachycardia, beta. Kalpana, T for tachycardia. Okay. Sodium bicarbonate is a drug of choice. Drug of choice. Okay. Then moving to last, atypical drugs. Among the atypical drugs, the important one you need to remember, one is bupropion. Bupropion. Second is S-ketamine. Third is trazodone. Just remember about these three drugs which are likely to be asked in the exams. Bupropion is used as anti-smoking drug. Bupropion is anti-smoking. Anti-smoking. S-ketamine, the only special point is it is fastest acting antidepressant drug. Normally, all antidepressant drugs, they require around 3 weeks to produce action. S-ketamine can produce action in few hours only. Okay? सबसे ज़्यादा fast acting होती है. S-ketamine, like ketamine, is NMDA blocker. NMDA blocker. Like ketamine, it is NMDA blocker. S-ketamine is given by intranasal route. Intranasal. Okay? And it is used for treatment-resistant depression. If depression is not treated by other drugs, then we can use S-ketamine. Treatment-resistant depression. And trazodone, it causes side effect of priapism. Priapism. Priapism means painful prolonged erection. Painful prolonged erection. So trazodone देने से penis becomes like a bone. Penis will become like a bone. Okay? Don bone. Okay? So that is about antidepressant drugs. Clear? Then lastly, in the CNS, we have morphine poisoning. Morphine poisoning, it is characterized by sacrum. Symptoms of morphine poisoning you can remember from sacrum. S means sedation. So person will be in coma. In poisoning, person will be in coma. So when the person's brain is depressed, CVS is also depressed. So there will be low blood pressure, low heart. Then A means analgesia. This is the use, not the side effect. Analgesia is use of morphine. As C means constipation. So there will be absent bowel sounds. Absent bowel sounds. R means respiratory depression. So this is main feature of morphine poisoning. There will be low respiratory rate. U means euphoria. It is addictive drug. So you can find marks of needle stick marks you can find. And M for meiosis. That means it causes pinpoint pupil. Pinpoint pupil. So the characteristic feature of morphine poisoning are pinpoint pupil, respiratory depression, and hypotension. So depressed heart, respiratory depression, and pinpoint pupil. Pinpoint pupil, they are characteristic of morphine poisoning. And what is the drug of choice for morphine poisoning? Drug of choice is not atropine beta. Drug of choice for morphine poisoning is naloxone. Naloxone is drug of choice for morphine poisoning. Naloxone is a drug of choice for morphine poisoning. Clear? So that is about the CNS also. So I think we have completed two big topics, and we can take a small break, and then we will complete rest of the topics. Clear? So 5 minutes break. We will restart at 11:45. Naloxone, naltrexone में confusion क्यों रहती है बेटा? I think you did not attend my lecture. Naloxone is a shorter name, so it is short acting. So we need to give repeatedly. And naloxone, जो naltrexone है, उसके नाम में O आता है, means it is oral. Whereas naloxone के नाम में दो बार ओ आता है तो दे कैंसिल ईच अदर, सो नेलॉक्सोन इज आई। ठीक है, इससे ऐसे याद करते हैं। ओके, चलो लेट्स टेक अ ब्रेक। Hello guys, I'm back. So now we can start the next topic, which is anti-cancer drugs. So anti-cancer drugs, they are broadly classified into cytotoxic drugs. That means which kill the cells, which are toxic to cells, or they can be targeted drugs. They will find target inside the cancer cells. So the classification, first group of drugs are called alkylating agents. They will attach the alkyl group to DNA, and the drugs in the alkylating agent group you need to remember. These you can remember as if bus not present, take my cycle. Alkylating agents remembered as if bus not present, take my cycle. If means ifosfamide. Bus means busulfan. Not means nitrosoureas. P means procarbazine. T means temozolomide. M means mitomycin C. And cycle means cyclophosphamide. Cyclophosphamide. These are alkylating agents. Now, quickly, the MCQs about them. Cyclophosphamide and ifosfamide, they cause hemorrhagic cystitis. Hemorrhagic cystitis. Hemorrhagic cystitis, the treatment is steroid and the prophylaxis is mesna. Hemorrhagic cystitis treated by steroid, prevented by mesna. Okay. Then busulfan can cause pulmonary fibrosis. We will discuss the mnemonic to remember pulmonary fibrosis. I hope everyone remember which drugs cause pulmonary fibrosis. Temozolomide is a drug of choice for gliomas. Temozolomide drug of choice for gliomas, and mitomycin C is used for superficial bladder cancer and laryngotracheal stenosis or subglottic stenosis. So the special point about this drug is it is used topically, local anti-cancer drug, directly inside the bladder or in the trachea. So laryngotracheal stenosis and superficial bladder cancer, we use mitomycin C, just like BCG. So these are the important alkylating agents and their special points. Then coming to platinum compounds. Platinum compounds, the name end with the platin, like cisplatin, carboplatin, oxaliplatin. Now, special point about cisplatin to remember, it has three special side effects. It causes maximum nausea vomiting. Maximum nausea vomiting. It is nephrotoxic and it is ototoxic. Special point about cisplatin, highest nausea vomiting, nephrotoxicity and ototoxicity. Then anti-metabolites, that most important drug in this case is methotrexate. Methotrexate. Methotrexate, it acts by inhibiting dihydrofolic acid reductase. Dihydrofolic acid reductase inhibition. Dihydrofolic acid reductase inhibition, methotrexate. And special point to remember, it is a drug of choice for choriocarcinoma. Choriocarcinoma. And special point, the side effect is liver damage. It is hepatotoxic. So LFT monitoring is required. Bone marrow suppression, beta, bone marrow suppression is a common side effect of all anti-cancer drugs. Okay? Bone marrow suppression, diarrhea, alopecia, hyperuricemia, these are the common side effect of every anti-cancer drug. Okay? Yes. The antidote for methotrexate is folinic acid, not folic acid. Folinic acid. Folinic acid is antidote. Antidote is folinic acid. Clear? Then coming to mitotic spindle inhibitors. Drugs inhibiting mitotic spindle are vincristine and vinblastine. Vincristine, vinblastine like drugs are mitotic spindle inhibitors. Now, what is special to remember about vincristine? Vincristine is a drug which do not cause bone marrow suppression. We discussed all anti-cancer drugs can cause bone marrow suppression. Vincristine do not cause bone marrow suppression. Next, we have our topoisomerase inhibitors. Topoisomerase inhibitors, the examples, drugs ending with rubicin. Rubicin, like doxorubicin, daunorubicin, epirubicin. These are topoisomerase inhibitors. So we already remembered ruby dil le jati hai. So rubicins cause cardiotoxicity. Cardiotoxicity. These are cardiotoxic anti-cancer drugs. And it is prevented by dexrazoxine. Prevented by dexrazoxine. Dexrazoxine prevent the cardiotoxicity caused by anti-cancer drugs. Then miscellaneous drugs, it include asparaginase. L. asparaginase, and bleomycin. These are under the miscellaneous category. And both of these drugs do not cause bone marrow suppression. No bone marrow suppression. Special point to remember, L-asparaginase is used for acute lymphoid leukemia, and major side effect is pancreatitis. Pancreatitis is the main side effect. Use is ALL, side effect is pancreatitis. Whereas bleomycin, the main side effect are two. It causes flagellated dermatitis. And second, it also causes chemoman. So this C stand for cisplatin. So cisplatin के three important side effects: ototoxicity, smiling face means vomiting, maximum vomiting, and C kidney look like C means nephrotoxicity. Then periphery look like V. So V for vincristine and vinblastine. Vinblastine, they cause peripheral neuropathy, and that is in the head also. That means it is SIADH, secrete ADH from the brain. Okay? Then B, it stands for bleomycin and busulfan. So they will affect the lung. They cause pulmonary fibrosis. We have remembered them by better mnemonic, which is cycle bus truck car drone wala yaad kar liya. Then heart look like D. So doxorubicin, daunorubicin are cardiotoxic. Even again, we remember the better mnemonic. Ruby dil le jati hai, so rubicins are cardiotoxic. Then this look like 6. Liver look like figure of 6. So drugs starting with 6, like 6 mercaptopurine, 6 thioguanine, they are hepatotoxic. 6 mercaptopurine, 6 thioguanine are hepatotoxic. Clear? And only complete cycle is cycle of bladder. So cyclophosphamide, it cause hemorrhagic cystitis. Cyclophosphamide cause hemorrhagic cystitis. Is it clear? Okay. Sure. So that is about the typical, or we can say, cytotoxic anti-cancer drugs. Then coming to some antibodies, monoclonal antibodies which are used in cancer, you need to remember mainly 3 monoclonal antibodies: cetuximab, rituximab, and trastuzumab. Trastuzumab and related drug is pertuzumab. These are monoclonal antibodies. So cetuximab, you can remember C for colorectal carcinoma, used for colorectal carcinoma. And cetuximab is a monoclonal antibody against HER1. HER1, the full form of HER1 is human epidermal growth factor receptor 1. So basically it is against epidermal growth factor receptor 1. HER1 is also written as EGFR. Simply 1 nahi likhte. EGFR means HER1. HER1 means EGFR. Epidermal growth factor receptor. Human epidermal growth factor receptor 1. So HER1 के against monoclonal antibody is cetuximab, used for colorectal cancer. Then rituximab. So you remember the story of रितु, जो मेरी क्लास अटेंड करने आई थी, 20 साल की लड़की थी एंड उसको छुट्टी नहीं मिल रही थी. तो मैंने उसको क्या सजेस्ट किया था कि अगर सीएल लेगी तो नहीं होगी लेट. तो रिटुक्सीमैब, रितु को क्या बोला, सीएल ले लो तो नहीं होगी लेट. ठीक. तो इट इज अ मोनोक्लोनल एंटीबॉडी अगेंस्ट CD20. मोनोक्लोनल एंटीबॉडी अगेंस्ट CD20. 20-year-old रितु सीएल लेगी तो नहीं होगी लेट. Okay. Then trastuzumab look like brastuzumab, so used for breast cancer, and these are against HER2. Okay. ये HER2 के अगेंस्ट मोनोक्लोनल एंटीबॉडी है. सो यू कैन रिमेंबर HER2 उसके दो क्या होंगे, HER2 ब्रेस्ट आर देयर, तो यूज्ड फॉर ब्रेस्ट कैंसर. सो ट्रास्टुजुमैब. एंड फर्दर अगर ट्रस्ट करोगे तो दिल तो टूटेगा ही. तो ट्रास्टुजुमैब विल इज कार्डियोटॉक्सिक, दिल तोड़ देती है. ट्रास्टुजुमैब कार्डियोटॉक्सिक है. तो मैंने बोला था कि ब्रेस्ट वालों पे ट्रस्ट नहीं करने का, पर तू फिर भी करेगा, तो पर्टुजुमैब तू फिर भी करेगा तो तेरा भी दिल टूटेगा. तो पर्टुजुमैब इज आल्सो कार्डियोटॉक्सिक. Clear? So that is about the important monoclonal antibodies used in cancers. Okay. Sure. Now we will come to our general pharmacology. Okay. बड़े बड़े इंपॉर्टेंट टॉपिक्स हमारे हो गए. अब जल्दी से जनरल फार्मा से स्टार्ट करते हैं. प्लाज्मा कंसंट्रेशन टाइम ग्राफ. इट्स अ ग्राफ बिटवीन प्लाज्मा कंसंट्रेशन एंड टाइम. Graph is of this type. Three important parameters we note. This highest point on the y-axis is called Cmax. On the x-axis is called as Tmax. And this total area is called as AUC. So quickly tell me, Cmax depend upon what? Cmax depends upon dose of a drug. More dose, more Cmax, less dose, less Cmax. AUC tells about extent of absorption. How much total drug has reached the body, that is told by AUC. And Tmax tells about rate of absorption. How quickly the drug is absorbed is told by Tmax. Okay? So this is plasma concentration versus time graph. Okay. Then volume of distribution. How to calculate? Volume of distribution is calculated by amount given divided by plasma concentration obtained. But we give a particular dose and see what is the plasma concentration we obtain. We divide the two, that is called volume of distribution. So what does it tell? What is the importance of volume of distribution? What does it tell? More VD means more drug in tissues. So basically higher VD means drug is stored in the tissues. Higher VD means drug is stored in the tissues, and VD is used to calculate loading dose of a drug. Loading dose is VD into target plasma concentration, whereas maintenance dose is equal to clearance into target plasma concentration. Now this is the IV dose. If they ask you to calculate the oral dose, then you divide it by fractional bioavailability. What percentage bioavailability is there to divide? क्लियर? तो बायोअवेलेबिलिटी से डिवाइड कर दोगे तो ओरल डोज भी आ जाएगी. क्लियर? अगर ओरल नहीं है, आईवी पूछना है तो डायरेक्टली मल्टीप्लाई कर दो. ओरल निकालना है तो डिवाइडेड बाय बायोअवेलेबिलिटी. क्लियर एवरीडे? Then urinary alkalinization is required for what? So remember, when the medium is same, the drug can cross. That means acidic drug can cross in acidic medium, basic drug can cross in basic medium. Now, if there is poisoning with acidic drugs, acidic drug poisoning is there. So normally the drug will come in the urine, but it will be reabsorbed. Everything in the urine comes back. Okay? But in poisoning, we want that the drug should not come back. If we do not want the drug to move, so we need to change the medium, because in same medium it will cross. Here we want to stop the reabsorption, so we want to change the medium. So what we will do, we will make the urine alkaline. Clear? Drug is acidic, urine is basic, so drug cannot cross, so it will go out. Clear? So basically in acidic drug poisoning, we make the urine alkaline, make urine basic. That will prevent reabsorption. So drug is excreted out. So for which drug we commonly do urinary alkalinization? For acidic drugs. So obviously by giving sodium bicarbonate. By giving sodium bicarbonate, we make the urine basic. So for which drug it is used? It is used for acidic drugs like aspirin. Or we can also use it for methotrexate and barbiturates. These are acidic drugs. Just remember, if a drug is, but a sodium bicarbonate is used in TCA poisoning also, but TCA poisoning, the purpose is not to make urine alkaline. The purpose is to treat metabolic acidosis. ठीक है, उसमें तो acidosis है तो इसलिए bicarbonate दे रहे हैं. Clear? Now, remember, any drug ending with "ene" is a basic drug. So basically, they will ask the question, urinary alkalinization is done to excrete the drug in all of the following drug poisonings except. Okay? So 3 drugs will be without "ene", 4th drug will be with "ene". So "ene" will be the answer because these are basic drugs. Clear? Atropine, tuberculosis, any drug ending with "ene", atropine, morphine, कोई भी हो, ठीक है, जो भी "ene" में खत्म होती है, that is a basic. Okay? So that is about urinary alkalinization. Then graph of agonist, antagonist, you all know. So quickly, before going to them, we have 4 drugs: agonist, partial agonist, inverse agonist, antagonist. Quickly tell me what is the affinity and intrinsic activity. इनकी affinity और intrinsic activity के बारे में बताओ. All of them have high affinity. All of them have high affinity. Intrinsic activity of agonist is high. Partial agonist is low, or we can say in between. Inverse agonist is negative, and antagonist is 0. Okay? No intrinsic activity. So in agonist +1, partial agonist is between 0 to 1. Inverse agonist is negative, and antagonist is 0. Clear? So how the same question is asked in the form of graph? They will say percentage of maximum activity, and they will give a baseline. So if a drug is producing action highest, it will be agonist. If a drug is producing action less than baseline, it is inverse agonist. If a drug is producing at the baseline, that means no change, it will be antagonist. And if it is between high and baseline, it will be partial agonist. I hope you can answer this question. Easy है ना ये, तो इसमें तो गड़बड़ नहीं करोगे. ड्रग के नाम याद करने की जरूरत नहीं है बेटा. आपको एगोनिस्ट एंटागोनिस्ट तो पता ही होते हैं ना. ठीक है. तो यूजुअली ड्रग के नाम पे नहीं आता है, ऐसे ही आता है क्वेश्चन डायरेक्टली. ओके, चलिए. Next, moving to dose response curve. So from the dose response curve, particularly log dose response curve, which is S-shaped curve, sigmoid curve, we obtain two important parameters. One is potency, second is efficacy. Okay? Potency tells about dose of a drug, how much dose will produce the action, and efficacy tells maximum effect of a drug. So you can remember them with the help of help. Okay? So height tells about efficacy, left-sidedness tells about potency. Higher the curve, more efficacious, left-sided, more left, more potent. So quickly I will make 4 graphs. You need to tell this is drug A, this is drug B, this is drug C, this is drug D. So quickly arrange them in the order of decreasing potency. पहले सबसे ज्यादा potent, फिर कम. Decreasing potency. Potency is left side. So left से right में जाते रहो. तो most left is D, then we have A, then we have C, then we have B. Another important thing, do not see the lowest point or highest point. See the midpoint. Potency के लिए midpoint देखते हैं. Midpoint. Okay? Potency के लिए midpoint देखते हैं. Okay? Efficacy को arrange करो. Low to high. Sorry, high to low. Highest is C, then A, then D, then B. Okay? You can see. Potency is high. Potency is left to right. Efficacy is high to low. Okay. Now from the DRC, you can also tell about type of inhibition. DRC से आपको type of inhibition भी पता लग जाएगा, competitive है या non competitive है. So this is a graph without any drug, control graph. Now after giving a drug, the graph shifts to right. तो क्या हो जाएगा? Which type of inhibition it is? Competitive inhibition. क्योंकि competition right है, competition is right. But if the graph goes down, उसी जगह पे है पर नीचे चला गया, this नीचे चला गया, it is non-competitive. N for non-competitive, N for नीचे चला गया. ठीक, नीचे जाने पे non-competitive है, right में जाने से competitive. Clear? N for नीचे, N for non-competitive, and competition is always right. Okay? चलिए. Then enzyme inhibition from the Lineweaver work के plot. Now what is important, students get confused very commonly कि ग्राफ ये वाला दिया होता है and they are applying Lineweaver work के plot. So you need to see कि कहां पे ग्राफ दिया, किस किस चीज के बीच में ग्राफ दिया है. Okay? If the graph is given between dose and response, you need to apply this logic कि competition is right, नीचे गया तो non competitive. Dose response कब में ये लॉजिक है. ओके, whereas in case of Lineweaver work के plot where the graph is between 1 by substrate concentration and 1 by reaction velocity, इसको डबल रेसिप्रोकल प्लॉट कहते हैं. डबल रेसिप्रोकल बिकॉज बोथ आर रेसिप्रोकल्स, 1 by S 1 by V. ठीक है, तो अगर डबल रेसिप्रोकल प्लॉट है तो यहां पे वो वाला हमारा निमोनिक लगेगा कौन सा? इफ इट इज क्रॉसिंग ऑन वाई एक्सिस, C मींस क्रॉस, C मींस कॉम्पिटिटिव. If they are crossing on y-axis, it is competitive. क्रॉस कर रहा है वाई एक्सिस पे तो कॉम्पिटिटिव है। एंड इफ दे आर स्टार्टिंग फ्रॉम एक्स एक्सिस एंड गोइंग अवे जस्ट लाइक योर एक्स, तुम्हारी एक्स की तरह दूर चले गए, तो ये नॉन कॉम्पिटिटिव है, बिकॉज मेरे यार दादा कोई कंपटीशन ही नहीं, ठीक है, मेरे यार दा कोई कंपटीशन नहीं, सो दे आर नॉन कॉम्पिटिटिव। क्लियर? सो सी वेयर द फॉर्मूला यू नीड टू अप्लाई, ठीक है। मेनी स्टूडेंट्स वर अप्लाइंग दिस वाला लॉजिक एट दिस, कैसे चलेगा बेटा काम, है ना? दे आर सेइंग दे आर स्टार्टिंग फ्रॉम सेम पॉइंट, ये वाले लॉजिक नहीं लगाने हैं आपको। लॉजिक क्या लगाना है? सी दी ग्राफ। इफ द ग्राफ इज बिटवीन 1/b एंड 1/s, तो ये वाला लॉजिक लगाना है। दैट मीन्स एक्स वाला है दूर चला जाएगा, नॉन कॉम्पिटेटिव, एंड इफ द क्रॉसिंग ऑन एक्स एक्सिस इट वाई एक्सिस इट इज कॉम्पिटेटिव। बट हेयर अनकॉम्पिटेटिव नहीं करना बेटा, एफएमजी के लिए अनकॉम्पिटेटिव इज नॉट रिक्वायर्ड, ठीक। देन इफ इट इज राइट वाला इन डीआरसी, राइट इज कॉम्पिटेटिव, डाउन इज नॉन कॉम्पिटेटिव। ओके, ठीक है, चलिए। Then moving to clinical trials. Another very important topic for PG and test exams, FMG also. So first of all, we will write an application which is called as investigational new drug application. So we will do animal studies. Then we will write that application to FDA in America. In America, licensing authority is called FDA. In India, it is called as Drug Controller General of India. तो ये हमारे माई बाप हैं, इनको हमने लिखा, एप्लीकेशन लिखा, हमने भीख मांगी कि भैया दवाई टेस्ट कर लेने दो हमें, तो दे गिव द परमिशन, वी स्टार्ट द क्लिनिकल ट्रायल्स अंडर 4 phases, phase 1 to 3 4, phase 1 to 3 4. Now phase 1 is the first phase which is done in healthy people. Now because they are healthy, we cannot know whether the drug is working or not, so efficacy cannot be tested. That is very important, efficacy cannot be tested. What is the main aim? To know the maximum tolerable dose. The main aim is to know the maximum tolerable dose. Okay? After phase 1, we go to phase 2. Phase 2 is done in patients. So first time we are taking patients. So because we are taking first time patients, so first time efficacy we are testing. First time we are testing the efficacy. Yeah? So these are also known as dose ranging studies. Dose ranging studies भी कहते हैं. So here we can test them in different doses. 100 milligram में देख लिया, 200 milligram में देख लिया, 300 milligram में देख लिया. That is called the dose ranging studies. Then we will go to phase 3. Phase 3 again in patients, but difference is here the patients are in thousands, not 100 to 100. Here maximum up to 5,500 patients we enroll. Usually 100 to 100 ही लेते हैं, but maximum 500 होते हैं. Here we take thousands of patients, 5,000, 4,000, 3,000, and it is done at many different centers. We take heterogeneous population, अलग अलग तरह के लोग लेते हैं to cover different genetic makeup, multicentric studies. Now why we are taking so many people and from different places? That is to confirm. This is the key word here, confirmation. Efficacy तो इसमें भी करते हैं, but here we confirm the efficacy. If the question is asked first time efficacy, the answer is phase 2. But if the question is confirmation of efficacy, it is phase 3. And these are also known as efficacy trials. The other name of phase 3 is efficacy trials. Efficacy trials. Okay. So MTD is beta maximum tolerable dose. Maximum tolerable dose. Maximum tolerable dose. Okay. Then after phase 3, we will write another application to the licensing authority that is called as new drug application. New drug application हम FDA को या DCI को लिखते हैं, तो अब हम इस लव लेटर में इनसे ये भीख मांगते हैं कि भैया हमने इतने सारे ट्रायल कर लिए, बहुत सारे पैसे हमने वेस्ट कर दिए, अब कुछ तो कमा लेने दो भैया, प्लीज हमारी दवाई को अप्रूव कर दो. So this is for approval of a drug. If the FDA think that it can be good, then they will give the permission, drug will come in the market. So after which phase drug come into market? It is phase 3. Okay. Now when the drug come in the market, now we do the studies, they are called as phase 4 study. So obviously their name will be post-marketing studies. Post-marketing studies. And this phase involved lakhs of patients because everyone will be given drug by the doctor. So here we can come to know even if one side effect occur in lakhs of people, that means we can know the rare side effects. And second, we can also test if we give a drug for 5 years, 10 years, what happens? So that means long-term side effects. So rare and long-term side effects are mainly done in phase 4. Maximum risk of failure is in phase 2. Someone was asking why. The simple reason is जब हम पहली बार कोई चीज करते हैं तो फेल होने का चांस सबसे ज्यादा होता है ना. तो वी आर टाइम टेकिंग फर्स्ट टाइम एफिकेसी, पहली बार एफिकेसी देखने की कोशिश कर रहे हैं, तो वेरी हाई चांस कि हम यहीं पे फॉल्टर करें. ठीक है, क्योंकि फेज 3 में तो हम वही लेंगे जो फेज 2 में पास हो गया. अगर फेज 2 में पास हो गया तो हाई चांसेस है कि कुछ ना कुछ तो अच्छा होगा उसमें, है ना. तो फर्स्ट टाइम मैक्सिमम फेलियर इज इन फेज 2. हाँ प्योर, सॉरी भाई, मैंने तुम्हारे जज्बातों से खेल लिया, मेरा बिल्कुल ऐसा इरादा नहीं था। पहली बार भी पास हो जाते हैं, ठीक है, मेहनत करते हैं तो पहली बार भी पास हो जाते हैं, ठीक। ये तो उन लोगों के लिए है जो कॉन्फिडेंट नहीं है, जिनको लगता है पता नहीं होगा कि नहीं होगा, ठीक है। तो मेरे हमारे सारे स्टूडेंट्स बिलीव करते हैं दे विल पास एंड दे विल डेफिनेटली पास। ओके, चलो। So that is about different physical trials. Then another thing is blinding. Blinding. So there are three type of open label studies, means there is no blinding, no blinding. Single blind studies means only subject is blind. That means subject do not know which drug he is getting. Double blind studies means both subject as well as the investigator. मतलब पेशेंट और डॉक्टर दोनों को, किसी को नहीं पता कि कौन सी दवाई मिल रही है। क्लियर। सो ओपन लेवल स्टडीज आर डन इन फेज 0 और फेज 1, सॉरी। फेज 1 में ओपन लेवल होती, फेज 2 में सिंगल ब्लाइंड होती, फेज 3 आर डबल ब्लाइंड, एंड फेज 4 एनी ब्लाइंडिंग। यूजुअली ओपन होती है, यूजुअली ओपन होती है, बट फेज डिपेंडिंग अपॉन किस तरह की स्टडीज कर रहे हैं, दे कैन बी सिंगल ब्लाइंड, डबल ब्लाइंड ऑल्सो, ठीक। तो जस्ट एक एक माइनस करते जाओ। फेज 1 -1 0, दैट मीन ओपन। फेज 2 -1 सिंगल ब्लाइंडिंग, फेज 3 -1 डबल ब्लाइंडिंग। Clear? So double blind studies are the best studies. That's why after phase 3 the drug will come into market. Clear? Is it clear? So that is about clinical trials. Yes, गोगा से ही होगा. You just need to believe me as well as yourself. चलिए. Next is therapeutic index. Now for calculating therapeutic index, we do another DRC which is called as quantal DRC. What is quantal DRC? It is same DRC. We have log dose response. But what is the difference is response here will be checked in many people. So here we will not see the response, we will say percentage of subjects responding. कितने परसेंटेज लोगों में रिस्पॉन्स आया उस डोज के साथ। सो वेन एवर इट इज डन इन मोर देन वन, दैट्स व्हाई द टर्म इज क्वांटिटी। व्हेन वी आर गिविंग टू मेनी, इट इज कॉल्ड क्वांटिटी। सो फर्स्ट वी विल डू अ डीआरसी फॉर इफेक्टिव डोज, then we will do a DRC for a lethal dose. Lethal dose. Okay? The midpoint of effective dose, that means the dose at which 50% of the patient get the response, that is known as ED50. Effective dose in 50%. And similarly, the midpoint of this is LD50. That means lethal dose in 50%. Clear? And therapeutic index is calculated as TILE. So from the TILE, you can remember TI means therapeutic index is equal to LD50 divided by ED50. So we divide the two. LD50 by ED50 is therapeutic index, and therapeutic index tells about margin of safety. If a drug has higher therapeutic index, it is more safer. If a drug has lower therapeutic index, it is less safer. Clear? Chat GPT says, believe 100% Goga, you will pass. Better Chat GPT, I asked about myself in Chat GPT. Tell me about Dr. Govind Rai Garg. They have told everything. He's a pharmacology teacher, student like that. But at the end say, unfortunately, we lost them last year. है ना? तो चैट जीपीटी ने तो मेरे को पहुंचा दिया ऊपर। तो चैट जीपीटी पे ज्यादा भरोसा मत करना। चलो, next is physiological and pharmacological antagonist. So basically here antagonist, drug antagonism means two drugs with opposite action. With opposite action. Two drugs with opposite action are called as antagonist. Clear? But suppose one drug is causing tachycardia, increase in heart rate. Second drug is causing bradycardia, decrease in heart rate. So they are antagonists. But if the action is because of different receptors, like one drug is stimulating beta-1 receptor to cause tachycardia, and other drug is stimulating M2 receptor to cause bradycardia, then it is called as physiological. Physiological. So physiological means the receptors are different. Clear? So like adrenaline is causing tachycardia by stimulating beta-1, but atropine is causing bradycardia by stimulating M2. So they are physiological antagonist. Whereas if one drug is stimulating beta-1, other drug is blocking beta-1, then it is pharmacological. If same receptor, then it is pharmacological, like adrenaline and metoprolol. Metoprolol or any beta blocker, it will cause bradycardia by blocking beta-1. Clear? So physiological, different receptor, pharmacological, same receptor. Clear? So that complete the important topic. एट्रोपिन क्वेरी का क्या मतलब है बेटा? आई कुड नॉट अंडरस्टैंड योर क्वेश्चन। यस, रिसेप्टर नेम दिया रहेगा अवंती का। अभी तक जितने भी क्वेश्चन आया दे हैव गिवन द नेम ऑफ द रिसेप्टर्स। क्लियर? जैसे M1 ब्लॉक, सॉरी एट्रोपिन तो, सॉरी 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 सॉरी, हाँ सॉरी, थैंक्स फॉर करेक्टिंग, थैंक्स फॉर करेक्टिंग। इट्स नॉट M2 ब्लॉकर, इट इज M2 एगोनिस्ट, M2 एगोनिस्ट लाइक एस्टाइलकोलिन। थैंक्स फॉर करेक्टिंग। निहारिका थैंक यू। शर्मा जी थैंक यू। ओके, और किसी ने भी एट्रोपिन लिखा था उसके लिए भी थैंक यू। तनुज, तनुज थैंक यू। चलो, नाउ मूविंग टू ऑटोनॉमिक नर्वस सिस्टम, starting with Alzheimer's disease. We know Alzheimer's disease is due to deficiency of acetylcholine in the brain. That will lead to what symptom? Dementia, loss of memory. So the best thing will be to increase acetylcholine. So if we increase acetylcholine, we can treat Alzheimer's. And how to increase acetylcholine? By inhibiting acetylcholine esterase. If we inhibit acetylcholine esterase, memory will improve. And who is best to improve your memory? Okay? सबसे बेस्ट कौन है? Dr. Gobind, obviously. So Dr. Gobind drugs are drug of choice for Alzheimer's disease. So D for donepezil, R for rivastigmine, and G for galantamine. Donepezil, rivastigmine, and galantamine, they are drug of choice for Alzheimer's disease, and all of them are available orally. बट रिवास्टिगमिन का, रिवा का ब्रेकअप हो गया था तो उसका हमने पैचअप भी कराना है, तो रिवास्टिगमिन इज ऑल्सो अवेलेबल एज पैच। रिवास्टिगमिन इज ऑल्सो अवेलेबल एज ट्रांसडर्मल पैच। हाँ, डॉक्टर हाउस से सेइंग कितने अच्छे आदमी थे डॉक्टर हुआ, हम मरने के बाद हर कोई अच्छा ही कहता है। ठीक है, चलिए। देन मूविंग टू एनएमडीए ब्लॉक, सेकेंड टाइप ऑफ ड्रग इज एनएमडीए ब्लॉकर, इट इज मिमेंटिन। मिमेंटिन, so it will improve the memory of the man. Memory of the man is improved by mimetic, mimetic. And number 3, we have recently formed a monoclonal antibody जो आपको बिल्कुल याद नहीं करनी है, just showing my knowledge, aducanumab. Aducanumab. Aducanumab, it is a monoclonal antibody which target the underlying cause of Alzheimer's disease, which is A beta amyloid. It is against A beta amyloid, which is deposited in the neurons and used for Alzheimer's disease. Alzheimer's disease में use, clear? समझ गए? So you need to remember DRG drug and mimetic, बस। ठीक है, एडुकानुमाब करने की जरूरत नहीं। ओके, क्लियर? चलिए, then coming to myasthenia gravis, everyone knows that in myasthenia gravis there is formation of antibodies against NM receptors. So NM receptors are not stimulated enough, that lead to muscle weakness. Muscle weakness हो जाती है। But if NM receptors are overstimulated, that also lead to muscle weakness. Remember, NM receptor require optimal stimulation, ना कम चाहिए ना ज्यादा चाहिए, optimal चाहिए। Clear? So this condition is myasthenia gravis and this condition is cholinergic crisis. Cholinergic crisis. तो फर्स्ट ऑफ ऑल हाउ टू डिफरेंशिएट बिटवीन द टू, दोनों में कैसे डिफरेंशिएट करेंगे अगर मसल वीकनेस के साथ आएगा? तो बाय गिविंग एड्रोफोनियम। एड्रोफोनियम इज एस्टाइल कोलिन एस्ट्रेज इनहिबिटर। एस्टाइल कोलिन एस्ट्रेज इनहिबिटर है एड्रोफोनियम, बट इट इज वेरी शॉर्ट एक्टिंग, इट्स एक्शन रिमेन फॉर लेस देन 10 मिनट्स। सो व्हेन वी गिव एड्रोफोनियम, व्हाट विल हैपन? एड्रोफोनियम विल इंक्रीज एस्टाइल, acetylcholine will stimulate NM. So if NM is less stimulated and on stimulation of acetylcholine of NM receptors, the muscle condition will improve. If the condition improve for 10 minutes, it is myasthenia. And if the condition worsen for 10 minutes, because NM is already stimulated, it will stimulate further. It is myasthenia, cholinergic crisis. Clear? So this test is known as a Tanzilon test. Market name of adrophonium is Tanzilon. Clear? So Tanzilon test or hydrophonium test is same thing. So hydrophonium is used for diagnosis of myasthenia gravis. Clear? So hydrophonium देके diagnosis कर लिया, but we cannot use it to treat because it is very short acting. So if we want to treat, treatment will be long acting acetylcholine esterase inhibitor. So it is either neostigmine or pyridostigmine. Neostigmine or pyridostigmine, they are used for treatment of myasthenia gravis. Okay. Now, neostigmine, pyridostigmine दे दिया, what can be the main side effect of these drugs? These stimulate muscarinic receptors also. They do not stimulate only nicotinic but also muscarinic. So we have to block muscarinic receptor by giving atropine. So neostigmin like drugs are given with atropine. Atropine के साथ देते हैं. Why atropine is given? To prevent the muscarinic side effects. Muscarinic side effect रोकने के लिए we give atropine. Clear? Then coming to cobra bite. Cobra bite say again the snake cobra is neurotoxic means it will block NM receptor. So when NM receptors are less stimulated, there will be muscle weakness. So in cobra bite also there is muscle weakness. So because the problem is same, the treatment is also same. So treatment of cobra bite is neostigmin plus atropine. Neostigmin plus atropine is used for treatment of cobra bite also. But if they ask what is the drug of choice or treatment of choice for cobra bite, what is the treatment of choice? Treatment of choice for any snake bite will be anti-snake venom. Treatment of choice for any snake bite is anti-snake venom. So if anti-snake venom is not available or it is not able to treat completely, then we use neostigmin atropine. Okay? तो anti-snake venom तो first choice रहेगा ही रहेगा. Okay? Then moving to organophosphate poisoning. Organophosphates like malathion, parathion. These are irreversible inhibitors of acetylcholine esterase. Acetylcholine esterase को permanently inhibit कर दें. So that will lead to increase in acetylcholine. So when acetylcholine increases, it will stimulate M1, M2, M3, all the muscarinic receptors. And you know where M1, M2, M3 are present? कहाँ होते हैं? पहले खाओ पियो, फिर दिल लगाओ, बाकी काम बाद. तो M1 in stomach, so there will be increase in acid in the stomach. फिर दिल लगाओ M2 in heart, so there will be depression of heart, bradycardia, decreased conduction, all these will be. And M3 represent everywhere else. Like in the eye, it will cause pinpoint pupil. In the glands, it increase all secretions. All secretions, tears will be coming, sweating will be there, diarrhea will be there, all secretions will be increased. These are the two most important symptoms. Apart from that, there will be bronchoconstriction, there will be diarrhea, there will be urination, and all the receptors are present in the brain. So when overstimulated, person will go to coma. Coma. Okay? So the most important symptom you need to remember are these two. If both of them are present, diagnosis is always organophosphate poisoning. अगर ये दोनों के दोनों हैं तो हमेशा organophosphate poisoning ही होगा और किसी चीज में नहीं होते दोनों इकट्ठे. ठीक है, लैक्रीमेशन होगा ये सब. ठीक है, एंड मोस्टली दिस इज सीन इन फार्मर्स बिकॉज दे आर कॉमनली यूजिंग दीज एज इंसेक्टिसाइड्स. तो सिम्टम्स डायग्नोज हो गए. सो फॉर ट्रीटमेंट सिंपली वी विल ब्लॉक देम. So the drug of choice for organophosphate poisoning is atropine. Drug of choice is atropine. Atropine is given IV. It is given every 5 minutes. Every 5 minutes till हर 5 मिनट बाद देते रहते हैं. कब तक? Till we get some symptoms like when these two are reversed. That means there is dilated pupil, mydriasis occur, then secretions decrease. And third is tachycardia. Heart rate become more than 100. So when these symptoms come, that means we have given effective dose of atropine, we will stop. These are called signs of atropinization. Okay? तो ये देते रहे. Now question asked is, atropine cannot reverse which symptom of organophosphate poisoning? Organophosphate poisoning में कौन सा symptom है जो atropine reverse नहीं कर सकता? Atropine can reverse all of them because they are because of muscarinic. When we block muscarinic, they will be reversed. But acetylcholine can also stimulate nicotinic receptors. NM receptor को भी तो stimulate कर सकते. And overstimulation of NM receptor result in muscle weakness. So muscle weakness is the only symptom which cannot be reversed by atropine. Atropine muscle weakness को reverse नहीं कर सकता. And to reverse muscle weakness, we use another drug which are called oximes. Oximes are two, PAM and DAM. Pralidoxime and diacetyl monooxime. They can reverse muscle weakness. And what is the important is PAM and DAM. These are not the drug of choice. ये याद रखना आप. Drug of choice is always atropine, that is life saving. Oximes are used after using atropine, and oximes are basically acetylcholine esterase reactivators. ये acetylcholine esterase को फिर से काम करने लगाते हैं. Acetylcholine esterase reactivators are oximes. Clear? Differentiate oximes and neostigmin. बेटा इन दोनों में तो सिमिलरिटी कोई नहीं है बेटा. Oximes are acetylcholinesterase reactivator. Neostigmine is acetylcholinesterase inhibitor. There is no similarity between the two. Beta, organochlorine poisoning is irreversible. It cannot be reversed with atropine. Okay? Organochlorine only symptomatic treatment is there. Organochlorine cannot be reversed with atropine. बस just जितना याद कर लो. Cannot be reversed by atropine. Just remember this. Clear? Sure. So that is about organophosphate poisoning. So that is cholinergic drugs. Now moving to anticholinergic drugs, dropping the system of parasympathetic system. So we may have M1 block. The drug is piranzepam. M1 कहाँ था? Stomach में. पहले खाओ पियो. So when we block M1, that will result in decrease in acid. So used for peptic ulcer. Peptic ulcer. Okay. M2 blocker is atropine. M2 कहाँ था? In the heart. So M2 was depressing the heart. So if heart is already depressed, we will like to block M2. So atropine is a drug of choice for bradycardia and AV block. Bradycardia and AV block, drug of choice is atropine. Bradycardia, AV block. Yes, PAM and DAM are not indicated in carbamates. Carbamate poisoning में नहीं देते because it cannot be reversed. That is permanent, totally permanent. Okay, even oximes cannot reverse that. Then coming to M3 blockers. In the bronchus, M3 was causing bronchoconstriction. So blocker will cause bronchodilation. So bronchodilation we require in asthma and COPD. And the drug used is ipratropium. Ipratropium. Another similar drug is tiotropium. Ipratropium, tiotropium are used in asthma and COPD. Then M3 blocker in the bladder. M3 cause contraction of bladder. Contraction of bladder. And where we do not want contraction of bladder, in overactive bladder. In overactive bladder, when the bladder is contracting without purpose, we want to block M3. And the drug which are blocking M3 are remembered as soft bladder. Soft bladder. So soft bladder stand for solifenacin, oxybutynate, flavoxate, tolterodine, and trospium, and darifenacin. You need to remember all of them because questions are asked on them. ये सारी याद करनी है आपको. Solifenacin, oxybutynate, flavoxate, tolterodine, trospium, and darifenacin. They are used in overactive bladder. And lastly, M3 in the eye. The drug we are using is usually atropine or tropicamide. Atropine or tropicamide. So these are used mainly for refraction testing and fundoscopy. Refraction testing and fundoscopy. These have two actions. One, they cause mydriasis. And second, they cause cycloplegia. Mydriasis and cycloplegia. Someone is doing calculation. Johnny Sins. Johnny Sins इतना छोटा सोचता नहीं है वैसे. Johnny Sins saying 1,000 students average bought the plan for FMG 23,000 INR, 6 months revenue 23 CR only from FMG. है ना? Very good. Now, do you know how much expenses are there? चलो छोड़ो. Johnny Sins को अलग से बैठा के बात करेंगे. चलिए. Atropine, tropicamide. Atropine and tropicamide. Now, what is important? Atropine is a drug of choice for refraction testing in children because it is strongest cycloplegic drug. Whereas tropicamide is shortest acting, so it is preferred in adults. Atropine is a drug of choice in children, whereas tropicamide is shortest acting drug. It is preferred in adults. Okay, so 4 to 6 hours. This is working for 7 days. This is working for 4 to 6 hours. Okay, so that is about anticholinergic drugs. Now coming to very important topic, overactive bladder. So in overactive bladder, we can use two type of drugs. One, we can use M3 blockers. And second, we can use beta-3 agonist. If we stimulate beta-3, we can relax the bladder. M3 blockers we use are soft bladder. soft bladder. We just discussed the drugs. And beta 3 agonist we use is mirabegron. 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 Now, important question to remember. Now, the drug of choice for overactive bladder overall has become mirabegron. अब mirabegron drug of choice हो गया है. Mirabegron, मेरा bladder gone. Yes, मेरा bladder gone. Mirabegron is now the drug of choice. Okay. Previously, the drug of choice was oxybutine. If mirabegron is not in the option, तो oxybutine choose कर लेना. ठीक है. But if they ask the question, what is the drug of choice for overactive bladder in a patient with Alzheimer's disease? In Alzheimer's disease, we will not like to block cholinergic system because acetylcholine is already less in the brain. So obviously, the drug of choice will be mirabegron. बिना अल्जाइमर के भी मीरा बैकग्राउंड है, अल्जाइमर के साथ भी मीरा बैकग्राउंड है. बट द क्वेश्चन इज आस्क्ड यूजुअली अबाउट द ओल्डर. 5 साल पहले जब मीरा बैकग्राउंड नहीं थी, एट दैट टाइम among the soft bladder drugs we have to use, and that drug we use was trospium, because trospium has minimum CNS penetration. ट्रोस्पियम सीएनएस पेनिट्रेशन सबसे कम होती है. एंड अगर ट्रोस्पियम भी ना दिया हो तो नेक्स्ट बेस्ट आंसर इज टॉलटिरोडेन. Now, why I am giving this range? Because you do not know कि एग्जामिनर को कितना आता है. ठीक है, कितने साल बाद उसने पढ़ना बंद कर दिया. ठीक है, अगर टोलटिरोडिन बनने के बाद उसने पढ़ना बंद कर दिया तो उसका आंसर टोलटिरोडिन देगा. अगर टोलटिरोडिन के बाद उसने थोड़े साल और पढ़ लिया, ट्रोस्पियम आ गया था, तो आंसर ट्रोस्पियम हो जाएगा. अगर वो बिल्कुल अपडेटेड है, फिर आंसर मीरा बैकग्राउंड आ जाएगा. क्लियर? सो इन दिस सीक्वेंस यू नीड टू आंसर. मीरा बैकग्राउंड इज द बेस्ट ड्रग नाउ. अगर मीरा बैकग्राउंड नहीं है दिया ऑप्शन में, नॉर्मली वी यूज ऑक्सीब्यूटानिन, बट इन पेशेंट विद अल्जाइमर्स डिजीज यू मस्ट चूज ट्रोस्पियम. यस बेटा, दिस इज यूरिनरी इनकॉन्टिनेंस ओनली. ओवरएक्टिव ब्लैडर में यूरिनरी इनकॉन्टिनेंस. एडी इज अल्जाइमर डिजीज बेटा. एडी इज अल्जाइमर्स डिजीज. अल्जाइमर डिजीज वी डू नॉट वांट टू ब्लॉक एसिटाइलकोलिन. रिमेंबर, एसिटाइलकोलिन ऑलरेडी लेस है अल्जाइमर डिजीज. क्लियर? Without Alzheimer's, the best is Mira background still. अगर Mira background is not in the option, then oxybutine. Then oxybutine. Clear है? चल. Then simple question asked, what is mechanism of botulinum toxin? So basically what happens, this is the neuron. Acetylcholine is stored here. It will come down, then produce the action. So botulinum toxin inhibit this. बोटुलिनम टॉक्सिन इनहिबिट दिस. सो बोटुलिनम टॉक्सिन बॉटल को पकड़ लेता है, नीचे से बॉटल को पकड़ेगा तो पानी लीक नहीं होगा. ठीक है, तो बोटुलिनम टॉक्सिन इनहिबिट द रिलीज और एक्सोसाइटोसिस ऑफ एसिटाइलकोलिन. ठीक, बोटुलिनम टॉक्सिन इनहिबिट द रिलीज ऑफ एसिटाइलकोलिन. क्लियर? ओके, चलिए. देन कमिंग टू लास्ट थिंग, एंटीकोलिनर्जिक पॉइजनिंग, एट्रोपिन पॉइजनिंग. एट्रोपिन पॉइजनिंग सिम्टम्स यू कैन रिमेंबर फ्रॉम धतूरा, बिकॉज एट्रोपिन इज ऑब्टेन फ्रॉम धतूरा. So remember, atropine poisoning or dhatura poisoning or belladonna poisoning are same thing, or anticholinergic poisoning, all are same thing. ये सब एक ही बात है. ठीक. So D for dryness, dry eyes, dry mouth, dry skin. Delirium, dilated pupil. H for hyperthermia. This is the most important symptom you need to remember. Commonly they confuse by giving hypothermia. So which is not seen in dhatura poisoning or atropine poisoning? Answer is hypothermia is not seen. Hyper is seen. A is agitation. The person is usually agitated, aggressive. T is tachycardia. Tachycardia. UR is urinary retention. Urinary retention. And A means accommodation is lost, which lead to blurred vision. Person cannot accommodate, vision will be blurred. So these are symptoms of atropine poisoning, and the drug of choice in atropine poisoning is physostigmine. Physostigmine is a drug of choice for atropine poisoning. Antidote, yes, drug of choice or antidote is same thing. In any poisoning, if we use to treat something, that is antidote. So antidote for atropine poisoning is physostigmine. Okay, चलिए लास्ट स्लाइड का स्क्रीनशॉट ले लो और प्रीवियस वाला. फाइजो और पेरिडो में कंफ्यूजन क्यों होता है बेटा? फाइजो तो मैंने आपको सिखाया था ना. फाइजो, फाइजो में SO आ गया, मींस इट इज लिपिड सॉल्युबल. फाइजो इज सॉल्युबल, लिपिड सॉल्युबल है. ठीक है, लिपिड सॉल्युबल वाले में हम फाइजो ही यूज करते हैं सर, बाकी नियोस्टिग्मिन पाइरिडोस्टिग्मिन आप सेम ग्रुप। ठीक है, क्लियर, चलिए। So that is about the cholinergic system. Now coming to adrenergic system or sympathetic drugs. So important sympathetic drugs you need to remember: adrenaline, noradrenaline, isoprenaline, dopamine, and dopamine. So adrenaline we commonly write A, noradrenaline we write Na, noradrenaline. Isoprenaline तो iso ही लिखते हैं, डोपामिन को मैं Da लिखता हूँ, डोपाम, एंड डो ब्यूटामिन तो पूरा डो ब्यूटामिन ही लिखते हैं। नाउ adrenaline A for all the receptors, it stimulate all the receptors. And the important receptors we have are alpha 1, alpha 2, beta 1, beta 2. चार मेन रिसेप्टर्स, तो adrenaline stimulate all of them. And adrenaline is a drug of choice in two conditions: one, anaphylactic shock; second, cardiac arrest. Anaphylactic shock and cardiac arrest. And in both cases, they ask what is the route of administration and what is the concentration used. For anaphylactic shock, we use intramuscular 1:1000. Whereas for cardiac arrest, we use intravenous 1:10,000. जब भी आईवी देते हैं तो 10,000 या उससे ज्यादा डाइल्यूटेड ही देंगे, उससे कम नहीं देंगे। सो एनाफाइलेक्टिक शॉक 1:1000, कार्डियक अरेस्ट 1:10,000। बेटा जब भी आईवी देना, जस्ट रिमेंबर आईवी वी हैव टू गिव डाइल्यूटेड, क्योंकि अगर आईवी देंगे सीधा हार्ट में जाएगा, हार्ट में हाई कंसेंट्रेशन चली जाएगी तो अरिथमिया कर देगा। ठीक है, तो आईवी इज ऑलवेज डाइल्यूटेड, इंट्राकार्डियक भी नेवर गिव। देन कमिंग टू नॉर एड्रेनालिन, इसमें लिखा है नॉट ऑल, सो इट विल स्टिमुलेट अल्फा 1, अल्फा 2, बीटा 1, और सडनली याद आ जाएगा अरे नॉट भी तो लिखा है, तो वी स्टॉप, इट डू नॉट स्टिमुलेट बीटा 2। नॉट ऑल, लास्ट को स्टिमुलेट नहीं करता। ठीक है, अल्फा 1, अल्फा 2 एंड बीटा 1। एंड नॉर एड्रेनालिन इज ड्रग ऑफ चॉइस फॉर सेप्टिक शॉक। ड्रग ऑफ चॉइस फॉर सेप्टिक शॉक इज नॉर एड्रेनालिन। देन आइसोप्रेनालिन स्टिमुलेट ओनली बीटा, बीटा 1 and beta 2, only beta, and it is primarily used in congestive heart failure. It stimulates beta 1, which will stimulate the heart, so used for congestive heart failure, acute CHF, basically acute congestive heart failure, inotropic drug, inotropic drug. Then dopamine stimulate dabba. Dopamine dabba means DBA. It stimulates D1, beta 1 and alpha 1. डोपामिन स्टिमुलेट D1, बीटा 1 एंड अल्फा 1। वी विल डिस्कस इट नेक्स्ट स्लाइड, डोपामिन पे ही है। डोपामिन इज अ ड्रग ऑफ चॉइस फॉर शॉक विद ओलिगोयूरिया। इफ शॉक इज एसोसिएटेड विद रीनल फेलियर, डोपामिन इज अ ड्रग ऑफ चॉइस। ड्रग ऑफ चॉइस फॉर शॉक विद ओलिगोयूरिया इज डोपामिन। लास्टली डो ब्यूटामिन स्टिमुलेट ओनली बीटा, एंड इट इज अगेन यूज्ड फॉर acute CHF, acute CHF. Clear? So these are the main drugs and their uses which are asked in the exams. Clear? Is it clear? If you want to take screenshot, ले लो, इस पे क्वेश्चंस आते हैं। Okay. Now coming to dopamine. We know dopamine stimulate DABA, DBA, DABA, all one, D1, beta 1, alpha 1. Now what is important is the dose. This is in this sequence. For stimulating D1 we use low dose. For beta 1 we use intermediate dose. And for alpha 1 we use high dose. If we remember for beta 1 other you can automatically remember the dose for beta 1 is 2 to 10 microgram per kg body weight per minute. That means less than 2 means 1 to 2 is D1. More than 10, that means anything more than 10, usually 10 to 20 or even 30, 40, 50 कितना भी कर सकते हैं, more than 10 कर लो। ठीक है, more than 10 is alpha 1. Clear? Now D1 is mainly causing renal vasodilation, so it is called as a renal dose of dopamine. Beta 1 stimulate the heart, so it is called as cardiac dose of dopamine, or simply inotropic dose of dopamine, inotropic dose. And alpha 1 cause vasoconstriction, so it is known as vasopressor dose of dopamine. So dose पे क्वेश्चन आता है, you need to remember. Clear? So D1 cause renal vasodilation, beta 1 stimulate heart, and alpha 1 cause vasoconstriction. Okay, so these are the dopamine doses which are important. Next is alpha blockers. Alpha blocker, cheese reaction. We know cheese reaction occur. Cheese contains a substance known as a tyramine. Tyramine is present not only in cheese but also in red wine. So if a person is taking cheese or red wine, tyramine person is taking, but this tyramine is metabolized by an enzyme known as MAO, monoamine oxidase. Clear? So if a person is taking MAO inhibitor and that person take cheese or red wine, tyramine cannot be broken. तो tyramine normally GIT में आता है और MAO इसको तोड़ देता है. But if MAO is not working, tyramine is not broken. And if tyramine is not broken, it acts as a sympathetic drug. So it will produce sudden increase in BP, that is known as cheese reaction. So cheese reaction means if a person take cheese or wine and person is also taking MAO inhibitor, person will suddenly develop hypertension. That hypertension is called as cheese reaction, and the drug of choice for cheese reaction is alpha blocker phentolamine. Phentolamine or tolazoline. They are alpha blockers. They are drug of choice for cheese reaction. Phentolamine or tolazoline are drug of choice for cheese reaction. Clear? Second is scorpion sting. Scorpion sting. So basically, there will be history of insect bite. Insect bite. And after insect bite, the person continuously keep on crying due to pain. So very painful, long-term painful condition, that is insect bite with severe pain. Answer is scorpion sting. Diagnosis scorpion sting. So there may be associated features like there may be pulmonary edema, there may be hypertension or even hypotension, anything can be there. There may be priapism. So many things can happen, but most important features are these two. If there is insect bite and long-term pain, person continuously cries in pain, so that is scorpion sting. The drug of choice for scorpion sting is prazosin. Prazosin is drug of choice for scorpion sting. Okay? So do not get confused that in the exam pulmonary edema is given. So prazosin should I give or this or something else? No, answer will be prazosin. Scorpion sting है तो prazosin है, खत्म. सोचना नहीं है, ओवर थिंकिंग नहीं करनी है एग्जाम. ओके, चलो. Next is BPH, benign prostatic hyperplasia. So we have two type of drug. One to decrease symptoms. Person have urinary retention symptoms. And second, to decrease the size of prostate. For treatment of symptoms, we will give alpha blockers. So alpha blockers are of two types. One are called as alpha 1A plus alpha 1B blocker. That means non-selective blocker. Their name end with josin. So drugs like prazosin, terazosin, doxazosin, any drug ending with josin. Their major side effect is they cause postural hypotension. Postural hypotension. We do not want postural hypertension. So we develop the drugs which are selective alpha 1A blocker because alpha 1B is present on the blood vessels. We do not want to block B. So we made alpha 1A blocker, and that drug was tamsulosin. And a new drug in this category is silodosin. So they have now become the drug of choice for BPH. Tamsulosin and silodosin are drug of choice for BPH. Number two, we want to decrease the size of prostate. And size of prostate depend upon dihydrotestosterone. So normally in the body, testosterone is converted to dihydrotestosterone by 5-alpha reductase enzyme. This is causing growth of prostate. So if we inhibit this enzyme, prostate will not grow. And the drug inhibiting this are whose name end with steroid. Steroid. So drugs like finasteride and dutasteride. They are 5-alpha reductase inhibitors and they will decrease the size of prostate. But problem is for decreasing the size, they need to be given for long term. They cannot decrease size in 1 or 2 doses. Usually they are given for 6 months, minimum 6 months. They are very slow acting basically, slow acting drugs. And another important use of these drugs is they are also used for androgenital alopecia. मेल पैटर्न हेयर लॉस में भी यूज करते हैं, एलोपेशिया में भी. So they can be used for alopecia, they can be used for BPH, but they are slow acting. So that is about the BPH, benign prostatic hyperplasia. Side effect is important. Their major side effect is reversible important. Male features कम हो जाएंगे, फीमेल फीचर्स बढ़ जाएंगे. बेसिकली टेस्टोस्टेरोन इज रिड्यूस्ड. So that was alpha blockers. Yes, gynecomastia can occur. देन कमिंग टू बेटा बोथ ड्रग्स यूज्ड इन एलोपेशिया, नो बेटा इसको एलोपेशिया में कैसे यूज करोगे? टैमसोलोसिन का क्या रोल होगा एलोपेशिया में? नहीं होगा ना। एलोपेशिया इज बिकॉज ऑफ टेस्टोस्टेरोन, ठीक है। टेस्टोस्टेरोन ज्यादा होने के कारण एलोपेशिया होते हैं, इसलिए इनको देंगे हम एलोपेशिया में 5 अल्फा रिडक्टेज इनहिबिटर्स, नॉट टैमसोलोसिन, ठीक है। इज इट क्लियर? चलो, नाउ कमिंग टू बीटा ब्लॉकर्स. Beta blockers may be beta 1 blockers, may be non-selective. So remembering about cardioselective or beta 1 blockers. So these are remembered as new beta blockers. Act exclusively at myocardium. New beta blockers act exclusively at myocardium. New is nebivolol. Beta is bitoxolol. B is bisoprolol. AC is acebutolol. E is esmolol. AT is atenolol. M is metoprolol. And C is celiprolol. So these are the main cardioselective beta blockers. They block only beta 1 receptors, not beta 2 receptor. So what is the advantage? They are relatively safe in which patient? Relatively safe in asthma, diabetes, and peripheral vascular disease. They are relatively safe in asthma, diabetes, and peripheral vascular disease. Yes, Harshvardhan, testosterone increase होता है, but it cannot produce action because DHT is not there. ठीक, तो asthma, diabetes, and peripheral vascular disease, the risk is less. Clear? So that is about cardioselective. Any other drug ending with LOL will be non-selective. बाकी कोई भी दवाई जो LOL में खत्म हो वो non-selective. Clear? Now coming to shortest and longest acting beta blocker. Shortest acting beta blocker now latest is Landiolol. It is shortest acting, but it is unlikely to be asked in the exam क्योंकि वो न्यू ड्रग है. प्रीवियसली द शॉर्टेस्ट एक्टिंग वाज एस्मोलोल, तो आपको एस्मोलोल ही याद करना है क्योंकि एग्जाम में क्वेश्चन इसी पे आए. ठीक है. वेयर एज लॉन्गेस्ट एक्टिंग बीटा ब्लॉकर इज नेडोलो. रिमेंबर, नाड़ा लंबा होता है तो नेडोलो लॉन्ग एक्टिंग, नाड़ा लंबा होता है नेडोलो लॉन्ग एक्टिंग. क्लियर? क्लियर? चलो, then coming to uses and side effects of beta blockers. Indications of beta blockers, there may be cardiac indications, there may be non-cardiac indications. Cardiac indication, you name any disease in heart, they are used. Like beta blockers are used in hypertension, they are used in angina, they are used in myocardial infarction, they are used in congestive heart failure, they are used in arrhythmias. So everywhere we can use beta blockers. Heart की सब बीमारियों में use कर सकते हैं. Where are non-cardiac indications, we remember them as play the game. Play the game. Okay? So P means performance anxiety. Performance anxiety. TH means thyrotoxicosis. G means glaucoma. A means akathisia. M means migraine prophylaxis, prevention of migraine. And E means essential tremors. Essential tremors. So cardiac and non-cardiac users of beta blockers. For non-cardiac users, all of them, the drug of choice is propranolol. Propranolol. Except glaucoma, where we use timolol. In glaucoma, we use timolol. All other cases, we use propranolol. Clear? Then contraindications are very easy. Contraindications of beta blockers are remembered as A, B, C, D. Contraindications are A, B, C, D. A for asthma and COPD. B for bradycardia. Bradycardia. C for CHF when it is acute. Acute CHF we will not like to block beta. And D for diabetes mellitus. Contraindications are A, B, C, D. A, B, C, D. Asthma, bradycardia, CHF and diabetes. Peripheral vascular disease भी add कर सकते हो. Yes, you can add peripheral vascular disease. Yes, you can take propranolol usually without any problems. Clear? PVD भी contraindication है बेटा. This is the common, easy to remember. इसलिए किया. ठीक. चलो. Then coming to third generation beta blockers, these are basically alpha plus beta blocker, which block alpha as well as beta. So examples include labetalol and carvedilol. Carvedilol. तो अल्फा और बीटा दोनों को ब्लॉक करके पूरी दुकान बंद करके घूमने जा रहे हैं, इसलिए इनका नाम है ला बेटा कारलेया, हम घूमने जाते हैं। ठीक है, तो ला बेटालॉल कार्बेडेलॉल, दे आर अल्फा प्लस बीटा ब्लॉकर्स। ला बेटालॉल एंड कार्बेडेलॉल आर अल्फा प्लस बीटा ब्लॉकर्स। क्लियर? So that is about third generation beta blockers. Then the last thing in second last thing in ANS is glaucoma. So the drugs used in glaucoma, they may act by decreasing the secretion, or we can say production of aqueous, or they may increase the drainage or outflow of aqueous. Now secretion reducing drugs you can remember as ABCD. ABCD. A for alpha agonist, drug stimulating alpha receptors. So drugs like apraclonidine, bremonidine, dipivefrin. So all of these stimulate alpha receptors. B means beta blockers. Beta blockers like timol. C means carbonic anhydrase inhibitors. Drugs whose name end with zolamide, like acetazolamide, dorzolamide like drugs. And D means diuretic. The only diuretic we use is mannitol. So ABCD decrease the production of aqueous. ABCD decrease the production. Now, outflow is of two types. It may be trabecular, which is the normal drain present in the eye, and second is uveoscleral, which is the emergency drain present in the eye. Trabecular outflow is increased by meiotic drugs like pilocarpine like drugs. And second, it is increased by a new drug called as nitarsudil. नेताजी का काम है नाली खुलवाना हमारी, तो जो नॉर्मल नाली है उसको खुलवाने का काम नेताजी का है, निटारसुडिल। Whereas uveoscleral is a special pathway, emergency pathway. It is opened by prostaglandin F2 alpha. क्लियर? तो जब हम पीजी बन जाते हैं तो हम स्पेशल हो जाते हैं, तो स्पेशल पाथवे ओपन्ड बाय स्पेशल पीपल, पीजीज। सो द ड्रग इज लेटानोप्रोस्ट, लेटानोप्रोस्ट। So these are the mechanisms of anti-glaucoma drugs. Clear? Now coming to side effects of anti-glaucoma drugs. If you want to take screenshot, you can take. ठीक, चलिए साइड इफेक्ट्स। एंटी ग्लोकोमा ड्रग के इंपॉर्टेंट साइड इफेक्ट जो है मियोटिक्स, मियोटिक्स कॉज सी मींस कैटरेक्ट एंड एस मींस स्टेनोसिस ऑफ नेसोलैक्राइमल डक्ट। एप्राक्लोनिडिन कॉजेस, एप्राक्लोनिडिन नेम में लिखा है लिड रिट्रैक्शन, एप्राक्लोनिडिन कॉज लिड रिट्रैक्शन। ब्रीमोनिडिन कॉज brain suppression in infants, so it causes apnea in newborn babies. Apnea in infants is caused by bremonidine. Then we have prostaglandin F2 alpha, PGF2 alpha. So P for pigmentation of iris, G for growth of eyelashes, and F means fluid in macula, that means macular edema, macular edema. And plus prostaglandin cause inflammation, so they are contraindication in uveitis. Glaucoma with uveitis, prostaglandins are contraindicated. Glaucoma with uveitis, prostaglandins are contraindicated. And lastly in nitarsudil, नेताजी है, नाली खुलवाने के लिए बुलाया था बट काम तो करेंगे नहीं, गोल गोल घुमाते रहेंगे। सो दे आर कॉजिंग वर्ल लाइक ओपेसिटीज इन द कॉर्नी, वर्ल लाइक ओपेसिटीज इन कॉर्नी। और जो ऐसे गोल गोल घुमाता रहे, काम ना करे हमारा, उसको क्या करे, वर्टिकली लटका के मारो उनको, कॉर्निया वर्टिसिलेटा, कॉर्निया वर्टिसिलेटा, कॉर्निया वर्टिसिलेटा और वर्ल लाइक ओपेसिटीज इन द कॉर्निया। क्लियर? सो दैट इज अबाउट एडवर्स इफेक्ट्स। ओके, चलिए क्विकली बीपी के ग्राफ्स देख लो, डायरेक्ट सी एंड आंसर वाले क्वेश्चंस हैं। इफ द बीपी ओनली इंक्रीजेस द ड्रग इज, if BP only increases the drug is noradrenaline. If BP only decreases चलो गाइस, आई एम बैक। देखो ना, देखो ना, देखो ना गाइस, देखो ना गाइस, आई एम बैक। चलो, यस। लोकल आंसर प्रेसिडेंट 1:1 lakh to 1:2 lakh, you are absolutely right. चलिए, so the next topic we are going to do is autoquotes. In autoquotes, the first and the most important thing is gout. Gout may be acute, it may be chronic. In acute gout, there is pain and inflammation of the joints because uric acid get deposited in them. So the drug of choice for acute gout is NSAIDs, non-steroidal anti-inflammatory drugs. Any NSAID can be used except paracetamol or aspirin. Paracetamol not effective, whereas aspirin cause hyperuricemia. All other NSAID can be used, and if NSAIDs are not effective, we can use colchicine. Colchicine is most effective drug for acute gout. Most effective drug for acute gout, but we commonly do not use because of the side effects of diarrhea and myopathy. Because of diarrhea and myopathy, we do not prefer colchicine. Clear? And colchicine mechanism is it inhibit chemotaxis. It inhibit chemotaxis. Then chronic gout. Here uric acid is high, so we need to decrease uric acid. The aim is to decrease uric acid. And uric acid we can decrease by three methods. Number one, we can increase the excretion of uric acid. The drugs are called as uricose uric agents. Uricose uric agents. Examples like probenecid, sulfenpyrazone, lazinurad-like drugs. These increase the excretion, uricose uric agents. Second, we can decrease the production of uric acid. Now, how uric acid is produced? Uric acid is produced from purines and proteins. They are converted to xanthin, and xanthin is converted to uric acid via xanthin oxidase. So if we inhibit this enzyme, uric acid will not be produced. Xanthin oxidase inhibitors we can use. And the drug inhibiting xanthin oxidase is allopurinol. And a new drug called as febuxostat. Febuxostat. Allopurinol and febuxostat, the name says xanthin oxidase static. Allopurinol is normally the drug of choice for chronic gout. Chronic gout. Okay. Now, lastly, we can further metabolize uric acid. Uric acid is metabolized to form allantoin, which is water soluble and excreted by kidney. And this is done by an enzyme called as uric acid oxidase. The other name of this is uricase. Uric acid oxidase or uricase enzyme. So we can use this drug. So this drug will act by increasing the metabolism of uric acid. And the drug which increase the metabolism is rasburicase. Rasburicase. Another drug in same category is pegloticase. So this is saying full name uricase. This is also saying icase means uricase. The problem with these drugs, although they are highly effective, but they need to be given by IV route. They are not effective orally. So they are not used routinely. So they are primarily used for tumor lysis syndrome. They are fastest acting uric acid lowering agent in tumor lysis syndrome. These are used for tumor lysis syndrome. जिस भी दवाई के नाम में पैग हो, पैग लगा के दवाई तो लंबा चलेगी. पैग लगा के दवाई लंबा चलेगी. Clear? तो it is longer acting. Yeah? So that is about the drugs used in gout. Clear? Then second important topic is rheumatoid arthritis. As the name tells, there is itis means inflammation of joints. So for acute inflammation, we can give NSAIDs. And if they are not working, we can give steroids. So these are for symptom relief. But we want to stop the joint degeneration. We want to stop the progression of disease. So the drugs which stop the progression are called as disease modifying anti-rheumatoid drugs. And because all of them are very slow acting, so the new name is slow acting anti-rheumatoid drugs. Slow acting anti-rheumatoid drugs. So here we have classical drugs which are normally used drugs. Classical DMARDs or traditional DMARDs, these are remembered as cute and pugly Malika Sharawat. Traditional DMARDs are remembered as cute and pugly Malika Sharawat. So C stands for chloroquine. Chloroquine. P is penicillamine. A is azathioprine. G are gold salts. L is leflunomide. I is inhibitors of Janus kinase. M is methotrexate. And S is sulfasalazine. So first thing you need to remember the name of all of them. Now important point regarding them. Chloroquine main problem is it cause eye problems. It cause corneal opacity and retinopathy. Cause corneal opacity and retinopathy. But it is safe in pregnancy. So it is DMARD of choice in pregnancy. DMARD of choice in pregnancy is chloroquine. Main side effect are eye problems. Methotrexate is overall drug of choice for rheumatoid arthritis. It requires LFT monitoring. LFT monitoring is required with methotrexate. Required LFT monitoring. Then JAK inhibitors, their name end with citinib. We have tofacitinib and baricitinib. Citinibs are JAK inhibitors. Citinibs are JAK inhibitors. Then second type of DMARDs are those which are biological DMARD. Biological DMARDs. So they basically target either interleukin 1 or interleukin 6 or TNF alpha. The drug stopping them. The drug which is interleukin 1 receptor antagonist is anakinra. Anakinra. The name says kin means interleukin receptor antagonist. A means 1. Interleukin 1 receptor antagonist. Interleukin 6 monoclonal antibody against interleukin 6 receptor is sarilumab. Sarilumab. Again, sarilumab says it is a monoclonal antibody against interleukin 6. S means 6. Used for RA means rheumatoid arthritis. Another similar drug is tocilizumab. Tocilizumab and sarilumab are of same category. Then TNF alpha blockers, you need to remember the names. They are remembered as AC inhibitor को गोली मारो. AC inhibitor को गोली मारो. तो A for adalimumab. Adalimumab. C for sertolizumab. Sertolizumab. E for etanercept. Etanercept. In for infliximab. And G goli for golimumab. These are TNF alpha blockers. TNF alpha blockers used in rheumatoid arthritis. Yeah? So these are the important drugs used for rheumatoid arthritis. Please take the screenshot. Sorry, important. Okay. Next is migraine. For acute attack of migraine, when the person is having unilateral pulsatile headache, the drug of choice is NSAIDs. NSAIDs are drug of choice. But if it is not controlled by NSAID, then it is called as severe migraine. The drug of choice for acute severe migraine are triptans now. Triptans now. Previously, it was ergotamine. So now it has become triptans. Triptans are now the drug of choice for acute severe migraine. On the other hand, if the question is a drug of choice for prophylaxis of migraine, the answer is propranolol. Propranolol is drug of choice for prophylaxis, but drug of choice for treatment is triptans. Now, problem is both triptans and ergotamine, they act by stimulating 5-HT1B1D receptors. And this receptor is present in the blood vessels, which can result in vasoconstriction. So due to vasoconstriction, they can worsen coronary artery spasm. And they can also lead to peripheral gangrene. So they are contraindicated in patient with coronary artery disease. Coronary artery disease, they are contraindicated. So now we have developed some new drugs for. Now what are the special points? Nitrates, particularly nitroglycerin, is a drug of choice for acute attack of angina. By which route? by sublingual route. Nitroglycerin is drug of choice for acute attack of angina by sublingual route. And nitrates are contraindicated with which drug? Nitrate should never be given with which drug? किसके साथ कभी नहीं देना? Yes, with sildenafil like drugs, phosphodiesterase inhibitors, because if we give them together, there will be severe hypotension. Nitrate should never be given with sildenafil like drugs, they result in severe hypotension. Clear? Then second group are calcium channel blockers. Calcium channel blockers we use in angina are verapamil and diltiazem. Verapamil and diltiazem. The major side effect of these drugs is constipation. This is totally different from most of the drugs which cause diarrhea, but verapamil, diltiazem cause constipation as a side effect. Constipation as a side effect. Next is beta blockers. Special point about beta blockers to remember, they are used only for classical angina, but they are contraindicated in variant or prinzmetal angina. Beta blockers are contraindicated in variant or prinzmetal angina. Nicorandil is a drug which acts by dual mechanism. It is NO releaser and it is potassium channel opener. The name says NO releaser and IC if we write together it becomes KO means potassium opener. Potassium opener. Okay. Next drug is trimetazidine. The name says meta. So it acts as a metabolic modulator. Metabolic modulator means it inhibits the fatty acid oxidation. So the heart will start using glucose. Glucose is a better fuel. So heart start using glucose. Ranolazine. Ranolazine is late inward sodium channel inhibitor. Late invert sodium channel inhibitor. The name says La means late, In means invert, Na means sodium. So it is inhibiting the late invert sodium channels. Late invert sodium channels. बेटा दोपहर के 1:23 हुए अमिताभ बच्चन अरे सॉरी माफ किया दादा अमिताभ बच्चन जी हम चाय पी रहे हैं. Last drug is ivabradine. Ivabradine, it is a funny current block. Ivabradine is a funny current block. It acts as a bradycardiac agent. It decreases the heart rate. The major side effect is visual problems like photopsia. Photopsia is the main side effect, visual problem. Okay? So the name says I means IF blocker, funny current blocker. VA means visual acuity problem. Photopsia is the problem. And brady means bradycardiac agent, act by causing bradycardia. Clear? So that is about the important points of anti-anginal drugs. Okay? Yes, phosphodil is a rho kinase inhibitor बेटा. ऐड कर सकते हो phosphodil is a rho kinase inhibitor. Then CHF, which drugs decrease mortality in congestive heart failure? Remember RAS inhibitors, renin angiotensin aldosterone system inhibitors. You need to remember RAS inhibitor decrease mortality. तो renin angiotensin system पहले renin उससे start होता है बीटा से. Beta 1 will secrete renin. So beta blockers. So 3 beta blockers are approved. These are metoprolol, bisoprolol, and carvedilol. So only 3 beta blockers are used in CHF. These are metoprolol, bisoprolol, and carvedilol. Then second drugs will be AC inhibitors. That means any drug ending with prin. Third will be angiotensin receptor blockers. There will be more toxicity. Clear? Then अगर डिजॉक्सिन देंगे तो जो क्वीन है क्वीन की वाट लग जाए. So quinidine, verapamil, amiodarone, thiazide, thromycin, they increase toxicity. And digoxin excreted by kidney, so renal failure में toxicity हो जाए. So that these are the factors increasing toxicity. Now important thing is how to treatment of toxicity. So first is correct interactions. We need to correct these factors. After that, even still, if there are ventricular arrhythmias, the drug of choice is lignocaine. If lignocaine is not able to treat, then it means it is a severe toxicity. So for severe toxicity, drug of choice is digibind. Digibind is drug of choice for severe digoxin toxicity. So basically, it is antibody against digoxin, which will bind digoxin and clear? Digibind. Is it clear? बट इट इज ऑल acute digoxin toxicity. ये एग्जाम में जो क्वेश्चन आता है दैट इज ऑन acute digoxin toxicity only. ठीक है ना? Next question is hypertension in pregnancy. Which drugs are safe for hypertension in pregnancy? So you can remember them as LHMC. Lady Harding Medical College जो है, they are safe. These include Levitalol, Hydralazine, Methyl dopa, and calcium channel blockers like Nifedipine. These drugs are safe for hypertension in pregnancy. Levitalol, LHMC. Okay? But which drugs are absolutely contraindicated? These are prils and sartans. AC inhibitors and ARBs are absolutely contraindicated in pregnancy. AC inhibitors and ARBs are absolutely contraindicated in pregnancy. Clear? Labetalol is usually the drug of choice. Labetalol is drug of choice. Okay? But Arni and Liskirin are not approved in hypertension in pregnancy. They are contraindicated also. Yes, labetalol is safe in pregnancy but contraindicated in asthma. अगर प्रेग्नेंट को एस्थमा है तो उसमें लेबेटालोल नहीं देंगे. ओके, प्राजोसिन इज आल्सो सेफ. मैं जो बता रहा हूं इंपॉर्टेंट जिस पे आने के चांसेस. Amiodarone is an antiarrhythmic drug with the longest half-life. Half-life of amiodarone is more than 3 weeks. And amiodarone has all 4 mechanism of action. That means it is a sodium blocker, it is a beta blocker, it is a potassium blocker, and it is a calcium blocker. All 4 mechanisms are there. Okay? And amiodarone, the main important question asked is on side effects. These are remembered as the periphery of my lung and cornea is photosensitive. So the TH stand for thyroid. It can cause hyper or hypothyroidism. Some people develop hyperthyroidism, some develop hypothyroidism. Periphery means peripheral neuropathy. It can cause peripheral neuropathy. My means myocardial depression. It can cause negative inotropic action. Lung fibrosis. Remember, we remember from drone. It is a vehicle drone. Corneal deposit. It can get deposited in the cornea. And photosensitivity leading to blue man syndrome. Blue man syndrome. So all these are side effects of amiodarone. Amiodarone side effects are commonly asked in the exams. So remember, the periphery of my lung and cornea is photosensitive. Okay. ठीक है. The last topic in CVS are anti-dyslipidemic drugs. Anti-dyslipidemic drugs. The most important being statins. We know statins, their name will end with vastatin. Liver भी add कर लो बेटा, हाँ कर सकते हो. Vastatin. Their name end with vastatin. We have atorvastatin, simvastatin. Beta Redman was vancomycin. Vancomycin. Vastatins. Atorva, simva, pravastatins. Mechanism, they act by inhibiting HMG-CoA reductase, which is the main rate limiting enzyme in formation of cholesterol. Special point, they cause maximum decrease in LDL cholesterol. Maximum decrease in LDL cholesterol. But important, their major side effect being MDH. MDH, asli masale such, myopathy, most important myopathy, diabetes, and hepatotoxicity. They cause myopathy, they cause diabetes, they cause hepatotoxicity. Myopathy, diabetes, and hepatotoxicity. The major side effects. Okay? Then coming to fibrates, the drug containing fibro in the name, like clofibrate, fenofibrate, gemfibrozil. So fiber or fibro is in the name. Mechanism, they act by stimulating PPAR alpha. They stimulate PPAR alpha. And these are the drugs which cause maximum decrease in triglyceride level. Maximum triglyceride is lowered by fibrates. And the major side effect of these drugs is gallstones. Main side effect of fibrates is gallstones. Gallstones. Then coming to ezetimibe. Ezetimibe, it acts by inhibiting the absorption of cholesterol. So it acts in the GIT, it inhibits the absorption of cholesterol. Next is bile acid binding agent. Bile acid binding agent, their name start with choli. Cholestyramine, cholestipol, cholecalciferol. So the name starting with choli means cholelithiasis, cholecystitis, choli means bile. So they are bile acid binding agent. So what is special thing about them? They are drug of choice for dyslipidemia in pregnancy and children. मेंबर जब प्रेगनेंसी है या बच्चे हैं तो उनको दवाई मत दो, बाबा के पास ले जाओ, ठीक है, तो बाबा के पास ले जाते हैं बाबा। देन नायासिन, नायासिन इज सिंपली विटामिन B3, it cause maximum increase in HDL cholesterol. Maximum increase in HDL cholesterol is done by niacin. The most common side effect of niacin are itching and flushing. Itching and flushing. They are most common side effects. But the other side effects which are asked in the exam, they include it cause hyperuricemia and gout. It can also cause insulin resistance, and it can cause liver damage also, hepatotoxicity. Special side effects of niacin. Okay, then दिस इज द इन ड्रग नाउअडेज। बेम्पेडोइक एसिड पढ़ लेना, ये बहुत नई दवाई है, सारे एग्जाम्स में पूछी जा रही है, तो एफएमजी में नहीं पूछी गई आज तक, बट लाइकली दैट इट कैन बी आस्क्ड इन द एफएमजी आल्सो। Bempedoic acid is a drug which is a competitive inhibitor of another enzyme, ATP citrate lyase. This is also involved in formation of cholesterol. कोलेस्ट्रॉल बनाने के लिए सबसे पहले ये एंजाइम काम आता है, फिर बाद में जाके एचएमजी कोए रिडक्टेज काम आता है। So statins also inhibit formation of cholesterol. Bempedoic also inhibit formation of cholesterol. But what is the difference? The difference is bempedoic acid is a pro drug, and it is activated in liver only. Activated in liver, not in muscles. This is the main advantage. ये लिवर में एक्टिवेट होती है बट मसल में नहीं होती, सो दैट मींस इन दी मसल देयर इज नो स्टॉपेज ऑफ कोलेस्ट्रॉल फॉर्मेशन, सो इट विल नॉट कॉज मायोपैथी। दैट इज द मेजर एडवांटेज, इट डू नॉट कॉज मायोपैथी। बेम्पेडोइक एसिड का मेन फायदा यह है कि ये मायोपैथी नहीं करता, सो इट कैन बी यूज्ड विद स्टैटिन्स और विदाउट स्टैटिन्स आल्सो, तो मायोपैथी नहीं करता। मेजर साइड इफेक्ट ऑफ बेम्पेडोइक एसिड इज हाइपरयूरिसीमिया। बेम्पेडोइक एसिड कैन कॉज गाउट, हाइपरयूरिसीमिया कर सकता है। बेटा दोनों ही आंसर आएंगे, अगर दोनों ऑप्शन में होंगे तो दोनों आंसर आएंगे, दोनों ऑप्शन में नहीं देंगे बेटा। एंड लास्टली वी हैव एलिरोकुमैब, विवोलोकुमैब, दीज आर PCSK9 inhibitors. PCSK9 inhibitors, these are injectable drugs because they are monoclonal antibodies, so they are injectable. PCSK9 inhibitors, they are injectable drugs. Clear? So that is about the cardiovascular system also. Okay, स्क्रीनशॉट तो नहीं लेना इसका। All MABs are injectable. Yes, beta. All MABs are injectable. Clear? Next topic is kidney, small topic. We divide the diuretics based on their site of action. Diuretic which work in proximal tubule are called carbonic anhydrase inhibitors. Examples of carbonic anhydrase inhibitors are zolamides, like acetazolam. Acetazolamide is a drug of choice for mountain sickness. It is drug of choice for mountain sickness. Acetazolamide is drug of choice for mountain sickness. Then diuretic working in loop of Henle are called loop diuretics. Example like furosemide like drugs are mainly used for edema. So whenever there is any edema, mostly we prefer furosemide. Furosemide like drugs are mainly used for edema. Then thiazides, they work in distal tubules. Now in the loop of Henle, there is a pump known as sodium potassium 2 chloride pump. Loop diuretic inhibit that. Whereas in the distal tubule, there is sodium chloride pump, thiazide inhibit that. Thiazides are primarily used in hypertension, mainly used for hypertension. Then in the collecting duct, the diuretic working are called potassium sparing diuretic. And we have two type of potassium sparing diuretics. One are epithelial sodium channel blockers, and second are aldosterone antagonists. Epithelial sodium channel blockers include amiloride and triamterene. Whereas aldosterone antagonists include spironolactone and eplerenone. So the name tells they are potassium sparing, means they all can cause hyperkalemia. They retain potassium that can cause hyperkalemia. Now what is important? Difference between spironolactone and eplerenone. Spironolactone causes gynecomastia. Drugs causing gynecomastia, I hope everyone knows. Disco drugs सबको पता है? I hope we don't need to revise. Clear? Digoxin, spironolactone, cimetidine, ketoconazole, estrogens. They cause gynecomastia. Eplerenone do not cause gynecomastia. Now moving to special point regarding these diuretics. Important चीज हमने already कर लिए. Thiazides. Thiazide cause side effects. Both loop and thiazide दोनों के पढ़ लेते हैं. Loop as well as thiazide cause common side effects. They cause loss of all the ions in the urine: sodium, potassium, magnesium, hydrogen. But they retain the metabolic substances like uric acid and glucose and lipids. So they cause hyperuricemia, hyperlipidemia, hyperglycemia. So because thiazide cause hyperuricemia and they are used in hypertension, we have to use for long periods. So they are avoided in patient with gout, with hypertension. अगर किसी को हाइपरटेंशन का गाउट भी हो तो हम उसको थायराइड नहीं दें. Second important thing, only diuretic which are effective in renal failure, are loop diuretics. No other diuretic is effective in renal failure. Among the thiazide, normally they are ineffective in renal failure, like everyone, except one thiazide which is effective is metolazone. Metolazone is the only thiazide which can be used in renal failure. All other thiazides are ineffective in renal failure. Then we discussed all the effects are same, loop and thiazide effect are same. Only difference is on calcium. So you can remember as loop loses calcium. So that means loop diuretic cause hypocalcemia, whereas thiazides cause hypercalcemia. Loop cause hypocalcemia, thiazide cause hypercalcemia. Clear? Then coming to osmotic diuretics. Osmotic diuretics like mannitol. The indications of mannitol, we all know mannitol is drug of choice for cerebral edema. But it is contraindicated when there is cerebral hemorrhage. So it is contraindicated during hemorrhage. It should be given after the bleeding has stopped. Second, apart from cerebral edema, it is drug of choice for acute congestive glaucoma. It is contraindicated. Acute congestive glaucoma, it is contraindicated, and it is contraindicated in acute renal failure. Sorry, तो contraindication आ गया. Acute congestive glaucoma, it is drug of choice. So drug of choice for two main conditions, cerebral edema and acute congestive glaucoma. Whereas contraindication, it is contraindicated in acute renal failure. And it is contraindicated in left ventricular failure or pulmonary edema. Left ventricular failure or pulmonary edema. So these are the important points regarding the mannitol. Clear? Then moving to aldosterone antagonists like spironolactone, eplerenone. इस पे क्वेश्चन आता है very commonly. This question is asked, what are the uses? Clear? They are potassium sparing, so you can remember their uses as cause potassium retention. Cause C means congestive heart failure. Remember, they decrease mortality. Second, Conn syndrome, they are drug of choice. Third, edema in cirrhosis, cirrhotic edema, they are drug of choice. This is the question asked, which diuretic is a drug of choice for cirrhotic edema? The answer is spironolactone-like drugs. Second, hypokalemia. So whenever there is hypokalemia, we can use potassium sparing diuretic. So they will retain potassium and prevent hypokalemia. And another very important, they are drug of choice for resistant hypertension. Clear? So that is important about the aldosterone antagonists. Okay. So that completes our diuretics also. Okay. So next topic is endocrine system. Starting with gonadotropin releasing hormone. We know if we give it pulsatile, it increases gonadotropins. If we give continuously, it will decrease gonadotropin. So we can use them whenever we want to increase gonadotropins, like in case of hypogonadism. We can use them in delayed puberty. So wherever we want to increase, we can use. Similarly, we can use them when we want to decrease, like in case of prostatic cancer, endometriosis, precocious puberty. We can use. So we can use whenever we want to increase or we want to decrease. The manner will be different. Pulsatile to increase and continues to decrease. Now, what are the drugs? Drugs which we use are called GnRH agonists. Their name end with relin, like nafarelin, gozerelin, buzurelin, relins. And one drug which was before these relins, that was leuprolide. leuprolide. So they can be used as pulsatile for increasing and continuously for decreasing. But problem is when we use them for these indications to decrease, at the start of therapy they increase. And when they increase, that result in flare up reaction. The symptom will increase. So to prevent the flare up reaction, what we developed? We developed GnRH antagonist. So what will antagonists do? They will decrease right from the beginning. So their name end with relics. X means cross. Relics. So drugs like cetrorelix, ganirelix, they will decrease right from the beginning. So they do not cause flare up reaction. No flare up. So elagolix is oral, yes. So these are the important differences between GnRH agonist and antagonist. Okay. Then coming to one very important thing, acromegaly. Acromegaly we can treat by either, acromegaly is basically due to excessive growth hormone. So for treatment, either we can decrease the secretion of growth hormone or we can give growth hormone receptor blocker. Two type of drugs we can use. Drugs which decrease growth hormone, they are of two types. They can be oral, they can be injected. The oral drug are cabergoline and bromocriptine. Whereas injectable drug is somatostatin analog, that is octreotide. On the other hand, receptor blocker is also injectable, and this is pegvisomant. It is a long acting. Peg means long acting. Somant is somatotropin antagonist, growth hormone antagonist. So among them, the drug of choice is octreotide. Octreotide is a drug of choice. Octreotide is a drug of choice for acromegaly. Okay. Now next endocrine gland is, yes, cabergoline can be used for stopping the lactation, not lactating women when we want to stop lactation. Okay. Then coming to thyroid. So there may be hyperthyroidism, there may be hypothyroidism. Drug of choice for every patient of hypothyroidism is L-thyroxine. L-thyroxine is always started at low dose, usually 25 microgram, and then gradually increased. Okay? Started at low dose, then gradually increase. And remember, यहाँ पे पूजा होता सबके साथ. They ask the question, what is the drug of choice for hypothyroidism in first trimester of pregnancy? And every student close their eyes and mark PTU as the answer. Remember, PTU is for hyper, not for hypo. तो इसलिए ध्यान रखना है हाइपो पूछ रहे हैं या हाइपर पूछ रहे हैं. PTU is only in case of hyperthyroidism. Now in hyperthyroidism, the drug of choice is carbimazole or methimazole. They are normally drug of choice. But in first trimester, the drug of choice is PTU. PTU पहले ट्राइमेस्टर में यूज करना है, बट कहां यूज करना है? हाइपरथायरॉइडिज्म में, हाइपो में नहीं करना. तो पहले ट्राइमेस्टर में यूज करना है किसमें? व्हेन द फीमेल हैज हाइपरथायरॉइडिज्म. Clear? So that is about thyroid. Then moving to some new anti-diabetic drugs. Among the new anti-diabetic drugs, the most important being SGLT2 inhibitors. This is our kidney. Glucose is freely filtered by the glomerulus, but almost 100% of glucose is reabsorbed with the help of sodium and glucose pump known as SGLT. Sodium glucose transporter 2, SGLT2. It helps in reabsorption of 100% of the glucose. So if a drug inhibits this pump, glucose will not be reabsorbed. So when glucose is not reabsorbed, it will be excreted in the urine. So when glucose is excreted in the urine, the blood glucose will decrease. Clear? So these drugs act by causing glucoseuria. And because glucose come in the urine, so what will be the most common side effect of these drugs? Urogenital infections. Urogenital infection is very common with these drugs. And name of the drugs end with gliflozin. Like canagliflozin, dapagliflozin, empagliflozin, ertugliflozin. Drugs ending with gliflozin. And all the important things you can remember, just write urine at the end. It will become clear. So what they are saying, glucose flows in urine. So glucose will flow in the urine. Okay? So these are the main points. Now, what is the main advantage of these drugs? Advantage. Number one, they can cause weight loss because sodium glucose is lost in the urine. Weight loss can occur. Number two, they do not cause hypoglycemia. They do not cause hypoglycemia as a side effect. Number three, these drugs are very good for patient with heart and kidney disease. So these are having very good action for heart and kidney, cardioprotective and renoprotective, and they are separately approved for CHF also. Remember we discussed earlier, they can decrease mortality in CHF also. So they are very good drug for heart and kidney problems. Okay? So these are the special points about SGLT2 inhibitors. Okay. Then second type of new antidiabetic drugs, they include incretins. Incretins are the normal substances produced by GIT which secrete insulin. So when we take food, GLP-1, incretins like GLP-1 is secreted, that will stimulate the secretion of insulin so that blood glucose do not rise. Okay? Now GLP-1 after some time is metabolized by an enzyme called as DPP4. So in diabetic patient, we want to increase insulin. So what we do, we can give GLP-1 from outside. So drugs like exenatide. Exenatide was the first drug in this group. After that, we formed many drugs. We kept the name as glutides. Drugs ending with glutides like liraglutide, semaglutide, LB-glutide. So many glutides are there. Glutide means glucose lowering peptides. Tide, any drug ending with tide means peptide cannot be given orally. Clear? So we can give glutides. They are injectable drugs. But second thing we can do is we can inhibit DPP4. And the drug inhibiting DPP4 are gliptins. And gliptins are oral. So gliptins like sitagliptin, vildagliptin, alogliptin, linagliptin, sexagliptin. So these are oral drugs, these are injectable drugs. The common side effect of all the drugs is pancreatitis. All incretins can cause pancreatitis as a side effect. Pancreatitis is a side effect of all the incretins. Now, GLP analogs are also used for obesity. Not only for diabetes, they are also approved in obesity. GLP analogs are also approved in obesity. But the DPP4 inhibitors are all oral, whereas analogs, their name end with tide. GLP एनालॉग तो पेप्टाइड है ना, पेप्टाइड का नाम टाइड में ही खत्म होगा. पेप्टाइड का नेम टाइड में खत्म होगा. Okay, so gliptins are oral drugs. Now, what is important about gliptins to remember? Linagliptin is the only gliptin which is safe in renal failure. Safe in renal failure. Remember, अगर किडनी फेल हो जाए तो भी लेना है, इसलिए लेना ग्लिप्टिन है. लेना ग्लिप्टिन को तो लेना ही लेना है. Second, sexagliptin shows drug interactions. It is metabolized by CYP3A4. So it shows lot of drug interactions. Okay? So we discussed how we remembered कि अगर इंटरेक्ट करेंगे लोगों से तभी तो सेक्स मिलेगा ना. तो sexagliptin cause drug interaction. Sexagliptin cause drug interactions. Clear? So this is about incretins. Incretins. Okay. So second group of drugs are incretin-like drugs. Then moving to side effects of antidiabetic drugs. Side effect of antidiabetic drugs are commonly asked. Most important drug is metformin, which is a drug of choice for type 2 diabetes. So metformin, it causes unexplained diarrhea as a side effect. Unexplained diarrhea. Apart from that, it causes megaloblastic anemia. And it can cause lactic acidosis. Lactic acidosis. Three main side effects of metformin: unexplained diarrhea, megaloblastic anemia, and lactic acidosis. Sulfonylureas like glipizide. Example like glipizide. All drugs starting from gli are sulfonylureas. Their major side effect is hypoglycemia. Any drug ending with ide will cause hypoglycemia. जिसका नाम ide में खत्म होता है वो hypoglycemia करती है. Okay? So they can cause hypoglycemia. Glitazones like rosiglitazone, pioglitazone. Their main side effect is liver damage. So we need to monitor the liver function test. Hepatotoxicity. They retain sodium and water. So they are contraindicated in patient with CHF, hypertension, etc., where retaining sodium and water is harmful. And they can cause fractures. Osteoporotic fractures are seen with glitazones. Glitazones can cause fractures. Then individually, rosiglitazone, rosi को देख के दिल में दर्द होता है तो it can cause MI. Rosiglitazone can cause MI. एंड पायोग्लिटाजोन इट कॉज यूरिनरी ब्लैडर कार्सिनोमा। जब पानी पियोगे तो ब्लैडर में जाएगा, कैंसर करेगा। पायोग्लिटाजोन कॉज ब्लैडर कार्सिनोमा, ब्लैडर कार्सिनोमा। A carbose is a drug which inhibit absorption of carbohydrates. So most common side effect is flatulence. Most common side effect of a carbose is flatulence. Then incretin mimetic drugs we said all cause pancreatitis. Pancreatitis. And SGLT2 inhibitors cause urogenital infections. Urogenital infections. Clear? So EDR of antidiabetic drugs are asked in the exams. इनको मत भूलना. Okay? चलिए. Next is osteoporosis. Osteoporosis. So three type of drugs can be used. One which stimulate osteoblast. We have only one drug which stimulate osteoblast, and that is teriparatide. Teriparatide is the only one drug which stimulate osteoblast. And important to remember, it is given for maximum 2 years. T for 2 years. It should not be given for more than 2 years. Because if we give for longer than 2 years, what is the side effect? It causes osteosarcoma. If we give for longer than 2 years, it can cause osteosarcoma. Okay. Then we have drugs which have dual action. That means they will stimulate osteoblast also and inhibit osteoclast also. These are remembered as senior residents. We know senior residents have dual action of teaching the PGs also and seeing the patients also. So these also have dual action. We have strontium ranelate and romosozumab. Romosozumab. So strontium and romosozumab have dual action. Then all other drugs used in osteoporosis are acting by inhibiting osteoclast. बाकी सब osteoclast को inhibit करते हैं. So most important being bisphosphonates. Bisphosphonates. Their name end with the dronate, like alendronate, risedronate. These are drug of choice for osteoporosis. They are drug of choice for osteoporosis, and they can result in esophageal toxicity. They can cause esophageal ulcers. तो esophageal ulcer से बचने के लिए क्या करते हैं? Esophageal ulcer से बचने के लिए क्या करते हैं? The person should take them empty stomach with lot of water and person should not lie down. कम से कम आधे घंटे तक लेटना नहीं. ठीक, आधे घंटे तक कम से कम लेटना नहीं. Second, we can use calcitone. Calcitone. Third, we can use SERMs like raloxifene. Raloxifene. So all of them, they are inhibiting osteoclast. Osteoclast. Okay. So these are the important drugs used in osteoporosis. Now coming to most important, which drugs are used for fetal lung maturation? Fetal lung maturation, two drugs, either dexamethasone or betamethasone are indicated. Both are given by which route? Intramuscular. Both are given intramuscular. What is the dose of dexamethasone? Dexamethasone is given as a dose of 6 milligram, 12 hourly, total 4 doses. Whereas betamethasone is 12 milligram, 24 hourly, 2 doses. I hope you know D means 4 and B means 2. And total dose is 24. So 6 4s are 12 2s are. Total duration is 48. 12 4s are 24 2s. Okay. I hope you remember कि doses कैसे याद करनी है. Okay. Then coming to SCRM, selective estrogen receptor modulators, mainly tamoxifen and raloxifene difference. Remember, tamoxifen is mainly used for breast cancer and it is used for osteoporosis. Osteoporosis. Okay. So these have same action at some organs, only one difference. In the bone, both increase formation of bone. So that means both inhibit osteoclast. Both inhibit osteoclast. Both are good for bone. Both are increasing HDL in the blood. Both are increasing HDL, same action. Both are decreasing breast cancer. Tamoxifen is more effective, so it is preferred. This is the difference. In endometrium, tamoxifen increase the risk of endometrial cancer, whereas raloxifene decrease the risk of endometrial cancer. That is the main difference. In the liver, both increasing clotting factor, so both increase risk of thromboembolism. Both increase risk of thromboembolism. The major difference is on endometrial cancer. Tamoxifen increase, raloxifene decrease. Tamoxifen is a drug of choice for pre-menopausal breast cancer. So pre-menopausal breast cancer, drug of choice is tamoxifen. Post-menopausal में drug of choice is post-menopausal breast cancer, drug of choice is anastrozole. Anastrozole. Pre-menopausal it is tamoxifen. Clear? लास्टली ओरल कॉन्ट्रासेप्टिव. आई होप एवरीवन नोज दी स्टोरी. हीरो हीरोइन की स्टोरी जो ओयो रूम में जाके बंद हो गए थे, वो सब याद है ना सबको? क्लियर? सो हम जालिम दुनिया वाले हैं. वी वांट टू स्टॉप इन दोनों के प्यार कहानी को रोकना चाहते हैं. सो व्हाट आर द मैकेनिज्म्स? नंबर वन, वी कैन इनहिबिट ओवुलेशन. घर से निकलना बंद कर दिए. नंबर टू, वी कैन डिक्रीज फेलोपियन ट्यूब मोटिलिटी. सहेलियों को रोक दिया उसकी हेल्प करने से. नंबर थ्री, हमने गुंडे भेज दिए. मेक सर्वाइकल म्यूकस थिक एंड हॉस्टाइल. अगर सबके बावजूद भी मिल गए तो हमने ऑनर किलिंग कर दिया. इनहिबिट इम्प्लांटेशन. So four main mechanisms of oral contraceptives. Now, adverse effect of oral contraceptives. So you need to mainly remember the serious or adverse effect of oral contraceptives, which are remembered as four C's. Four C's. So first important C is this cardiovascular. It causes thromboembolism. So they can result in DVT, pulmonary embolism, MI, all of these can occur. Second, in the CNS, the main problem is depression. 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 Third C is cholestatic jaundice. Cholestatic jaundice. And fourth C is cancer. Now, which cancer risk is increased by OCP, which is decreased? Mainly increased risk is with breast cancer and cervical cancer, whereas decreased risk is CO, colorectal cancer, endometrial cancer, and ovarian cancer. Okay? And I hope you remember कैसे याद करना है. डायफ्राम से बॉडी को दो पार्ट में डिवाइड कर दो. इसके ऊपर के कैंसर ऊपर, नीचे के नीचे. ठीक है? डायफ्राम से ऊपर ब्रेस्ट आता है, ब्रेस्ट कैंसर का रिस्क बढ़ गया. उससे ऊपर सर्वाइकल आता है, ऑब्वियसली इसकी बात नहीं कर रहा. सर्वाइकल कैंसर, दैट मींस सर्विक्स के कैंसर का रिस्क इंक्रीज हो जाता है. बिलो द डायफ्राम वी हैव कॉलन, एंडोमेट्रियम, ओवरी सब नीचे हैं. देयर कैंसर रिस्क डिक्रीजेस. क्लियर? ऊपर वाले ऊपर, नीचे वाले नीचे. So that is important about oral contraceptives. Then last thing in endocrine system is emergency contraception. Emergency contraception, we can use combined oral contraceptives. That means estrogen progesterone combination. Estrogen progesterone combination that has to be used within 72 hours of unprotected intercourse. Second, we can use levonorgestrel. Levonorgestrel again within 72 hours. Third, we can use mifepristone. Mifepristone again within 72 hours. Then we have developed a new drug which is called as ulipristal. You need to remember 30 milligram single dose. It can be used up to 120 hours. That means if a female is coming after 72 hours, we can still use ulipristal. Ulipristal. Okay. And if the female is coming after 5 days, after 120 hours, usually none is reliable, but still we can use IUC. Intrauterine contraceptive devices we can try, but they are also not reliable. Clear? So that is about emergency contraception. That means we have completed the endocrine system also. Clear? So I'm extremely sorry I was not able to keep track of time and I am giving over board. So, but still 10-15 minutes we'll try to finish. Clear? Next is hematology. Hematopoietic growth factors. So growth factors which will increase the production of blood cells. So RBCs we want to increase in anemia. Anemia. Which anemia? Anemia due to chronic renal failure or anemia due to anti-cancer drugs. Normally RBC growth factor is erythropoietin. Erythropoietin. And the drug which is erythropoietin is darbepoetin. So darbepoetin is used for anemia due to CRF, anemia due to anti-cancer drugs. Then growth factor for WBCs are GCSF and GMCSF. So they will be used for leukopenia due to anti-cancer drugs. Leukopenia due to anti-cancer drugs. And the drug either end with grastim or gramostim. Grastim is GCSF, gramostim is GMCSF. So drugs like filgrastim or sargramostim, they can be used for leukopenia. Then platelet growth factor is interleukin 11. So it is used for thrombocytopenia. Thrombocytopenia. Again due to anti-cancer drugs. And the drug is oprelvecin. Oprelvecin. Oprelvecin, we know it is kin means interleukin. And if we remove the key, it becomes 11. 11. So oprelvicin is used for interleukin 11, that means for thrombocytopenia. So these are hematopoietic growth factors, and all of them are given subcutaneously. All drugs are given subcutaneously. Okay. Then moving to antiplatelet drugs. So platelet aggregation, it requires thromboxane A2 and adenosine diphosphate, ADP. Where is ADP? Yes, thromboxane A2 or ADP or thrombin. Three important substances. They will result in platelet aggregation finally by stimulating GP2B3. So if we inhibit any of them, we can use the drug as antiplatelet. So antiplatelet drug will be either decreasing thromboxane A2 or blocking ADP receptors or blocking thrombin receptors or blocking the final pathway, that means GP2B3. Thromboxane A2 inhibitor is COX inhibitor aspirin. Aspirin is inhibiting the production of thromboxane A2. ADP inhibitor, the drugs name end with grel, like clopidogrel, prasugrel. Grels inhibit ADP, and grels are irreversible ADP antagonist. Irreversible. So you can remember, जो girls हैं वो आपके दिल को irreversible damage करती है ना, तो ये भी irreversible damage करें. Okay? Then thrombin inhibitor, the receptor of thrombin on the platelets is PAR1, protease activated receptor 1, and the drug inhibiting PAR1, their name end with Pagzar. Protease activated receptor 1 antagonist. नाम में लिखा है Pagzar. So drugs like Etopaxar, Vorapagzar, these are PAR1 antagonists. And lastly, we have 2B3A antagonists. Drugs inhibiting 2B3A are Apixaban, Tirofiban, and Aptifibatide. So they are inhibiting 2B3A. So the name contains B and A together. नाम में B और A एक साथ आ जाएगा, तो 2B3A को इनहिबिट करेंगे. क्लियर? सो एस्पिरिन, A for aspirin, A for aspirin, clopidogrel, D for ADP, PAR1, PAR for Pagzar, and AB for BA. AB for BA. So these are antiplatelet drugs, mainly used for MI or stroke, arterial thrombosis mainly. Clear? So that is antiplatelet drugs. Take this screenshot if you want. Then we can go to anticoagulants. Anticoagulants may be oral anticoagulants or they may be injectable anticoagulants. Oral anticoagulant may be of two types. One which are vitamin K antagonist and second which are new oral anticoagulants. Vitamin A antagonist we all know is warfarin. Apart from warfarin, we have dicumarole. They act by inhibiting vitamin K. Whereas new anticoagulants may be of two types. They may inhibit 10A. They may inhibit thrombin. That means 2A. 10A inhibitors, the name end with Exaban. The name says 10A को ban कर दी. 10A. The drugs like Rivaroxaban, Edoxaban, Apixaban. So any drug ending with Exaban is 10A blocker. 10A blocker. Similarly, 2A blocker is only one drug. It is called as Dabigatran. Dabigatran, the name says thrombin antagonist, which is taken like दारू. जैसे दारू पीते हैं ना, oral. So thrombin antagonist जो oral लेते हैं. Okay. Then injectable anticoagulants, they are mainly heparin. They may be indirect thrombin inhibitors. All injectable are thrombin inhibitors. They may be indirect or they may be direct. Indirect thrombin inhibitors are drugs like heparins. And direct thrombin inhibitors are drugs like lepirudin, argatroban. They are direct. Okay. So these are the classification of anticoagulant drugs. Anticoagulant drugs. Okay. Now, but MCQ asks difference between warfarin and heparin. So if this is warfarin, this is heparin. Route of administration, warfarin is oral, heparin is subcutaneous or IV. Mechanism, warfarin act by inhibiting vitamin K, heparin activate antithrombin, which inhibit thrombin. Onset of action, warfarin action takes 4 to 5 days. Its action starts immediately. So warfarin is used for maintenance because slow acting. It is used for acute cases because fast acting. Pregnancy, warfarin is contraindicated. Heparins are drug of choice. Monitoring, warfarin is monitored by prothrombin time or INR, and heparin is monitored by APTT. APTT. And lastly, antidote. Warfarin we have vitamin K, and heparin we have protamine sulfate. Protamine sulfate. Clear? So that is about difference between warfarin and heparin. And quickly tell me, what is the target INR after giving warfarin? Normal INR is 1. Okay? After giving warfarin, the INR should be 2 to 3 for most of the indications. वारफरिन देने के बाद सब 2 से 3 के बीच में होना चाहिए, लाइक वीनस थ्रोम्बोएम्बोलिज्म, एट्रियल फिब्रिलेशन, एंटीफॉस्फोलिपिड एंटीबॉडी सिंड्रोम. Remember, everywhere it is 2 to 3. Only one condition where it is 2.5 to 3.5 is mechanical heart valves. Mechanical heart valves में 2.5 से 3.5 होना चाहिए, बाकी सब जगह पे 2 to 3 है. ठीक, mechanical heart valves 2.5 to 3.5. Everywhere else it is 2 to 3. क्लियर? प्रीवियस स्लाइड देख लो भाई, स्क्रीनशॉट ले लो जल्दी से. ओके बेटा, लेस देन 1.5 का मतलब है कि देर इज नो एंटीकोगुलेंट एक्शन. एंटीकोगुलेंट एक्शन नहीं आया तो सर्जरी से पहले हमें एंटीकोगुलेंट एक्शन नहीं चाहिए. सो वी विल स्टॉप सच दैट 1.5 से नीचे आ जाए, नीचे आ जाए. ओके, तो सर्जरी में ब्लीडिंग नहीं चाहते ना. ओके, चलिए. लास्ट इज थ्रोम्बोलिटिक्स. Thrombolytic drugs are nothing but tissue plasminogen activators. They will activate the plasminogen to form plasmin. So the important drugs are remembered as Surat. These are streptokinase, urokinase, retiplase, altiplase, and tenecteplase. These are used for acute MI, acute stroke, or even acute deep vein thrombosis. Overdose of these will lead to bleeding. Side effect is bleeding. And the antidote for them is EACA, epsilon aminocaproic acid, epsilon aminocaproic acid, or tranexamic acid. Tranexamic acid. EACA and tranexamic acid, these are the antidote of fibrinolytics. Epsilon aminocaproic acid or tranexamic acid are antidote for fibrinolytics. Clear? Thrombolytics. So that is important about the hematology. In the respiratory system, the most important topic is asthma. And we all know asthma is type 1 hypersensitivity reaction. So IgE antibodies produced and bind to this. So whenever antigen comes, it will bind to IgE antibody, leading to release breakdown of mast cell which contain leukotrienes. Mast cell are liberated, they will cause bronchoconstriction. Yeah? So the drugs used in asthma may be bronchodilators. Bronchodilators. And we know bronchodilators are of 3 main types. They may be beta-2 agonist like salbutamol. They may be anticholinergics like ipratropine. And they may be theophylline. So 3 main types of bronchodilators can be used in asthma. Okay. Second, we can stop leukotrienes. And leukotrienes, for that we need to know how leukotrienes are produced. Membrane phospholipids are converted to arachidonic acid by phospholipase A2. Arachidonic acid is converted by COX to prostaglandins and by LOX to leukotrienes. Leukotrienes bind to receptor, cause bronchoconstriction. So the drug may inhibit phospholipase A2, which are steroids. Drug may inhibit LOX, which is xylitol. Drug may block receptor, which is zafirleucast and monteleucast. So leucast are leukotriene antagonist. It will inhibit leukotriene number. Number will be inhibited. So these 3 drugs will stop the leukotriene action. Leukotriene action. So drugs stopping leukotriene action are these 3. If we inhibit COX, more leukotriene will be produced. So asthma attacks will increase. So that is called as aspirin triggered asthma or aspirin induced asthma. Aspirin will worsen asthma, not decrease asthma. The next, we can use mast cell stabilizers. Mast cell stabilizers like sodium chromoglycate or nidochrome. They are mast cell stabilizers. And lastly, we can stop antigen antibody reaction by giving a drug called as omalizumab. Omalizumab is a monoclonal antibody against IgE. It stops antigen antibody reaction. Okay, so these are the important drugs which we can use in asthma. Aspirin induced asthma we discussed, caused by aspirin because it inhibits COX, so that will lead to increased production of leukotrienes. Okay, that will worsen asthma. Okay, so I think the last topic before miscellaneous is GIT. Now in the GIT, most important is peptic ulcer. So drug of choice for peptic ulcer is drug of choice for peptic ulcer. For any type of peptic ulcer, drug of choice are proton pump inhibitors. Drugs ending with prazole. Whatever peptic ulcer they ask, answer will be prazole. But if they ask what is drug of choice for NSAID-induced peptic ulcer? Drug of choice for NSAID-induced peptic ulcer? Still PPI. But if they ask which is the specific drug for NSAID-induced peptic ulcer? Specific drug is misoprostol. So read very carefully. Misoprostol is specific, but not the drug of choice. And lastly, which is the fastest pain reliever in peptic ulcer? Which drug is given to stop the pain immediately? These are antacids like aluminum hydroxide, magnesium hydroxide. Okay? Fastest pain relievers in peptic ulcer. And what is the triple drug therapy for H. pylori? Triple drug therapy for H. pylori. So in India, we prefer capregic, clarithromycin, amoxicillin, and PPI. Clarithromycin, amoxicillin, and PPI. And another drug which we can use is metronidazole among these. So any two antibiotics out of these and PPI. Any two antibiotic and PPI is triple drug therapy for H. pylori induced peptic ulcer. Okay. Then what is the difference between metoclopramide and domperidone? Both are D2 blockers. Both are D2 blockers. The difference is metoclopramide can cross blood-brain barrier, domperidone cannot. So metoclopramide can result in extrapyramidal symptoms as a side effect. It will block D2 in the brain also. Domperidone do not block. That's why it is a drug of choice for levodopa-induced vomiting. For levodopa-induced vomiting, drug of choice is domperidone. Then metoclopramide has additional mechanisms. It can stimulate 5-HT4 and block 5-HT3 also. These are absent in metoclopramide. So metoclopramide is more effective antiemetic drug because it has additional mechanisms. Clear? Done? So now we can quickly move to the last topic of miscellaneous topics, बचे खुचे topics. And the table which is the most important, हर एग्जाम में एक क्वेश्चन तो पक्का है इससे. You cannot skip this. Drug of choice or antidote of different poisonings. Beta blocker poisoning, drug of choice is glucagon. Organophosphate poisoning, atropine. Benzodiazepine, flumazenil. Flumazenil. Zolpidem, same flumazenil. Cyanide, hydroxycobalamin. It is the main drug. If it is not given in the option, you can mark amyl nitrite. Amyl nitrite can be used. Methanol poisoning, fomepizole. If not given, ethanol. Same for ethylene glycol. Iron poisoning, acute iron poisoning, it is desferrioxam. Desferrioxam. And chronic iron poisoning, it is deferripiram. Deferripiram. Acetaminophen or paracetamol is N-acetylcysteine. Valproate is L-carnitine. L-carnitine. Atropine is physostigmine. Heparin is protamine. And warfarin is vitamin K. I hope you must have remembered these by now. अब तक तो ये रट चुका होगा ना. इसमें तो कोई प्रॉब्लम नहीं होनी चाहिए. ये तो टिप्स पे होना चाहिए आपके. अल्कोहल पॉइजनिंग, मिथेनॉल या इथिलीन ग्लाइकोल में आएंगे तो फॉर्मिपिजोल इज फर्स्ट आंसर. अगर नहीं है ऑप्शन में तो इथिलीन ग्लाइकोल, हाँ इथेनॉल, तो इथेनॉल. फॉर्मिपिजोल अगर ऑप्शन में है तो वही मार्क करना है हर केस में. ठीक है, चलो. इरेक्टाइल डिस्फंक्शन, इंपोर्टेंस, द ड्रग ऑफ चॉइस आर फॉस्फोडाइएस्टेज 5 इनहिबिटर्स लाइक सिल्डेनाफिल, वारडेनाफिल, यूडेनाफिल and tadalafil. So 2 points to remember. 1, they are contraindicated with nitrates. They can lead to hypotension. Second, other use of these drugs is pulmonary hypertension. Pulmonary hypertension. Other use of phosphodiesterase inhibitor is pulmonary hypertension. Tadalafil is the longest acting phosphodiesterase inhibitor. Tadalafil is the longest acting phosphodiesterase inhibitor. Clear? That is erectile dysfunction. Then anesthesia, IV anesthetic agents. वैसे after this class, Janvi ma'am will teach all of them, but quickly revising. Phenobarbital स्पेशल, इसके पास जादुई पावर्स हैं. क्या खास बात थी? इट इज हाईली लिपिड सॉल्युबल, सो इट शोज द फिनोमेनन ऑफ रीडिस्ट्रीब्यूशन. याद है हमने स्टोरी में पढ़ा था कि माँ अपनी शक्तियों का गलत इस्तेमाल कर रहा है ना. ब्रेन में घुस जाएगा, फिर बाहर निकल जाएगा, फिर घुस जाएगा, फिर निकल जाएगा. तो रीडिस्ट्रीब्यूशन, दैट्स व्हाई इट इज वेरी शॉर्ट एक्टिंग, वेरी शॉर्ट एक्टिंग. देन कीटामिन, ऑल एमसीक्यूज आर रिटन इन कीटामिन. कीटामिन में सब लिखा हुआ. किड्स, एनेस्थेटिक एजेंट ऑफ चॉइस इन चिल्ड्रन. इमरजेंस रिएक्शन, द पर्सन डेवलप CNS प्रॉब्लम ड्यूरिंग रिकवरी. थैलेमोकॉर्टिकल जंक्शन, और वी कैन से तोड़ देना, दैट मीन्स डिसोसिएटिव एनेस्थीसिया. डिसोसिएटिव एनेस्थीसिया. A for analgesic, maximum analgesia among all the anesthetic agents. Sorry, it's not phenobarbital. Please correct it. It is thiopentone. गलत कर दिया मैंने. It is thiopentone. Thiopentone. Please correct it. It is thiopentone. Thank you, Malvika. It is thiopentone, not phenobarbital. M means meals, can be given in full stomach. I means increase BP, intracranial pressure, etc. N means NMDA blocker. And E means excellent bronchodilator. Ketamine. Clear? Then coming to propofol. Propofol, main problem, most painful. P for propofol, most painful injection is of propofol. But it is a drug of choice for daycare surgery and total intravenous anesthesia. Daycare and total intravenous anesthesia, drug of choice is propofol. Etomidate, the main advantage is cardiovascular stable, do not affect cardiovascular system, preferred for aneurysm surgeries. But the disadvantage is cause adrenal suppression. Adrenal suppression. That is about IV anesthetic agents. Clear? Take this screenshot if you want. Then moving to muscle relaxants. We have depolarizing muscle relaxant like succinylcholine. They stimulate NM receptors. And succinylcholine, 3 MCQs written in the name. S means shortest acting muscle relaxant, less than 5 minutes. C means contraindicated in patient with nerve and muscle injuries. Why? Because in these patients there is risk of severe hyperkalemia, which can cause death. And H means it causes malignant hyperthermia. Malignant hyperthermia is the side effect. So SCH, shortest acting, contraindicated nerve and muscle injuries, and cause hyperthermia. Then non-depolarizing, which are NM blockers. They are NM blockers. So these may be curiums or curoniums. Curiums are the one which release histamine. Whereas curoniums, they have no histamine release. No histamine. The name says NO, no histamine. Clear? So curiums like atracurium, cis-atracurium, mivacurium. Curoniums like pancuronium, pipe curonium, V curonium, rho curonium. Now, atracurium and cis-atracurium undergo special elimination known as Hoffman's elimination. Remember, the name says they are Atam Nirbhar. Atra means Atam Nirbhar. Atam Nirbhar hai. That means they do not require liver or kidney. Automatically, they are metabolites. So, they are preferred in patients with liver and kidney disease. Cis-atracurium cause even lesser histamine release. Even lesser histamine release. That means almost negligible histamine release. Now, curoniums, they cause histamine, no histamine release. So, they are preferred in asthmatic patients. Preferred in patient with asthma, because in asthma, we do not want any histamine. And which drug is used to reverse the action of muscle relaxant? Reversal agents. Reversal agent can be neostigmine or Sugamadex. Sugamadex. The difference is neostigmine is for all non-depolarizing muscle relaxants, whereas Sugamadex is only for rho curonium or V curonium. Sugamadex is only for rho curonium or V curonium, but Sugamadex is fast acting, neostigmine is slow acting. That is the main difference. Clear? So that is about the muscle relaxants. Okay, take the screenshot. Then moving to local anesthetics. They may be ester, they may be amide, but the name of all will end with cane. All will end with cane. So esters like cocaine, procaine, chlorprocaine, tetracaine, benzocaine. Amides like lignocaine, bupivacaine, prilocaine, atidocaine, ropivacaine, dibucaine. And you all know how to remember. Cane से पहले there is no I in the ester. If there is no I, it is ester. Amide contains I. If there is I before cane, it is amide. I का रूल. सो इन केस ऑफ एलर्जी शिफ्ट द ग्रुप. अगर किसी को प्रोकेन से एलर्जी है तो कोई भी एस्टर नहीं दे सकते, गिव अमाइड. अगर अमाइड से एलर्जी है तो कोई भी अमाइड नहीं दे सकते, गिव एस्टर. क्लियर? नाउ इंपॉर्टेंट थिंग, cocaine is the only local anesthetic which cause vasoconstriction. All other cause vasodilation. Chlorprocaine is shortest acting. Dibucaine is longest acting. Lignocaine is most commonly used local anesthetic. Bupivacaine is maximum cardiotoxic. Maximum cardiotoxic local anesthetic. Prilocaine causes methemoglobin. Prilocaine causes methemoglobin. Clear? So that is about local anesthetics also. Okay. So I think with that we have completed most of the things in pharmacology. I have tried to cover maximum I could. So this I always keep on saying. It doesn't matter what others are doing. It matters what you are doing. Okay? दूसरों को देख देख के परेशान नहीं होना. वो पढ़ नहीं रहे तो भी परेशान नहीं होना, पर ज्यादा पढ़ रहे हैं तो भी नहीं होना. ठीक है? अपने आप पे ध्यान रखो, बाकियों पे ध्यान ना. एग्जाम तक रहेगा बेटा वीडियो. क्लियर? सो आई थिंक 2:30 तो बज गए. मैम को बोल देते हैं 5 मिनट का ब्रेक दे दे, है ना? 10 मिनट का. चलिए, थैंक यू गाइस, लव यू एंड ऑल द बेस्ट. मैम नमस्कार.
Hello, sir.
सॉरी मैम, आई टुक अ लिटिल लॉन्गर.
No, no, of
मैम
course,
यू
no
आर
problem.
म्यूट.
सर आ रही आवाज? मेरा तो ऑडियो
अभी
ऑन
भी
है.
नहीं, या हम ही नहीं सुन पा रहे.
आ रही है आवाज सर.
गाइस आर यू एबल टू हियर मैम?
या चैट बॉक्स
कहीं
में
मेरे
लिख
लिए
रहे हैं हमें आ
स्पेसिफिकली
रही है.
ब्लॉक तो नहीं कर दिया?
हाँ, आपकी तरफ से कुछ ब्लॉक है सर.
नहीं मैम, आवाज नहीं आ रही है. एक
ठीक
बार
है सर,
कनेक्शन
आई
देखिए
गिव
मैम,
देम
आपका
अ
साउंड
ब्रेक.
देखिए. मेरी आवाज, आपकी आवाज नहीं आ रही. चलो ठीक है मैम, थोड़ा सा ब्रेक दे दीजिए बच्चों को.
ओके सर.
थैंक यू मैम.
थैंक यू सर.
एंड गाइस ऑल द बेस्ट. ऑल द बेस्ट. बाय बाय.
ओके, आई थिंक ऑल ऑफ यू आर एबल टू हियर मी गाइस. कितना टाइम ब्रेक चाहिए? लिख दो. 15 minutes ब्रेक इज फाइन. यस. ओके, 15 minutes. तो वील स्टार्ट एट 2:45. ऑलराइट. नहीं नहीं, 30 मिनट नहीं. खाना ले आओ अपना 15 मिनट में और बैठे बैठे मुझे देखते जाना. ओके. चलो, 15 मिनट का ब्रेक. वील स्टार्ट एट 2:45. हेलो। मैम तो इधर ही है, लेकिन ये क्या मुझे शेयर करने क्यों नहीं दे रहे ये लोग पीपीटी? हाँ चलो, स्क्रीन शेयरिंग चालू हो गया। दिख रहा है स्क्रीन? हेलो। 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 यस, सब कुछ चालू हो गया। ओके, चलो, वेलकम एवरीवन टू क्लास। बहुत कुछ चालू है, स्क्रीन दिख रही है, सब दिख रहा है, स्क्रीन दिख रही है, मैं दिख रही हूँ। ब्रेक हो गई है, सुसु पॉटी नहाना खाना पीना सबका सब कुछ हो गया है अच्छे से। अभी पढ़ने को तैयार हो? ठीक है, सो वी आर गोइंग टू डू अ मैसिव rapid revision of anesthesia, and I have tried to keep as many topics as possible in this marathon, so that you are done with nearly 70 to 80% of anesthesia in this revision only. ठीक है, अब मेरा रिविजन ऐसा होता है that I am not going to sit and write everything, because already आपके नोट्स में मिशन नोट्स में ये सब है. So we are just going to discuss amongst each other. I'm going to ask you the question, you are going to answer it for me, and then we are going to go ahead with it. ठीक है, जो भी ये मैराथन सेशन में आता है ना, लास्ट 3-4 साल से तो लगातार स्टूडेंट्स बोल रहे हैं कि मैम आपके मैराथन सेशन में से एनेस्थीसिया के क्वेश्चंस आए, क्वेश्चंस हैव कम फ्रॉम मैराथन, क्वेश्चंस हैव कम फ्रॉम मैराथन. सो एज अ रिजल्ट ऑफ दिस आई highly recommend this marathon session, and because I talk so fast and because I take everything in speed without wasting any time, तो you don't have to watch it at 1.5x later. अभी का अभी देख लो और खत्म करो, ठीक है? चलो, so let's start off. The first one that we have is the American Society of Anesthesiologists ASA classification. ठीक है, तो मुझे बताओ in ASA classification how many classes are there? Fast, fast, fast. It has to be fastest finger first on your chat box. मेरे में इतनी एनर्जी है, इसमें डाइट कोकी है और कुछ नहीं मिला है. Very good. There are 6 classes in ASA classification. Okay. So if I say that my patient has no comorbidities, my patient is absolutely healthy, fine. What is this ASA classification? One is healthy. Okay. If I say my patient is brain dead and he is posted for organ donation, cadaveric organ donation, what is the ASA classification? ASA 6. Okay. If I say my patient has severe systemic disease that is a constant threat to his life, severe systemic disease that is a constant threat to his life, तो क्या है ये ASA classification? ये है ASA classification 4. If I say my patient is moribund patient, see it's a revision session, हाँ, marathon मतलब revision, पहली बार नहीं पढ़ा रही हूँ मैं ये. If I say patient is moribund and he will die without surgery, it is ASA status 5. ठीक है, alright, चलो. So again, ASA classification basically tells you about the pre-operative assessment of your patient prior to surgery. ठीक है, the patient is fit for anesthesia or no, what is his risk of anesthesia, वो बताता है. इसमें we have 6 classes. Class 1 is normal healthy patient. Class 2 is mild controlled systemic disease. Class 3 is moderate to severe systemic disease. Class 4 is severe systemic disease that is a constant threat to life. ये याद रखो, पूरा इतना लंबा sentence. Severe systemic disease that is a constant threat to life. That is status 4. ASA physical status 5 is moribund patient who will die without surgery. ठीक है, ब्रेकअप हो गया, दिल टूट गया, अगर दिल जोड़ा नहीं तो वो हो जाएगा moribund patient who will die without surgery. Okay, and ASA status 6, ASA status 6 is going to be dead patient जिससे we are going to take organs. So cadaveric patient posted for organ transplant. Yes, brain dead patient. All right. तो दिस हो गए आपके सारे ASA क्लासिफिकेशन. नेक्स्ट हम लोग क्या करेंगे प्री ऑप इवैल्यूएशन में? I will ask you what medications are stopped or what medications are continued prior to surgery. अब ये क्वेश्चन आया है recently in FMG exam. Your patient is on antihypertensive agent. Which antihypertensive agent will you stop prior to surgery? Will you omit on the day of surgery? Very good. ACE inhibitors and angiotensin receptor blockers. जो आपके प्रिल्स है और sartans है, you will stop them prior to surgery. Which antihypertensives will you continue on the day of surgery? Which antihypertensives will you continue on the day of surgery? Yes, your beta blockers, calcium channel blockers, all of them you will continue on the day of surgery. Okay, fine. अब मुझे बताओ कि if your patient is diabetic इंसुलिन को क्या करोगे ऑन द डे ऑफ सर्जरी? कंटिन्यू और स्टॉप? You will stop the insulin because on the day of surgery patient is going to be fasting. अगर patient fasting होगा तो वो क्या करेगा? वैसे भी भूखा मरा हुआ होएगा, blood sugar levels उसके low होंगे. So what you have to do is don't give the patient OHA or insulin on the day of surgery. If patient is diabetic, OHA or insulin needs to be stopped or omitted on the day of surgery. ठीक है? Okay. Patient को thyroid disease है. Patient is taking thyroxine. He is hypothyroid. Will you continue or will you stop on the day of surgery? Okay, thyroid medications are continued. Patient is on antithyroid drugs, propylthiouracil, carbimazole, methimazole, ये सब. You will continue. Any thyroid medication, you will continue on the day of surgery. ठीक है, next. If your patient is taking OC pills, continue or stop on the day of surgery. इंडिया की population बढ़ाने वाले हो, कम करने वाले हो तुम लोग? OC pills continue or stop on the day of surgery? Continue. Okay. If patient is taking anti-TB drugs अगर ले रहा है तो continue करोगे या stop करोगे? Anti-TB drugs continue. ठीक है. So which test will you do in case your patient is taking anti-TB drug? Pre-op में कौन सा टेस्ट करोगे? LFT करोगे, liver function test करोगे. G6PD कशाला यार, काहीतरी म्हणतात तुम्ही. G6PD नहीं, liver function test करोगे तुम लोग because your tubercular drugs will affect the liver. Okay. Now, next, your patient is taking clopidogrel. How many days prior to surgery will you stop? Clopidogrel. 5 days prior to surgery, you will stop. Your patient is taking ecosprin or aspirin. How many days prior to surgery, you will stop? 3 days. Barabar. Okay. Your patient is taking warfarin. How many days prior to surgery will you stop? 5 days. Okay. Your patient is on unfractionated heparin. जो बड़ा वाला होता है, मोटा वाला होता है, unfractionated heparin. How many hours prior to surgery will you stop? 4 hours prior. Your patient is taking low molecular weight. Cut. मटन को कैसे कट करते हैं वैसे बड़ा हिपैरिन का मॉलिक्यूल को कट स्मॉल पीस में कट करके you take one molecule that is low molecular weight heparin. When is the last dose of low molecular weight heparin? 12 hours or 24 hours prior to surgery. अगर twice a day dose चल रहा था, if it was a BD dose of unfractionated heparin, then last dose will be taken 24 hours prior to surgery. If it is OD dose of unfractionated heparin, last dose to be taken 12 hours prior to surgery. Okay, guys, this pattern is okay for you all कि तुम लोग को ऐसे लग रहा है हमको आता नहीं है, पूरा क्यों नहीं पढ़ा रही है मैम, स्क्रीन क्यों नहीं दिखा रही है मैम, लिख क्यों नहीं रही है? Because this has become like a revision session for you all. You all are doing an active recall. You all are trying to remember what you all have already studied. Okay, ये recall method ही बराबर है prior to exam. ऐसा मुझे spoon feeding नहीं करना है अभी, जैसे बाबू को करते हैं हम लोग. Okay, बाबू की spoon feeding, बाबू इधर नहीं है. I won't be able to show him to you, but definitely I can show you how we spoon feed him. See, even he is not spoon fed. He eats on his own. Vardhan Nasta also eats on his own. See. You know, you're looking very funny. You know, you're looking very funny. Are you liking your sweet potato sticks? Are you liking your sweet potato sticks? You Christmas bunny? Yes. So see, इसको भी हम लोग ये नहीं करते हैं स्पून फीड, तो मैं तुमको क्यों स्पून फीड करूँ? ओके, ऑल राइट. Yes, he looks exactly like Amrit sir. See. He is Amrit part 2. All right. Now let's go back to our class. Next, steroids. Will you continue or will you stop steroids on the day prior to surgery? Will you continue or will you stop on the day prior to surgery? You will continue steroids on the day of surgery as well. ठीक है. अभी next हमारा ये बहुत important question है, IV line के बारे में question they ask. So I am going to ask you quickly. I have a pediatric patient. Patient is 3 years old and I have to put an IV line in her. I want to put a 24 gauge IV line. What is the color of the IV line? What is the color of 24 gauge IV line? Yellow. Very good. Okay, I have a 10-month-old child and I want to put an IV line. What is the color of 26 gauge IV line? Purple color. Okay. I have a patient who has undergone an accident right now, and there is a lot of blood loss. I want to quickly rush blood. So I am giving you 4 options. Tell me which IV line you will put in her. Okay. Green, yellow, pink, blue. Green, yellow, pink, blue. Green color, because you are going to do resuscitation. You are going to give blood at a very fast pace. So as a result of this, you will put green color IV line in the patient, that is 18 gauge. Okay. So quickly write in the chat box. Orange color IV line, what is the gauge? Orange, 14 gauge. Okay. Gray color IV line is gray, 16 gauge. Okay. Green color IV line is green, 18 gauge. Okay. Pink, 20 gauge. Very good. 22 gauge color, 22 gauge color, 22. तुम्हारी गर्लफ्रेंड की एज 22 गेज ब्लू. ओके. 24 गेज कलर, 24 गेज कलर येलो, 26 गेज कलर पर्पल. ओके. अगर पूछे बच्चों में कौन सा आईवी लाइन डालते हैं, इन किड्स विच कलर आईवी लाइन यू पुट? Yellow and purple. In trauma or resuscitation, you want to give fluids fast, blood fast, you have to put which color IV line? 16, 18 और 20 तो नहीं डालते, ठीक है. 16 और 18 मोस्टली डालते हैं, कभी कभी 14 भी डाल देते हैं. ओके. ऑरेंज. ऑलराइट. चलो नेक्स्ट. Fasting guidelines. Patient is posted for elective hernia surgery. Patient has eaten pav bhaji. After how many hours will you take the patient? Pav bhaji with butter and kanda on the side. Yes, so if patient has had a full meal, then you will give the patient for elective surgery, you will take the patient after 8 hours. ठीक है. चलो, patient has had real का orange juice with pulp. After how many hours will you take the patient for surgery? Real का orange juice with pulp after 6 hours. Okay. Patient has had breast milk. अब तुम ये मत सोचो 25-30 साल का पेशेंट है, छोटा बाबू है. ओके. 6 महीने का बाबू है. He has had breast milk. After how many hours you will take him for surgery? 4 hours. Okay. Patient has had a glass of water. ठीक है. गलती से पानी पी लिया. So after how many hours will you take him up for surgery? 2 hours. Okay. So fasting guidelines for clear liquids, 2 hours. Breast milk, 4 hours. Any other milk, cow's milk, formula milk, almond milk, soy milk, oat milk, latte. Okay. Chai, biscuit, light meal, all of this is 6 hours, and full meal, it is 8 hours. Okay. So that is about fasting guidelines. Next, monitoring in anesthesia. सबसे important जो पूछते हैं एग्जाम में, identify this monitor. जहाँ पे मैंने क्वेश्चन मार्क डाला है. Yes, if you see a grey color, ऐसा cloud, ऐसा grey color के clouds दिखाई दे रहे हैं. So this is nothing but capnography. This is capnography. Okay. चलो, नंबर 1 मॉनिटर क्या है, जल्दी बता दो. 1 जो मैंने मार्क किया है, 2 जो मैंने मार्क किया है, 3 जो मैंने मार्क किया है, और ये वाला 4 जो मैंने मार्क किया है, वो भी बता दो. Okay. So 1 which is marked, this is nothing but ECG. 2, what is 2? 2, the one that is blue, that is SpO2. SpO2. 3 क्या है? 3 over here, this this is invasive blood pressure. ठीक है. रेड कलर का है तो it is invasive blood pressure. This red over here is invasive blood pressure. बाकी what you have is non-invasive blood pressure also, जो यहाँ पे दिया नहीं है. Okay. Then this one is capnography, as you all know, and this one, number 4 monitor that you guys can see, 35.8, is nothing but temperature monitor. Okay. Chalo. Now we go to the LMAs. So we will discuss on basically on the basis of what is asked in your FMG exam. If it was NEET or if it was INI, then ना LMA के बारे में अंदर से ढूंढ के चीजें पूछते हैं. लेकिन FMG exam में they will simply ask you to identify the LMA. Okay. आराम से, ठीक है, आराम से करती हूँ मैं. But they will ask you only for identification of these LMAs. और ज्यादा सिर्फ max to max इसका generation पूछेंगे कि first generation है, second generation है, third generation. So let's discuss this. Okay. Now 1 and 2 and 3. LMA number 1, 2, 3 में you can see how many tubes coming out. You can see how many tubes coming out? 1 tube. Either 1 tube is coming out, 1 tube is coming out, 1 tube is coming out. So all these LMAs are first generation LMAs. All these LMAs are first generation LMA. ओके, अब ये फर्स्ट जनरेशन एलएमए जो है, इनके नाम बताओ। सबसे पहले तो दिस वन इज मेड अप ऑफ सिलिकॉन एंड दैट्स व्हाई यू कैन सी इट इज स्किन कलर्ड, इट कैन बी रीयूज्ड अगेन एंड अगेन। तो ये कौन सा है? दिस वन इज LMA क्लासिक, फर्स्ट जनरेशन LMA विच इज मेड अप ऑफ सिलिकॉन, LMA क्लासिक। अब फर्स्ट जनरेशन LMA विच इज मेड अप ऑफ PVC, प्लास्टिक टाइप मटेरियल का, यूज एंड थ्रो है, यूज एंड थ्रो। जेप्टो की थैली कैसे होती है? जैसे ही आती है वेस्ट, जेप्टो का माल फेंको और थैली भर भर के, दिन में 10 थैली तो हम लोग यूज एंड थ्रो ही करते रहते हैं। Yes. So this one is not LMA Supreme, my dears. If it is having only one tube, LMA Supreme has two tubes coming out of it. This looks similar to LMA Supreme, लेकिन यहाँ पे कैसे है? Only one tube is coming out. So this one is called as LMA Unique. Unique. Okay. Unique मतलब एक ही बार यूज करना है और फिर उसको थ्रो करना है. So this one is LMA Unique. Okay. अब LMA Unique को तुमने एकदम ऐसे ना एक्सरसाइज करा दी, फ्लेक्सिबल योगा करा दिया मलाइका अरोरा वाला, सो ये एकदम ऐसे टर्न हो गया LMA यूनिक। ओके, सो इसको हमने बोला दिया LMA मलाइका, नॉट LMA मलाइका, LMA लाइक मलाइका, फ्लेक्सिबल, फ्लेक्सिबल। ओके, सो दिस all three of them are first generation LMA. तो जब भी LMA का फोटो आए in the exam, whenever you see a picture of the LMA, first you have to look at how many tubes are coming out of it. ठीक है? So if only one tube is coming out, so it has to be one of these three, either LMA classic or LMA unique or LMA flexible. Okay. Now the minute you see कि दो tubes बाहर आ रही है, not one tube but there are two tubes coming out, then you start looking at the second generation LMAs. Okay. So यहाँ पे आपको दिखाई दे रहा है second generation LMA. Why second generation? Because you can see two tubes coming out of it, one here and one here. Second generation LMA means two tubes coming out of it. Okay. So in second generation LMA, two tubes coming out and this is made up of disposable material. It is made up of PVC. तो क्या है ये? क्या है ये? Yes, it is made up of PVC and it is disposable. It has two tubes coming out. It also has your white block over here. So this one is called as LMA Supreme. This one is called as LMA Supreme. Okay. All right. This is LMA Supreme. दिखा रही हूँ डॉक्टर जियस, शांति रखो, दिखा रही हूँ तुमको। तुम लोग अपनी गर्लफ्रेंड से भी ऐसी बात करते हो, इसका फोटो, उसका फोटो, उसका फोटो, शांति से, स्लो इज गुड। ओके फाइन। सो दिस हो गया LMA नंबर 4 सेकेंड जनरेशन, दिस इज LMA सुप्रीम। अब आ गए हम लोग नेक्स्ट लेवल पे, नेक्स्ट बेस। ओके, सो 5 6 7 एंड 8, 5 6 7 एंड 8। अब सब कुछ दो दो दिखाई दे रहा है, पहले एक एक ही दिखाई दे रहा था, अब सब कुछ दो दो दिखाई दे रहा है। आई एम टॉकिंग अबाउट द नंबर ऑफ ट्यूब्स कमिंग आउट ऑफ द LMA। ओके, so here again you have two tubes coming out of the LMA. Okay, up 6 में you can see only one tube coming out. 7 में again there are two tubes, one here, and 8 में again there are two tubes, one here and one here. Okay, so most of them are second generation LMA. So this one over here, this second generation LMA that you can see, which is made up of silicon, that is skin colored material and can be reused again and again. नाम बताओ इसका, क्या नाम है इसका? प्रोसील। यस, दिस इज LMA प्रोसील, दिस इज LMA प्रोसील। ओके फाइन। नाउ नंबर 6 में जो आपको दिख रहा है, दैट इज एक्चुअली वन ऑफ योर अम्बू LMAs। ओके, तो अम्बू ओरा 40 है इसका नाम, एंड जो नीचे वाला है जो ग्रीन कलर का है फुल, अम्बू ओरा गेन, अम्बू ओरा 40 एंड दिस वन इज अम्बू ओरा गेन। ओके, अम्बू ओरा ग्रीन को कैसे याद रखना है? यू कैन रिमेम्बर दिस इज अम्बू ओरा ग्रीन। फुल LMA is green in color. Whenever full LMA is one single color, it is belongs to this अम्बू कैटेगरी। ठीक है, अब तुम्हारे एग्जाम में मोस्टली अम्बू कैटेगरी नहीं पूछने वाले हैं, तो इसलिए इसके ऊपर ध्यान मत दो। INI-CET में पूछा था, इसलिए हैव इंक्लूडेड इट। नाउ नंबर 8 LMA बहुत आ सकता है। अगर कोई मुझे बोले FMG एग्जाम में कौन सा क्वेश्चन आएगा मैम, ये वाला आएगा कि ये LMA का नाम बता दो, पेपर लीक कर दो, लोग बोलते हैं ना, ये पेपर लीक में से मुझे लग रहा है। Okay, so this LMA, as you can see, there are two tubes coming out of it, and this balloon or that you can see over here, यहाँ पे जो balloon होता है, ये balloon नहीं है इसमें. Okay, so the balloon is nothing but pilot balloon to inflate the cuff. So if you don't see a pilot balloon to inflate the cuff, तो ये LMA हो गया I-gel LMA. I-gel LMA. This is a second generation LMA. I-gel LMA. This is a second generation LMA. Okay, understood, everyone? Yes. Okay. Chalo. So all the LMAs that we have seen over here, now these LMAs are little bit of extra LMAs. जो करने हैं वो मैं बताती हूँ, जो नहीं करने हैं वो जाने दो. Alright? ये इसको तो बड़ा सा ऐसा क्रॉस मार दो, इसको भी बड़ा सा ऐसा क्रॉस मार दो, पकड़ पकड़ के क्रॉस मार दो. अब ये वाला देखो. There is an LMA which is made up of silicon, and there is a handle over here. There is a handle over here that you can see. It is a steel handle. Okay, and what you have over here is that there is a tube, endotracheal tube, which is going inside the LMA. So LMA का नाम क्या है? It is used for intubation. Correct. So this one is called as LMA fast track. LMA fast track, and it is also called as intubating LMA. LMA fast track or intubating LMA. And one thing you need to know about this is that it is a special LMA. There is no generation, first generation, second generation, third generation, ऐसे नहीं है. This is a special LMA. Okay. अब ये दो LMA का सिर्फ नाम बता रही हूँ, याद रखने की जरूरत नहीं है. I don't think it will come in your exam. It is too high-fi, so you don't need to know. Okay. This one over here is बस्का मास्क. इसका नाम लिखा है, वो क्या होता है, बन मस्का. बन मस्का बोलते हैं ना, वो बन में जब बटर लगाते हैं, तो बन मस्का का एक नाम क्या होता है, बस्का. ओके, सो बस्का खाते खाते, बन मस्का खाते खाते ये LMA बनाया गया था, इसलिए इसका नाम रखा गया है बस्का मास्क. ओके, अब ये बस्का मास्क में आपको क्या दिखाई देगा? यू विल सी वन साइडवेज, देयर इज वन ग्रीन कलर का ओपनिंग लाइक दिस. ओके, एंड यहाँ पे सांप का कैसे मुंह होता है, नागिन वाला मुंह. दैट इज हाउ द कफ लुक्स लाइक. ओके, इट लुक्स लाइक अ snake का hood. And the other one that you see over here is called as LMA Teleflex. Teleflex है ना इसका नाम? Yes, LMA Protector और LMA Teleflex यहाँ पे लिखा. मैम LMA Teleflex कैसे याद रखे? The pilot balloon over here is having color like signal, red, yellow and green. Okay, बस. अब ये दोनों जो है ना वो बहुत ज्यादा है, इतना दिमाग मत लगाओ, ज्यादा इंपॉर्टेंट नहीं है. अब हम नेक्स्ट वाले टॉपिक के ऊपर जाते हैं. मैं फटाफट फटाफट तुमको स्टार मार्क कर देती हूँ, जैसे बच्चों को कैसे स्टार मार्क करते हैं कि कौन से इंपॉर्टेंट है. 1 स्टार, 2 स्टार, 3 स्टार एंड 4 स्टार. ओके, ये 4 LMA तुमने अगर याद रख लिए तो दिस इज मोर देन इनफ. ओके, फाइन. नाउ these are LMAs and their sizes. अब इसमें यहाँ पे एक छोटा सा चेंज है, क्योंकि यहाँ पे प्रिंटिंग में ही गलत आया है. टप 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 टप. ओके, दिस इज 30 to 50 kg, 50 to 70 kg एंड मोर देन 70 kg. इतना बस चेंज कर दो. अब अगर आपको LMA पूछे एग्जाम में कि देर इज अ 35 kg individual and you have to put an LMA, what size LMA will you put? Okay, तो उसके लिए ये थोड़ा याद रखना जरूरी है. तो how will you remember? Just remember 3 and 3, size 3 LMA, size 3 LMA starts, इधर 3 लिख दो, 30 to 50 kg, 30 to 50 kg. तो 35 kg में you will put size 3. Okay, अब बताओ कि साइज अपना 25 kg का इंडिविजुअल हुआ तो उसमें क्या साइज डालोगे तुम? 25 kg में क्या डालोगे? If size 3 is from 30 to 50 kg, तो 25 kg is little lesser than size 3, तो उसमें थोड़ा सा कम कर दो साइज. तो instead of putting size 3, you will put size 2.5. ठीक है, तो ये हो गया आपका साइज गाइडलाइंस फॉर LMA. क्या ये एग्जाम में आ सकता है? इतना इतना चांस है, ज्यादा चांस नहीं है, बट अगर पूछे तो कॉमन सेंस से आंसर दे दो. इसलिए मैं बोल रही हूँ कि सिर्फ साइज 3 याद रखो. साइज 3 30 to 50 kg. फिर अगर वो लोग पूछे 20 किलो, 25 किलो या फिर 55 kg, सो अप्रोक्सीमेटली आगे पीछे यू कैन से इट इज 1 size लेस और 1 size मोर. ओके ओके, अब ये सब लोग कौन है? बराबर. They won't ask because size does not matter. Yes. So all of these couples, Virushka, Ralia, and Deepveer and Vic Cat. और हमारा क्या है? एनेस्थीसिया का कौन है? Couple. Yes. So anesthesia couple is this. Laryngoscope and tube. Okay. Yeah. The nibba nibbi in anesthesia. अब nibba nibbi के बारे में let's discuss different types of anesthesia laryngoscopes and different types of anesthesia endotracheal tubes. Okay. So मुझे फटाफट से बता दो number 1, number 2, number 3, number 4. What are the names of the laryngoscopes? So the first laryngoscope is a curved blade laryngoscope used commonly in adults. इसका नाम क्या है? Used commonly in adults. क्या नाम है इसका? Macintosh. Macintosh. Absolutely correct. Okay. Number 2 is a straight blade laryngoscope. Straight blade laryngoscope that is used commonly in children. What is the name? What is the name? It is Miller's laryngoscope. Miller's laryngoscope. Okay. Number 3 is a curved blade laryngoscope with a lever attached to it. Lever attached to it. Yes, this is called as McCoy laryngoscope. McCoy laryngoscope. Okay. Number 4 is a video laryngoscope. Okay. It has a small camera over here. It's a video laryngoscope with a camera attached to it. So this is called as video laryngoscope. Video laryngoscope. ठीक है? इसमें से एग्जाम में कौन सा आ सकता है मैम? This can be a statement based question where they ask you this laryngoscope, number 2 laryngoscope is used in whom? Adult, children, difficult airway, pregnant patients. Adult, children, difficult airway, pregnant patients. Answer is child. Okay. Or they can give the picture and ask you identify the laryngoscope. So the name of the laryngoscope is Miller's laryngoscope used in children. ऐसा question आ सकता है exam में. Okay. चलो. अब next ट्यूब के बारे में बताओ. नंबर 1 ट्यूब, 2 ट्यूब, 3 ट्यूब कौन सी है? एंड वेयर इज इट यूज्ड? यस. सो नंबर 1 ट्यूब जो आपको दिखाई दे रही है यहाँ पे ऐसे राइट एंगल पे है. नंबर 2 ट्यूब यू शेप्ड है. यू शेप्ड. ओके. सो नंबर 1 ट्यूब जो राइट एंगल पे है व्हाट ट्यूब इज इट? This is called as a North Pole tube. This is called as a North Pole tube, which is used in head and neck surgeries. What about number 2 tube? U shape वाली ऐसे U ऐसे. Yes. So this is a South Pole tube. This is a South Pole tube. South Pole tube कहाँ पे use होती है? This is all the Diet Coke talking. Yes, correct. मैं यू ऐसे क्यों चिल्ला रही हूँ तुम लोग को? ज्यादा ये एक्साइट करने के लिए नहीं. ये देखो साउथ में आता है यू. साउथ में आता है यू. सो योर एंडोट्रेकियल ट्यूब इज ऑल्सो यू शेप्ड. ठीक है. सो दिस इज अ साउथ पोल ट्यूब विच इज यूज्ड इन हेड एंड नेक सर्जरी. हेड एंड नेक सर्जरी. ओके. नंबर 3 ट्यूब में क्या दिखाई दे रहा है? व्हाट इज स्पेशल अबाउट नंबर 3 ट्यूब? सारी फन क्लासेस आज ही रखी है. गोगा सर की, मेरी. उसके बाद मैं चुप हो गई क्योंकि मैं कोका कोला पी रही थी इसलिए. ओके. Yes, so South Pole and North Pole tube both are used in head neck surgeries. And number 3 tube, you cannot see any cuff over here. यहाँ पे cuff दिखाई नहीं दे रहा है. Okay, cuff मतलब cuff नहीं, cuff मतलब cuff, CUFF cuff. Okay, so this is a uncuffed tube. Number 3 tube that you can see is a uncuffed tube. अब मुझे बताओ uncuffed tube कहाँ यूज करते हैं? शाम को तुम लोग सब लोग पूजा करने वाले हो. पूजा करने की तो जरूरत है तुम सबको, फिर ही एग्जाम में पास हो गए. Okay, so uncuffed tube is used, uncuffed endotracheal tube is used in children. It is used in children for intubation. ठीक है. Alright, now मुझे बताओ ऊपर वाली ट्यूब कौन सी है, नीचे वाली ट्यूब कौन सी है? ऊपर वाली ट्यूब कौन सी है, नीचे वाली ट्यूब कौन सी है? ऊपर वाली ट्यूब. Yes. So if you see over here, there is metallic wiring present inside the tube. So this one is called as a flexometallic tube. ऊपर वाली ट्यूब जो है उसको बोलते हैं flexometallic tube. Again, it is used in head and neck surgeries. Just like North Pole and South Pole tube. What about नीचे वाली tube? FMG की favorite? FMG favorite. FMG likes everything 2-2. FMG people don't like anything 1-1. दिखाना है तो डबल डबल दिखाओ, एक एक नहीं चाहिए हमको. यस, बट मार्क्स तुम्हारे ट्रिपल डिजिट्स में आने चाहिए. हाँ, यस, एब्सोल्युटली करेक्ट. शंकर क्या बोल रहा है? मैम, आई विल गेट डबल डबल एवरीथिंग. डबल डबल मार्क्स मीन्स दिस शुड बी योर टारगेट इन एफएमजी. 2-2-2, डबल डबल डबल. इसलिए हमारा मिशन है 200+, क्योंकि डबल चौका, डबल क्या बोलते हैं, सेंचुरी मारने का है ना. Yes, okay. So this one over here, you can see everything double double. You can see two ends of the tube. You can see two pilot balloons and you can see two cuffs. So this one is called as double lumen tube. Double lumen tube. Where is it used? Double lumen tube is used in thoracic surgery. किसके लिए यूज करते हैं? फॉर वन लंग वेंटिलेशन. ये ट्यूब तो बहुत ही इंपॉर्टेंट है. इट हैज कम इन एफएमजी एटलीस्ट 2-3 टाइम्स. सो ऑल ऑफ यू शुड नो दिस फ्रॉम योर पीवाईक्यूज. अच्छा, सबसे पहले मुझे बताओ, तुम में से कितने लोगों ने एफएमजी मॉक 3 दिया है? एफएमजी मॉक 3 किसने किसने दिया है? मैंने. ओके, क्या मार्क्स आए हैं एफएमजी मॉक 3 में? 170, 164, 193, 155, 248 किसका आया भाई? 224. ओके, नॉट बैड. ठीक है, 180 के ऊपर अगर आया है, 180 190 के ऊपर, दैट मीन्स यू आर ऑन द राइट ट्रैक ऑफ प्रिपरेशन. अगर उसके नीचे आया है तो थोड़ा रिविजन अच्छे से करो. ठीक है, मैराथन सेशंस रिविजन अच्छे से करो. मॉक 3 वाज मेनली बेस्ड ऑन प्रीवियस ईयर क्वेश्चंस. हमने क्या किए? प्रीवियस ईयर क्वेश्चंस उठाए और उनको तोड़ मरोड़ के, या फिर टॉपिक को तोड़ मरोड़ के, वी हैव मेड द mock 3. That is why it is important that you guys should have got decent marks in that. Maybe more it than what you will get in the actual exam, because we kept it a little easier also. Okay. Mock 3 was the easiest. Mock 1 and mock 2 were slightly difficult. जिसने नहीं दिया है जाके दो एग्जाम एंड प्रॉपरली दो. जैसे एग्जाम में देने वाले हो, यू आर गोइंग टू सिट थ्रू पार्ट 1 फॉर 3.5 hours, देन यू आर गोइंग टू सिट थ्रू पार्ट 2. वैसे जाके दो बराबर से. ओके, चलो. नाउ व्हाट वी हैव ओवर हियर इज योर अच्छा, ये वाला भी क्वेश्चन रिसेंटली इट हैज बीन आस्क्ड इन नीट एग्जाम. सो नीट में पूछा है, तो एफएमजी वाले क्या करेंगे? वहां से उठा पिटा के थोड़ा चेंज वेंज करके उसकी मलम पट्टी करके डाल देंगे इन योर main exam. Okay, so this is another one that can be asked in the exam. So number 1 and number 2 are type of airways. What airways number 1? What airways number 2? What are the names of the airways? Okay, very good. So number 1 is Giddle's oropharyngeal airway. And number 2 that you see over here is your nasopharyngeal airway. Number 1 is Giddle's oropharyngeal airway and number 2 is nasopharyngeal airway. Okay? Look at this very nicely in nasopharyngeal airway, and please make sure that you know what is the difference between nasopharyngeal airway and uncuffed tube. नीट एग्जाम में ये क्वेश्चन दिया था. इसकी फोटो ऐसे, इसका यहाँ पे ऐसे नाक फुंडाया हुआ है ऐसा, ताकि तुम्हारी नाक में आके अटक जाए बाहर से. ओके, सो यू विल पुट द रेस्ट ऑफ द ट्यूब इनसाइड द nasopharynx and only the outside circular part will get stuck here. Okay, so this is your nasopharyngeal airway, but this is very very different from an uncuffed tube. Uncuffed endotracheal tube will look something like this. It will have markings on it, it will have a connector, वो सब है. Because क्या हुआ, बहुत सारे लोगों ने एग्जाम में कंफ्यूज होके they marked this picture को as uncuffed endotracheal tube. So this is not uncuffed endotracheal tube. Fundeli naak means this is a nasopharyngeal airway and this is made up of rubber. So it is very flexible. Okay. All right. Now Next, we will discuss about Munnabai and circuit, that is our machine and circuit in anesthesia. All right. So let's discuss some important parts of the machine and circuit. So this is the first part I want to discuss with you, vaporizers and their colors. So vaporizer के color के हिसाब से tell me what is the gas that is present inside. Okay. Red color vaporizer has which gas? Bolo. Red color vaporizer has halothane. Okay. Purple color vaporizer has isoflurane. Yellow color vaporizer has sevoflurane. Okay. And what is the color of desflurane vaporizer? Desflurane, what is the color of the vaporizer? Blue. Very good. Okay. Out of all four vaporizers, which is a special vaporizer? Special vaporizer? Desflurane. Very good. And what is the name of that desflurane special vaporizer? Tech 6. TPM fine. Tech 6. Tech 6. ओके फाइन. ये क्या है यहाँ पे? ये ट्यूबिंग जो दिख रही है, ग्लास ट्यूबिंग्स, एनी आइडिया व्हाट इज दिस? व्हाट इज दिस? पत्ती गुल. फ्लो, yes, flow what? So this is a flow meter. Correct. This is a flow meter. Okay. This is a flow meter. Okay. Now this flow meter, you can adjust the flows of your fresh gases. That is your oxygen, air and nitrous oxide. Alright. ठीक है. यहाँ पे there is an emergency button for oxygen. Emergency oxygen button. Emergency oxygen button, which will give large amount of oxygen in one flow. What is the name of this emergency oxygen button? This is called as oxygen flush. This is called as oxygen flush. Okay, fine. Then यहाँ पे you have a dabba, and this dabba will have small particles in it which help in absorbing the carbon dioxide. So this is called as carbon dioxide absorber. This is called as CO2 absorber. CO2 absorber के थोड़े एग्जांपल्स बताओ मुझे फटाफट. कौन सी एग्जांपल्स होते हैं? सोडा लाइम, बैरा लाइम, एम okay, soda lime, bara lime, amsol. All right, so these are examples of the CO2 absorber. Fine. So these are some parts of the anesthesia machine. अब डायरेक्टली तो तुमको ये नहीं पूछेंगे, डायरेक्टली तुमको क्या पूछेंगे? व्हाट आर द डिफरेंट टाइप्स ऑफ सर्किट्स? सो सर्किट्स में दिस वन दैट यू सी व्हिच गोज लाइक अ सर्कल, दिस इज कॉल्ड एज सर्कल सिस्टम. This is called as circle system, or this is called as closed circuit in anesthesia. ठीक है. अब ये वाला जो दिख रहा है, where only one mask is there, that is called as open circuit in anesthesia. लेकिन एग्जाम में जो पूछते हैं, एग्जाम लायक जो आता है, this is about semi closed circuit. सेमी क्लोज सर्किट में हमारे भाई का नाम क्या है जो सबको तंग करता है? भाई साहब हमारे, जिनको सब गाली देना चाहते हैं कि आपने इतने सारे यूजलेस सर्किट्स क्यों बनाए हैं, बिकॉज वी हैड टू स्टडी देम. यस, मेपल्सन भाई. ओके, सो दीज आर आर मेपल्सन सर्किट्स और सेमी क्लोज सर्किट. ठीक है. अब वी ऑल नो मेपल्सन सर्किट में वी हैव ए बी सी डी ई एफ. आई एम गोइंग टू आस्क यू गाइज ओनली question, 3 questions about Mapleson. Okay, first question about Mapleson. In children, which is the Mapleson circuit of choice for spontaneous or controlled ventilation? Very good. And this is one FMG question that they like to ask. It is a PYQ, so you should know the answer to this. In children, to have a child, you need to F. Okay, to have a child, you need to F. So any child you are using a Mapleson circuit, you will use Mapleson circuit F. Okay. Now please tell me what is the full name of Mapleson circuit F? Anyone knows the name? Scientist के नाम पे जो है, Jackson Reef circuit. Jackson Reef circuit. Okay. Now you have an adult patient. उसमें you have 2 types of ventilation. You have spontaneous ventilation and you have controlled ventilation. You have spontaneous ventilation and controlled ventilation. तो spontaneous ventilation में मुझे बताओ, your Mapleson circuit, which one is used in adults? Adults spontaneously like as. Okay, adults spontaneously like as. So In adults for spontaneous circulation, spontaneously as को मारते हैं ना, we use Mapleson circuit A. अब ये सब पूछ रहे होंगे मैम एस क्यों बोल रहे हो? A and S, that is why. एस से ज्यादा आस हो गया, एडल्ट A and S, आस. ओके, ऑलराइट. अरे यूट्यूब है तो बीप हो जाएगा, कोई बात नहीं. एंड एडल्ट्स इन कंट्रोल्ड सर्किट, इन एडल्ट्स फॉर कंट्रोल्ड सर्किट क्या हुआ? You are making a CD out of it. Okay, so you make a C and a D, Mapleson circuit D. So controlled ventilation in adults, we use Mapleson circuit D. Okay, Mapleson circuit A का दूसरा नाम बताओ फटाफट. Bain circuit? No, wrong. Wrong. Magel circuit. Mapleson A is Magel circuit. Mapleson circuit D का नाम? Circuit D is yes, Bain circuit. Okay, BAIN, Bain circuit. अच्छा, जो भाई साहब हमको पूछ रहे थे इंडिविजुअल फोटो से भी नाम पूछेंगे क्या मैडम? अब आई रियली होप कि नहीं पूछे. इट्स वेरी डिफिकल्ट टू आइडेंटिफाई द इंडिविजुअल मेपल्सन सर्किट. फिर भी मैंने एक दो फोटो डाली है तुम्हारे बेनिफिट के लिए कि अगर आ जाए तो तुम सिर्फ आंखें बंद करके याद रखो, जानवी मैम जय माता दी, जानवी मैम जय माता दी, ऐसे और आंसर दे दो, ठीक है. बट होपफुली ऐसा नहीं आएगा एग्जाम में. So you see over here, there is double tubing over here. डबल ट्यूबिंग, बाहर से प्लास्टिक की ट्यूबिंग है व्हाइट व्हाइट और अंदर से ग्रीन ट्यूबिंग है. जैसे तुम्हारी गर्लफ्रेंड होती है ना, बाहर से कुछ और अंदर से कुछ और. तो डबल डबल है, देख लो तुम, बाहर से प्लास्टिक और अंदर से ग्रीन कलर की गुड़िया. सो दिस वन इज मेपल्सन डी, मेपल्सन डी बेन सर्किट. वो कवरिंग की वजह से ना सब अलग दिखता है, मतलब मेपल्सन सर्किट में. ऑलराइट, एंड the other one that you can see over here, यहाँ पे छोटी सी बैग है, small bag, and then you have a small white tubing attached over here. ऐसे लंबी सी white tubing नहीं है, this is small short white tubing attached over here with a green oxygen tubing. This one, everything is small small, just like बच्चों में होता सब कुछ small small. बच्चों में और तुम्हारे लास्ट बॉयफ्रेंड में कैसे सब कुछ small small था, वैसे ही. So this is Mapleson F and this is called as Jackson-Reeve circuit. Mapleson F, Jackson-Reeve circuit. Okay. Now I am calling this Jackson-Reeve. हाँ, मैं इसको बुला रही हूँ Jackson-Reeve. इसका एक्चुअल नाम है Jackson-Reeve, but you know why I call it as Jackson-Reeve? ताकि आपको याद रहे ये F, Mapleson circuit F का नाम है Jackson-Reeve. Okay. All right. चलो. Now we go to the most important part. अभी बहुत सारे हमारे जोक्स हो गए, अभी important part करो एग्जाम के लिए. उसके पहले इंपॉर्टेंट पार्ट के पहले एक छोटा सा वीडियो देख लेते हैं. किसका वीडियो देखे? तुम्हारे सर्जरी वाले सर का. हैप्पी न्यू ईयर वरदान, हैप्पी 2026.
चलिए आदमी आ रहा है मेरे को कब से.
Tell Papa to take us out. New year, new place, new outing, new outing. Let's go out. Let's go gumi gumi. He said out. He said out. Yes. Let's go out. Out. Happy New Year 2026. Out.
No, this means no.
Eat your father if he's not taking us. Out. सर इज द बिगेस्ट होम बडी दैट यू विल सी एवर. सर को घर से बाहर जाना बिल्कुल पसंद नहीं. सर बोलते हैं घर से बाहर जाने में मुझे बहुत बोर होता है, बाहर जाके मुझे बोर होता है. सो सर एंड सर सन एंड मी आर उल्टा, हमको सिर्फ बाहर ही घूमना है बस. ऑलराइट, ओके, फाइन. चलो, next is this. What are we going to discuss now? We are going to discuss all your सर की क्लास कल है ना 8 घंटे की, मुझे बोला है उन्होंने, डिस्टर्ब नहीं करने को. चलो, अब now we are going to discuss oxygen delivery devices. In FMG exam, this is a very important question and सबसे important asked again and again, PYQ is oxygen delivery device number 1. Okay, तो मैं 1 2 3 4 मार्क करती हूँ, तुम लोग मुझे बोलते जाओ कि what is the oxygen delivery device and how much is the FiO2, maximum FiO2 और maximum oxygen percentage delivered by the device. Okay, तो नंबर 1 क्या है बताओ जल्दी. यस, नंबर 1 आंटी जो ऐसे खड़ी है, आंटी को याद मत रखो, रिमेंबर, ये मैंने एफएमजी में हमेशा बोलती हूँ मैं, इफ यू सी अ बिग बिग डब्बा, बड़ा सा डब्बा है, यहाँ पे बड़ी सी ट्यूबिंग्स है, मोटी मोटी ट्यूबिंग्स आ रही है एंड डायरेक्टली it ends into nasal cannula. So big dabba, big tubings and ending into nasal cannula. So this one over here is high flow nasal cannula. Okay. So this is HFNC. इधर लिखती हूँ मैं HFNC और high flow nasal cannula. High flow nasal cannula से हम लोग कितना दे पाते हैं? Any idea? What is the maximum FiO2 given? We can give 100% FiO2. I think इधर लिखा है, अच्छा इधर नहीं लिखा है, मैं लिख देती हूँ. ओके, नेक्स्ट वाला बताओ क्या है. व्हाट इज नंबर 2? यस, नंबर 2 ओवर हियर इज योर नॉर्मल नेजल कैन्युला. योर नॉर्मल नेजल कैन्युला और नेजल प्रोंग्स जो बोलते हैं, इसमें कितना दे सकते हैं मैक्सिमम? इसमें दे सकते हैं 40%. ओके, नाउ नंबर 3 दैट वी हैव ओवर हियर इज अ हडसन मास्क. हडसन मास्क, यस, फॉल्ट इन आवर स्टार्स वाला, बराबर. इन फॉल्ट इन आवर स्टार्स वो पहनता है ना नेजल कैन्युला, बराबर. सुशांत सिंह, दिल बेचारा, उसकी तो पुपड़ी बेचारी हो गई, इसलिए मैं तुम सबको बोलती हूँ गर्लफ्रेंड सोच समझ के चूज करो. Okay, now next one that we see over here is your Hudson mask. This Hudson mask is also called as simple face mask. इसको simple face mask भी बुलाते हैं. Any idea कि कितना है maximum FiO2? Maximum FiO2 is 60% over here. Okay, so this was called as your Hudson mask or simple face mask. Okay, next what you have over here is that you see there is a simple face mask with a bag attached to it. Okay, so this bag is attached to it, so this becomes NRBM, non-rebreathing mask, and this is also an FMG favorite to be asked again and again in the exam. Okay, so इसको हम लोग बोलते हैं NRBM. NRBM. And how much is the FiO2 delivered by this? Maximum FiO2 delivered by this is 80%. This is 80%. All right. Okay. Yes, आता है ना full form, तो फिर in your exam they will say non-rebreathing mask. NRBM नहीं डालेंगे in the exam, they will say non-rebreathing mask. तो ये याद रखो. Okay. Now what about number 5? A mask है which is tightly fixed to the patient's face and it is connected to the ventilator. Yes, so that is your NIV mask. NIV mask. And number 6 जो यहाँ पे दिखाई दे रहा है, this is oxygen helmet. Mostly ये नहीं पूछेंगे आपको exam में. So I am going to discuss only till number 5. Okay. So this is NIV or non-invasive ventilation mask. NIV or non-invasive ventilation mask. Okay. And this gives a maximum of 100% FiO2. Yes. Okay. So ये सब आ गए आपको. Oxygen delivery devices बोलते हैं इनको. Now the next thing that we'll discuss quickly is, हाँ अच्छा सॉरी, इधर मैंने बनाया हुआ था यहाँ पे टेबल of how much is the flow, oxygen flow that you will also give through the oxygen delivery devices. चलो, FMG का सबसे फेवरेट क्वेश्चन ये क्या है, इसको क्या बुलाते हैं? व्हाट इज द नेम ऑफ दिस एयरवे टेस्ट? पेपर लीक कर दो, हर ऑल्टरनेट एग्जाम में ये क्वेश्चन पूछा जाता है. हर ऑल्टरनेट एग्जाम में ये लोग मुंह खोल के दिखाते हैं ऐसे और फिर पूछते हैं जय माता दी, लेट्स रॉक, व्हाट इज दिस क्वेश्चन? Yes, this is your Malampatti classification. Malampatti classification में क्या करते हैं? You ask the patient to open his mouth wide and you see the structures on the back of the oral cavity. Okay. अब मलमपट्टी क्लासिफिकेशन याद रखने के बहुत सारे तरीके हैं, बट आई विल टीच यू वन इजी टेक्निक. सबसे पहले मुझे बताओ कि मलमपट्टी क्लासिफिकेशन इज यूज फॉर व्हाट? Yes, so Malampati, not intubate. Malampati tells you about the airway assessment. Airway assessment prior to surgery. Is it an easy airway or is it a difficult airway? Okay. Airway assessment, yes. Which one over here in Malampati classification is easy and which one is difficult airway? Batao jaldi. Malampati class, there are 4 classes. 1, 2, 3, 4. Out of this, class 1 and 2 is easy airway. Class 3 and 4 is difficult airway. Okay. ये easy हो गया, ये difficult हो गया. Now, how to identify this in the exam? Just look at the uvula. Uvula जो है उसको देखो. If the uvula is hanging freely, पूरा uvula आपको दिखाई अगर दे रहा है, uvula को uvula जैसे ही देखना है और कोई चीज की तरह नहीं देखना है, ठीक है? तो अगर पूरा uvula आपको दिखाई दे रहा है, from the base of the uvula, this is called as the base of the uvula, and this is called as the tip of the uvula. If the whole thing is being seen hanging freely, that means this is class 1. ओके. यूव्यूला का बेस इज सीन, बॉडी इज सीन, बट पीछे जो है वो टिप नहीं दिखाई दे रहा है. ओके. टिप ऑफ द यूव्यूला इज नॉट सीन, देन दैट इज कॉल्ड एज क्लास 2. देन class 3 is base is seen, but you can't see the body and the tip of the uvula. Okay. And class 4 means uvula is not seen at all. So basically what you see is class 1 is entire uvula is seen. Class 2 में tip of uvula is not seen. Class 3 में only base of the uvula is seen, body and tip is not seen. And class 4 में no part of the uvula is seen. Okay. So this is your Malampatti classification. अब अगर और कोई तरीके से याद रखना है, so you can also remember it like this. P is for palate. Palate means hard palate. Sorry. Sorry, not P is for not hard palate. P is for pillars. टॉन्सिल के जो पिलर्स होते हैं, टॉन्सिलर पिलर्स, उसको बोलते हैं पी. ओके, दिस इज योर टॉन्सिलर पिलर. टॉन्सिल के साइड के जो पिलर होते हैं, दैट इज पी. यू इज फॉर यूव्यूला. S and H, soft palate and hard palate. Okay, so this is how you guys can remember your parts or class of Malampatti. So in class 1, you can see push, tonsillar pillars, uvula, soft palate, hard palate. In class 2, you can see ush, uvula, soft palate, hard palate. In class 3, you can see only sh, soft palate and hard palate. And in class 4, you can see only hard palate. ठीक है? तो ऐसे भी आप याद रख सकते हो. और अगर आपको, if you guys want to remember from the tip of the uvula, from the picture that I showed you, full uvula hanging freely or the tip not seen, that is also the other way to remember. Okay. But till date, they have not asked anything about class 1, class 2, class 3, class 4. All they have asked is how does the, means what is this classification? Name is Malampatti classification. Bas. Okay. Fine. Now this is another airway assessment test that we do. You just have to identify the name of this airway assessment test. और कुछ नहीं. और ये NEET में आ चुका है. If it has come in NEET, that means there is a high chance it will come in FMGQ. Yes, so this one, where you can see your epiglottis, your arytenoids, and you can see your vocal cords and stuff. This is called as Cormack-Lehan grading. This is called as Cormack-Lehan grading. This is Cormack-Lehan grading. Okay, fine. Okay, now next, ये क्या है यहाँ पे? जल्दी बताओ, जल्दी. If someone is pressing over your cricoid cartilage, that is called as what, and what is it used in? Yes, so if someone is pressing over the cricoid cartilage, that is called as Sellick's maneuver. Sellick's maneuver. Okay, एग्जाम में पूछेंगे Sellick's maneuver is used in what? जल्दी बताओ, किस चीज में यूज करते हैं? It is used in rapid sequence induction. Yes, rapid sequence induction. तो अभी मुझे बताओ rapid sequence induction के steps क्या है? Rapid sequence induction is done when someone is not fasting for surgery, when someone is full stomach and there is a high risk of aspiration. So you want to stop the food from getting aspirated. Okay. So rapid sequence induction का first step क्या है? What is the first step in rapid sequence induction? First, you pre-oxygenate the patient. अच्छे से oxygen दे दो. Fill his lungs with oxygen. Then, after that, next thing, आफ्टर प्री ऑक्सीजनेशन आगे बढ़ो. ये मत बताओ 100% ऑक्सीजन इन 3 minutes, वो मुझे आता है, वो प्री ऑक्सीजनेशन है. फिर क्या करना है? देन यू अप्लाई सेलिक्स मनूवर. वेरी गुड. इन वन ऑफ योर जीटीज आई हैव एक्चुअली पुट द स्टेप्स वन आफ्टर द अदर ऑफ आरएसआई. ओके, सेलिक्स मनूवर और क्रिकॉर्ड प्रेशर देने के बाद क्या करेंगे? फिर यू गिव रैपिडली एक्टिंग IV induction agent plus muscle relaxant. Rapidly acting IV induction agent plus muscle relaxant. Okay. So ये कौन सा दोगे आप? Mostly we give propofol over here or ketamine, and in the muscle relaxant always remember it is succinylcholine, and अगर succinylcholine contraindicated है तो you will give rocuronium. Okay. चलो. Now next, you have given rapidly acting muscle relaxant and IV induction patients हो गया. Shall I bag mask ventilate the patient? No. In rapid sequence induction, bag mask ventilation is contraindicated. Bag mask ventilation is contraindicated. So remember this, that bag mask ventilation जब भी आप करने वाले होते हो, it can push air into your stomach and that can cause the food to come up, aspirate. Okay, so you avoid bag mask ventilation in this case. Okay, and number 5 में क्या करोगे? Intubate the patient with a cuff tube. Next is intubate with cuff tube. Okay, यहाँ पे I want to ask you guys one question. What is the gold standard method? And one very important question asked in FMG again and again. What is the gold standard method to confirm that you have correctly put the tube in the trachea? That you have correctly intubated the patient. You have done proper endotracheal intubation. Gold standard method is capnography. Okay, chalo. Number 1, number 2, number 3. What are these positions in anesthesia? And where is it used? Okay, number 1 is ramp position. Where do we use it? यहाँ पे slope जैसे दिख रहा है. Ramp is used for intubation in obese patients. Intubation in obese patients. Okay. Number 2 position का नाम क्या है? Number 2 position, if you are seeing that there is one pillow below the head and one below the shoulder, ऐसा extra extension दे रहा है, so this is called as rose position. Rose position कहाँ पे use करते हैं हम लोग? Rose position कहाँ पे use करते हैं? Thyroid surgery, tonsillectomy में, yes, okay, all of those. Fine. Then what is the normal position that you give for intubation? अगर exam में पूछा जाए, ऐसा position है you give for intubation, what is the name of that position? That is called as sniffing position. Okay, fine. Number 3 position is given when you're shifting an unconscious patient. When you're shifting an unconscious patient. Unconscious matlab he is alive, pulse is present, breathing is present, but he is unconscious. ठीक है, बेहोश है सिर्फ, मरा हुआ नहीं है, बेहोश है. So you're shifting the unconscious patient. This is called as recovery position, and this has been asked 2 times in NEET PG exam. Recovery position. ठीक है, ऑलराइट. या मरा नहीं है, सिर्फ बेहोश है. जैसे तुम्हारे सॉक्स की गंदी बदबू सुन के आजू बाजू वाले लोग बेहोश हो जाते हैं, दैट इज बेहोशी, मरते नहीं है उससे. ओके, ऑलराइट. नाउ क्विकली टेल मी व्हाट इज पोजीशन ए. आई एम नॉट गोइंग टू राइट, यू हैव टू टेल मी. पोजीशन ए, पेशेंट इज लाइंग डाउन. व्हाट इज दिस? सुपाइन पोजीशन. ओके. पोजीशन पी, पेशेंट्स हेड इज डाउन. Very important, this is Trendelenburg and I'm writing it only because it has been asked in FMG exam many times. ठीक है, सर नीचे है तो Trendelenburg. सर झुका के रखो, ट्रेंड आजकल वही है, Trendelenburg वही है, सर झुका के रखो. ओके, फाइन. व्हाट अबाउट सी, पोजीशन सी, सर ऊपर है. Yes, so this is called as reverse Trendelenburg. This is called as reverse Trendelenburg position. ओके, सर ऊपर पैर नीचे. फाइन. पोजीशन डी, पोजीशन डी गायनेक में देखते हैं, दिस इज कॉल्ड एज लिथोटमी पोजीशन. पोजीशन ई, एक साइड पे बंदा लेटा हुआ है, दिस इज कॉल्ड एज Position E is lateral position. Now, is this right lateral or left lateral? Jaldi batao. Right or left lateral? Which side is down? Right side is down. So this is a right lateral position. Okay, whichever side is down, वो position है. Position F कौन सा है? Right lateral में if you have a break in the table, right lateral में break in the table, this is kidney position. Okay. Position H, G छोड़ दो. Position H, patient is sleeping on his face. This is called as prone position. आजकल मेरा बेटा ये position में सोता है रात को, prone position में. Okay. What about position I? Patient is just sitting, जैसे गोवा में बीच पे बैठे हुए हैं ऐसे. Yes, गोवा में बीच पे जो बैठे हुए हैं इसको बोलते हैं बीच चेयर पोजिशन. जाओगे ना सब लोग गोवा FMG पास होके, दो जगह ही जाते हैं, या फिर गोवा जाते हैं या फिर मनाली. दो जगह पे ही वैसे भी काम की चीजें मिलती है ना, तो उधर ही जाते हैं फिर सब लोग. Yes, so this is called as beach chair position or Fowler's position. Okay, or sitting position. Fine. थाईलैंड के बजट वाले लोग नहीं है यहाँ पे, सारे पैसे तो क्लासेस में खत्म हो गए है ना. गोवा में सेरेबेलम, तो तुमको गोगा सर को बोलना चाहिए था. दिस वाज अ गुड आइडिया, गोवा में सेरेबेलम. फाइन. So this is Fowler's position or sitting position or beach chair position. Now in the exam if they ask you what is the complication associated with prone position, तो क्या है एग्जाम आंसर? वैष्णो देवी एकदम सही जगह है जाने के लिए. Yes, so in prone position, what can happen is you can get injury to the eye. Okay, if they say that what is the main complication associated with beach chair position or sitting position, क्या है आंसर? Main complication associated with sitting or beach chair position, it is venous air embolism. Yes. गोवा जाओगे तो ऐसे एंजॉय करोगे. वैसे तो मैंने डाला है गोवा की फोटो. हम उसको सब काम की जगह पे लेके जाते हैं क्योंकि हमको पता है कि आगे जाके भी ये गोवा ही जाने वाला है, इसलिए इसको एक एक गली वाकिफ कर देते हैं. ओके, चलो. हाँ, हमने इसको सब इम्पोर्टेंट भी सिखा दिया है, देखो. ये देखो, स्ट्रैटेजी लाइफ में सक्सेसफुल होने की यही होती है. दिस इज कॉल्ड स्टार्टिंग सॉलिड्स. ओके, चलो. Now, next is this. So, this is regional anesthesia and this question has been asked in NEET exam. तो NEET exam में number 2 का फोटो दिया था और यहाँ पे देखो क्या क्या है. And they had asked what is this? Simple question पूछा था. So, you have a double cuff tourniquet attached. Double cuff है, ऐसे कैसे पता चलेगा? There are 2 manometers for the cuff. And they will show you that there is one IV line and IV line में से we are giving local anesthetic. तो local anesthetic का नाम इधर दिया है lignocaine. And ये लोग ने क्या बोला? Identify what is this regional anesthesia technique. Yes, so this is called as Bayer's block. This is called as Bayer's block, or this is also called as intravenous regional anesthesia. Intravenous regional anesthesia. Okay, अब मुझे एक दो चीजें बताओ कि in this intravenous regional anesthesia, what are the local anesthetics that you will use? कौन से यूज करोगे? We will use lignocaine and prilocaine. Which one is avoided? Bupivacaine, because it is cardiotoxic. ठीक है. In which conditions is Bayer's block contraindicated? ये मत बोलना हाथ नहीं है या पैर नहीं है तो Bayer's block is contraindicated. ठीक है. Bayer's block is contraindicated in case of any peripheral vascular disease like Raynaud's disease या sickle cell anemia अगर patient को होगा तो. ठीक है. और if you're going to have a long duration surgery, you have to keep the tourniquet on for more than 1 hour. So bias block, local anesthetic allergy, infection at the site where you're going to give the injection, all those normal things. But mainly Raynaud's disease, sickle cell anemia, PVD में avoid bias block. Okay. ऊपर वाला बताओ, number 1, what is this type of regional anesthesia technique? Yes, so this you are going to give an injection over here in the sacral area to the child, और ये sacral area का opening जो होता है, opening from where you give the injection, that is called as sacral hiatus. Sacral hiatus, उसमें से you will give one injection that is called as your caudal anesthesia. That is called as your caudal anesthesia. Caudal anesthesia. Okay, so caudal is given in children. And how you give it? You give an injection through the sacral hiatus. Alright? बस इतना ही पूछेंगे. I don't think आपको और पूछेंगे. सिर्फ children में देते हैं. अब question asked in FMG exam again and again and again. What is number 1? Already लिखा है actually. What is number 1? So number 1 कैसे identify करना है? You have to see that there are two wings. There are two wings to hold this needle. And ये needle में alternate light and dark markings हैं. Okay? So if you have something to hold, two wings, and there is alternate light and dark marking, then this is your 2-Hoy epidural needle. 2-Hoy epidural needle used for epidural anesthesia. Okay? Then, if you see there is a simple straightforward needle. Lumbar puncture कितने लोगों ने किया है? Lumbar puncture की needle ऐसे दिखती है. Simple stainless steel needle with a transparent hub over here. This one is called as your Quincke spinal needle. Quincke spinal needle. Okay? Got it? Everyone understood? Yes. So this is your spinal needle. Fine. Then what you have to understand is this. Okay. Now this one over here that you see, this is your epidural needle. So you see alternate light and dark markings and you see your wings. So this is your epidural needle and this is your LOR syringe, loss of resistance syringe. इतना कोई नहीं पूछेगा, जाने दो. But यहाँ पे epidural का catheter है. This catheter, the patla catheter that you can see is epidural catheter. Okay, so this is your epidural set. इसको हम लोग बुलाते हैं epidural set. To put a catheter in the epidural space. और ये जो है ये आपका epidural catheter होता है, पतला वाला. Alright? Yes. So if you are able to identify only spinal needle and epidural needle also, this is more than enough. Don't worry. Okay. Now next. Very important. What are the structures pierced from outside to inside while giving spinal anesthesia? ठीक है? तो ये you should know. कौन सा है वो अपना श्रीकांत सर का Ilidas, SSS Ilidas, correct? SSS ILEDAS, structures pierced while giving spinal anesthesia or while performing lumbar puncture. Okay, तो अभी SSS में क्या है? S is for skin subcutaneous tissue, skin subcutaneous tissue, and this one is supraspinous ligament. Okay, I is interspinous ligament, L is ligamentum flavum, and E is epidural space. D is dura mater, A is arachnoid mater, and then finally S is your subarachnoid space where we give the spinal anesthesia. Yes, I know your आप सबके फेवरेट है श्रीकांत सर. Okay, fine. अब मुझे इसमें बताओ, मैं आपको सिंपल क्वेश्चन पूछूं. What is the last structure pierced while giving spinal anesthesia? Last structure pierced while giving spinal anesthesia, arachnoid mater. Very good. In which space do we give spinal anesthesia? In which space do we give spinal anesthesia? Subarachnoid space. In which space do we perform lumbar puncture? Lumbar puncture is also performed in subarachnoid space. Okay, in which space? What is the last structure pierced while performing epidural anesthesia? Last structure pierced while performing epidural anesthesia? Ligamentum flavum. ठीक है. So ये important questions है. They can ask you about spinal and epidural. Okay. अब एक simple question पूछती हूँ. Someone is undergoing a surgery, LSCS, lower segment cesarean section. What anesthesia do we prefer for LSCS? Normal elective LSCS. What is the anesthesia preferred? Spinal anesthesia. ये please याद रखो. If they ask you LSCS cesarean section के लिए कौन सा anesthesia देते, it is always spinal. ठीक है? Short acting surgery is also only 45 minutes to 1 hour, and it gives good anesthesia, and patient is awake during surgery, so she can hear her child when the child is born, hold her child when the child is born. Okay, do skin to skin contact. इसलिए we prefer spinal anesthesia. Okay, fine. अब अगर यहाँ पे कोई needle खोद रहे होंगे, if they are putting some needle over here and asking you what block is being given over here, then what is the answer? अरे सेंट्रल वेनस कैन्युलेशन नहीं, मैं ब्लॉक पूछ रही हूँ. ब्लॉक, सम नीडल इज गोइंग ओवर हियर एंड दे से वी आर गिविंग अ ब्लॉक. व्हाट इज द ब्लॉक? विच ब्लॉक? यहाँ पे कौन सा प्लेक्सस है ऑफ नर्व्स? इट इज ब्रेकियल प्लेक्सस. यस, इट इज ब्रेकियल प्लेक्सस ब्लॉक. If they are putting any needle over here in the neck and asking which block is being given, remember it is brachial plexus block. Okay. अब आपको they won't ask you the ultrasonographic images, बहुत ज़्यादा difficult हो जाएगा for brachial plexus block. But let me give you a case scenario like this. So they give you a case scenario, and this is very common. In fact, it can come in your exam this time. I'm leaking the paper. So they ask you this question. There is a patient who is receiving a brachial plexus block with 0.5% lignocaine. Suddenly, patient starts complaining of tinnitus and perioral numbness and tingling, and patient is getting arrhythmias, cardiac arrest, seizures. What is the problem and what is the treatment? Yes. So block time. If your patient starts getting tinnitus, perioral tingling and numbness, headache, metallic taste in mouth, and seizures or cardiac arrhythmias leading to cardiac arrest, the patient is getting local anesthetic systemic toxicity. Local anesthetic systemic toxicity. Okay, treatment क्या है local anesthetic systemic toxicity का? It is 20% intralipid. Okay, तो इधर लिख देती हूँ last. Treatment of last is IV, intravenous 20% intra. Okay, fine. Up, name the following. We'll be discussing about all the important one-liners about the drugs in anesthesia. Okay. So first, what are the 4 IV induction agents that you guys know of? 4 IV induction agent कौन से हैं? Thiopenton, propofol, ketamine and चौथा कौन सा है? Etomidate. बराबर. Thiopenton, propofol, ketamine और etomidate. ठीक है? Okay. So question number 1, which is the barbiturate used as an IV anesthetic agent? Barbiturate used as an IV anesthetic agent? It is thiopenton. Okay. Which is the preferred IV induction agent for neurosurgery? Neurosurgery, we prefer which IV induction agent? Thiopenton, because it is anti-epileptic. Anti-epileptic. Okay. Accidental intra-arterial injection of which drug causes vasospasm and patient starts shouting, ah, ah, vasospasm ho gaya. Accidental intra-arterial injection of thiopenton causes intense vasospasm. Okay. Which IV anesthetic is not used in patients with egg allergy? It is propofol. Okay. Which IV anesthetic should be discarded if kept open for more than 6 hours? Propofol, क्योंकि उसमें बैक्टीरिया जमा होंगे. Which is, ये बहुत important question है. Which IV anesthetic agent is most used in daycare anesthesia? Propofol, very good. Which IV anesthetic agent is contraindicated in porphyrias? Porphyria में thiopenton is contraindicated. Yes. Which IV anesthetic agent causes adrenal suppression? Again, very important. Exam में ये पूछा था ये. Adrenal suppression होगा तो which IV anesthetic is avoided? Etomidate. It causes adrenal suppression leading to reduced steroid production. Okay. Which is the most cardiostable IV induction agent? It is etomidate. Very good. Okay. Which IV anesthetic causes hallucinations and post-op delirium? Ketamine. Okay. Emergence delirium is caused with what? Emergence delirium is caused with what? Ketamine. Okay. What is the other thing that ketamine causes? Emergence delirium and dissociative anesthesia. ये याद रखना बहुत important है. पूछते हैं एफएमजी में, डिसोसिएटिव एनेस्थीसिया इज कॉज्ड बाय व्हाट? डिसोसिएटिव एनेस्थीसिया इज कॉज्ड बाय ketamine. Okay, which is the most painful IV induction agent? Most painful IV induction agent, propofol. IV induction agent that increases the intracranial pressure and the intraocular pressure, ketamine. Okay. IV induction agent which is the best bronchodilator used in asthma. Best bronchodilator used in asthma. It is ketamine. Okay. IV induction agent that is the best in hypotension, bleeding or shock. It is ketamine. Okay. Hypotension, bleeding or shock, it is ketamine. All right. Fine. Okay, now let's go to our inhalational anesthetic, inhalational agents. अभी inhalational agents में नाम बताओ सबके. Red color vaporizer as halothane, yellow color vaporizer as sevoflurane. Then you have purple color vaporizer, isoflurane, and finally you have blue color vaporizer, that is desflurane. Okay, chalo. Which gas causes second gas effect or diffusion hypoxia? बहुत इंपॉर्टेंट क्वेश्चन है, बहुत बार पूछते हैं एफएमजी में. Which gas causes second gas effect or diffusion hypoxia? Nitrous oxide. Nitrous oxide. Okay. Which gas is contraindicated in closed cavity surgeries? Should not give in closed cavity, otherwise it will diffuse and cause increase in pressure of closed cavity. Again, nitrous oxide. Which और सबसे फेवरेट क्वेश्चन पूरा जितना भी पढ़ा है उसमें सबसे फेवरेट क्वेश्चन एफएमजी का. Which gas is preferred for inhalational induction in children? It is sevoflurane. Sevoflurane. Okay. Which gas is preferred for induction in obese patients? में कौन सा गैस दोगे for induction? Desflurane. Okay, desflurane. Okay. Which gas? अच्छा, एक और FMG का एक और favorite. Which gas has the lowest blood gas partition coefficient? Desflurane. कितना है इसका blood gas partition coefficient? कितना है? 0.45. 0.45. Which gas is preferred for induction in asthmatic patients? Asthmatic patients में sweet smelling gas prefer करते हैं sevoflurane. Okay. Which gas causes liver damage? Halothane hepatitis. Halothane hepatitis. Which gas is preferred for induction in neurosurgery? Not cardiac surgery. Neurosurgery and liver surgery. It is isoflurane. Okay. Which gas is preferred for induction in daycare surgery? ये important. Daycare surgery. Sevoflurane. Okay. Sevoflurane. Fine. Okay. Then you have your agents and their MAC. अब MAC आज तक पूछा नहीं गया है, but FMG एग्जाम में क्या पूछेंगे? They will not ask you the absolute values of MAC. वो लोग बोलेंगे arrange in order of lowest to highest MAC और arrange in order of highest to lowest MAC. Okay, तो वो शंकर इज आस्किंग मी मैम मैक कैसे याद रखे. मैंने बहुत अच्छे निमोनिक्स दिए हैं. आई कांट डिस्कस इट ओवर हियर बिकॉज बहुत टाइम लग जाएगा, बट यू कैन इवन गो ऑन यूट्यूब एंड पुट मैक निमोनिक जानवी से, तो आपको आ जाएगा. ओके, सो हैलोथेन का मैक है 0.75, सीवोफ्लोरेन का 2, डेस्फ्लोरेन का 6, आइसोफ्लोरेन का 1.4 एंड नाइट्रस ऑक्साइड इज 104. आई हैव गिवन निमोनिक्स फॉर ऑल ऑफ these to be remembered in the exam. But remember, in the exam, what they will definitely can ask you is arrange in the order of increasing MAC or arrange in the order of decreasing MAC. Directly नहीं MAC पूछेंगे, increasing या decreasing MAC पूछेंगे. Okay, मुझे से बता दो which is the gas with the highest MAC, gas with the highest MAC and gas with lowest potency. Gas with highest MAC is nitrous oxide 104. Gas with lowest potency is again nitrous oxide. High MAC means low potency. Okay, which is the gas with the lowest MAC? Methoxyflurane. Ideally तो methoxy है 0.016. नहीं sorry 0.16, 0.16. बट अगर ऑप्शंस में नहीं दिया है, ये सब में से दिया है, तो लोएस्ट मैक आएगा हैलोथेन का. ओके फाइन. फाइन, नाउ वी टॉक अबाउट द न्यूरोमस्कुलर ब्लॉकिंग एजेंट्स या फिर मसल रिलैक्सेंट्स. तो न्यूरोमस्कुलर ब्लॉकिंग एजेंट्स में बताओ व्हाट इज द शॉर्टेस्ट. पहले तो दो टाइप के हो जाते हैं, डीपोलराइजिंग एंड नॉन डीपोलराइजिंग. व्हाट इज द एग्जांपल फॉर डीपोलराइजिंग एजेंट? डीपोलराइजिंग एजेंट का एग्जांपल कौन सा है, जल्दी बताओ. कितने स्लाइड बाकी है हमारे? 17 स्लाइड्स फटाफट करने हैं हमको। मैडम की क्लास कितने बजे है? पूजा मैडम की क्लास 5 बजे, ओके ठीक है। तो नहीं, हमको उसके पहले ही खत्म करना है विद द 15 मिनट ब्रेक। ओके, तो शॉर्टेस्ट एक्टिंग डीपोलराइजिंग न्यूरोमस्कुलर ब्लॉकिंग एजेंट में आ जाता है सक्सेनाइल कोलिन, या फिर उसका पेट नेम है कोलिन। ओके, देन यू हैव योर नॉन डिपोलराइजिंग न्यूरोमस्कुलर ब्लॉकिंग एजेंट्स, जहां पे हमारा आता है रॉकिरोनियम, वेकिरोनियम, एट्राक्यूरियम, सेसाट्राक्यूरियम। ओके, सो बहुत इंपॉर्टेंट चीज एक करवा देते हैं यहाँ पे, व्हाट इज द शॉर्टेस्ट एक्टिंग न्यूरोमस्कुलर ब्लॉकिंग एजेंट? What is the shortest acting overall? Succinyl choline. Okay, barabar. But if they ask you in the exam, what is the shortest acting non-depolarizing? ओवरऑल में सक्सिनाइल कोलिन है। अगर नॉन डिपोलराइजिंग में पूछते हैं तो शॉर्टेस्ट एक्टिंग नॉन डिपोलराइजिंग कौन सा हो जाता है? मीवाक्यूरियम। वेरी गुड। ओके, व्हाट इज द फास्टेस्ट एक्टिंग ओवरऑल न्यूरोमस्कुलर ब्लॉकिंग एजेंट? ओवरऑल अगेन इट इज सक्सिनाइल कोलिन, इसका शॉर्ट फॉर्म लिख रही हूं मैं। बट इफ दे आस्क यू फास्टेस्ट एक्टिंग नॉन डिपोलराइजिंग न्यूरोमस्कुलर ब्लॉकिंग एजेंट, तो इसका नाम क्या होगा? इसका नाम होगा रॉक्यूरोनियम। रॉक्यूरोनियम, ओके। Rocuronium, R for rocuronium, R for rapidly acting. Okay, fine. Neuromuscular blocking agent that causes fasciculations should be avoided in patients with burns, muscular dystrophy, and malignant hyperthermia. Which neuromuscular blocking agent is contraindicated in malignant hyperthermia? ये क्वेश्चन आ सकता है एग्जाम में। Which neuromuscular blocking agent is contraindicated in malignant hyperthermia? Succinyl choline. Okay. In which electrolyte abnormality will you not give succinyl choline? If your patient has hyperkalemia, agar already potassium levels are high, you will avoid giving succinyl choline. Okay. What is the longest acting neuromuscular blocking agent? Pancuronium. Pancuronium. अब very important question. मेरी बात सुनो. There is a neuromuscular blocking agent or a muscle relaxant, जो भी है, which is given to the patient. Patient starts getting full rash, redness on the face, itching, urticaria, and hypotension. What is the muscle relaxant given to the patient? Itching हो रहा है, histamine release हो रहा है, rash हो रहा है, hypotension हो रहा है, atracurium is given to the patient. Alright. So ये question पूछा था NEET में ये time. Okay. Cisatracurium नहीं होगा. Cisatracurium does not cause histamine release. Okay. Which is the neuromuscular blocking agent that undergoes Hoffman's elimination? Hoffman's elimination या अपने आप से हो जाता है degrade. It is atra and cisatra both. Now, super duper 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 important question. If you ask me, ma'am, paper leak कर दो, this is paper leak कर दो question. A patient has been given rocuronium or vecuronium, and now the patient is not able to breathe. You can't intubate the patient. How can you immediately reverse the muscle relaxant? How can you immediately reverse rocuronium or vecuronium action? Answer is Sugama Dix. Immediate reversal of rocuronium or vecuronium. What is the normal reversal agent for non-depolarizing agents? Normal reversal agents. Neostigmine and glycopyrrolate. Neostigmine and glycopyrrolate. ठीक है? What is the neuromuscular blocking agent preferred in daycare surgery? Rocuronium and Sugama Dix. And what is the most commonly used nerve for clinical monitoring of neuromuscular blockade? How do you know whether patient? अच्छा, इसकी फोटो आई थी आपके यहाँ पे अभी. FMG का ये है ना अपना PYQ. एक फोटो दी थी मॉनिटर की. It is attached to the thumb and there are two leads attached over here to the hand. And ये पूछा था कि ये क्या है. So ulnar nerve पे you are doing train of 4 on neuromuscular monitoring. फोटो सबको याद है? फोटो सबको याद है या नहीं? ऐसा फोटो था. ये पूछा गया था एग्जाम में. करेक्ट? Yes, so this is your train of 4 on neuromuscular monitoring done to see whether patient is still under muscle relaxant, paralyzed or not. Okay, चलो. अब ये local anesthetics के बारे में. Which is the first ever local anesthetic used? थोड़े local anesthetic के नाम बताओ. Cocaine, prilocaine, lignocaine, bupivacaine, benzocaine. Fine. अब मुझे बताओ इसमें से अमाइड लोकल एनेस्थेटिक कौन सा है? आई एम गिविंग यू 4 ऑप्शंस. कोकेन, लीवोब्यूपीवाकेन, ब्यूपीवाकेन एंड लिग्नोकेन. इसमें से which is amide local anesthetic? Yes, if only one eye is present, if only one eye is present, they are all esters. So cocaine over here was ester. If two eyes are present, then it is amide. Okay, so lignocaine, bupivacaine, levobupivacaine, all of these were amides. Okay, so amides have an extra eye. Amides have an extra eye. Okay, esters and amides में amides have an extra eye. So इसमें आ जाएंगे आपके कोकेन, प्रोकेन, और इसमें जो है आपका आ जाएगा प्राइलोकेन एंड ब्यूपीवकेन, ये सब. ऑलराइट, फाइन. चलो, व्हाट इज द फर्स्ट एवर लोकल एनेस्थेटिक यूज्ड? Cocaine. What is the only naturally derived local anesthetic having a sympathomimetic effect? Same, cocaine. Most commonly used local anesthetic, lignocaine. Lignocaine का safe dose क्या है? अगर plain lignocaine है तो it is 5 mg per kg. If it is lignocaine plus adrenaline, it is 7 mg per kg. अब very important question in the exam. Emla cream contains what local anesthetic? Emla, eutectic mixture of local anesthetic, contains lignocaine and prilocaine. Very good. It contains 2.5% lignocaine, 2.5% prilocaine. अब मुझे ये बताओ, which is the most cardiotoxic local anesthetic? एग्जाम में अगर पूछा गया which is the most cardiotoxic local anesthetic, most cardiotoxic is bupivacaine. Okay, very good. All right. Now identify this condition. Patient has been given general anesthesia with, ये भी पूछा गया है recently आपके last exam में ही. Favorite question है मलम पट्टी, M for मलम पट्टी, M for malignant hyperthermia. Patient is given inhalational anesthetic agent and succinylcholine. Suddenly his carbon dioxide levels start going up. ऐसा आ जाता है step ladder pattern of EtCO2. हाइपरथर्मिया हो जाता है पेशेंट को, मसल रिजिडिटी हो जाती है, मसल्स एकदम टाइट हो जाती है, मसल रिजिडिटी. व्हाट इज द कंडीशन? सो द कंडीशन इज मैलिग्नेंट हाइपरथर्मिया. मैलिग्नेंट हाइपरथर्मिया का जेनेटिक इनहेरिटेंस क्या है? ऑटोसोमल या फिर एक्स लिंक्ड? ऑटोसोमल डोमिनेंट. ओके, विच क्रोमोसोम इज अफेक्टेड? क्रोमोसोम 19. कौन सा जीन अफेक्टेड है उस पे? राइनोडिन रिसेप्टर 1 जीन. राइनोडिन रिसेप्टर 1 जीन. Ryanodin receptor 1 gene. Okay. Or what is the treatment? Treatment बताओ. Yes. So the treatment is dantrolene sodium. Treatment is dantrolene sodium. Okay. So this is about your malignant hyperthermia. Dantrolene तो तुमको आना चाहिए, हम 100%. Okay. अब ये क्या है? You have given one block to the patient and patient is getting seizures and patient is getting arrhythmias, metallic taste in the mouth, tinnitus, headache, all of that, nausea, vomiting. This is local anesthetic systemic toxicity. Local anesthetic से हुआ है. Treatment क्या है? IV 20% intralipid. Okay. सिलेंडर से बताओ क्या है गैस अंदर? सिलेंडर के अंदर क्या है? Number 1. Blue color cylinder has nitrous oxide. There is no nitric or nitrogen oxide in anesthesia. तो याद रखो nitrous oxide ही है. मैं क्या दिख रही हूँ आज मैं क्या दिख रही हूँ? Black body with white shoulder. क्या दिख रही हूँ मैं? Oxygen cylinder. Black body with white shoulder. आज मैं दिख रही हूँ oxygen cylinder. Alright? Okay. Gray color cylinder क्या है? This is carbon dioxide. ग्रे कलर में है कार्बन डाइऑक्साइड. चलो, ये क्या है? सही होल में सही पिन घुसना चाहिए. व्हाट इज दिस? सही होल में सही पिन घुसना चाहिए. व्हाट डज दैट मीन? दिस इज पिन इंडेक्स सिस्टम टू प्रिवेंट इनकरेक्ट अटैचमेंट ऑफ सिलेंडर टू द एनेस्थीसिया मशीन. और कुछ मत सोचो, एनेस्थीसिया मशीन में सिलेंडर गलत नहीं लगना चाहिए. ओके, चलो, पिन इंडेक्स सिस्टम में पिन बताओ और गैस बताओ. Who's our man? We have to remember. Yes, we have to remember A con, A for air, O for oxygen and N for nitrous oxide. फाइन. तो इसका क्या है पिन इंडेक्स 1,5, ऑक्सीजन का 2,5, नाइट्रस ऑक्साइड का 3,5, 1,5, 2,5 एंड 3,5. ओके. नाउ कलर कोडिंग ऑफ पाइपलाइंस में बता दो. एयर पाइपलाइन का कलर क्या है? एयर पाइपलाइन, एयर हमारी सब AQI 500, 600, 800 के ऊपर है, तो एयर तो हमारी एकदम पॉल्यूटेड है, ब्लैक है. ऑक्सीजन पाइपलाइन का कलर क्या है? व्हाइट. नाइट्रस ऑक्साइड का कलर क्या है? ब्लू. और वैक्यूम का कलर है येलो. वैक्यूम का कलर है येलो. ओके, सो ब्लैक, व्हाइट, ब्लू एंड येलो, दीज आर द कलर ऑफ द पाइपलाइंस. ओके, फाइन. अब प्री एनेस्थीसिया ऑर्डर्स रिगार्डिंग मेडिकेशन तो हो चुका है ऑलरेडी. अब CPR के बारे में वेरी क्विक. सो CPR के बारे में दे आस्क लॉट ऑफ क्वेश्चंस अबाउट हाई क्वालिटी CPR. ये एग्जाम में बहुत इंपॉर्टेंटली पूछते हैं. यस. हाँ, तो हाई क्वालिटी CPR का क्वेश्चन नंबर ये सब आना चाहिए. अब आई एम गिविंग समवन CPR. व्हाट इज द रेट ऑफ चेस्ट कंप्रेशन इन एडल्ट्स? Rate of chest compression in adults 100 to 120 chest compressions per minute. What is the chest compression to ventilation ratio in adults? Chest compression to ventilation ratio in adults is 30:2. In children कितना है? In children अगर दो रेस्क्यूअर है, अगर मैं हूं और सचिन प्रकाश है, okay, if two people are rescuing the child, then the chest compression to ventilation ratio is 30:2. Okay, but if there is only one rescuer, सिर्फ मैं बचा रही हूँ, सचिन प्रकाश भाग गया है from the scene, so in that case the chest compression to ventilation ratio, sorry, if there is one rescuer, then chest compression to ventilation ratio is 30:2. And if there is more than one, if there are two rescuers, ज्यादा लोग हैं, तो chest compression to ventilation ratio is 15:2. Okay, उल्टा बता दिया मैंने आपको. Okay, neonates less than 28 days में कितना होता है chest compression to ventilation ratio? 3:1. Okay, what is the depth of chest compression in adults? कितना deep, धपा धप धप, कितना deep press करना है? Okay, in adults it is 5 to 6 centimeter या फिर 2 inches. ठीक है, याद रखो 5 to 6 centimeter या 2 inch बस है लाइफ में. Okay, but in children what is the chest compression to ventilation ratio? In children you can't say na 2 inch या 5 to 6 centimeter. तो children में you have to say 1/3 of the AP diameter, 1/3 of the antero-posterior diameter. Okay, fine. Then if they ask you कि हाँ अभी रास्ते पे एक आदमी पड़ा हुआ है, तुम जाते हो, तुम उसके बाजू में देते हो बैक पाइपर का एक इतना बड़ा बॉटल पड़ा है. ठीक है, अब व्हाट आर योर स्टेप्स दैट यू विल डू? व्हाट इज द फर्स्ट स्टेप? वेरीफाई सीन सेफ्टी. रास्ते के बीच में पड़ा है, उसको साइड में लेके आओ. ओके, बॉटल रहने दो बीच में, बॉटल काम की नहीं है, खाली है, कुछ फायदा नहीं है. नेक्स्ट व्हाट विल यू डू? यू विल चेक फॉर रिस्पॉन्स. यू विल चेक फॉर रिस्पॉन्स. काका मामा आंखें खोलो. If there is no response, then number 3, you will call for help. Help, 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 help. Okay. Now, once you have called for help, then you have to check his pulse. And pulse कौन सा check करोगे? Central pulse, that is the carotid or femoral, for 10 seconds. Pulse को 10 seconds से ज़्यादा या कम नहीं check करना है. Okay. And also look for respiration. Breathing, chest movements है या नहीं. If there is no pulse and no respiration, then you will start CPR. CPR 30:2 के रेशियो में you will start chest compression, ventilation you will give. Now let's say that the ambulance arrives. Ambulance अगर आ जाती है तो सबसे पहले क्या करना है? एम्बुलेंस आ गई तो सबसे पहले क्या करना है? भाग जाना है? नहीं, कंटिन्यू गिविंग चेस्ट कंप्रेशन. टेल द डॉक्टर यू पुट द डिफिब्रिलेटर पैड. डिफिब्रिलेटर पैड लगाओ. ओके, अब ये है डिफिब्रिलेटर, ये वाला तो है मैनुअल डिफिब्रिलेटर, और ये वाला जो आपको साइड में दिखाई दे रहा है इसको बोलते हैं AED, ऑटोमेटेड एक्सटर्नल डिफिब्रिलेटर. AED, ऑटोमेटेड एक्सटर्नल डिफिब्रिलेटर. तो स्टेप लैडर वाले ऐसे ही है, काम बीच में छोड़ के निकल जाओ. पेशेंट अभी तक बचा नहीं है, तुम डॉक्टर पे डाल के चले जाओ. ओके, फाइन. सो इसमें पूछते हैं ऑटोमेटेड एक्सटर्नल डिफिब्रिलेटर में कि where do you put the AED pads? So the AED pads, one pad is put in the parasternal area. कौन सा parasternal? Right parasternal area. And one pad is put at the apex of the heart. ये left side है ना, apex of the heart. One pad is right parasternal, one pad is apex of heart. ओके चलो, उसके बाद क्या करेंगे, शॉक जो देंगे हम लोग, वो शॉक एनर्जी कितना होगा, मतलब बाईफेजिक और मोनोफेजिक का डिफरेंस पता है? मुझे इतना यूट्यूब यूट्यूब का सुना रहे हो, तुमको बाईफेजिक और मोनोफेजिक का डिफरेंस पता है? यस, सो मोनोफेजिक में यू विल गिव मोनोफेजिक डिफिब्रिलेटर में यू विल गिव 360 जूल्स। बाईफेजिक अगर है डिफिब्रिलेटर, एक तरफा प्यार नहीं, दो तरफा प्यार में कम प्यार लगता है। ओके एक तरफा प्यार मोनोफेजिक, तो तुमको ज्यादा प्यार देना पड़ता है, 360 जूल्स। ओके एंड दो तरफा प्यार होगा तो थोड़ा कम लगता है, दूसरा वाला भी थोड़ा बहुत कॉम्पेंसेट कर लेता है। सो यू गिव 150 to 200 जूल्स बाईफेजिक डिफिब्रिलेटर। ओके फाइन, देन उसके बाद ओके नेक्स्ट दे विल आस्क यू कि यू हैव इंट्यूबेटेड द पेशेंट, नाउ वंस यू इंट्यूबेट द पेशेंट, तो हाउ मेनी breaths will you give per minute in adults and how many breaths will you give in children? Yes, so in adults you will give 10 breaths per minute, in children you will give 20 to 30 breaths per minute। ठीक है, अब तुमने आईवी लाइन डाल दिया, आईवी लाइन डाल दिया तो उसमें से कौन सा ड्रग देंगे? सीपीआर में कौन सा ड्रग है? सीपीआर का ड्रग ऑफ चॉइस इज एड्रेनालिन। व्हाट इज द डोज ऑफ एड्रेनालिन इन एडल्ट्स? It is 1 mg every 3 to 5 minutes, 1 mg every 3 to 5 minutes। ये एडल्ट्स में 1 mg every 3 to 5 minutes है। अगर आप चिल्ड्रन का डोज देखो, यहाँ पे मैंने फोटो डाली है, ठीक है, चिल्ड्रन के डोसेजेस थोड़े अलग है, तो यहाँ से प्लीज पढ़ लेना, ये पैल्स गाइडलाइन से लिया है, पीडियाट्रिक लाइफ सपोर्ट गाइडलाइन। सो योर यू कैन सी एपिनेफ्रिन का आईवी डोज इज 0.01 mg per kg एंड रिपीट एवरी 3 to 5 minutes। एंड एम्योडेरॉन का डोज जो एडल्ट्स में होता है दैट इज 300 mg फर्स्ट डोज, 150 mg सेकेंड डोज। अभी फिर से बोलोगे मैम आप पट 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 बोल रहे हो, हमको कैसे याद रहेगा? तो ये वाला जो है ये एडल्ट गाइडलाइंस है, एडल्ट सीपीआर गाइडलाइंस, तो ये वाला एक बार पढ़ लेना, ये तो पढ़ना ही पड़ेगा। यहाँ पे एम्योडेरॉन का दिया है फर्स्ट डोज 300 mg, सेकेंड डोज 150 mg। ओके सो इन children you divide that dosage, it becomes 5 mg per kg, total dose of 3 doses can be given। okay चलो देन उसके बाद एडल्ट्स में मैंने आपको कैसे बोला, शॉक एनर्जी मोनोफेजिक यू गिव 360 जूल्स, बाईफेजिक यू विल गिव 150 to 200 जूल्स। ओके बट चिल्ड्रन में कैसे रहता है, चिल्ड्रन में योर शॉक एनर्जी इज एज पर केजी। सो फर्स्ट शॉक विल बी 2 जूल्स पर केजी, वापस अगर शॉक देना है तो 4 जूल्स पर केजी, एंड सब्सिक्वेंट शॉक्स यू कैन इंक्रीज इट फ्रॉम 4 जूल्स 5 जूल्स 6 जूल्स 7 जूल्स अप टू 10 जूल्स पर केजी और एडल्ट डोज। ओके ओके सो दिस इज योर शॉक एनर्जी फॉर डिफिब्रिलेशन। राइट, सो ये आपके एडल्ट सीपीआर गाइडलाइंस है, ये आपके पीडियाट्रिक सीपीआर गाइडलाइंस है। अब सब माँ कसम मुझे बोल के जाओ कि एक बार तुम लोग ये रिवाइज करोगे क्लास खत्म होने के बाद। अभी पूजा मैम की क्लास के पहले नहीं, इतना मैं तुमसे काम नहीं कराने वाली, लेकिन आज रात को या कल सुबह एक बार ये यहाँ से एडल्ट सीपीआर गाइडलाइंस और पीडियाट्रिक सीपीआर गाइडलाइंस रिवाइज करो। यस 100%, गॉड प्रॉमिस, चुम्मा प्रॉमिस। यस ओके फाइन, चलो अब नेक्स्ट ये जल्दी 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 ये बताओ ये क्या कर रहे हैं, मुंह दिखाई किसकी चल रही है? यस सो दिस इज हाउ टू ओपन अप अ ब्लॉक्ड एयरवे। तो यहाँ पे ब्लॉक्ड एयरवे है एंड मनूवर्स टू ओपन अप ब्लॉक्ड एयरवे, मनूवर्स टू ओपन अ ब्लॉक्ड एयरवे। तो कौन से मनूवर्स होते हैं टू ओपन अ ब्लॉक्ड एयरवे? चिन लिफ्ट, हेड टिल्ट एंड तीसरा वाला क्या है? जॉ थ्रस्ट। चिन लिफ्ट, हेड टिल्ट एंड जॉ थ्रस्ट। ओके सो दिस इज चिन लिफ्ट, चिन को लिफ्ट कर रहे हैं, इधर से हेड को टिल्ट कर रहे हैं, सो दिस इज हेड टिल्ट, एंड देन द थर्ड वन दैट यू हैव इज जॉ थ्रस्ट, जिसका फोटो भी आप लोग बाद में देखोगे। These are all maneuvers to open up a block airway. Okay. Fine. Then you have this chain of survival. कल्पना सिर्फ यही वाला एडल्ट का सीपीआर गाइडलाइंस रिवाइज करना है। ओके देन दिस इज चेन ऑफ सर्वाइवल, पूछा गया है एफएमजी एग्जाम में, व्हाट इज द सिक्स्थ लिंक एडेड टू द चेन ऑफ सर्वाइवल? तो याद रखो चेन ऑफ सर्वाइवल मींस व्हाट आर द स्टेप्स यू विल फॉलो सो दैट यू आर एबल टू सेव योर पेशेंट वेल। ओके IHCA मतलब इफ पेशेंट हैज हैड अ कार्डियक अरेस्ट इन द हॉस्पिटल, मतलब वार्ड में या फिर कोई तो आईसीयू में पेशेंट को कार्डियक अरेस्ट हुआ है, सो दिस इज इन हॉस्पिटल कार्डियक अरेस्ट. OHCA मीन्स दिस इज आउट ऑफ हॉस्पिटल कार्डियक अरेस्ट. रोड पे, रेस्टोरेंट में, एयरपोर्ट में किसी को कार्डियक अरेस्ट हुआ है. हाउ डू यू नो द डिफरेंस बिटवीन IHCA इन हॉस्पिटल एंड OHCA आउट ऑफ हॉस्पिटल? यहाँ पे एम्बुलेंस एम्बुलेंस दिख रही है, मतलब OHCA है, आउट ऑफ हॉस्पिटल कार्डियक अरेस्ट. ओके, सो द सिक्स्थ लिंक, चेन ऑफ सर्वाइवल में 6 लिंक्स है. 6 लिंक्स, 6th लिंक दैट इज एडेड रिसेंटली इज रिकवरी. रिकवरी मतलब पेशेंट घर चला गया, उसके बाद यू विल स्टिल कॉल अप, फॉलो अप विद हिम. उसका साइकोलॉजिकल रिकवरी, रिहैबिलिटेशन, फिजिकल एंड मेंटल, इमोशनल रिकवरी, वो सब भी देखना है. ओके, काउंसलिंग वगैरह सपोर्ट. ओके, सो दैट इज कॉल्ड एज रिकवरी और द 6th लिंक एडेड टू द चेन ऑफ सर्वाइवल. ओके, अब ये सब हमने कर लिए है ऑलरेडी डिस्कस. इसमें दो चीजें डिस्कस नहीं हुई है, एक तो है 10-20-40 रूल और एक है TTM. TTM इज नथिंग बट टारगेटेड टेम्परेचर मैनेजमेंट. तो लेट्स से यहाँ पे हमारे पास कौन है, जिराया. जिराया है हमारे पास, जिराया का कार्डियक अरेस्ट हो जाता है एंड मैं उसको धपाधप CPR देती हूँ. नाउ जिराया इज रिवाइव्ड, बच गई है, ROSC हो गया है, रिटर्न ऑफ स्पॉन्टेनियस सर्कुलेशन, लेकिन जिराया की हालत अभी भी एकदम खराब है. सो व्हाट आई डू इज टेक जिराया एंड आई पुट हर इन द फ्रीजर for 24 hours. Okay, so not in the freezer. I reduce her body temperature to 32 to 36 degrees Celsius for 24 hours. This is called as targeted temperature management. इससे क्या होगा, जिराया का मेटाबॉलिज्म कम हो जाएगा, the body will heal faster and she will come out of the cardiac arrest better. Okay, बच गई है, वो बोल रही है मैं ठीक हूँ अभी. Okay, 10-20-40 रूल क्या है कार्डियक अरेस्ट का? So कैसे पता that you are giving good quality CPR? बेकार CPR तुम नहीं दे रहे हो. Your minimum EtCO2 during chest compression should be 10 mmHg. Okay. Your minimum diastolic blood pressure during chest compression should be 20 mmHg. And 40 means that आपका EtCO2 जब 40 के ऊपर है, EtCO2 is more than 40, so then there is return of spontaneous circulation. There is ROSC or return of spontaneous circulation. Okay, so this is about your 10-20-40 rule. 10-20-40 rule. Okay, अगर किसी को इसके बारे में और पढ़ना है तो यहाँ पे है, this point. Okay, so you can read about this 10-20-40 rule, and I've also taught this in your CPR guidelines. Okay, and last thing that we have to discuss today कि कैप्नोग्राफ्स के डिस्कस, आई मीन वी हैव टू आइडेंटिफाई द कैप्नोग्राफ्स. तो नंबर 1 कैप्नोग्राफ क्या है, ये ऐसे 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 जा रहा है. नॉर्मल EtCO2 कितना है पहले मुझे बताओ. Normal EtCO2 is 35 to 45 mmHg. Okay, so this one is normal EtCO2, normal कैप्नोग्राफ. ठीक है, अब जो सेकंड वाला है वो क्या है, सेकंड वाला है वो क्या है, ऐसे जा रहा है, शार्क फिन अपीयरेंस. दिस इज शार्क फिन अपीयरेंस. ओके, इसको बोलते हैं हम शार्क फिन अपीयरेंस. वेयर इज इट सीन? इट इज सीन इन अस्थमा, इट इज सीन इन COPD. ओके, या नाउ नेक्स्ट व्हाट यू कैन सी ओवर हियर इज दैट ऐसे दूर दूर है, एकदम दूर दूर जा रहा है, दूर दूर जा रहा है. तो ये क्या है, अगर द capnograph is further apart from each other, so this is hypoventilation. Hypoventilation. Okay, and if the capnograph is close to each other, close, okay, and it is going down, so this is hyperventilation. This is hyperventilation. Okay, fine. Ab very important capnograph over here, number 5. ऊपर ऊपर जा रहा है, स्टेप लैडर पैटर्न. सो दिस कैन बी टू थिंग्स, आइदर दिस कैन बी मैलिग्नेंट हाइपरथर्मिया और दिस कैन बी रीब्रीदिंग. मैलिग्नेंट हाइपरथर्मिया या फिर रीब्रीदिंग. कैसे पता चलेगा मैम कौन सा है? यू हैव टू लुक एट द क्वेश्चन. व्हाट इज द क्वेश्चन आस्क्ड? अगर क्वेश्चन डिस्क्राइब्स मैलिग्नेंट हाइपरथर्मिया, मसल रिजिडिटी, हाइपरथर्मिया आफ्टर एक्सपोजर टू सक्सिनाइल कोलिन और वोलेटाइल एनेस्थेटिक्स, तो मैलिग्नेंट हाइपरथर्मिया. अगर बोले कि सोडा लाइम चेंज नहीं किया है, इट हैज बीन अ लॉन्ग टाइम सिंस CO2 absorber is changed, then it is rebreathing of carbon dioxide. Okay, fine. बहुत important वाला, you can see there is a notch that is present in this. नॉच, वो गाना याद आ रहा है, नॉच 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 बेबी, कौन सा है वो? ओके, सो दिस वन इज क्यूरार क्लेफ्ट. Curar cleft means patient has started breathing on his own. Patient is out of the action of the muscle relaxant. Patient is unparalyzed. तो अपने आप से patient is breathing. Patient is not awake. He is unparalyzed. He is breathing on his own. So this is called as curar cleft or curar notch. Okay. Fine. अब ये वाला कौन सा है? EtCO2 टाइप है ही नहीं, स्क्वायर शेप वेवफॉर्म है ही नहीं, थोड़ा 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 20 के नीचे है कुछ, तो ऐसे 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 ऐसे. This is when you are trying to give CPR. So your CO2 is coming out like this. You're giving CPR. And CPR देते देते suddenly you see there is a rise in the EtCO2 to above 40. Sudden sustained release of EtCO2 more than 40. This means this is ROSC, return of spontaneous circulation. मतलब patient बच गया. Okay, यहाँ पे लिखा है ये sudden sustained increase. ये देखो, ये वाला abrupt sustained increase in EtCO2 more than 40. That means it is ROSC, return of spontaneous circulation. Okay, चलो तो हो गया. अभी सब तुम लोग ने लेट चालू किया, फिर भी मैंने टाइम पे खत्म कर दिया. यही हमें हमारी कहानी है. Yes, all those of you who want to go for tea break, you can go. The rest of you, I have full faith that you are going to pass in this exam itself. All of you have studied very, very hard. The only thing that you guys have to remember is that एग्जाम में सब कुछ आएगा और फ्री में आंसर कर सकता हूँ ऐसा नहीं होता है. ठीक है, यू हैव टू यूज अ लिटिल बिट ऑफ योर लॉजिक, यू हैव टू यूज अ लिटिल बिट ऑफ योर लक ऑल्सो, एंड यू हैव टू थिंक किधर ना मेरे दिमाग में वो टॉपिक है, मैंने पढ़ा है उसके बारे में, तो और कुछ नहीं तो स्टार्ट रूलिंग आउट दी ऑप्शंस. एग्जाम में डरना नहीं है, कोई भी पॉइंट पे रुकना नहीं है कि मुझे ये नहीं आ रहा. अगर क्वेश्चन नंबर 1 2 3 4 5 डिफिकल्ट लग रहा है तो पीछे से चालू कर दो. ठीक है, पीछे से चालू करके आप अपना 50 49 48 ऐसे चालू करके सॉल्व करना, या फिर पीछे से नहीं करना है, आगे से नहीं करना है तो बीच में से घुस जाओ किधर. ओके, बीच के क्वेश्चन थोड़े सॉल्व करो. एट द एंड ऑफ द डे you know you have those slots and you have fixed amount of time. एक बार वो slot का time चला गया then you will not be able to come back to it. Okay, so please make sure, अगर आपको लग रहा है मैं भूल रहा हूँ सब कुछ, मुझे कुछ याद नहीं आ रहा है, एग्जाम में सब याद आ जाएगा. वो टाइम पे ना क्या होता है, सब एग्जाम दे रहे हैं तो सडनली आपको भी लगता है कि हाँ मैंने पढ़ा है, मुझे आ जाएगा और आई विल बी एबल टू डू इट. नर्वसनेस पूरी जिंदगी रहती है. आप डॉक्टर बन जाओगे, आप केस के लिए जाओगे, हर केस में एनेस्थीसिया देने के पहले भी नर्वसनेस रहती है, चाहे आपने हजारों बार किया हो. ओके, बीइंग नर्वस इज गुड, but going and freezing over there and not remembering anything is something that you should avoid. And how will you avoid that? अपने आप पे भरोसा रखो. You all have worked very hard and अभी लास्ट के थोड़े दिन हैं, कुछ भी नया मटेरियल मत पढ़ो, सिर्फ रिविजन 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 करते रहो. इफ देयर इज वन थिंग आई हाईली एडवाइस इज, इफ यू हैव नॉट गिवन एनी जीटी तो एक जीटी के लिए सिर्फ बैठ जाओ. डरो मत, आ रहा है नहीं आ रहा है कुछ भी आ रहा है, बस बैठना कैसे है एग्जाम में, दिमाग कैसे लगाना है, रूल आउट कैसे करने हैं ऑप्शंस, वो आपको प्रैक्टिस के लिए आप हो सके तो जीटी दे सकते हो. ओके, या देयर इज नो नीड टू यूज एनी परफॉर्मेंस एंजाइटी मेडिकेशन. दिस इज those are used for other performances का एंजाइटी. ठीक है, तो इस ये तो एक एग्जाम है यार, निकल जाएगी. आप सब इतने एग्जाम दिए हैं, प्ले स्कूल से लेके फर्स्ट स्टैंडर्ड से लेके अभी तक एग्जाम देते ही गए हो. जस्ट हैव फुल फेथ इन योरसेल्फ. एग्जाम के पहले कोई भी अंटू बंटू शंटू से बातें मत करना, बिकॉज भड़काने के लिए तो लोग बैठे हुए हैं. ठीक है, सो जस्ट कीप टू योरसेल्फ, जस्ट प्रे टू गॉड, जस्ट बी अराउंड पीपल हु आर पॉजिटिव. नो नीड टू डिस्कस एनी लास्ट मिनट टॉपिक्स. मेक श्योर दैट आप जो व्हीकल में जा रहे हो एग्जाम के टाइम पे, तो आपके वो क्या बोलते हैं ना, टॉक्सिक लोग नहीं है आसपास में. किसी के साथ कुछ भी डिस्कस करने की जरूरत नहीं है. बस अपने मन में याद रखो कि मैंने पढ़ा है, मुझे आएगा, और अगर मुझे नहीं आ रहा है मेरे पास उसकी भी स्ट्रैटेजी है कि मैं बाकी के ऑप्शंस रूल आउट करूंगा. और अगर मुझसे ऑप्शंस भी नहीं रूल आउट हो रहे हैं तो उसकी भी स्ट्रैटेजी है मेरे पास कि मैं अपने फेवरेट भगवान को जय माता दी, लेट्स रॉक करके आंसर मार्क करके आ जाऊंगा। तो अभी आपको किससे बात करने की जरूरत है ही नहीं, ठीक है। तो स्ट्रेटेजी तो हमारे पास है, पढ़ता है, आना आता है मार्क कर दो आंसर, नहीं आता है रूल आउट करो, रूल आउट भी नहीं हो रहा है तुक्का मार दो, ओके। बस दैट्स हाउ being calm and being composed is what will get you beyond that 150 mark. And once you are beyond that 150 mark, of course we all will meet in cerebellum, and that should be your goal कि मुझे cerebellum में जाना है और मुझे सिर्फ जानवी मैम के साथ फोटो खिंचवानी है, और किसी के साथ नहीं खिंचवानी है, सिर्फ जानवी मैम के पास सीधा जाके मैं फोटो खिंचवाऊंगा, ओके। यस, फिर गोवा में मांगना सेरेमनी, यस। उतना गोल मैं नहीं बोल सकती हूँ, बट ये गोल याद रखो कि मुझे वहां पे जाके फोटो खिंचवानी। ऑलराइट, यस। अब वो सब छोड़ दो कि मुझे ये जीटी में इतना मिला, वो लेट नाइट पीवाई क्यू मैराथन में इतना मिला, जिसमें जितना भी मिला, एग्जाम फाइनल एग्जाम होती है उसके मार्क्स फाइनल होते हैं, ये सब छोड़ना और एग्जाम में दिमाग लगाना छोड़ दो। how much ever marks you have got in any GT or any exam, your focus right now should be I will pass, I will make it, and I will do it this time itself. Okay, chal. Thank you very much, and I will share this PDF with you guys ASAP. अभी share कर दूंगी, and see you guys. Take care. Love you. All the very best.
Hello, good evening, good evening. So how are the classes going on? All well? Yes? We'll start in 4 minutes or so, right? We have some time. Baby's sleeping. He took a bath just now and he's sleeping right now. Let him sleep so that we can take at least 2 hours of class, 2.5 hours of class, right? Yes, PDF I'm going to send to the team. You can ask the team to send you. And I have sent it in the morning. So if the team has got it, so might be it is there on the Telegram group. Just kind of search it, search it there. It might be there. Okay. There are some changes. Tablet, lab 2 se there are some changes. English, I will try, right? I will try, but I cannot promise you because there are some people who cannot understand Hindi and the exam is in the English. So mostly हम English में रखेंगे, ठीक है? Good evening, good evening. Already है group में, right? The PDF is there on the group, right? Thank you, Deep. All right, so 3 minutes. Hindi, Shahrukh, I'm telling you, I'll try, है ना? हम try करेंगे, but it's just that अभी the exam is in English and ऐसे कुछ लोग हैं जिनको हिंदी नहीं समझ में आती, so it is going to be difficult for them, so that's why. Yes, your name is coming tablet to everyone. मेरा नाम tablet आ रहा है. Yes. Raftar, thank you. आशीष बच्चे, the exam is in English ना. तुक्के मारने की टेक्निक बताओ. वो आपको गोगा सर ने नहीं बताया. अक्कड़ बक्कड़ बम्बे वो. तुक्के मारना है तो कुछ भी मारो यार. चलो, there are 2 minutes left. I guess मॉर्निंग में कौन सी क्लास हो चुकी है आपकी? I guess pharmacology and anesthesiology, if I'm not wrong, right? What we are going to do is we are going to go quickly through the topics. Now, in between, you might do not understand something. Then what you're going to do? Have the blank paper beside you. Have the blank paper beside you. Whatever you do not understand, just write it there, note it there, and move forward. At that time, I will not be able to repeat the topics again because this is a marathon and you have to be a quick, you can say you have to grab the quick speed, right? So that's why we are going to be a little bit quick, all right? That is what it is, right? End में I think this is my last class, so end में we are going to get the time. कुछ नहीं समझ में आया तो please ask me at the end, ठीक है? Thank you. Blur दिख रहा है? Right. Now is it clear? Now is it clear? नहीं, मेरे साइड में तो क्लियर है यार. चलो. The PDF is there on the group, beta. Buffalo wings. So the PDF is there on the group. This is a new PDF. There are some changes according to the last year questions, right? There are some changes, so that is going to be there. कोई filter नहीं है यार. I think there is something on the camera might be. चलो. Chalo. So can we start? It's 5 o'clock. Let's start. Whatever doubts are there, please note it down on the blank paper and ask me at the end. That is going to be better, right? If specific things are there, you can ask me there, but do not ask me to repeat because I'm not going to repeat the topics. You have to grab the speed. This is nothing but marathon, right? So let's start with the first thing. Inhale, exhale. It is well. It is well. All of this is a part of story that you will tell in the cerebellum, right? After the exam, we are going to meet in the cerebellum and you're going to tell me कि मैम आपने ये वाला slide दिखाया था and this was the question which has come, right? And these all stories, late nights and early mornings, the sleepy afternoons, everything you're going to tell me, right? So with that excitement, let's start. There are some regulatory mechanisms of homeostasis, which is the most common regulatory mechanism. Yes, please. You're going to give the answers fatafat se, right? I'm going to write, you're going to give the answers, right? So tell me, what is the most common mechanism mechanism of homeostasis? It is nothing but a negative feedback mechanism, right? Wonderful, guys. Negative feedback mechanism. So what we are going to do, we are going to do the smart study. We are going to learn the positive feedback and the feed forward ka examples. Rest all are going to come under. Rest all are going to come under the negative feedback. Just now we started. Ayush, don't worry. All right, this is the very first slide. All right. So what are the examples of positive feedback? याद कैसे रखोगे? H2 clamp. There are two H2Cs, right? And then you have lamp. So H2 clamp. What is that? Head's paradoxical reflex. We know that the world is not happy when we are born. They want us to cry. So first cry of the newborn. What happens at the first cry of the newborns? First few breaths of the baby. First few breaths of the baby. In that, what is going to happen? Yes, please. Inflation stimulates further inflation. Few breaths only. After that, hearing prover reflex will be activated. That we are going to see in the respiratory system. So head's paradoxical reflex, inflation of the alveoli for the first few breaths increase or stimulates further inflation of the alveoli. Then comes the Hodgkin cycle, which will be seen in the action potential. Action potential, right? Action potential, mein what is going to happen? Opening of few sodium channel will open up more and more and more sodium channel, more and more sodium channel. All right. Then C for clotting cascade. Clotting cascade. Clotting cascade क्या है? Your intrinsic pathway, extrinsic pathway. One clotting system or one clotting factor you activate, that is going to activate the another one. That is going to activate the another one, and so on and so forth, unless and until the fibrin thread is formed, right? So that is your clotting cascade. CICR, calcium induced calcium release. You guys are going to tell me calcium induced calcium release. This is seen in two types of muscle. Can you name those? Does it seen in the skeletal muscle? Yes or no? No, it is only be seen in the smooth muscle and your favorite, cardiac muscle. Smooth muscle and cardiac muscle. Wonderful, guys. Wonderful. Right. LH surge. Surge means the complete triangular structure, right? So surge start 32 to 36 hours before the ovulation. Peak, that means the highest point is going to reach around 8 to 10 hours before the ovulation, right? Then activation of digestive enzyme trypsinogen to trypsin. You guys are going to be. Sound is not good. Is the sound okay? Audio video. Audio में कोई problem है क्या? It's fine, beta. Just refresh on your side. Trypsinogen to trypsin. Trypsinogen to trypsin. So who is going to activate trypsinogen? Answer is going to be intestinal peptidase, that is enteropeptidase. Enteropeptidase, right? Enteropeptidase इसी को हम क्या बोलते हैं? Enterokinase. Enteropeptidase and enterokinase, right? So please remember that. Activation of digestive enzyme. Milk letdown reflex and parturition reflex. Milk letdown reflex के ही क्या क्या बोलते हो? What are the other names of milk letdown reflex? You can call it as suckling reflex also. You can call it as milk ejection reflex also. You can call it as galactokinesis also. All of this is nothing but the same thing. So all of these are because of which hormone? If I ask you, the answer is going to be oxytocin. And if I ask you, tell me, oxytocin is going to be released by which nucleus? Tell me. The oxytocin is going to be released by, yes, this is responsible for the mother and baby's love bonding. So it is going to be प्यारा hormone, प्यारा ventricular से release होगा. So please remember, paraventricular nucleus of the hypothalamus is going to release the oxytocin. Parturition is nothing but delivery. Literally, it means delivery. All right. So parturition reflex is responsible. It is one of the example of positive feedback. Oxytocin is responsible for it. Okay. Chalo. Next. So these were the example of positive feedback. Feed forward क्या है? Feed forward. Feed forward is going to be, yes. All right, feed forward mechanism is anticipatory control. Guys, concentrate over here. है ना, बाकी सारी चिट चाट छोड़ दो. Feed forward mechanism is anticipatory. We are anticipating what is going to happen in the exam or which questions can come over here, right? So anticipatory control. Correction occurs even before the variable has been changed. Before आया तो it is going to be feed forward only, right? So what are the example? Temperature regulation. In the temperature regulation, there are two things which are going to be there. First is going to be the core body temperature. If they ask core body temperature, means the temperature of the blood or deep viscera. If they ask about core body temperature, it is going to be feed forward. But if they ask about the skin temperature, it is going to be negative feedback. So I'm writing it over here itself. So if they ask about the shell body temperature or a skin temperature, that is going to be example of negative feedback. How we have already discussed that, right? So agar skin ya fir shell pucha, it is going to be negative feedback. Otherwise, core temperature pucha, blood ka temperature, deep viscera ka, that means liver, kidney, spleen, all these are the organs, right? So organs ka agar temperature pucha, it is going to be feed forward. Increase, duk 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 duk, it must have been started right now, hai na? So kya hai, your heart must be saying duk 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 even before the exam has started. So increase in the heart rate just before the exercise, any stress for that matter. We are taking the physiological example, that is exercise. Cephalic phase of gastric acid secretion, let's say you haven't had your snacks because you started to prepare, but then I started the class. So you left that and you came to the class, right? So whatever you like, Maggie, burger, pizza, brownie, whatever you plan to do, right? Plan to eat, right? At that point, I started the class. So what is going to happen? Yes, biryani. Itni jaldi snack mein biryani kaun khata hai re? Cephalic phase of gastric acid secretion. As soon as I took those names, I'm not going to eat you all these things, but I just took the name. That is going to activate your cephalic phase and increase your gastric acid secretion, right? So these are the three examples: core body temperature, increase in the heart rate, and cephalic phase of gastric acid secretion of the feed forward mechanism, right? All right. Next, cell membrane. Okay, cell membrane kya hai? The voice is not clear. Hi ma, beta, I have asked already. It's all clear. This side all okay aa raha hai mere ko, all good, clear hai, continue, right? So please refresh on your side, beta, or put the headset or something like that, right? So that you can find out some solution. Okay, chalo आगे बढ़ते हैं. I'm sitting in the same. Let me try something else. I'm sitting in the same studio, beta, in which I have taken the class. Nothing has changed, right? So I don't know what is the problem. Okay. माइक तो है ही नहीं, कैमरा वाला ही माइक है बेटा. आई कैन नॉट चेंज दैट. चलो आगे बढ़ते हैं. सेल मेम्ब्रेन. द मॉडल इज सिंगर एंड निकोलसन फ्लूइड मोज़ेक मॉडल. नाउ द मोस्ट इंपॉर्टेंट थिंग ओवर हियर इज गोइंग टू बी phospholipid. Please remember, most common lipid is going to be phospholipid. We have just finished one topic, beta, we are slow only. Okay, it's a marathon. So phospholipid is going to be the most common lipid, right, which gives the lipid solubility. Solubility kaun sa? Lipid soluble substance ka solubility, and that is because of the tail part. See, head part, H for head, H for H2O. It is the water loving part, right? Tail is going to be there, and tail loves the lipid. So this is the one which is going to give the lipid solubility. Yes, wonderful. The tail part is going to give the lipid solubility. Now it has both the properties, water solubility also, lipid solubility also. That is, one part is it is water loving, one part is lipid loving. So both the properties are there, and that's why you call it as amphipathic lipid. So if they ask you most common lipid, if they ask, what is going to be your answer? Yes, Stephen Strange, you're absolutely correct. If they ask most common or most abundant component पूछा, protein आएगा. Most common lipid पूछा, phospholipid आएगा. If I ask you, tell me which is the lipid which is not going to be present in the cell membrane, the lipid that is absent in the cell membrane, is it going to be cholesterol? No, cholesterol is going to be present over here. Teen tigada kam bigada. So please remember, triglyceride will be absent. Right? Cholesterol is very, very important for the solubility, and it gives the fluidity and flexibility, and that is going to act as a fluidity buffer. Okay, so which is absent? Lipid that is absent. No matter whichever cell membrane you take, that is going to be triglyceride. Triglyceride is going to be absent over here. Next, cell membrane mein lipid hoga ya protein hoga. Mainly these are the two components, right? Carbohydrate is less than 5%. So let that be, right? But the most important property is lipid solubility. Who gives the lipid solubility? Is nothing but phospholipid. The flexibility and fluidity by question has come. Who acts as a fluidity buffer? If they ask who acts as a fluidity buffer, your answer is going to be cholesterol, right? And if you're a male because of the cholesterol. If you're a female because of the cholesterol, right? Why I'm saying so? Because the sex steroid, which gives the secondary sexual characteristics, they are going to be formed of cholesterol. Cholesterol is the precursor of all the sex steroids, for that matter, all the steroids, right? And that's why I said, if you're a male because of the cholesterol. If you're a female because of the cholesterol. If something else, we need to find out, right? So let's move on to the next thing, that is protein. Rest all the functions are going to be done by the proteins, right? So channel पूछे, pumps पूछे, receptors, transporter, carrier, even the antigen, they are made up of proteins. ठीक है? चलो नेक्स्ट, इंट्रासेल्युलर जंक्शन. somebody, Pratik is saying मैं तो भगवान हूँ, फिर आप FMG एग्जाम क्यों दे रहे हो? My question is to you, इंटरसेल्युलर जंक्शन, अगर सच में भगवान हो तो हमारे सेरेबेलम के सारे बच्चों को पास कर देना, ठीक है? 200 प्लस. इंटरसेल्युलर जंक्शन. Intercellular junction, there are two junctions, gap junction and tight junction. First thing, gap junction, it is going to create the gap between two cell membranes, right? From one cytoplasm cell, from ICF of one cell, that is cytoplasm of one cell, it is going to go to the cytoplasm of another cell without entering into the ECF, direct ICF to ICF entry, right? So that is going to be what? That is going to be your gap junction. They connect to two cells. So what are the protein? Connexin and connexon. 6 such subunits are going to come together. That is going to be connexon. Now, if I ask you where these connexons, they are present, heart, vessels, smooth muscle, in these things, the connexin are present. What is their benefit? The benefit is going to be very, very quick transport, because they are going to create the shortcuts, isn't it? So shortcuts are created, and that's why it is going to cause very, very quick transfer. Now, let's take the example of one ventricle. Let's say I have to do systole. Now, these are, let's say, the muscles of my ventricle. What is going to happen? One muscle will contract, then another, then another, then another. This is going to happen, or all of them contract simultaneously? All of them contract simultaneously. Thanks to the gap junction, they act as a one single unit, and that one single unit is nothing but syncytium. That one single unit is called as syncytium, right? So this is about the gap junction. Please remember, syncytium पे question आया हुआ है, connexin connexon पे question आया हुआ है. All right, next, tight junction, exactly opposite to the gap junction. If you do not want to allow someone, you're going to put the barricades, right? So let's see, there are barricades on the road. Either the road will be occluded or partially closed, or there will be traffic jam. Jam is what? Junctional adhesional molecule. So please remember, these are the proteins: occludin, cloudin, jam protein. If I ask you, tell me, फटाफट से बताओ, if I ask you, there is a watery diarrhea in a small kid and rice gruel stool. The stool type is rice gruel stool is going to be there. Then which microbe or which organism is responsible? Yes, wonderful. It is going to be Vibrio cholerae. And on which receptor it is going to sit? GM1 ganglioside. But if I ask you which junction it is going to attack on, then the answer is going to be tight junction. Tight junction, if it is not in the option, they will give you the protein directly. ZO1 protein. ZO1 protein, please remember, it is a subfamily of occludin, zona occludens, right? So please remember, cholera के बारे में पूछा, they are going to ask you indirectly, it is going to be occludin protein. Now, in the INICT, they have asked the question, in which membrane it is present? On which membrane? Basolateral पे होता है या apicolateral? Just remember, it is present on the apical side, that is apicolateral membrane पे. You're going to have the tight junction, which prevents the paracellular transport. What do you mean by paracellular? What do you mean by transcellular? See over here, trans literally means across, right? So across what? Across cellular, that means across the cell. It is going to break this membrane, then it is going to break this membrane, and then it is going to go on to the other side. So it is going across the cell. So that's why we are going to call it as transcellular transport, right? But If it is not going through the cell, it is going from the periphery of two cells, right? There are going to be spaces which are going to be available between the two cells. So if it is going between two cells or from the periphery of the cells, you're going to call that as paracellular transport. And see over here, this is shown as Claudin. If you have Claudin, the paracellular transport will not be allowed for all the substances, right? It will be inhibited. So it prevents the paracellular transport. Where it is present in the blood-brain barrier and nephron. Blood-brain barrier and nephron mein this is going to be present, right? Next, body water. Tell me the rule of body water. Voice is clear, beta. Please refresh it or use the headphones, okay? Body water. Try to refresh your feed. Now, which rule I told you? 60, 40, 20 rule. What I mean by 60, 40, 20 rule, if I take body weight as 100%, then the total body water, TBW is total body water is going to be 60%. Then you have more ICF because all the factory is going to be inside your cell. Everything, एक बार हाइमा प्लीज एक बार री एंटर करके देखो बेटा, because it is clear for most of the students है ना, that's why I'm asking you. ICF, so 40% is ICF, all the factory material, that means nucleus, Golgi apparatus, mitochondria, everything is there in the cell. So that's why ICF is going to be 40% and 20%. 20% is what? ECF. The 20% is going to be your ECF, okay? Haima, everybody is giving you the solution. That is YouTube try kar lo ek bari, YouTube se open karke dekho. All right, chalo. ICF and ECF, 20% is going to be the ECF. Now, if I ask you in the newborn babies or in the infant, you have more ICF or you have more ECF? Tell me, in the newborn babies, you have more ECF. As it comes towards 1 year, it is going to be ICF, which is going to be more. So please check. Before 3 to 4 months, you have more ECF, and after that, you have more ICF because cells are growing. So more cells means more water in those cells. Okay. Now, total body water, we can divide it into two parts, ICF and ECF. Intracellular has no subdivisions, absolutely no subdivisions, but ECF has subdivisions. Now, first of all, TBW, if I ask you, it is 60%. This is going to be 40%, but 40% of what? 40% of body weight, right? 40% of body weight, and this is going to be 20% of body weight, right? But if I ask you that out of total body water, so if I ask you out of total body water, okay, I have done 3 different parts, right? 2 parts I have to give to the ICF and 1 part I'm going to give to the ECF. That means 1/3 of and 2/3 of total body water. 2/3 of total body water is going to be ICF, and 1/3 of TBW is going to be ECF. Now, ECF is going to be divided mainly into 2 parts, plasma and interstitial fluid. Bigger the name, bigger will be the contribution. Who has bigger name? Interstitial fluid, big name, right? So interstitial fluid is going to be having more contribution. If I ask you, tell me how much it is of the total body water. And if I ask you, tell me, first of all, according to weight. Weight ka kitna percent hoga? If I divide this 20% into 4 parts, the 3 parts are going to be here and only tiny part is going to be here. So 5% of and 15% of weight is going to be the division, right? But if I ask you, tell me out of ECF, how much is going to be the plasma, how much is going to be the interstitial fluid, then 25% of ECF, and this is 75% of ECF. Right, is going to be interstitial fluid. So what they have asked, according to that, the numbers are going to be changed, right? But what question they have asked? The transcellular fluid is a part of, I told you that ICF does not contain any subdivision. So whatever subdivision is there, it is going to be of ECF for sure, right? So what is this transcellular fluid? Transcellular fluid is what? Transcellular fluid which is present in the 3rd space or fluid in the cavities, right? Which cavity? Dental cavity, kya? No, fluid in the cavities that you have outside of the organ cavities, such as lung ke bahar kya hai? Pleural cavity, so pleural fluid, right? Pericardial cavity, so pericardial fluid. Then peritoneal fluid. Right, CSF. Aqueous humor, vitreous humor, synovial fluid, all of them are going to come under transcellular fluid, but this is less than or equal to 1 liter depending on the height of the person and total body weight of the person, right? So we do not take this into the consideration, we leave it, okay? So transcellular fluid combinedly, if I combine all the transcellular fluid present in my body, it is going to be less than 1 liter, right? So that's why we do not bother about it. Otherwise, we would have taken it into the consideration. So this is the whole chart, right? I hope you have written it or you have taken the screenshot of it. Let's move on to the next thing. Now, see over here, depending on how we calculate that, we cannot, send that person in the sugarcane juice ka machine and take him out, right? Otherwise, we will be behind the bars, right? So we cannot do that. So what we do, we are going to inject the dye and take the concentration. So let's say this is the blue dye. This blue dye is going to cross the plasma membrane as well as the cell membrane. It is going to go everywhere. So what is this? Inside the cell, you have ICF. Outside the cell, you have ECF, right? ECF maybe there are two parts. If in the ECF, it is present inside the vessel, you are going to call it as plasma. If it is present outside the vessel, you are going to call it as interstitial fluid, right? So if this blue dye is going everywhere, it is going to give me total body water. Now let's say, then this is the green dye. Yes, it crosses the plasma membrane, but it cannot cross the cell membrane. So what it is going to give me? It is going to give me the ECF. It is going to give me the ECF, right? Because it does not enter into the cell. Now, there is a third dye, which is the black dye. It does not cross the plasma membrane. Of course, if it does not cross the plasma membrane, it will not be able to cross the cell membrane also. So it will just give me the plasma membrane. So if I have to measure the ICF and IF, that is nothing but intracellular fluid or interstitial fluid. Intracellular fluid, interstitial fluid will be measured by indirect method, right? I to yaad rakhna, indirect method. That means you do not require only one dye, you require two different dyes. So what are the two different dyes you're going to use? Tell me the formula. You are going to calculate the total body water first and you're going to subtract the ECF. That's how you are going to get the ICF, right? So ICF is equal to TBW minus the ECF, right? And IF is going to be ECF minus plasma. ECF minus plasma. That's how you're going to calculate the interstitial fluid, right? In direct method mein you require two different dyes, right? Now, what are the direct method? Direct method mein you require just one dye. Let's see. Total body water. If I ask you, give me dihydrogen oxide, will you able to give me? Yes, you will be able to give me. Don't worry. I'm not working with some terrorist group. It is nothing but water, right? Just the water. I'm not, planning to build a bomb or something like that, right? डॉक्टर की रेपो वैसे भी खराब हो गई है. So total body water D2O T2O aminoporin. So H2O is water, right? The brothers of this that is the radioisotopes, that is D2O T2O and aminopirin. D2O T2O aminopirin is going to be the one which is going to used for the total body water measurement. Then if I have to measure the ECF, ACF, so ECF के लिए क्या use करोगे? ECF के लिए you're going to use Simon. What is Simon G? Sucrose, inulin, mannitol and radio-labeled sodium. Why we are labeling it with the radioisotope? Because the sodium is already present in my body. If I give the exogenous sodium, I will not be able to know how much sodium I have given and how much sodium was already present, right? So that's why when I take the concentration, I should know that which sodium is the sodium which I have given to the patient, right? So please remember, sodium thiosulfate and sodium iothalamate are some examples. plasma. If I remove P and N and just keep this, what is going to be? It is going to be asthma, and asthma is usually blue, and that's why you use blue dye, right? So plasma is going to be measured by Evans blue dye or radio labeled albumin. Albumin is a big molecule. It won't come out of the blood vessel. Now, RBC till now they haven't asked in the FMG, but they can ask. So just remember, RBC के लिए you are going to use the radioisotope labeled RBCs. And which are the radioisotopes? Iron or chromium labeled RBCs. RBC measurement के लिए you require RBCs, but you have to label that with the radioisotope. And what are the radioisotope that you are going to use? Iron and chromium. Iron and chromium. Okay. Chalo. Transport across the cell membrane. Active transport, it is against the gradient, requires the ATP. But if you are going passive, right, you do not want to attend this class right now because 2 classes are already been there, right? So what do? You chill out. So that is going to be the passive transport, does not require any energy, but you are having higher motivation going against your limbic system ka will, right, and doing the right thing via attending the class. So that is requiring the mental ATP, right? Lots of ATP and lots of motivation should be required. That is active transport. So let's talk about active transport. There are 3 mechanisms of active transport. So that is primary, secondary, and vesicular transport. Primary transport uses the energy directly. Remember the example that we have taken in the mission classes? Chotu bacha and you, right? So let's say you are going on a date, right? The private vehicle, whatever bike, car you have, it is not be starting, right? Because it's a cold weather, winter is there, right? So it is not starting at all, battery died. Now you called Uber wala bhaiya ji and Ola wala bhaiya ji, they are not going ready to go there, right? So you go via the public transport, but the public transport is khachakach full, right? What do? You do dishum. That means you use the energy, nothing but the ATP. You use your own ATP to reach to the destination, right? But if your partner asks you to bring that chotu bacha also, so what you have to do? You have to take that chotu bacha. So now what you're going to do? Again, the same scenario. You have to do the dishum for yourself and that chotu bacha. So what is going to happen? That chotu bacha is a very, very smart boy. Why? Because remember, he uses your energy to reach to the destination. It is like a secondary active transport. But one thing, the secondary active transport, that chotu bacha is dependent on you. If you do not go, he also will not be able to go, right? So he is dependent on you because you are the one who is going to create the space or gradient, right? So please remember, secondary active transport is dependent on the primary active transport. If you block the primary active transport, the secondary active transport will be blocked automatically, right? So what are the examples of primary and secondary? Primary examples are all the pumps, such as the sodium potassium pump, or you can call it as sodium potassium ATPase. Also calcium pump bolo ya calcium ATPase bolo, one and the same thing. Hydrogen pump or proton pump bolo, or you can call it as H plus ATPase. It's same, right? So primary active, P for pumps, P for primary active. What about secondary active? See over here, S for secondary, S for symport. Symport के साथ साथ याद रख लो antiport also. Symport का example though, wonderful Raj, it is going to be SGLT, rotavirus, wonderful. It is going to be SGLT. Antiport, Dhwani, Aishwarya, admin, right? So it is going to be NCX. NCX is what? Sodium calcium exchanger. Sodium calcium exchanger, sodium hydrogen exchanger is also there, right? So which we are going to see in the renal system. So symport and antiport, SGLT and sodium calcium exchanger or sodium hydrogen exchanger. What is the difference between the symport and antiport? See over here, symport is going to go in the same direction. Antiport is going to be, one is going to go in and one is going to go out without using their own energy, right? Now, SGLT, how it is going to work? See over here, this is dependent on the sodium potassium pump. As soon as the sodium potassium pump comes in the mind, what is the role of it? It is going to take all the sodium from the cell, put it into the blood, right? Outside into the blood. So slowly and steadily, what is going to happen in the sodium concentration inside the cell? If you take the sodium from the cell, put it outside. Take the sodium from the cell, put it outside. Dheere dheere, the sodium levels are going to fall inside the cell. So it creates the gradient towards the apical side, na? See over here, high sodium to low sodium. It does not require to use any energy, right? It goes along the concentration gradient of the sodium. But in the overall process, to use or to create the gradient, you have already utilized the ATP. So that's why it is going to come under the active transport. All right, just example yaad rakhna. SGLT पूछा, it is going to be active transport. Mind you, there is another transport, facilitated transport, which is a passive ka example. It is going to be GLUT. Both are going to transport the glucose, but SGLT पूछा तो याद रखना, if they ask SGLT, it is secondary active. S for S याद रखना. Okay, vesicular transport. What is vesicle? It is the round storage body. If something is going to come inside the cell with the help of vesicle, we call it as endocytosis. If something is exiting out of the cell with the help of the vesicle, you call it as exocytosis. And from one side it is coming in, from other side it is going out, called as transcytosis. All right, but cytosis jab word aata hai, that means it is happening through the vesicle, right? If the vesicle is not involved, it will not be the vesicular transport. All right, chalo. Passive में आते हैं. Passive में you have osmosis and diffusion. Nobody is going to ask you about the osmosis because we have learned that since a 5th standard, right? But they are going to ask you about diffusion, simple diffusion and facilitated diffusion. याद रखना. All the lipid soluble substances, such as some people are there who pass the gas very easily. Very disgusting example, but very efficient to remember, right? Such as oxygen, carbon dioxide and ammonia. These are the gases which are going to transport via simple diffusion. Then there are some hormones. Hormone कौन से हैं? Lipid soluble hormones are nothing but thyroid and steroid. Steroid and thyroid, they are going to be what? They are going to go via simple diffusion. Then gas is there, hormone is there, and there are some vitamins which are going to transport. So ADEK. ADEK also gets transported via simple diffusion, right? Then comes the facilitated diffusion. Facilitated में C आता है. It requires the carrier protein. I gave the example of GLUT to you, right? Glucose transporter. This GLU is for glucose, T is for transporter. Glucose transporter, without using the energy, it is going to cause the transport just via a transporter. How come? See over here, this is suppose the GLUT. As soon as the glucose molecule comes and sit onto the GLUT, what is going to happen? This GLUT molecule is going to change its configuration or its structure. So suppose this is the GLUT, it is going to flip like this, right? So it is going to flip and release the glucose molecule into the cell, right? So this is known as configurational change or conformational change. That means structural change is going to occur. But this is the carrier protein, and proteins are limited on the cell membrane. So what is going to happen? Eventually, they are going to get saturated as and when you are going to increase the concentration, right? So please remember that. Okay. Now see over here. What is shown? First thing first, you are going to look at the X and Y axis and you are going to search for any hints are there or not. So over here, concentration of substance. As you are increasing the concentration of the substance, the rate of diffusion increases proportionately, and that's why you're going to have a simple straight line. If you have a simple straight line, just remember that this is simple diffusion, but as and when you are increasing the concentration of substance, first of all, the rate of diffusion increases. But after a particular point, when the saturation has taken place, the facilitated diffusion cannot increase its rate of diffusion. It is going to be plateaued out or flattened out. Right? So there is going to be plateau because of the saturation. So please remember, it is going to cause the saturation. याद कैसे रखोगे? If you have a simple straight line, it is going to be simple diffusion. If you have a curved graph, you're going to be the facilitated diffusion. It is of the facilitated diffusion. Can the amino acid sit onto the glucose transporter and transport the amino acid? Kya? No, it is not going to transport the amino acid. Why? Because it's very specific for the glucose only. So specificity is also one of the properties. So those C's and those S, yaad rakhna, that is carrier protein is required, configuration change is going to occur, and specificity and saturation kinetics, these are the two properties of the facilitated transport. Now, Next is osmolarity and anion gap. You have to know the formulas of these two, right? They can ask you to calculate also, especially the anion gap. So please yaad rakhna anion gap ka formula. Very, very simple. Let's get rid of it. How to calculate the anion gap? You're going to take one first thing, cations, and you're going to subtract them. Right, you're going to subtract the anions from them. That is cation minus anion. Simple, cation minus anion, right? So that is nothing but your anion gap, anion that. Okay, anion gap. All right. So please remember sodium plus potassium minus chloride plus bicarbonate. Right. So that is going to be your anion gap. Next, osmolarity and anion gap. Osmolarity का क्या formula है? First of all, what is the normal osmolarity? 285 to 295 milliosmoles per liter. Now, we do not live in US, UK. Why? Because everything will be given in the millimole per liter. Right, so it is very, very easy to calculate if the denominator is the same. If all of them are going to have the denominator that is per liter, right? So this electrolytes will be given in milliequivalent per liter, and glucose and BUN will be given in the millimole per liter. It will be very, very easy to calculate 2 sodium plus potassium plus glucose plus BUN. As simple as that. But unfortunately, we don't live in such countries. We are going to live in the what thing? We live in the India. So in India, you're going to be having the electrolytes given in the milliequivalent per liter, but it is going to be the mg per deciliter, in which the glucose and blood urea nitrogen will be given. The question has asked which of the following is not required. Which of the following is not required to which of the following is not required to what thing? To measure the osmolarity. So the options were sodium, glucose, calcium, and nitrogen. So calcium is not required. Remember that. Okay. So blood, urea, nitrogen, glucose, sodium, and potassium will be required. Okay. So that is osmolarity and anion gap. Stop doubting yourself. Work hard and make it happen. I want you to crack this exam in this attempt, no matter what. Okay, चलो आगे बढ़ते हैं. We have finished what thing? All of them are going to occur. Nephron में बहुत सारे type of transport are going to occur. What exactly you wanted to ask बेटा? Nephron में tight junctions are present. Okay. ट्रांसपोर्ट तो बहुत सारे होते हैं बेटा. पैरासेलुलर भी है, ट्रांससेलुलर भी है, प्राइमरी एक्टिव, सेकेंडरी एक्टिव भी है, राइट? सो देयर आर मल्टीपल one to everyone. Yes, I have seen your this thing question, right? So please remember, it is going to be there. SGLT is present in the apical end. Yes, Dhwani, you're absolutely correct. Apical end, you have SGLTs, and in the GIT, if I specifically tell you, both the things will be there. SGLT is also there and GLUT is also there. But as you said, the SGLT will be present on the apical membrane. Basolateral pe you have the GLUT. Same is going to happen in the nephron. SGLTs are present on the apical side and GLUTs are present on the basolateral side. Once it has absorbed into the cell, from the cell, GLUT are going to transport them into the blood. Okay, remember that. चलो आगे बढ़ते हैं. There is unequal distribution of the ions. First of all, if I ask you most abundant cation into the cell, tell me the answer. Most abundant cation is going to be Aishwarya. Wonderful. It is going to be potassium. Raj, Nobita, Abhishek, iPad, Johnny, yes, whatever names I can read. Okay, so wonderful, guys. But if I change the question to most abundant divalent cation, then the answer is going to be, it is not going to be potassium because it is monovalent, right? It is going to be magnesium. If I ask you, tell me most abundant cation in the ECF, then the answer will change to sodium. And please remember, most abundant anion is going to be chloride over here, phosphate over here, right? With the phosphate, just remember P walas are inside the cell. That is nothing but phosphate and protein. Sodium and chloride, salt is going to be more outside. Remember that. Alright, salt के साथ साथ क्या क्या होता है? Calcium plus bicarbonate is also more outside. Alright, now some non-padhaku bachchas are going to come in the chat because they might not have to give the exam right now and you have to learn to ignore them, right? Otherwise, they are going to disturb your padhai. So, non-padhaku bachchas are going to affect the, we can say, padhai of padhaku bachchas are going to be called as Gibbs Donan equilibrium. So अगर कोई भी question आता है regarding the distribution or differentiation, your answer is going to be Donan's equilibrium, right? So effect of non-diffusible ions, which will not allow the diffusible ions to go completely outside, right? Because there is an electroneutrality which you have to maintain. So please remember effect of non-diffusible ion on the distribution of diffusible ion, which is also known as permeant ion. Permeant bolo, diffusible bolo. Non-diffusible bolo, non-permeant bolo, one and the same thing, right? The answer is going to be Gibbs-Donan equilibrium. Now, which are the two ions which are permeable or which are diffusible at rest? If I ask you at rest, see, stimulus deke I can open any channel, no? But if I'm not giving the stimulus at rest, only two ions will be permeable. Potassium is fully permeable. Partially permeable is going to be chloride. Potassium more than chloride. Yes, wonderful guys. Now, if this question comes, what will be your answer? Tell me the answer fatafat se so that we can move ahead. So I told you, if any question comes regarding unequal or asymmetrical distribution or differentiation, it is going to be Donan's effect, right? So please remember, it is nothing but Gibbs-Donan reaction. Now, there were a bhai sahab. Ek bhai sahab the, right? Who were they? Who was he? He was the nurse, and he gave the formula for equilibrium potential. He said, I can calculate the equilibrium potential. Ye bhai sahab ne bola, hum calculate kar sakte hain. So, what is the formula for equilibrium potential he has given? RT by ZF log, natural log of concentration outside upon concentration inside. Very, very difficult formula. We are the students of biology, right? We do not want to complicate the maths. As easy it is going to be, we are going to make it easier, right? So we are going to remember 61 upon Z. Z is nothing but the valency, right? Whatever cap is the electrolyte wearing. For example, potassium is wearing +1 ka cap, calcium is wearing +2 ka cap. So it is going to be +2 over here. If I take chloride, it is going to be -1 because it is wearing the -1 ka cap. All right. So Z is nothing but the valency, or you can write it as valency, right? And natural log is difficult to calculate. So we're going to calculate the log 10. Right? So concentration outside upon concentration inside. So 61 upon Z, log 10 of concentration outside upon concentration inside. That is the formula. You have to remember this. They can ask you to calculate it. Okay. Chalo. So equilibrium potential is different, which was given by the Nernst equation, and RMP is completely different. Please remember, equilibrium potential is for just a single ion, right? It is not for the multiple ion, or it is not for the whole membrane, right? But if I ask you about the potential across the whole membrane, it is going to be called as resting membrane potential, right? So resting membrane potential. Log कैसे solve करते हैं? विराग. So log 10 अगर आया 10 का, number of zeros you are going to take, right? Log 10 of 10 is going to be how many number of zeros are going to be there. According to that, you are going to calculate, okay? Log 10 of 10 is 1 because 1 0 is there, 2 zeros are there, 3 0. Something come like 50, 60, 70. So it is between 10 and 100. So you can take 1 point something like that, all right? So that's how you're going to calculate the log, and calculators will be given to you. Don't worry, all right? So equilibrium potential of the sodium is going to be +60, chloride is going to be -70, potassium +90, and calcium double that of the sodium +120 on an average. That is +110 to +130. Now, how the plus and minus signs they are decided? So please remember, potassium is more where? Potassium is more inside the cell. When positively charged ion goes outside more, what is going to happen? The positivity leaves the cell, and that is going to make my cell negative. Right? But if I ask you what is going to happen in the chloride movement, chloride is going to come in, but this is a negatively charged molecule. Negativity is coming inside the cell, will make my cell negative. But if I ask about the sodium and calcium, see over here, sodium and calcium both are more outside. And if I open their channel, both of them are going to come inside the cell. Both of them are positively charged. As and when they come inside my cell, they are going to cause the positivity to build up. All right. So please remember, yes, potassium is minus. You guys are absolutely correct. Yes, it's printing mistake. So it is minus. Minus 90. You guys are absolutely correct. Yes. So potassium and chloride, they are minus. Neurons का क्या है? Neuron का minus 70. Skeletal muscle, cardiac muscle, they have to produce the force. So magnitude is going to be a little bit higher. That is going to be minus 90. Smooth muscle minus 50. Please remember, in some exams they have asked the question on the pairing. They have given the smooth muscle as 8 to 12. No, it is not that less. Right? 8 to 12 होता है आपके RBCs का. All right, but smooth muscles are going to have minus 50 millivolt. So the SA node on BR, that is nothing but the basal electrical rhythm, which is produced by the GIT ka pacemaker cells. What are the pacemaker cells of the GIT? It is pacemaker cells of Kahar, which are going to produce what thing? Basal electrical rhythm, which is fluctuating RMP, and fluctuating RMP is from minus 40 to minus 60 below, या फिर minus 60 to minus 40 below, one and the same thing. Okay, so that is going to be your RMP. RMP is not for the single ion, it is for the complete membrane. Multiple ions will be involved. Remember that. All right. Now there are two terminologies that you have to remember, that is IPSP and EPSP. If I ask you which one of these are going to call the negativity inside the cell, which one of these are going to call negativity inside the cell? See, inhibitory postsynaptic potential नाम में ही N है, that means negativity inside the cell, and X looks like positive, not your X I'm talking about the X alphabet which looks like positive. So please remember, the positive charges, excitatory postsynaptic potentials, are positive. So what are the examples of inhibitory potentials? Inhibitory potential का example दो फटाफट. Is going to be potassium efflux, and chloride influx, which we have already seen, right? Excitatory ka all the positively charged ions. Sodium, calcium, or even potassium ka influx. Yes, the influx of potassium also occurs in the ear. Right, so please remember, positively charged ion, when they are going to move inside the cell, no matter which ion I'm talking about, if it is positively charged, when it comes inside my cell, it is going to build up the positivity. Sodium, calcium, and potassium ka influx. All right, chalo. RMP. Let's talk about RMP. Genesis is caused by the diffusible ions. And can you tell me diffusible ions? कौन से होते हैं diffusible ion? फटाफट से बताओ. At the rest, you're going to have wonderful. It is going to be Catherine, wonderful. Dhwani, rotavirus. Yes. Rohit Sharma, iPad. Virat Kohli. Okay. So it is going to be potassium more than chloride. Potassium more than chloride. If I ask you, tell me, sodium alone has any role in the RMP or no role? It has absolutely na. It itself says na, absolutely no role. But if I ask you sodium potassium pump, then it has a minor role. Remember that. Okay. What is Nokia pump? Nokia pump is sodium out, potassium in ATPase. How many sodium out? Sodium has 2 alphabets in its symbol. Add 1 into it will become 3. And potassium is 1 alphabet. Add 1 into it, it becomes 2. So it takes the sodium, 3 sodium, and put it outside, takes 2 potassium in exchange and put it into the cell. If I give you 3,000 rupees, okay, if I give you 3,000 rupees or 30,000 rupees, let's say, right, agar 3 kam lag rahe hain to, and you give me back how many? Only 20,000 rupees. So I will be in the loss of 1,000 or 10,000 rupees, right? But I'll assume that you have utilized that for the purchase of question bank or something which is going to help you in the study, right? So I can say that yes, it is a gain, right? So you can say positive ka loss, or वन पॉजिटिव का गेन, राइट? जरूरत सबको होती है, आई नो दैट, है ना? मैं कंगाल हो जाऊंगी अगर सबको सेंड करनी पड़ी तो। नेक्स्ट, वन पॉजिटिव लॉस, वन नेगेटिव का गेन। आई डिड नॉट इवन इमेजिन कि डायपर में इतना खर्चा होता है। द मोस्ट आई एम स्पेंडिंग राइट नाउ इज ऑन द डायपर, राइट? सो चलो आगे बढ़ते हैं। कपलिंग रेशियो, हाउ मच इज द कपलिंग रेशियो? 3:2, है ना? 3:2 is going to be the coupling ratio. 3 sodium out, 2 potassium in. Maximum ATP consumption at rest or basal condition. Okay, ये जरूरत सबकी होती है। So maximum ATP consumption at rest or basal condition is BMR. Why? Because at rest you're going to have the sodium potassium pump on every cell which is working all the time, and it is active transport. Remember which active you are going to tell me. Which active transport? Sodium potassium pump is primary active, secondary active, or what? Absolutely correct. It is pump, so primary active. It maintains high sodium outside because who comes inside? If the sodium is going to come inside, piche water is also going to come inside. Cell swelling will occur and cell will burst, which we do not want, and that's why we have to keep this sodium out, right? And it maintains some more potassium in. That is going to create the gradient, and which is going to generate the RMP, right? And that's why it is going to be called as electrogenic pump. Electrogenic pump. All right, cell injury. Yes, Shahrukh Khan, wonderful. All right, next, if I ask you, ये हो गया RMP का, but what about action potential? If I ask you, in the motor neuron, where the action potential is generated, at what site of the neuron, your answer is going to be initial segment. If I ask you, in the sensory neuron, where it is produced, it is going to be in the nodes of Rambier, right? So please remember how to remember. You are going to remember Miss Senorita, right? What is Miss Senorita or Miss Senor? MIS, that is nothing but motor neuron mein initial segment, sensory neuron mein nodes of Ranvier. That's how you're going to remember it. Action potential in the nerve, you are going to remember one more mnemonic, Dinkar. What is Dinkar? See over here, as soon as you give the stimulus, the sodium is going to be coming inside, known as sodium influx, which is going to cause depolarization. So depolarization is because of the influx of the sodium, and then what is going to happen? You're going to reach to the spike potential. As soon as you reach to the spike potential, what is going to happen? As soon as you reach to the spike potential, what is going to happen? You're going to close the sodium channel. Just give me a minute. All right, so let's start. Existential crisis ho gayi. Chalo, next. So spike potential, what you're going to do? Spike potential is going to be, spike potential mein you're going to close whatever channel is open. So we have opened already the sodium channel. So we are going to close sodium channel closed. फालतू चीजों में कितना इंटरेस्ट होता है आपको बातें करने में? ध्यान दो, एग्जाम आ रही है. सो पोटेशियम चैनल, ओपन द पोटेशियम चैनल ओपन, है ना? सो potassium efflux is going to cause the repolarization. So I'm just changing the influx ke niche, influx of sodium, right? So Dinkar, what is Dinkar? Depolarization is because of influx of sodium. And what is Kar? Kar is KER, that is the potassium efflux causes repolarization, right? But there is a problem. What is the problem? The sodium channel and potassium channel, they're absolutely opposite. What I mean by that, if I ask the sodium channel to open, it will quickly open. But if I ask them to close, it will quickly close. But if I ask the potassium channel to open, it will open very, very slowly. And it will close very, very slow. Right? While it is closing, what is going to happen? More and more potassium will go outside even when you have reached to the RMP already. So the potassium outside will continue, the efflux will continue, and that is going to cause what thing? More negativity, hyperpolarization. That is because of slow closure of potassium channel. Slow closure of potassium channel. All right, please remember that. All right, chalo. Next, if I ask you this question, answer दो फटाफट से, तब आगे बढ़ेंगे. Dinkar mein, who comes first? N comes first and then comes the K. So please remember, it is going to be sodium channel which is going to open. As soon as the action potential starts, that means Hodgkin cycle starts. In the Hodgkin cycle, you have the sodium entry, that is sodium influx is going to start first. Right, next, refractility. What do you mean by refractility? Means absolute no response, but already one response is going on. So we can write it as no second response, no second response, because already one response is going on. Now what happens here is that from the beginning, or you can say from the firing level till 1/3 of repolarization, I just changed the color. See over here, from firing level till 1/3 of repolarization, if I give in this duration, if I extrapolate this, in this duration, if I give any stimulus here, there will be no second response. That means there will be no second action potential which is going to be produced, right? So that means it is absolutely refractory period. So assume that this is the away time. That means it is a very first few months of the semester, right? During which my brother did not study, right? No matter which language my dad applied. But as soon as the exam comes near, as soon as the RMP comes near, a strong stimulus, his girlfriend is going to say that if you do not pass or get marks equal to or more than me, then I'm going to leave you. This is a very strong stimulus near to the exam. फिर क्या होता है? Yes, the second action potential is going to come like this. But please understand, this second action potential started from the point which is already somewhat away from the RMP, right? So it is not a mature response, it is premature response, right? So it is very premature. नहीं, लड़की के इसमें पढ़ रहा है, right? कुछ भी हो, हमारे लिए तो फायदेमंद था, right? So please remember, from the firing level till 1/3 of repolarization is going to be absolutely refractory, no matter which language my dad has used, right? Chappal ka language, Belen ka language, he does not study. But when the relative refractory period start, yes, the strong stimulus can produce the response. Strong stimulus or stronger and please remember that if the ectopic foci, that means some abnormal foci falls into what? Some abnormal foci. All right, I'll change the Wi-Fi. Is it okay now? I'll change the Wi-Fi, wait. Is it fine now? 4 वाईफाई लगा रखे हैं, ठीक है? हॉस्पिटल का एक है, घर का एक है, पता नहीं कौन कौन सा कनेक्ट हो जाता है. एल प्रोफेसर, क्लास नहीं अटेंड कर पाओगे नेक्स्ट टाइम. चलो, so ARP, long the ARP, I hope you have कहाँ तक थे हम? I don't know from where the lag has started. Anyways, चलो. So first thing first, absolutely refractory period. I'm repeating this slide again. Refractory means no secondary response. Firing level से 1/3 of repolarization. Before 1/3 repolarization, absolute refractory. After 1/3 repolarization till the RMPC, 2 hours are coming now. Sorry. So 2 hours are coming. So RRP, so relative refractory period, RRP. All right. Stronger stimulus than the first stimulus can produce the second action potential, second response. But see over here, ARP is longer in the heart muscle. It is longer in the heart muscle. So please remember, thanks to that the second ectopic foci will not be able to produce the second action potential, and heart will not go in the sustained contraction. And sustained contraction is what? Sustained contraction is going to be, sustained contraction is what? the tetany. So heart muscle cannot be tetanized. Heart muscle cannot be tetanized. Ectopic foci. Please remember the abnormal foci. Ectopic means abnormal site. So if the foci has come and it is going to fall into the RRP, it can produce the response which is going to be premature. So we call it as premature ventricular contraction, PVC. Premature ventricular contraction. Which is also known as extrasystole. Yes, absolutely correct. That is known as extrasystole, right? Which is a risky phase. Why? Because it can produce the arrhythmia. The rhythm is broken. Abnormal rhythm will be formed. That is known as arrhythmia. RRP ka significance. Coming on to the myelin. Myelin sheath is there in the PNS as well as CNS. Peripheral nervous system, it is going to be formed of Schwann cells. Central nervous system, it is formed of oligodendrocyte. See the difference. This is one Schwann cell. This is another Schwann cell, another Schwann cell, another Schwann cell. And this is the nuclei of those cells. So see over here, one Schwann cell is covering only one site of one neuron to myelinate, right? But see over here, this is one oligodendrocyte. It is covering multiple sites to myelinate of multiple neurons. So if the antibodies are formed against the oligodendrocyte, one site will be sclerosed or multiple sites will be sclerosed at a time. Multiple sites will be sclerosed. So this is known as multiple sclerosis. When I'm going to see the neurons under the microscope, multiple sites will be sclerosed, hence the name multiple sclerosis. All right. So they're going to ask you multiple sclerosis may against which cells the antibodies are formed. So please remember, antibodies against oligodendrocyte is going to cause multiple sclerosis. Axoplasmic flow. In the cell you have cytoplasm. In the axon you have axoplasm. If you go from the cell body, that is nothing but soma. From the soma, if you go towards the axon terminal, this will be called as anterograde transport. Anterograde transport is with the help of two proteins, that is nothing but kinesin and myosin. Kinesin and myosin. Please remember that from the soma towards the terminal anterograde. But there are some things which are going to go back, such as empty vesicles or unused neurotransmitter, some mitochondria, unused nerve growth factor. This is going to be carried by another transporter. But while taking all those things, it can take some viruses and toxins such as rabies, herpes, polio, tetanus. So what are these? Rabies, herpes, polio and tetanus. Right? These can go with this retrograde transporter and it can make the person die. Who helps the person to die? That is nothing but dynin. So please remember, the protein dynin is going to help the person to die with carrying all these toxins or the viruses. That is rabies, herpes, polio, tetanus. That is known as retrograde transporter. Right? So this question has come in the 2023 January. So can you solve this question? Kinesin, dynin and myosin, they are what? Are the cell membrane protein? No. Cell organelle adherent protein or junctional protein? Kya? No, they help us in the axoplasmic flow or axoplasmic transport, anterograde or retrograde transport. There were two bhai sahab, Erlanger and Gasser. What they said? They said ki sun lo. There are three types of nerve fiber. एक तो होता है thick myelinated A fiber, thin myelinated B fiber, and teeny tiny C fiber, which is thin unmyelinated. As you go from A to B to C, what is going to happen? The myelination decreases. Yes, then the thickness decreases or the diameter decreases, and because of that, the speed of conduction, that means velocity decreases, right? So as you go towards C, the speed of conduction of the impulse or the velocity is going to decrease. Now, they also said that B and C does not have any subdivisions, but A has 4 subdivisions. What are the 4 subdivisions? A, alpha, beta, gamma, delta, right? 2 are motor, 2 are sensory. 2 are motor are alpha motor neuron, gamma motor neuron, remember, and then beta and delta, they are sensory. Let's get rid of this B and C because they're easiest one. You must have heard of the sympathetic preganglionic fibers, they are smaller, and postganglionic fiber, they are larger because sympathetic changes near to the spinal cord. right? So preganglionic is shorter and postganglionic are larger, right? Vice versa in the parasympathetic system, which are the part of autonomic nervous system. So be that the sympathetic or parasympathetic, the preganglionic fibers are formed of B fibers, B type of nerve fibers, and postganglionic are formed of C type of nerve fiber. But C was not happy with just being the postganglionic ANS fiber. She says कि मैं कोई sensation भी carry करूँगी, I'm going to carry some sensation also. So we give pain and temperature to carry. But A delta also carries pain and temperature. Who will be faster amongst A delta and C fiber? Of course, it is going to be A delta, which is going to be faster. So the pain which it carries, we are going to call it as fast pain and temperature, and this is slow pain and temperature. In the temperature, just remember, C never goes with C. That means cold temperature will not be carried by C. It is going to be carried by A delta. And if they ask warm temperature or hot temperature, it is going to be carried by C fiber. Just remember, C never goes with C. Okay. Yes. Now, A fiber and the A alpha fiber and gamma, they are motor. But again, medicine इतनी आसान होती तो बात ही क्या थी? A alpha says I'm going to carry some sensation also. So which sensation? Proprioception. What is proprioception? Sensation of position, right? So proprioception will be carried by A alpha. So three sensation we have learned about. Either it is pain, either it is temperature or proprioception, right? Except pain, temperature, proprioception. Rest all the sensation except pain, temperature and proprioception, rest all sensations will be carried by A beta fiber. So if I ask you, fine touch is carried by A beta, crude touch is carried by A beta, vibration is carried by A beta, stereognosis, graphesthesia is carried by A beta, everything else is going to be carried by A beta except the pain, temperature and proprioception. Now, if I ask you, tell me, if I start compressing these nerves, right? So from here also and from here also, who is going to get compressed first? It is going to be the A fiber, but because it does not have much of the margins to expand or compress for, right? So who is going to get affected first? If I say susceptible, most susceptible is A fiber, then B fiber and C fiber. So who is most susceptible for pressure? A more than B, more than C. It is most susceptible A, and this is least susceptible C. Right? But if I ask you, let's say your friends were there, you are giving the exam, but they wanted to, enjoy their winter vacation. So they went onto the mountain trekking. But as they go up, what is going to start? The air will be thin and they have dyspnea. So they know that you are a medico. So they call you ki bhai, dyspnea ho raha hai. So first of all, you are going to abuse them ki blah, 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 dash, 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 dash. Right? But then you are going to ask them to come back, right? Because that is the best solution. So come back. So B more than A more than C is going to be the susceptibility of the nerve fibers to the hypoxia. Remember that. All right. So 28-year-old present with a complaint of weakness, numbness, right hand mein after a night of heavy drinking. What is this? After a night of heavy drinking and falling asleep with his arm draped over the back of the chair. That is nothing but Saturday night palsy. Draped over back of the chair is compressing it from below and the head is compressing from above. So it is going to be A more than B more than C. The more than ka sign is not there over here. The sign is reversed, that is less than. And this is the question which has come on in the last exam. So be careful about it. So it is going to be C less than B less than A. It is going to be option C. Wonderful. It is neuropraxia. Right. Next, इसी coupling में आते हैं excitation contraction coupling. I want your complete attention over here. First thing first, the action potential will be generated into the nerve, right, which is going to come into the axon terminal. There will be one channel which is going to help me in the exocytosis of the neurotransmitter. You guys are going to answer me. There is one ion. If it is increased in the muscle, it is going to cause contraction. In any other place, it is going to cause exocytosis. What is that? Wonderful, guys. It is going to be calcium. Calcium is the one which is going to cause exocytosis in the nerve. So it is changed or opened because of the depolarization which has come through the action potential. So I'm going to call this channel as voltage gated calcium channel. Everything is written. Just give me 100% attention over here. Voltage से open हुआ, voltage change से open हुआ. That's why we are going to call it as voltage gated calcium channel, which causes the release of acetylcholine. which type of acetylcholine receptors are going to be there on the motor end plate. What is motor end plate? The end of the muscle which is coming in contact with the axon terminal will be called as motor end plate, right? Motor end plate, you're going to have acetylcholine receptor. My question is, which type of acetylcholine receptor? Is it muscarinic or nicotinic, guys? It is going to be nicotinic type of acetylcholine receptors. What is going to happen? Of course, the acetylcholine are going to sit over here. So suppose these are the acetylcholine receptor, one acetylcholine sit over here, one acetylcholine sit over here, and they themselves act as the sodium channels also. As soon as the acetylcholine is going to sit over here, these channels are going to open up. So they act as ligand gated sodium channel. Acetylcholine receptor bolo ya fir ligand gated sodium channel bolo, one and the same thing, right? So please remember, they are going to open up and the sodium entry will start. As soon as the sodium starts to come in, if the adequate sodium has come in, it is going to cause depolarization. Sufficient depolarization can produce the action potential. Now, action potential is going to propagate forward. That means it is going to move forward. Kab tak? Infinity tak kya? No, not till the infinity, till the point it hits the DHPR. What is DHPR, guys? DHPR is dihydropyridine receptor. Mind you, we are learning about the skeletal muscle. In the skeletal muscle, ye by heart kar lo. In the skeletal muscle, DHPR is just activated, it won't open. Right, and that's why only and only calcium source is going to be sarcoplasmic reticulum. What happens? Action potential starts, it hits the DHPR. This DHPR in turn is connected with the spring-like structure, which is mechanical connection to another channel known as ryanodine receptor, which is RYR, present on L-tubule, and L-tubule is nothing but sarcoplasmic reticulum. See over here, there are two tubules. If this is the muscle membrane, transverse to the muscle membrane, I have transverse tubule. Parallel or longitudinal to the muscle membrane, I have longitudinal or L-tubule, right? So please remember, transverse tubule pe if I ask you which calcium channel is present, your answer is going to be DHPR. If I ask you L-tubule pe, longitudinal tubule pe, which calcium channel I have RYR. Yes, both of them are calcium channel. In the skeletal muscle, DHPR is just activated, it will not open. RYR will open all the time. As soon as the DHPR is activated, see over here, DHPR and RYR ka relationship. In the resting phase, it is going to be like this. As soon as you stimulate the DHPR, the spring will be coiled, and as soon as the spring is coiled, what is going to happen? The RYR will be open, and the sarcoplasmic reticulum is the storehouse of calcium. Bhar ke calcium is going to come out from the high concentration towards the low concentration into the myoplasm. And I told you, whenever you're going to increase the calcium in the muscle, it is going to cause contraction. Calcium, increase in the calcium in the muscle, contraction in any other tissue, it is going to cause exocytosis, right? Calcium causes contraction in the muscle. So this is about the excitation, contraction, coupling. So see over here, nerve action potential is going to cause opening in the calcium channel of the axon terminal, right? That is going to cause exocytosis of acetylcholine, and that is going to open up the ligand-gated acetylcholine channels. That is nothing but, what is this? Nicotinic acetylcholine receptor, one and the same thing, right? Action potential will be produced in the muscle. It causes activation of DHPR, and activation of DHPR is with the help of action potential. So electromechanical coupling, electrical activation of DHPR causes mechanical contraction of the spring-like structure, opening of RYR. So electromechanical coupling is there between the DHPR and RYR, which is going to cause release of calcium contraction. Now there is only small change over here in the cardiac muscle. I told you in the skeletal muscle, the DHPR won't open. It just activated, but in the cardiac muscle and smooth muscle, it will be opened. So as soon as it opens, the calcium will come from outside. This calcium ions are going to sit over here onto the RYR. There will be no spring-like structure present in the cardiac and smooth muscle. So it is going to be calcium-induced calcium release. Action potential in the muscle is going to cause opening, not activation, opening of the DHPR in the cardiac muscle causes ECF calcium to come. Please remember, ECF calcium is only 20%, but it is essential because unless and until this ECF calcium comes, this will not be able to come and this will not be able to release the calcium from the sarcoplasmic reticulum. So please remember, ECF calcium, though it is smaller in amount, but it is essential, right? So calcium enters into the myoplasm, and that is going to cause calcium-induced calcium release. That is CICR. Yes, it will only the one which is going to open up. RYR ka defect ho gaya. Somebody is already told. Yes, Dr. Bacteria has already told. If there is a hypersensitivity of RYR is going to cause what? Or you can say gain of mutation. It is going to cause malignant hyperthermia. What do you give? Wonderful. You give dantrolene over there. You give dantrolene. Solve this question. Voltage gated calcium channel present on to the T tubule. T tubule pe kaun hota hai? T tubule pe you have DHPR, T and D. Remember that. And L tubule pe you have RYR. L tubule pe you have RYR. All right. Chalo. आगे बढ़ते हैं. How the calcium is going to cause contraction? Actually, what is the underlying mechanism, molecular mechanism? It is going to be this, right? So please remember, there are four things: actin and myosin, which is going to come together actually, right? The myosin ka hidden active site of actin, but there is a problem. What is the problem? See over here that these are the active site of actin, but it is covered by the Papa G of myosin, which is nothing but tropomyosin, right? So there is one more protein, troponin. Why it does not help? Because the Papa G has the gun, right? So troponin is scared of that. So who is going to give the encouragement, or who is going to give that courage to the distraction? For the distraction of Papa G, it is going to be calcium. When the calcium and troponin complex is formed, there will be displacement of tropomyosin. So Papa G of myosin actually prevents the contraction. The calcium troponin complex is going to remove or displace the tropomyosin. As soon as the tropomyosin is displaced, active site of actin are free to bind with the myosin head, and that's how the contraction will start. So please remember four names. The actin myosin, these are going to be the ones which are going to cause the cross bridge formation or cause the contraction. Tropomyosin prevents the contraction, right? And it is going to be the troponin calcium complex which is going to remove the this troponin. Calmodulin is present in the smooth muscle. We are talking over here about the skeletal muscle. In spite of troponin, you are going to have calmodulin, which is in the muskan. It is going to be present in the what thing? Yes, please. It is going to be present in the smooth muscle, not in the skeletal muscle. And you have the titin in the skeletal muscle, which is going to give the elasticity, which you do not have in the smooth muscle, which gives you plasticity. Okay. Chalo. See over here, myasthenia gravis and Lambert-Eaton syndrome. Yaad kya rakhna hai? Please first remember, both are the autoimmune diseases. Antibody against voltage gated calcium channel in the pre-synaptic or you can say terminal neuromuscular junction ka pre-junctional antibodies are going to cause Lambert-Eaton syndrome against the calcium channel. And myasthenia gravis is antibody against the acetylcholine receptor. If that is not there in the option, acetylcholine is not given in the option, then you're going to mark it as musk protein. Okay. So how to remember? Remember that when the patient feels better, right? That means in the evening or in the morning. In the morning, the patient of myasthenia gravis is going to feel better because lots and lots of stores of acetylcholine will be available, right? So he feels better in the morning, but he feels worse because the symptoms are going to be worsening as the day progresses. So he feels worse in the evening. Remember that, right? And if I ask you Lambert-Eaton syndrome, it is going to be feeling better in the evening and worse in the morning because the calcium is not sufficiently coming in. How to remember? Remember when the patient feels better. If it is Eaton-Walla syndrome, he feels better in the evening. right? And if it is myasthenia gravis wala patient, he feels better in the morning, and vice versa you can do if they have given worsening of the symptom. Okay, chalo. A patient came with the symptom of drooping of eyelid. What is this? Answer this ka. Symptoms increases as the day progresses, means he is going to feel worse in the evening, better in the morning. Better in the morning, that means myasthenia gravis. So better in the morning, myasthenia gravis. Skeletal muscle mein, you're going to have different bands and different zones over here. Pink color one, let's say this is myosin. Whole of the myosin. That means the complete myosin. Whole myosin means complete myosin. That means overlapped on non-overlap part. Overlap by the actin or non-overlapped part by the actin. Both the myosin. That means non-overlap myosin and overlap myosin. What I mean by that, see over here. These green molecules are actin. Pink molecules are myosin. There is some part of myosin which is overlapped by this green part, nothing but the actin. Right? So whether it is overlap part here and here or non-overlap part only myosin over here, both of them are going to come under the A band. A band means complete myosin, right? But if I have to take only non-overlap part, only myosin, then only myosin will be called as H zone. H zone, wonderful. It will be called as H zone. Similarly, only actin if I take, that will be called as Hanji. Only actin. That means which should not be covered by the myosin, that will be called as I band. You have the I band over here, you have another I band over here. Ajo, I band over here and another I band over here. Exactly in the middle of I band, what do you have? Exactly in the middle of I band, you have Z line, right? Exactly in the middle of I band, you have Z line. All right. Now, so, and exactly in the middle of sarcomere bolo or exactly in the middle of A band bolo, you have the M line in the middle. In the middle, you have M line, right? So see over here, Z to Z is going to be your sarcomere. The whole thing is known as sarcomere, right? And in the middle of sarcomere, you have M line. Now, if I ask you, tell me, what is going to decrease? What is going to decrease? Okay. Dr. Bacteria, it is going to be better in the morning, beta. Better and worse likha hai na? Worst in the evening. Worst in the evening means the symptoms are going to increase in the evening. Okay, right. Now, see over here. So what is happening? That the I band is going to be there and A band is going to be there, right? So if I ask you, what is going to happen if the contraction begins? So what is going to happen to the only myosin? It will start to decrease and even it can disappear when the complete overlap is there. If there is a complete actin myosin overlap, the H zone can disappear. It can disappear also. Right, H zone can disappear. Now see over here, what happens the I band, what happens to the I band? Of course the overlap increase, so only wala are definitely going to decrease, right? Because the overlap increase, so only actin is also going to decrease. What happens to the M line? Tell me. M line is going to say the same, right? It is not going to change, rather it will become more prominent. So M line won't change. And A band, what is happening to the A band? Tell me that also. A band will also not change. So two things which will never change, the M line and A band will never change. Never decrease, I can say. Thank you. So it is not going to change. So M line and the A band will never decrease. So please remember, today some Chaturthi is there, right? Which comes in 6 months. Every 6 monthly only this Chaturthi comes, right? And what happened yesterday? My baby was playing in the night, so I was also playing with him, right? And he didn't sleep, so I didn't sleep, of course, right? Then there is a nappy change and everything, and then the feeding part, and then again waking up part. So I woke up late. I took bath very late. late, right? Around 9 o'clock, something like that in the morning. So my mom started scolding me, right? Ki today is the Chaturthi and you haven't taken bath yet, right? Because in the morning, it seems that 5 o'clock or 6 o'clock, you have to take the bath before the sun comes, all right? So ma will never change, no matter even if I become a mom, right? So तना मारना है तो बहाना मिल जाता है उनको कोई ना कोई, right? So please remember, ma will never change. No matter what happens, I should take the bath, right? Otherwise, Ganeshji is going to be upset with me. All right. So ma will never change. Remember that. Okay. Chalo. Next, calcium bind to which one of the following protein in the smooth muscle contraction? Tell me. In the smooth muscle, they have asked. Please remember, troponin is absent in the smooth muscle. Yes, घर में मोदक बन रहा है, right? And first modak is going to go to my baby. Just, you know, I don't know how he's not going to eat it, but you know, वो होता है कि my mom is sitting, taking him in the lab and doing that all puja and everything, right? So yes, whatever it is, and I'm taking the class, है ना? Though I require it the most. Absent in the smooth muscle. The troponin is absent, ma will be ma. So absent in the smooth muscle and calmodulin, right? Calmodulin is going to be the calcium binding protein. Chalo, ध्यान दो यहाँ पर calcium binding protein. Otherwise, I'll be scolded because she's here now. So calcium binding protein in the smooth muscle is going to be calmodulin. I have to be very, very careful now. Troponin is absent in the smooth muscle. Titin is also absent in the smooth muscle. Please remember that. Even the Z line. Instead of Z line, which is analogous to the Z line, what structure is present in the smooth muscle? It is going to be, yes, please, anybody. It is going to be dense bodies, right? Dense bodies. So Z line is going to be dense bodies. Z lines are present in the skeletal muscle, but they're not present in the smooth muscles. Smooth muscles mean you have dense bodies. Remember that. Okay, dense bodies. All right, chalo. Which of the following component is absent in the smooth muscle? Actin myosin, you require that. Tropomyosin is also present, but troponin is absent. In spite of troponin, you have, or instead of troponin, you have calmodulin. So we have covered nicely the general physiology and nerve muscle. Let's move on to your favorite topic, cardiovascular system, right? Your heart must be doing duk 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 now, right? As the exam is approaching near. But I know my bachas are going to do well in the exam. All right, chalo. First thing first, you don't have to worry about your heart beating or not because it is taken care by the nodal tissue. Thankfully, it have the autorhythmicity. No matter whether you are, you know, under the stress or not, it is going to be. 2 घंटे क्लास कर लेते हैं, है ना? 7 o'clock we will take a break. Okay, just give me 2 hours, right? 30 minutes are there, right? 30 minutes के बाद कर देते हैं पक्का, है ना? Not now, otherwise it is going to be too early, है ना? Autorhythmicity we have to finish it also. Autorhythmicity, just listen to me for next 25-30 minutes. Definitely I'll give you the break. Okay, autorhythmicity, it is because of 3 ions. Which are the 3 ions? ध्यान दो यहाँ पर. Funny current, so leaky channel or funny channel we can say, or HCN gated. What is HCN gated? Hyperpolarization activated cyclic nucleotide gated channel. Nobody is going to ask you the full form. Just remember that they are going to open in the hyperpolarization, right? So hyperpolarization activated with channels. It is going to be the sodium channels. And that's why I have highlighted the N over here, right? So please remember, it is going to be your sodium channel, the first, and then second is CAT. What is CAT? C को अलग करो and T को अलग करो. It is calcium T channel. T means transient. What do you mean by transient? Transient means for very long duration or for very short duration. It is going to be for very, very short duration. है ना? And PIC is what? P for potassium. You can remember it as kick also. So remember potassium immediate closure. Actually, the potassiums are Kachua channel. We have learned that, but over here in the heart has given such an importance, right? In the Bollywood, Tollywood, Hollywood, everywhere. So please remember, it is the potassium channel, which is going to be different over here. Potassium immediate closure is going to occur here, right? So please remember, can you tell me the RMP of this nodal tissue? Tell me the RMP of nodal tissue, Zara. बताना क्या है RMP of the nodal tissue? Yes, please. It is going to be, yes, absolutely correct. It is unstable or non-stable RMP. It is going to be -60 to -40 millivolt. First is going to be increase in the sodium because of their opening, right? Then you are going to have the calcium T channels. increased calcium calcium influx, right? Positively charged ions, right? And then you have potassium immediate closure. I'm writing increase in the potassium because potassium will not be able to go outside, right? And because it is going to close, and that's why I'm going to mention it like this, potassium channel closure, right? Please remember this is a pacemaker potential, but this is the RMP also, and RMP is usually which phase? It is going to be phase 4. RMP is phase 4. Remember that, right? As soon as you reach to the firing level is what? It is nothing but your minus 40 millivolt. As soon as you reach to the minus 40, what is going to happen, Hanji? What is going to happen as soon as you reach minus 40? The calcium channel, other calcium channels are going to open. And which are these calcium channels? These are calcium L channels. L channels means short acting, long acting, of course, long acting channel, right? And they are going to be open till infinity. Kya? No, unless and until it reaches to the peak, and peak is known as spike potential. What you do at spike potential? Whatever channel is open, you close that channel and you open potassium. So potassium will be opened. As soon as the potassium will be opened, what is going to happen? Ji, bataiye. Potassium efflux will be started, right, till minus 60, and then immediate closure. So potassium efflux will start. That is going to cause repolarization. You are returning back to your normal negative polarity. So please remember, this is before the RMP, next RMP, and that's why this is nothing but phase 3. Phase 3, right? And depolarization in the heart. Please remember, D looks like O, na? So depolarization in the heart, I'm writing over here. Depolarization in the heart is none other than phase 0. Phase 0, remember that. So which two phases are absent? If I ask you, 1 and 2 are absent. Phase 1 and 2 in nodal tissue. So in the nodal tissue action potential, phase 1 and 2, they are absent. But this action potential will be produced in the nodal tissue. That is nothing but the SA node. SA node se it is just going to carry forward into the AV node. AV node se it is going to go in the bundle of His. Bundle of His se kahan jayega? Bundle branches mein. And after the bundle branches, it is going to go in the Purkinje fiber. From the Purkinje fiber, these Purkinje fibers go and stimulate your cardiac muscle. Cardiac muscle is different, nodal tissue is different. If this is different, it is going to produce different action potential also. So I'm going to draw the cardiac muscle ka action potential here. It looks something like this. Right? Now tell me the RMP of cardiac muscle, it is nothing but minus 90. As soon as the Purkinje fibers are going to carry the action potential, that's act as a stimulus for the action potential in the cardiac muscle. So as soon as stimulus comes, sodium channel opens, right? And sodium influx starts, right? Till what point? Till the point you reach to the spike. Spike pe kya karoge? Close the sodium. Spike potential. Spike potential mein what do? Close the channel, whichever is open. So sodium channel is open. So close the sodium and open what? Open potassium. And potassium is the one which is not going to stay unless and until it reaches towards the RMP. Till the RMP, it is not going to close, right? So first of all, there is a transient opening potassium channel. So these are transient opening and these are delayed opening, you can remember, right? So to do, yaad rakhna, to do list banate na, to pehle aata hai to, that is the transient opening and delayed opening, right? So first comes transient opening, which is going to be opened, and after the transient opening potassium channel, there are one channel which is going to open, that is calcium, which is going to open in between. Now see over here, this phase, concentrate on this phase. One positively charged ion coming in and one positively charged ion going out. So the potential is going to be balanced. It is not going to be negativity or positivity which is going to be created or generated. So this is known as plateau phase over here. So this is a flat line which is known as plateau. Plateau sounds like 2, so I'm going to call this as phase 2. After 2, what comes? After 2 comes 3. So this is going to be phase 3. This is your RMP, and I told you in the cardiac muscle. RMP is phase 4, right? So 2 के पहले क्या आता है? What is this phase? This is phase 1, and 1 से पहले क्या आता है? Phase 0. So please remember, depolarization is again phase 0. Please don't get confused. If they ask phase 1 is because of, students directly mark it as sodium. This is not phase 1, this is phase 0. Remember that phase 1 is because of potassium channel opening. Potassium channel opening. So RMP is going to be phase 4. So this is about the action potential in the cardiac muscle. What your cardiac muscle says, what your heart says. फालतू के आंसर्स मत दो. It says just S1, S2, S3, S4. That's all, right? और कुछ नहीं बोलता है ये. It just says S1, S2, S3, S4, right? But S3 and S4 will not be audible to the normal ears, right? Normal ears को क्यों नहीं सुनाई देता है? If somebody is saying that मुझे सुनाई देता है S3 and S4 just after putting the head stethoscope, then you need to check, right? There are some genes of bat. Bat is what? Chamgaddad, right? Why? We cannot hear it because this is below 15 hertz, and normal human being, they have the audible range of 20 to 20,000 hertz, right? So please remember that हाँ आपके में बैटमैन के या चमगादड़ के कोई ना कोई genes आए होंगे. So S3 and S4 is not audible, but there is one physiological condition, not pathological. Pathological तो बहुत सारे हैं, but there is one physiological condition in which the S3 can be audible, and because of the increased plasma and increased RBCs, that is nothing but your pregnancy. Pregnancy is the only one physiological condition I'm saying in which you can hear the S3, right? Anemia hai, cardiac ke bahut sare diseases hai in which you can hear the S3 and S4, but these are pathologies. Only physiological condition, pregnancy. Now, the S3 and S4, let's complete that. It is because of ventricular filling. Early ventricular filling causes S3, late ventricular filling causes S4. It is like you open the tap and keep the bucket below, you're going to hear the sound. Now, S1 and S2, please remember, closure of the valves will make the sound, opening will never make a sound. Closure will make a sound, opening will never make a sound. So please remember, first thing, valve closure are going to make the S1 and S2 sound. First thing first, the first alphabet in English language is A. So please remember, AV valve closure is nothing but your S1 sound, and S for second, S for semilunar valve. So semilunar valve closure is going to make S2 sound, S2 sound. Okay, so S1, S2, S3, S4. Coming on to the systole and diastole, which is the cardiac cycle. See over here, from S1 to S2. If I go from S1 towards S2, I'm going to call this as systole. And when I go from S2 to next S1, if I go from S1 to S2, I call it as systole. And when I go from S2 to next S1, I'm going to call this as diastole. So systole and diastole. Okay. Now see over here, S1 to S2, I'm going to have 3 phases. Which are the 3 phases? Early, mid, and late systole. So S1 to S2, I'm going to divide it into early, mid, and late. What? Early systole, mid systole, and late systole, right? Why? Because as far as physiology is concerned, I'm not very much, required this information. But then in the pathology, in the medicine, and everywhere, you're going to learn about mid-systolic murmur, late systolic murmur, pan-systolic murmur. So in that, you should know which phase is actually showing the defect or having the defect, right? That's why we have divided the systole into 3 different phases. Now, let's see first thing first. Let's say there is heart. Suppose you have, I'll change the color. Let's say this is your left atrium, left ventricle, and let's say this is aorta. Now see, in the beginning of the systole, both the valves will be closed. With which both the valves? AV valve will be closed and the SL valve will be closed. Now I want my heart to go in the systole. Systole mein what I want? I want to eject the blood outside. But there is a problem. What is the problem? The heart is being in the diastole. What is the minimum pressure available or possible in the diastole? In the aorta. Aorta mein minimum pressure is going to be 80 over here. And what is the minimum pressure is present in the, you can say in the ventricle during the diastole? It is 0. You're about to go. You're about to go in what? You're about to go in the systole. You just finished the diastole. So the minimum pressure is going to be 0 over here. And the minimum pressure in the aorta is going to be 80. there is one problem. I need to open the semilunar valve. I need to open this valve, right? Semilunar valve opening. I require that, but it has its own terms and condition. What it says I'm only going to open when the ventricular pressure is more than aortic pressure. Right? Now, how I can increase the pressure? I can increase the pressure via asking the ventricle to contract. So my ventricle will start to contract. The pressure will rise from 0 to 10 to 20, 30, 40, 50, 60, 70, 80. Let's say it became 80 over here, it's 80. It's still equal, but not more, right? But the pressure has increased from 0 to 80. Meanwhile, my heart was contracting. My muscles of the ventricle, they were contracting, but whatever blood the volume was present, neither no new volume has come nor it has gone outside. So please remember, whatever blood volume was present in my ventricle, it is the same. So that's why it is known as the isovolumetric contraction. This is known as isovolumetric contraction. But eventually, because of this contraction, the pressure inside the ventricle will increase and eventually the semilunar valve will open. As soon as the semilunar valve will be opened, as let's say the pressure became 81 and this valve has opened, what is going to happen? As soon as the valve is open, the blood is going to go out, known as ejection phase, right? As soon as this becomes 81. So there is two types of ejection: early ejection and late ejection. In the beginning of the ejection, the heart starts to contract, so contraction requires ATP. We call it as active ejection. Later on, just because of the momentum, right? Just because of the momentum, the blood is going to go out, known as passive ejection. This is also known as a rapid ejection. This is also known as slow ejection. 2/3 blood of the out of stroke volume. 2/3 of the stroke volume is going to go out in the early ejection, and 1/3 of the stroke volume will be gone in the late ejection. Once the ejection is over, what the ventricle is going to do, once the ejection is over, the ventricle will start to relax back again. As soon as it starts to relax, the aortic pressure will be higher and the ventricular pressure will be lower. And this valve will close back again. So semilunar valve will be closed. S2 sound will come. All right, yes. As soon as the work of the ventricle is over, as soon as this class is over, my work is done, right? So suppose I am the ventricle, my work is done, that I have taught you well, right? So I'm going to relax, I'm going to chill out, right? So that is going to close the valve, that is SL valve is going to close. All right, so these are the phases. Please remember, isovolumetric phase is the first phase of whether it is systole or diastole, right? Let's move on to the diastole. There is first phase of diastole. It is not proper diastole, but it is protodiastole. What do you mean by protodiastole? Semilunar valves start to close, but they take some time. How much time? Hours, days? No, only 0.04 seconds. So in this duration, I know that the SL valves are open, but my ventricle started to relax. No, as soon as the ventricle started to relax, I'm going to call it as diastole. But the valves are not closed, so it is not a proper diastole. Hence, I'm going to call it as before the diastole. Just before the diastole, I'm going to call it as protodiastole. After that, the diastole is going to start. Again, diastole क्या होगा? Again, diastole में you're going to divide it into three phases: early, mid, and late diastole. Right? Now, early diastole में same thing is going to happen, that you have to open. Now you have to open. See, this is the diastole. So my ventricles are not having much of the blood. So they want the blood. But there is one problem. What is the problem? Both the AV valves and SL valves, they are closed. Now I want to open which valve? I want to open which valve? Yes, please. I want to open this AV valve. How the AV valve will be open? It has its own terms and condition. What is the AV valve says? It says that atrial, mind you, it's the atrial pressure, not aortic pressure. Aorta is different, atria is different. Should be more than the ventricular pressure. That means the pressure over here should be more than this. All right. Now, how I can increase the pressure in the atria? I cannot increase the pressure in the atria. Rather, I need to decrease the pressure in the ventricle. I ask my ventricle to relax. Right? As soon as it starts to relax, what is going to happen? Yes, please. As soon as it starts to relax, the pressure will fall, but it will take some time. During that time, yes, I agree that the ventricles are relaxing, but the volume is not changing. Neither the blood is coming nor it is going out. So it is known as isovolumetric relaxation. But eventually the ventricular pressures is going to decrease, right? It will go below the atrial pressure, that is almost zero, and the AV valve will open. As soon as it is going to open, so AV valve will be open. What is going to happen as soon as the AV valve is opened? Yes, please. The blood will start coming from the atria into the ventricle, known as ventricular filling or atrial emptying, right? So the blood will be filled in the ventricle. That's why it is known as ventricular filling. Now, as soon as the filling starts, there are two things which are going to be there. First thing, the pressure in the atria, let's say it is 10 mmHg. Pressure in the ventricle, let's say it is 0 mmHg. So there are two things which are helping me out. First thing is pressure gradient. And second thing, most of the time in the day, you are going to be upright. That means you are going to be either sitting or standing upright position. So the gravity also pulls the blood down into the ventricle. Atria is on the top, ventricles are below. So the gravity is also helping. So there is going to be first rapid filling or early filling. Am I contracting the atria over here? No, it is going to be passive. So please remember, first phase of the ventricular filling is going to be passive. Though it is rapid, but it is passive because of the delta P and gravity. Now what happens? Slowly, I'm going to start filling the ventricle. So what is going to happen in the pressure of the atria pressure started to decrease. But the ventricle is filling, so the ventricular pressure start to increase. There will be a point where both of these pressures are almost equal. So almost negligible filling is going to be occurring over there, known as slow filling phase or diastasis. It looks as if what? Diastasis is what? As if the heart or this heart has stopped in the diastole, known as diastasis. Okay, so slow filling or diastasis phase. Together they are going to cause two-third filling, or you can say this causes two-third filling, and together they are going to cause 80% of the filling, right? 80-20 yaad rakho, better hai. All right, and late rapid filling is going to cause 20% of the filling. All right, later on what happens? Later on, since the pressure gradient has nullified, and if the patient is lying down supine, so there is no gravity also, but there is some amount of blood still remaining in my atria even after the diastasis. What should I do? I'm going to ask my atria to contract and increase the pressure, right? So that's why it will be called as active filling. This is the late filling or late rapid filling, but this is going to be active because of the atrial contraction, and complete filling will occur. And then what happens? Once the complete filling of the ventricle takes place, what is going to happen? The atria will relax, and atrial relaxation will cause the closure of the AV valve, which is going to cause S1 sound. So please remember, isovolumetric relaxation and ventricular filling. If I have to give the summary of systole and diastole, I can write it like this. Let's say this is systole, and let's say over here this is diastole. Now, you guys are going to tell me the first phase of systole. It is going to be isovolumetric, of course. What? Systole ka first phase isovolumetric contraction. Diastole ka first phase isovolumetric relaxation, right? And then there will be volume change phase. What is the volume change phase? First is going to be early and then is going to be late, right? Here you're going to have the ejection phase, and here you're going to have ventricular filling phase, right? Ventricular filling phase, right? Okay, chalo. So this is going to be your summary of it. All right. Now, isovolumetric relaxation ko I'm going to write it as IVR. Isovolumetric contraction ko I'm going to write it as IVC, right? Because we are going to make the khichdi out of it. Okay, doctor, please ask me if you want me to repeat anything, please ask me at the end. Okay, because it is going to break the flow, and whomsoever understood, it is going to be waste of time for them. Okay, I'll be there. Don't worry, I'll be there after the class. A phase. A is what? A phase is because of this JVP. Upstroke, that means pressure is increasing. That is going to give me the upstroke. We call it as wave. If it is the downstroke, that means the pressure is decreasing. We call it as descent. So, A wave is because of. This question has asked multiple times atrial contraction. A wave is because of atrial contraction. C wave is because of bulging of tricuspid valve. So I'm just writing TV bulging. Right, tricuspid valve bulging into the atria. Which atria? Right atria. All right, TB bulging into the right atria is going to give me the C wave. V wave, V for V, that I told you. Remember V for VR and IVR. What is VR? Venous return. Venous return. All right, then you have what thing? You can call this as atrial filling also. Atrial filling. All right, atrial filling or the VR and IVR. All right. Chalo. X descent and Y descent. X descent is what? It is because of atrial relaxation. And Y descent is because of atrial emptying. Empty. All right. So relaxation X, Y is because of emptying. V for V, venous return. You can remember like that, right? And A for A, that is atrial contraction. So these are the waves and descents in the JVP, which is nothing but the central venous pressure, which is nothing but the right atrial pressure. Coming on to the volume changes. What are the volume changes? You're going to have 4 volume changes. At the end of diastole, whatever volume I have in my ventricle, I call it as end diastolic volume. At the end of diastole, whatever volume I'm having, that is 120 to 130 ml, will be called as end diastolic volume. Then at the end of systole, whatever volume I'm going to have will be called as end systolic volume. That means even after systole, some volume will be left into the systole, this ventricle, right? So whatever volume remained into the ventricle. Now, if I give you the EDV and ESV, can you calculate the stroke volume? How much blood has gone outside? Yes, I can calculate the stroke volume as EDV, how much blood came, minus how much is remaining, right? So that is going to give me how much gone outside. So stroke volume is equal to EDV minus ESV. Remember that, okay? Then if I give you the stroke volume and EDV, can you calculate ESV? Yes, you can calculate the ESV as EDV minus stroke volume, right? That's how you can calculate both the things. But if I ask you the ejection fraction, what is it? Fraction means percentage, remember. Amount is better or percentage? Always the percentage is better. So it is percentage of blood pumped. Whatever blood has come into the heart, that is nothing but at the end of diastole, whatever blood volume is available, EDV, right? And whatever is gone outside, iska fraction hai. So stroke volume upon EDV into 100 is going to give me ejection fraction. Now, as we know, 50% means pass and 50 below 50 means fail. So we can assume plus minus 5 over here for the heart. If we get more than 55%, ventricular is working efficiently, right? Ventricles are working efficiently, ventricular efficiency. But if the ventricle is not even able to give me 45% of the ejection fraction, I'm going to call that the ventricle is failing or the heart is failing. So either it is called as ventricular or it is called as heart failure, ventricular failure or heart failure. Echo mein, 2D echo, when you're going to do, the first thing that you check is going to be your ejection fraction. Now, we have learned about pressures, we have learned about the volumes. Let's make the khichdi out of it, right? Let's start from the A to B. When I go from A to B, see over here what is happening. When I go from A to B, on the x-axis you have volume, on the y-axis you have pressure. Let's say this is a left ventricular volume and let's say this is left ventricular pressure, of course, right? What is happening when I'm going to go from A to B? I agree that the pressure is rising, but look over here, the volume is the same. When the volume is going to be same, I'm going to call it as isovolumetric, but the pressure is increasing, which must be because of isovolumetric contraction. When I'm going to come from C to D, exact opposite thing is happening. See over here, when I'm going to come from C to D, I agree that the pressure is decreasing. The pressure is decreasing, but the volume is the same. So this must be isovolumetric phase because the volume is same, but the pressure is decreasing, which must be the relaxation phase of the ventricle, right? So if I'm going to go from D to A, see over here what is happening. The volume is increasing drastically. The pressure is not changing much. The volume is increasing into the ventricle. That means the ventricular filling must be occurring over here. So this is nothing but a ventricular filling. And when I'm going to go from B to C, what is happening when I'm going to go from B to C? See over here, the volume is decreasing drastically. There is almost no change in the pressure, right? So that means volume is decreasing inside the ventricle. That means blood is going out of the ventricle. That is nothing but ejection is taking place, right? Now, at the end of, if I ask you, IVR and ventricular filling is nothing but the diastole, isn't it? So at the end of diastole, whatever volume I'm going to get, I'm going to call it as EDV. So this must be EDV, right? And at the end of systole, so IVC and ejection is systole. At the end of systole, whatever volume I'm going to get is going to be equal to the D point now, because this is going to be the straight line. So this is whatever volume I'm going to get at the end of systole. I call it as ESV. EDV minus ESV will give me stroke volume. So please remember, when you have to calculate stroke volume, maximum minus minimum kar do. Whatever maximum value you're going to get at this point and whatever minimum value you're going to get at this point, just do maximum minus minimum. That is going to give you the stroke volume. All right. So that is there. If I ask you, tell me which valve is going to open where and which valve is going to close where, then what will be your answer? See over here. Ventricular filling you have to do. When you have to do the filling in the left ventricle, which valve you are going to open? You're going to open mitral valve. So mitral valve is going to be opened here, and mitral valve, once the filling is done, mitral valve is closed, right? When you have to do ejection, at that time aortic valve should be open now. And when the ejection is over, that valve is going to close. How to remember now? Just remember MAM COCO. What is MAM COCO? MAAM, that is MAM, and COCO, that is COCO. MAM COCO, just remember MAM COCO over here. What is MAM COCO? M for mitral valve, and A for aortic valve, O for open, and C for closed, right? So please remember that. And just remember, whatever alphabet they give over here, X, Y, Z, B, C, D, whatever they give, you have to start at the right hand side lowermost point for the MAM COCO mnemonic. Otherwise, the khichdi, you won't like it. All right. So please remember that. All right. So that is about the pressure volume loop. Coming on to the cardiac output is equal to stroke volume into heart rate. Stroke volume into heart rate. And there are two types of regulation, heterometric and homometric. Metry over here means length. Metry over here means length, and hetero means different, or you are going to change the length, right? And homo means same. You're going to keep the length of the muscle same. So via changing the length of the muscle, or you can say via changing the length of the muscle or keeping it same, you're going to regulate the cardiac output. Let's see. Mehek, I have read that. Okay, I'll try to explain that, right? But not in this class, okay? So I'll try to explain that. You can message me directly. I'll definitely explain it to you, all right? And I don't think so they will be asking you that, because that has not asked even in the NEET PG exam. So FMG ke liye chhodi do. If you are giving FMG, don't stress about the curves that is there. Okay, don't worry about it. Okay, unnecessary stress mat do, burden mat do. Jitna hai utna padh lo pehle. Okay, so you can message me on the Telegram. Definitely, I would love to help you out. Next, Frank-Starling law. See over here. This says that initial length of the muscle is directly proportional to the stroke volume. Input is directly proportional to the output. Okay. So venous return. Venous return is what? Increase in the venous return. That is nothing but the input causes increase the stroke volume. All right. So I'm going to write the stroke volume over here. That increases the stroke volume. How? Let's see. When you increase the venous return, the EDV will be increased. As soon as you increase the EDV, what is going to happen? When you increase the EDV, the stretching will increase, right? Stretching of the muscle will occur. And as soon as you stretch the muscle more, it is going to cause increase in the initial length of the muscle. As soon as initial length of the muscle is increased, there are two things which are going to take place. First thing, troponin C sensitivity increases, which is going to bind to the calcium. And another thing, actin myosin cross bridges, which is going to cause contraction. they are also increased. And when the actin-myosin cross bridge is increased, what is going to happen? The force of contraction increases. That is nothing but contractility increases. Contractility increases, stroke volume increases automatically, right? So that's how it is going to be. So please remember, when you change the length of the muscle, when you increase the length of the muscle, stroke volume will be increased within the physiological limit. That is about the heterometric regulation. So see over here, if I have to make you understand the heterometric regulation. So see, on the x-axis you have end diastolic volume, on the y-axis you have stroke volume, all right? Length tension relationship. See over here, first of all, if the length was only till the 60 ml, then the output was 40 ml. If I increase the initial length to 120, right, so that is going to cause 80 ml ka output, right? As and when I increase the stretching more and more till the physiological limit, what is going to happen? More and more stroke volume you are going to get, all right? Remember that. But this is known as Frank-Starling law. This orange color graph is nothing but Frank-Starling law, right? But if I do not want to increase the length, but I want to increase the contractility, what I'm going to do? I'm going to increase one ion, that is nothing but calcium ion. I'm going to increase the calcium ion. As soon as I increase the calcium ion, the graph will shift towards the left hand side, right? What happens, see over here, on the same, let's say 120 ml only, I have the 70 ml ka, or I had the 70 ml ka stroke volume. But as soon as I shift towards the left hand side, what happens? 120 ml is going to give me approximately 80 ml ka output. That means without changing the length, via changing the ion, I have increased the contractility, right? And that's why it is known as inotropic effect. Which ion they are going to ask you? Then the answer of yours is going to be calcium. Beyond the physiological limit, you have to give the ionotropic drugs such as cardiac glycoside, digitalis, digoxin, which are going to block the sodium-potassium pump and ultimately causing the calcium to stay inside the cell, right? And increasing the contractility. I'll give you the break. Let us complete the कुछ ज्यादा नहीं बचा है यार 5-6 पेजेस बचे हैं सीवीएस का सीवीएस कंप्लीट कर लेते हैं ना देन विल टेक अ ब्रेक ओके थोड़ा पेशेंस दिखाओ बच्चों है ना so let's cover this and then take a break. Okay, types of blood vessels. 5 types of blood vessels are there, right? Wind-Kessel vessel. Wind-Kessel vessel is going to have a recoil property, means returning to its normal position, right? It's like an elastic rubber band. You stretch it, it will contract. And this is present in which vessel? फटाफट से आंसर बताओ, फटाफट खत्म करेंगे, है ना? फटाफट ब्रेक लेंगे. It is going to be present in the aorta and large arteries because of the elastin protein, right? And this is going to help me in the diastolic blood pressure. Recoil of aorta is going to give me diastolic blood pressure. Capacitance vessel. There are vessels which have the capacity to store the blood. Almost 53 to 56% of the blood is present at rest in these vessels, right? They prevent from the shock. Whenever shock-like condition comes, what is going to happen? Whenever shock-like condition comes, then the stored blood is going to come into flow, and that is going to maintain the perfusion, isn't it? So it prevents the patient to go into a very low blood pressure, right? So that is the capacitance vessel. Which are these? These are the systemic veins and venules. Systemic veins and venules, who are most permeable, and because of their parallel arrangement, they have least resistance despite of having minimum diameter. They have least resistance. Can you tell me who are porous or highly permeable and best for the exchange? These are nothing but the capillaries. And who decides how much blood the organ requires? Their own resistance vessels. And the resistance vessels are the one which are going to have maximum smooth muscle per unit surface area. Maximum smooth muscle per unit surface area, right? And which are these? These are nothing but, yes, please, wonderful. It is nothing but arterioles. And the one which does not have per se any property, but they just transfer the blood from point A to point B, these are nothing but small arteries known as conduit vessels. Conduit vessel does not have any specific property, they just conduct or transfer the blood, that's all. Right, so these are the types of blood vessels. So this question that they have asked, which of the following vessels shows the Wind-Kessel effect? Then the answer over here is going to be aorta. Aorta is going to show the Wind-Kessel effect. Now, there's something known as turbulence, Reynolds number. Just remember the formula. Formula of the Reynolds number is rho dV by eta. What they're going to ask you is, if I increase the viscosity, what is going to happen to the Reynolds number? If I increase the density, what is going to happen? So whatever is present in the numerator, that is rho, diameter and velocity, rho dV, that if I increase the rho dV, the turbulence increases, means the flow is going to be noisy. So you're going to have noisy flow. Noisy flow, right? But if I increase the viscosity, viscous fluid, if I take, then what is going to happen to the Reynolds number? Reynolds number decreases, right? So turbulence decreases. Remember that. If the number comes out to be more than 3000, it will cause turbulent blood flow. Less than 2000, laminar blood flow. 3000 to 2000. Maths will not be asked. They will just ask you that if I increase the density, what is going to happen to the Reynolds number? Diameter se kya hoga, and if I increase the viscosity, then what happens? Okay. Now, there was a bhai sahab known as Poiseuille-Higgins law. But before that, there is a formula for the flow. What is the formula for the flow? Flow is delta P by capital R. R, capital R is always the resistance. Delta P is pressure gradient. Now, that bhai sahab said that I can calculate the R also. He said it is 8 eta L upon pi R raised to 4. Right now, if I put this formula into the Floca formula, the Floca formula will be delta P upon R, that is upon 8 eta L upon pi r raised to 4. Denominator becomes numerator. So this is going to go up. So radius is directly, capital R is resistance, small r is a radius. So please remember that the R is the radius. Radius is directly proportional to the flow. Radius is directly proportional to the flow. If I ask you, which is the most important factor over here, most important is going to be radius. Most important is the radius. Why? Because it has fourth power. It has fourth power, right? If I double the radius, what is going to happen? If I double the radius, if I double, it is going to be 2 into 2 into 2 into 2. That means the flow will be increased by 16 times. If I triple the radius, it is going to be 3 into 3 into 3 into 3. That is nothing but 9 into 9, 81 times the flow is going to be increased. So most important is going to be the radius. Why? Because it is having the fourth power. So this question we have already solved. Triple hoga to it is going to be increased by 81 times. 81 times. Okay. Then the second last topic, BP. Yaad rakhna. If the BP is increased, it's like a speed. If you're going on a very, very high speed, you have to lower it down to the normal range. Otherwise, either the accident will occur, or especially in Delhi, you have the speedometers, right? Cameras lage hue hain, you will have the challan, right? So you have to pull the brakes. So baroreceptors, you have to activate the baroreceptors. So baroreceptors act as brakes to the BP. Who acts as brakes to the BP? Brakes to the BP are nothing but baroreceptors. And do they act all the time? No, they do not act all the time. They act only in a specific range, that is 60 to 200 mmHg. What is this? This is systolic, diastolic, or pulse pressure? No, it is mean blood pressure. Remember that. But what if the speed is very, very slow? I need to activate the accelerators, right? Who act as accelerators to the BP? Accelerators are nothing but the chemoreceptors. Now, both the things are going to activate in the same range. Kya? No. This will activate only if the BP falls below 60 mmHg. Of course, it is mean blood pressure. Now, there are two centers. What are the two centers? First is going to be CIC and CVC. That means it is cardio-inhibitory center or cardiovagal center, right? That will be activated if I have to pull the brake. Parasympathetic system, cardiovagal center will be activated, right? So parasympathetic system will be activated, and who is going to be inhibited? the vasomotor center. Motor is going to be lower down. ना brake लगा रहे हो ना, so motor को slow कर रहे हो. So vasomotor center is going to be inhibited. On the other hand, if I ask about chemoreceptors, chemoreceptor do the reverse thing. VMC will be stimulated and CIC-CVC will be inhibited. Remember that. All right. So vasomotor center will be stimulated in the chemoreceptor. Okay. Last, then CVS reflexes. Please remember these reflexes. I'm going to tell you again and again. If you do some mistake in the reflexes, I'm going to send you on these bridges without any life support for sure. Right. Let's say you reach to this bridge without any life support and say that I'm having good pincer grasp, I'm athletic. Then I'm going to send you on the scariest bridge of this world, right? From where nobody comes back. So that is nothing but as soon as you see this bridge, what is going to happen? Your heart is going to do duk, 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 right? So increase in the heart rate. So please remember that this is the only reflex, bridge wala reflex. As soon as you see the bridges, you are going to have the tachycardia. This is the only reflex in which you have tachycardia. The tachycardic reflex, only one reflex in whole CVS, whole respiratory system, that is bridge wala reflex, vein bridge reflex. When you give the rapid infusion of the fluid, what is going to happen? When you give rapid infusion, venous return increases. As you increase the venous return, the heart rate increases, which stimulates the SNO directly or indirectly. Just remember, rapid infusion causes tachy. Tachy देखते ही mark करना है vein bridge. Don't think anything else. Then, if I have Bizarre Jarich, when you give bizarre things IV, not orally, when you give bizarre things IV such as serotonin, veratridine, and capsaicin, capsaicin, which is present in the chilies also, but you have to take it IV. ऐसे सस्ते नशे जब करोगे, when you do such bizarre things, your heart and respiratory system goes shh. That means everything is going to decrease. The heart rate, BP, and respiratory rate decreases. Right? So name itself telling you, when you do bizarre things, सस्ते नशे करोगे, your heart and respiratory system goes shh. Right? So everything decreases, heart rate, BP, and apnea. Then there is a confusing reflex, which is Cushing's reflex, increased intracranial tension, right? So intracranial tension, when it is going to increase, that is going to cause confusion in the heart rate and blood pressure. What is that? The BP increases, but the heart rate decreases. One is increasing, one is decreasing. Respiratory system doesn't know whom to follow, so irregular breathing. I know how to remember this. I know tachy means bridge wala reflex. So all of the are going to have brady. So bradycardia, increase in the BP, that is hypertension, and irregular breathing is the triad for Cushing's reflex. This happens because the vessel compression occurs as soon as the intracranial tension increases. That will cause hypoxia, and hypoxia is the most potent stimulus for activation of VMC, which increases the blood pressure, right? Which increases the blood pressure. So that is all about the CVS system. Change brings challenges. Learning and a sense of new. Change is full of promise, right? कितनी slide बची है? Count कर लो in the PDF. क्या question पूछते हो? चलो. So let's take 10 minutes का break. Okay, I agree. Let's take 10 minutes का break and then we can start the Boyle's law, which is nothing but your respiratory system, which says that the pressure is inversely proportional to the volume. When the pressure is increased, the volume is decreased. Chalo. So let's start if after the break. 10 minutes का break ले लेते हैं, then we'll start. Saying 15 minutes. Some people are saying 15 minutes का break, right? 15 minutes क्या होगा बेटा? 15 minutes फिर हमें increase करने पड़ेंगे after 9:30, है ना? So that is there. So let's start at 7:25. Let's start at 7:25, but you should increase it. Okay? Chalo. All right, can we start the class? Yes. Chalo, let's start. All right, so respiratory system, don't worry about it. Maximum 9:30 tak hum khatam kar denge because respi and CNS are the ones which are going to take time more, right? And rest systems, they won't take time. Endo, GI, bahut chote chote hain. Okay. Chalo, so let's start. Mechanics of respiration. Boyle's law, pressure is inversely proportional to the volume. All right. And as we learn in the cardiac cycle, systole and diastole, here you have inspiration and expiration. See over here, inspiration means you have S, so suction pressure, negative pressure is there. X looks like positive. Again, X is the alphabet I told you, right? So that is going to be positive pressure. Respiratory pressures, intra-alveolar pressure inside the alveolar. How to remember? Please remember, is the first alphabet. So during inspiration and expiration, it is going to change by 1 mmHg, 1 mmHg, 1 mmHg over here, right? But inspiration mein S is negative, so -1, and this is +1, expiration mein positive. But if they ask during, then the answer is going to be -1 and +1. But if they ask at the beginning or at the end of inspiration and expiration, no matter what, see over here, at the end of inspiration and expiration, the pressure is going to be 0, right? Because it is the open system. We have discussed that in the mission classes. Next, ITP. What about ITP? Intrathoracic pressure, T for 2 also, T for 3 also. So we are going to take in between. Please remember, it is negative because of the opposite recoil of the lung and thoracic wall. So it is -2.5. Inspiration may it should go more in the negativity. So it is going to be -6 mmHg, and expiration may it will come back to -2.5 mmHg. If you decrease the pressure, volume increases, and if you increase the pressure, volume decreases. Boyle's law. Which volume is this? Which is 0.5 liter or 500 ml? It must be the tidal volume. Tidal volume, right? Which are the muscles which you contract during the inspiration? Diaphragm and external intercostal. Diaphragm is the major contributor, 75%, right? In goes with X, X goes with in. Remember that. Why I said so? Because during inspiration, external intercostal helps, but during forceful expiration, internal intercostal helps with the abdominal muscle. Then sternocleidomastoid and scalene, which are accessory muscles which will help us in the forceful inspiration. If I ask you during quiet resting time, who helps me in the expiration? None of the muscle is going to contract. Just to relax whatever muscle you have already contracted, right? So this is going to be your passive expiration, which is normal or quiet. Compliance. What do you mean by compliance? Distensibility or stretchability. How do you calculate compliance? Compliance is equal to delta V upon delta P. Please remember this formula. You can get the calculation wala question on this, right? So delta V by delta P, it is nothing but stretchability or this distensibility. Okay, then compliance and recoil, these are two properties of alveoli. Compliance means stretchability, recoil means returning back. So inspiration, expiration, inspiration, expiration, that should be the case. But emphysema mein this recoil will be gone. So what will happen? The compliance is very, very good. There is a good compliance, but what is poor? Poor is the recoil. Recoil is going to be very, very poor. So what happens? Compliance is important for inflation of the alveoli. That means inspiration is good, but expiration is poor. Poor expiration. Every time he is going to expire less amount of air. So inspiration, expiration, inspiration, expiration, inspiration, expiration. What is going to happen because of this? The air will be trapped inside the alveoli. Air trapping is going to occur. Because of that, you're going to have a hyperinflated alveoli. And that is going to lead to wonderful barrel chest. That is going to lead to barrel chest, which is nothing but your emphysema, old age, and alpha-1 antitrypsin deficiency. So see over here, this is the normal shape and this is the barrel shape, right? So anterior-posterior diameter is going to increase. It looks like a barrel, right? So barrel chest is going to be there. It is no longer like an elastic rubber band. This tissue became like a chewing gum. Yes, it is going to get stretched, but it won't contract, right? So this is nothing but emphysema, alpha-1 antitrypsin deficiency. or old age. Only 3 example in which the compliance is better, right? In all other examples, the compliance will be poor. If I take the graph, pressure volume graph of this, delta V by delta P, if it is more, that means it is emphysema, alpha-1 antitrypsin deficiency, or old age. If it is less, then any other disease. So please remember, if the value is increasing, the graph is increasing, volume is increasing, much more lung volume, then that means it is emphysema, alpha-1 antitrypsin deficiency, or old age. Then comes the fibrosis. Fibrosis is like a wood or the steel. Both the things are going to be poor. What are the things? The compliance is also poor and recoil is also poor. So both the things are poor, so compliance is going to be decreased, right? So there is no particular, you can say, any pattern which will be seen. It's just that the compliance is going to be very low. So the graph is going to come down. The graph is going to be come down. All the interstitial lung diseases are going to come under this. Okay. Yes. Next. Chalo. आगे बढ़ते हैं towards the surface tension. What do you mean by surface tension? That in the alveoli, as soon as you are born, there is going to be water which was present, and you're going to take the air in the lungs. As soon as the media, two media, that is air media and gas, the air media and water media, they are going to come together. The adhesive and cohesive forces are come into play of the water molecules, right? That means they are going to generate the inward force. If I allow this inward force, two problems are there. First, the alveolar collapse can be seen, which is also known as atelectasis. And you do not just have the alveoli, but also you have the blood vessels over here. And if I allow that inward force to act on the blood vessel, it can cause the pulmonary edema. So that is another problem. That's why I do not want this surface tension, nothing but air-water interface. So I have to decrease this air-water interface so as to decrease the inward force, so as to decrease the surface tension. How can I decrease that? What I'm going to do is, I'm going to put the lipid molecule on the top. That will decrease the air-water interface, and that is nothing but surfactants. Surfactants, what is the peak value? At what gestational age the surfactant is going to be at the peak? It is 35 to 37 weeks of gestation, intrauterine life. Before that, if the baby is born, the surfactant will not be sufficient and the baby is going to have the problem in the respiration. Alveolar collapse is going to take place and the baby is going to have distress during respiration, known as respiratory distress syndrome or hyaline membrane disease, seen in the preterm babies. What you're going to do? If the mother is having risk of preterm or labor, you're going to give her the steroids and thyroid. But if the baby is already born, you're going to give the artificial surfactant. Which cells are going to produce the surfactant? It is type 2 pneumocyte. If that is not there in the option, then you are going to choose Clara cells. Which is the most or major component of or major phospholipid of this surfactant? It is going to be DPPC. What is DPPC? Zara batana. Dipalmitoyl. Phosphatidyl. Choline. But if this is not in the option, it is not dipalmitoyl phosphatidyl ethanolamine, mind you, this is choline. You're not going to mark ethanolamine. If that is not in the option, choline is not there in the option, you're going to mark it as lecithin because this is also known as lecithin. What is the minor phospholipid? Sphingomyelin. And if I have to check the lung maturity of the fetus, then I'm going to do LS ratio, which is nothing but the lecithin sphingomyelin ratio. Lecithin sphingomyelin ratio. So lecithin sphingomyelin ratio, LS ratio. All right. चलो आगे बढ़ते हैं. न्यूबॉर्न बेबी का केस दिया हुआ है. Surfactants are not adequately found, and because of that, collapse of the alveoli is seen. It's a clear case of respiratory distress syndrome. What is the hint? Newborn baby hai, surfactants are not there, so respiratory distress syndrome. It is not due to any allergy, so asthma, pneumonia and pleural effusion will not be the options, right? आगे बढ़ते हैं. Now let's talk about the volumes and capacities. Single amount, volume, two or more का combination, capacity. Now, if I ask the person to take the breathe in, normal breathing, right? So whatever amount of air he's going to take in during inspiration or take out during expiration, that will be called as tidal volume. Tidal volume, how much it is? 500 ml, right? If I ask him to inspire forcefully, the extra amount of air, mind you, it is the extra amount of air. That means I'm not including the tidal volume into this. So extra amount of air that the person has taken over and above the tidal volume, that will be called as inspiratory reserve volume, which will be 2 to 3 liters, right? Similarly, the extra amount of air he has expired during forceful expiration after normal expiration, that will be called as expiratory reserve volume, which is around 1.1 to 1.2 liters. Right? And no matter how much force you apply, there is some amount of air which is going to reside in your lung, remaining in your lung, that will be called as residual volume. And how much is the residual volume? It is little bit more than the ERV, 1.2 to 1.3 liters. Doesn't matter. 1.2 दोनों में याद रख लो, कोई बात नहीं. All right. So this is going to be residual volume. The instrument with which you measure this lung volume and capacity is known as spirometer, and the procedure is known as spirometry. If the air is not coming out, you cannot measure that air, so RV cannot be measured, right? And if I talk about capacities now, let's talk about capacities. I'm changing the color over here. If I add the IRV and TV, what that will be? It will become inspiratory capacity. If I add ERV and TV, it will be expiratory capacity. If I add ERV and the RV, that will be functional residual capacity, right? So that will be FRC. If I add the IRV, TV and ERV, that will become vital capacity. And if I add everything into this, that will become TLC. Now, one question. If you cannot measure RV, you cannot measure FRC, of course you cannot measure TLC because everything contains RV, isn't it? So you cannot measure the RV, FRC and TLC. So please remember, RV, FRC and TLC cannot be measured by spirometry. Cannot be measured by spirometry. Yes, you can measure the FRC via some methods. So what are these? These are the definitions you can read up later on. We have already discussed them. All right. So FRC can be measured by helium dilution method, nitrogen washout, Fowler's method, and plethysmography. Two questions that they have asked till now is the best method. Best method kaun sa hai? That is nothing but plethysmography. That was the question. And how do you measure the anatomical dead space? Anatomical dead space can be measured by a method known as Fowler's method. How to remember? Anatomy mein, there are going to be dead bodies in the dissection hall, which smells foul. Foul smell is going to be there. And if you have to get rid of that smell, you wash the lab with the nitrogen, right? Wash it off with the nitrogen. So you can remember via this mnemonic that when you go to the anatomy, dissection hall mein dead bodies are there, foul smelling dead bodies, right? So anatomical dead space measured by Fowler's method, physiological dead space, if you want to remember, you can, or just leave it. Bohus method, okay? And helium dilution method is one another method with which you can measure the FRC. Just names are important. Now, coming on to the FeV1 percentage. Now, what is FeV1 percentage and how do you calculate it? I told you that during a first second, how much air? First second, that means I have to take what thing? I asked the person to inspire forcefully. See over here, what I have asked. I asked the person to inspire forcefully and then expire forcefully as quickly as possible. Whatever amount of air he has expired during first second, that will be called as FeV1, right? And whatever complete air he has taken out, no matter how much time, 1 second, 2 second, 3 second, 4 second, doesn't matter, right? Whatever complete air he has taken out, known as FVC. So if I have to measure the FeV1 upon FVC, FeV1 percentage, then I have to measure it with the formula FeV1 upon FVC into 100. Out of total, how much has come out in the very first second, that is FEV1. How much is the value? Value is distinction. Yaad rakhna, 75 to 85% is the distinction. Now, if it is the obstructive lung disease, old may, you just remember that as you become old, everything decreases, right? The capacity to sit, the capacity to concentrate, the capacity to walk faster, everything decreases, right? Similarly, in the old, the FEV1 decreases, as well as if the numerator decreases, the ratio also decreases. FEV1 percentage also decreases. So as you become old, so please remember, it is going to decrease. Just remember, old may FEV1 percentage decreases, that means obstructive lung disease may, it is going to decrease. Of course, in the restrictive lung disease, it is going to increase or remains the same, but never decreases. Just remember, increase or remains the same, but never decreases. Only in the old, it is going to decrease. FEV1 percentage decreases in the old obstructive lung disease. And RLD may, it is going to be increased. Okay. Now, they have given this question over here. What are the hints? The patient is suffering from chronic productive cough. First thing, it is chronic. Right. Second thing, what is it? Productive cough hai. On examination, FEV1 percentage is reduced. That means I'm sure that he's suffering from OLD. Fibrosis, sarcoidosis is not OLD, it is RLD. Interstitial lung disease, fibrosis condition will occur over here. Asthma and COPD both are obstructive lung disease. Airway ka obstruction is going to occur, but asthma will not have chronic productive cough. It is just going to have choking feeling. All right. So I'm going to mark it as COPD over here, right? Next, flow volume curve mein, two curves you have to remember. First thing, if you get the right shift, shifts are important, right? And if they ask you to calculate vital capacity, please remember this point. This end point is going to be TLC, and over here is going to be the RV. This is the end point of the RV. RV I cannot calculate by any method. Right. So TLC minus RV is going to be vital capacity. So over here, whatever this value is there, that is going to be your vital capacity. So this value from TLC to RV is going to be vital capacity. Remember that. Maximum minus minimum karoge, vital capacity you'll get. Now, let's talk about the shifts. If it is shifting towards the right hand side, right shift diya, it is going to be your RLD. All the interstitial lung disease, fibrosis, sarcoidosis, tuberculosis, asbestosis, all the interstitial lung diseases which can cause fibrosis is going to be showing you the right shift. What if it is a left shift? Now, left shift may you have to be more careful. Is it showing any pattern or just left shift? What I mean by that, if it does not show any pattern, see over here, asthma and emphysema, both are OLDs, but what is happening over here? See, there is a left shift in asthma also. There is a left shift in the asthma also, but there is no pattern change. Whatever shape is there, that is maintained, just the left shift. Okay. There is a left shift, I agree. Right. But there is no pattern change. But if you see scooped out pattern, scooped out or dog leg pattern, then you are going to mark it as emphysema, dog leg pattern or scooped out pattern. It looks as if someone has taken the scoop out of it, then you're going to call it as the emphysema. So, तीन चीजें याद रख लो अभी के लिए. If it is shifting towards the right hand side, restriction, R for R, restriction. And if it is shifting towards the left hand side, it is going to be your shape change will not occur, right? COPD, if you have given, then I'm going to choose the emphysema wala graph because COPD consists of both bronchitis and the emphysema, right? The major problem is going to be because of emphysema. So I'm going to choose COPD because obstructive hai, left shift pakka hoga. I don't think so they're going to give you the COPD, but if they give, I'm going to choose the scooped out pattern because emphysema is the major problem, not the bronchitis. Okay, bronchitis specific wala diya, so you're going to choose the asthma wala pattern. All right, chalo. Next, coming towards the dead space. What is dead space? Dead means it is not helping me in the physiology. That means it is unexchanged air, which is not getting exchanged. So there is physiological dead space which is divided into I'm going to write DS for the dead space, right? DS for the dead space. So physiological dead space is divided into two, that is anatomical dead space and alveolar dead space. Anatomical DS and alveolar DS. Anatomical DS and alveolar DS. Now see over here, how much is the anatomical dead space? Tell me, can you tell me how much is the anatomical dead space? Suppose these are the airways and this is your alveoli. Now you're going to have Weibel's classification, if you remember, 0 to 16, airway number 0 to 16, in which no exchange of gas occurs because of the anatomy of these airways. So 150 ml will remain unexchanged into, let's say I'm taking 500 ml of air, 150 will remain into this 0 to 16 generation, right? And next you have the generation number 17 to 23, after which you're going to have pulmonary capillaries, right? Whatever 350 ml of air comes out into the 17 to 23, all of that will be exchanged, right? So 0 is going to be 0 ml will remain unexchanged over here. The amount of air getting remained unexchanged from 0 to 16 generation, that is known as anatomical dead space. Normally it is 150 ml. Normally it is 150 ml. Alveolar dead space, normally it is going to be 0. Normally how much it is? Normally it is going to be 0. Whatever amount of air remain unexchanged in area generation number 17 to 23, right? But if I ask you how to calculate physiological dead space, can you calculate the physiological dead space? Yes. And let's say this is the normal healthy scenario. Normal person mein kya hoga? We are calculating that. Physiological dead space is equal to anatomical dead space plus alveolar dead space, isn't it? So how much is the physiological dead space? Anatomical dead space normally is 150 ml plus 0. You add 0 into anything, it is going to be that value only. So it is going to be 150 ml in the normal person. So can I write physiological dead space is equal to anatomical dead space? Yes, I can write physiological is equal to anatomical dead space in the normal healthy person. But if there is, let's say, fibrosis, silicosis, asbestosis, let's say example fibrosis ho gaya patient ko, and if I have to calculate the physiological dead space now, let's say there is 20 ml of air which remained unexchanged in this condition, right? So physiological dead space is equal to again anatomical dead space plus alveolar dead space. 20, 30 जो भी लेना है ले सकते हो, right? I have taken 20, so I'm going to write, this is not going to change, 150 ml, this is 20 ml, so it is going to be 170 ml now, right? Physiological dead space is going to be 170. Can I write physiological dead space is equal to anatomical dead space now? Can I write this? Yes or no? I cannot write this. So what they have given, it is not equal to the anatomical dead space. The physiological dead space is going to be more than anatomical dead space. Right? Anatomical is 150, physiological is going to be 170. So please remember, physiological dead space is going to be increased when there is a disease like fibrosis, asbestosis, silicosis, in which the exchange has been hampered. All right, so that is going to be there. All right, then anatomical dead space, Fowler's method. What is going to happen in the Fowler's method? We can measure the FRC, right, via the Fowler's method, and the anatomical dead space can be measured by this. Okay, next. VQ ratio. VQ ratio is what? Ventilation perfusion ratio. How much air coming for exchange? In the lung, and how much blood coming for exchange in the lung? Usually it is 4.2 liters and this is 5 liters. Liter cancel ho jayega. It is going to be normally 0.8. Wonderful iPad. It is normally going to be 0.8, right? Now, one thing that they can ask you, what is the normal value? Second thing that they can ask you is this apex and base ka, right? So let's see apex and base mein what are the changes. Is your lung cylindrical? Kya? No, your lungs are triangular, and that's why all the changes are going to occur over here. See, let's say this is apex, let's say this is broader base. In the apex, you have only few alveoli which are well expanded over here, right? But smaller but numerous alveoli you're going to have at the base because you have more space available there, right? And what about blood? So let's talk about ventilation first. So ventilation, if I talk, where it is going to be maximum, tell me. Only ventilation, where you have maximum alveoli, isn't it? So it is going to be at the base, you're going to have the maximum alveoli, and that's why this is going to be minimum over here and this is going to be maximum at the base, right? If I talk about perfusion, where you are going to have maximum pulmonary capillary, over here you're going to have few capillaries, and over here you're going to have multiple numerous capillaries, right? And plus the gravity also pulling the blood downwards. So please remember, you're going to have minimum perfusion here, maximum perfusion at the base. When I talk about perfusion or when I talk about ventilation, I'm comparing the apex versus base, isn't it? But when I talk the VQ ratio, let's say, when I talk about VQ ratio, okay, so first thing first, when I say that VQ ratio at the apex, then I'm going to compare the ventilation and perfusion at the apex itself. I do not have to do anything with the base. Please remember, I agree that the ventilation is less at the or minimum at the apex, but the perfusion is even lesser than the ventilation at the apex. And that's why if the denominator decreases, the ratio reaches to the maximum. And please remember, the same goes with the VQ ratio at the base. So I'm going to compare the VQ at the base. So please remember, I agree that the maximum perfusion is there, maximum ventilation is there, but the perfusion is much more than the ventilation. When you increase the denominator, the numerator is going to be minimum. Please remember that at the apex, I agree that there is a lesser oxygen. Let's say here it is 3 liters, here it is 2.5 liters, right? But the 2 liters of blood is coming, 2.5 liters of air is coming. Now, even all the air has been exchanged with the blood, whatever is the demand, still 0.5 liters of the blood is the air has remaining without any, you can say, giving up the oxygen. So oxygen is going to be much more at the apex. Remaining oxygen is going to be utilized by the aerobic bacteria to proliferate. So TB-like aerobic bacteria, they are going to increase or proliferate at the apex, right? Base by VQ ratio is going to be minimum. Coming towards the reflexes, we have discussed the Head's paradoxical reflex in the newborn babies. It is going to inflation of the alveoli causes further inflation or stimulates further inflation. What about hearing brewer reflex? There are two hearing brewer reflex. Hearing brewer inflation reflex or hearing brewer deflation reflex. Hearing brewer inflation reflex, hearing brewer deflation reflex. Inflation reflex is whenever you cause inflation of the alveoli, it inhibits further inflation because I do not want my alveoli to burst. Okay, and deflation inhibits further deflation because I do not want my alveoli to collapse. So that is nothing but hearing brewer reflex. Only for the first few breaths you're going to have Head's paradoxical reflex. Otherwise, you're going to have hearing brewer inflation and deflation reflex. Right? Coming on to the gas transport, two gases are there. How they are transported? See over here. First thing first, 4 ml% of the carbon dioxide or 200 ml per minute pucha to 200 ml will be transported. Oxygen will be little bit more, 5 ml% or 250 ml per minute. Now, as you go via car, bus, metro, or some private vehicle, similarly, the carbon dioxide is going to choose the mode of transport: bicarbonate, carbon compound, or dissolve. You're going to remember by in this format only. Why? Because it is easy to remember. B, C, D. Carbamino means CO2 attached with the hemoglobin. Remember, carboxy is different. Carboxy hemoglobin means oxygen molecule is single molecule, that is carbon monoxide attached with the hemoglobin, which we are not talking over here. So please remember, it is carbamino compound with which you are going to have the transport of carbon dioxide. How much percentage? Bicarbonate 70%, which is going to be maximum. The rest 20% is going to be carbamino, and always minimum is going to be in the dissolved form, no matter whether it is oxygen or it is the dissolved form. Oxygen or carbon dioxide dissolved form is always going to be lesser. What about the oxygen? Oxygen loves to go via hemoglobin, that is 98 to 99%. Dissolved form is always lesser, 1 to 2%. Remember that. Okay, so that is about the oxygen. Coming on to the oxygen hemoglobin dissociation curve, they are going to ask you whether it is right shift, left shift, or identify which of the following is going to cause right shift, except. Just remember, you have to put the right tag on this question. You want to increase the right tag ka number, right? Correct answers ka number in the exam. So you have to increase the tag in the oxygen hemoglobin dissociation curve if you want to do right shift. So increase tag means what? Increase the temperature, increase acid, be that any acid. Acid can be H plus ion, acid can be CO2. Whenever you're going to increase the CO2, the oxygen will be decreased, and decreased partial pressure of oxygen means hypoxia. So hypoxia also causes right shift, remember that, right? And then it can be lactic acid also. If I ask you, when I have acidosis, what is going to happen to the pH? pH increases or pH decreases? Remember, decrease in the pH is going to cause a right shift. Wonderful, right? Don't get confused there with the pH and acid, okay? Glycolysis and 2,3-BPG. Increase in the 2,3-BPG. Bisbolo, yeah, dibolo, one and the same thing, all right? So 2,3-BPG or 2,3-DPG, when it is going to increase, you're going to have right shift. All these things, when you start doing exercise, your body temperature increases, and all these things will be seen. Acid is going to increase, glycolysis increases to provide you with the more energy, 2,3-BPG increases. So exercise maybe you're going to have right shift. Rest all the condition, no matter which condition they give, stored blood bank wala blood, HbF, that is fetal hemoglobin, decrease in the 2,3-BPG, decrease in the temperature, decrease in the PCO2, anything they give, right? Increase in the pH. Please remember, it is alkalosis, right? So all these are going to cause left shift. Methemoglobinemia, carbon monoxide poisoning, everything is going to have left shift. If they give this graph, what you're going to do? First thing, remember, doesn't matter whatever the condition is, this oxygen hemoglobin dissociation curve maintains this thing, shape, that is sigmoid shape. It maintains its shape no matter which condition arrives, right? So it is going to be sigmoid shape. Now what you can see over here, that sigmoid shape is present in this and this graph. Actually, this is the normal graph which is given in the green color, and this is the left shift wala graph. But they have asked about red color graph. Can you see that red color graph is having a different shape? What is that? That is nothing but hyperbola. And hyperbola curve is going to be, or hyperbolic curve is seen in the myoglobin. So please remember, hyperbolic curve pucha, you're not going to mark it as carboxy, methemoglobin, or fetal hemoglobin, which is going to show the left shift. This is not the left shift. This is actually, yes, too much towards the left. It is nothing but your myoglobin ka hyperbola curve. Blue curve is the left shift. Blue curve is the left shift of the bacteria. Okay. Chalo. Next question. We have discussed this question in detail in the mission classes. Next thing, let's come on to the regulation of respiration. Let's draw the upper pons, lower pons, and medulla. Again, the upper pons, lower pons, and medulla. In the medulla, you're going to have the VRG, right? Which is going to have both the, which is going to have both the I neurons and E neurons, but they only activate whenever there is an extra drive for respiration. So let's say this is a DRG, and let's say this is pre-Botzinger complex, which acts as a pacemaker for the respiration. Again, pacemaker of the respiration is going to be pre-Botzinger complex. Pacemaker of the GIT is going to be the Cajal cell, right? DRG, and this is going to be VRG, okay? that is going to be there. PBC and the DRG, they are going to activate, but DRG contains only I type of neurons, and they act as an on-off center. I told you that they are going to cause which type of respiration? Yes, please. They are going to cause irregular and shallow respiration. They are going to be causing irregular and shallow respiration, but I want deep respiration. No. So I'm going to take the help of apneustic center. This apneustic center is present in the lower pons. Right, what it is going to do, it is going to go in the DRG and stimulate the DRG, which is nothing but I neurons. So it is important for the depth of the respiration. But what is the problem? If you do not inhibit it, I agree that the depth will be increased like this. But if you do not inhibit it, it is going to cause spasm in the inspiratory muscle, which is going to lead to inspiratory spasm, which is known as, yes, please, which is known as apneusis, all right, which is known as apneusis. Then if I ask you who is going to inhibit this, two centers which are going to have the inhibitory control on this, that is nothing but first thing is this, that is a pneumotaxic center. First thing is this, that is pneumotaxic center. What happened? Just a minute. Pneumotaxic center, and one more thing, it is going to be your lungs, which are going to have the vagus nerve, which will be going towards the this apneustic center and inhibiting it. Okay, just give me a minute, something happened. All right. Pneumotaxic center. All right, so that is going to inhibit it and causing, it is going to be responsible for the rate of respiration. This is going to cause regular deep respiration. All right, now this is going to be the one which is going to inhibit it, and downstairs you are having the lungs. Downwards, you're going to have the lungs, which are going to cause the inhibition via the vagus nerve. Just give me a minute. I'm just going to. All right. Right, downwards, you're going to have the lungs in which you have the vagus nerve, right? And it is going to be the one which is going to inhibit it, right? So two inhibitions are there. So let's talk about the lesions. If I have the lesion below the medulla, nothing is going to be carry forwarded from the medulla towards the lung, right? And that's why the respiratory arrest is going to take place. Then if I have the lesion at the pontomedullary junction पे अगर lesion है तो what is going to happen? Irregular and shallow respiration, because only and only medullary centers are going to work. But if I say there is a lesion at mid-pontine area, you have to be very careful. If only mid-pontine lesion is given, then you're going to talk about deep and slow respiration. You're not going to mark it as apneusis, because at least vagus is inhibiting the apneustic center. If they give mid-pontine with the vagus cut, bilateral vagotomy, then you're going to mark it as apneusis or inspiratory spasm, right? Then if I say that there is a lesion above the pons, is there anything which is going to change? Yes. What is there? You are not be able to celebrate your birthday. But what I mean by that, you will not be able to do the voluntary breathing. You will not be able to blow the balloons or blow the candles or inflate the balloons. So voluntary control will be gone. Voluntary respiration will be gone. You will not be able to hold your breath voluntarily. And this is the automatic control which will stay intact if there is a lesion above the pons. Automatic. respiration, right? Now, if there is a condition known as the online curse in which bulbar polio will be there. So if there is a bulbar polio, bulb ke neurons are damaged, but the corticospinal tract is intact. There is no cut anywhere. It's just that the neurons has been damaged of the brainstem, but the corticospinal tract is intact. So because of the intact corticospinal tract, the voluntary breathing is intact, but involuntary or automatic will be gone, known as online curse. The death of the person is going to be due to, it is going to be due to lack of sleep. Coming on to the chemical regulation of respiration. Chemical respiration, if they ask peripheral chemoreceptor is going to be having which channels, you're going to mark it as potassium channel, right? If the chemoreceptor present in the central nervous system, you call it as central chemoreceptor. Nahi to you call it as peripheral chemoreceptor if it is present outside of it, right? Ventral medulla. What about ventral medulla, right? So ventral medulla is the location of the central chemoreceptor. Carotid body and the aortic body is going to be there in the peripheral nervous system. Okay. Next, H plus ions in the CSF. GT में जो भी questions आए हैं, mock में जो भी आए हैं, I think the video explanation is already present, Harry. You just go and check there on the app. Okay. H plus ion in the CSF. H plus ion, because I have to see the question ना, ऐसे कैसे मैं बता दूं क्या आया था high altitude पे. So H plus ion in the CSF will be only and only stimulus for the central nervous system का chemoreceptors. The PCO2 increase, hypercapnia, hypoxia, and increase in the H plus ion. Okay, let's do the other discussions over here, and you guys are telling me कि 10 बज जाएगा, 11 बज जाएगा. So if you guys are going to create the distractions, what we can do, है ना? Chalo. So carotid body and aortic body. All right. So hypercapnia, hypoxia, and increase in the H plus ion. Where in the CSF? Kya? No, in the blood. In the blood. Okay. So increase hypercapnia, hypoxia, and increase in the H plus ion in the blood is going to stimulate the peripheral chemoreceptor. Now see over here, the CO2 can go into the, so let's say CC, that is central chemoreceptor, PC, that is peripheral chemoreceptor. So you have a hypoxia, hypercapnia, and increase H plus ion in the blood as the stimulus. H plus ion cannot cross the blood-brain barrier. This is the blood-brain barrier. Hypoxia, oxygen can cross the blood-brain barrier, but will it cause? No, it will not cross because it is decreased, right? And PCO2, yes, it is increased. It is more in the blood, so it can cross. CO2 goes and combines with the water, combines and act, the carbonic anhydrase will act upon it. H2CO3 will be formed, and that is going to get converted into H plus ion and bicarbonate, right? Ultimately, H plus will be increased. Now, if I ask you, most common stimulus for the respiration is going to be PCO2, because directly or indirectly, it is going to stimulate both. So main stimulus for respiration is going to be CO2. But if I ask you, central chemoreceptor will be stimulated by, the answer is going to be either both will be there as the option, such as increase in the CSF and increase in the PCO2. Both is the best option. If that is not there, you're going to mark it as increase in the H plus ion in the CSF. If that is also not there, central ke liye, specifically only and only for the central chemoreceptor, then you're going to mark it as increase in the PCO2. That is going to be your answers, right? Depending on what options are present. All right. So this is the question: oxygen sensitive channel in the peripheral chemoreceptor, which is for which of the following ions are going to be responsible for that? It is going to be the potassium and potassium channels which we have in the chemoreceptor, right? Follow your heart, but take your brain with you. All right. Chalo. So let's talk about the CNS system. Somatosensory system. We all know that there are going to be receptor. First thing first, who is present in the deep dermis? Deep dermis may you have the onion shape. There are going to be concentric circle which are going to be present, right? Concentric circles. That is going to be the onion shape. They have asked in the FMG exam only. The cocktail onion. Koi bhi onion puche, hostel ka onion, ghar ka onion, cocktail onion, any onion is going to be Pacinian. It is present in the deep dermis. So you have to give the higher frequency or higher frequency vibration, or the pressure wala stimulus, then only it is going to be stimulated. All of them are capsulated, only one is free nerve. And what is free in this world? थोड़ा ज़्यादा time बिठा दिया, 20 minutes ज़्यादा बिठा दिया, 1 minute ज़्यादा आया, right? So you are going to have this started. This feeling is free of cost, है ना? So it is going to be pain. Break नहीं दिया तो pain है, break ज़्यादा दे दिया तो pain है, खाने को दे दिया तो पेन है, नहीं दिया तो पेन है, राइट? सो इट इज फ्री ऑफ कॉस्ट, कुछ ना करने पे भी पेन आ जाएगा. Alright, then MM wala 2 receptors are there, measles and Merkel's. Please remember, both are responsible for fine touch and 2-point discrimination. We'll discuss it later, right? So if they ask rapidly adapting and slowly adapting, there is a mnemonic. Passy have messy hair. Just remember, rapidly adapting are Pacinian, measles, and hair and organ. Rest all are slowly adapting. And if they ask about the pain, free nerve ending, they are non-adapting. मर्द को दर्द नहीं होता, फालतू चीज है ना, उसको नहीं सुनना, right? Rest all are slow adapting, and pain तो does not adapt unless and until the primary feeling does not take place or primary healing does not take place. So non-adapting is going to be your free nerve ending. Pain doesn't adapt at least and until the primary healing takes place. Measles capsule, I told you, whichever is going to start with the MM, what is going to happen? M is going to carry the fine touch and 2-point discrimination. If they ask who is primary or who is most abundant, who is most common, or who is present on the glabrous skin, and who is responsible for static 2-point discrimination, right? Primary for 2-point discrimination, most abundant, most common, most static. Static 2-point discrimination, answer is going to be, most common भी लिख देती हूँ, right? That is going to be for 2-point discrimination, the answer is going to be measles, right? Best 2-point discrimination will be seen at the fingertips and lips. The distance is going to be minimum. And the worst 2-point discrimination, that means maximum distance, will be seen at the, yes, 30 to 40. Nowadays they have changed the value, that is 30 to 40, will be seen at the back on the scapula, right? Back पे कहाँ पर? On the scapula. Scapular area पे सबसे ज़्यादा, right? It is going to be pathetic, right? Remember, greater is the distance, worst is going to be 2-point discrimination. All right, glabrous means non-hairy skin. We have discussed about onion shape. It is deeper, so I have to give high frequency vibration or the pressure. Low frequency vibration or slow frequency vibration will be sensed by your measles capsule. All right, remember that. Coming on to the Merkel's disc patient, Shradul patients. Merkel's disc 2-point discrimination also will be sensed by this. But if they ask who is best for 2-point discrimination, who is best for braille reading, right? Or they ask the dynamic 2-point discrimination. Here comes the dynamic 2-point discrimination. The answer is going to be Merkel's disc, right? Why? Because it is better in the edges and point recognition also, right? What is this? This is nothing but braille reading. That's how the blind people read, right? So it is going to be, sorry, ulta ho gaya. Static is going to be, this is slowly adapting now. So slow adapting are going to be static. So dynamic is going to be this, right? So dynamic are going to be this. Aajao. So, and static is going to be, just give me a minute. Static is going to, so best is going to be this static, and this is going to be static 2-point discrimination, best 2-point discrimination, edges and points, right? Blind braille reading. All right. Glabrous skin, non-hairy skin, maximum measles more than Merkel's. Remember that, okay? Maximum pucha, most common pucha, most abundant pucha. Answer for the 2-point discrimination is going to be always and always measles. All right. Chalo, next. Fast vibration sense is mediated by. Fast vibration sense is mediated by. Iska answer bata do. Fast vibration is going to be mediated by Pacinian. Slow vibration पूछा होता तो measles. Slow vibration measles. Pain, dual transmission, fast and slow, right? Fast and slow. Characteristic क्या है इसके? It is going to be very sharp, pricking, superficial pain. Superficial pain. Superficial pain is going to be very, very sharp and pricking type of pain will be there. Sharp and pricking type of pain will be there. Is it going to be well localized? Yes, localization is very, very well localized, right? It is carried by, you guys are going to answer me for this. I'm going to tell you the rest of the things. It is going to be because of the glutamate. Carried by which nerve, that you have to tell me. And the skin injury is going to be the example of this. Characteristic of slow pain. What about slow pain? Slow pain is going to be carried by what nerve, that you are going to tell me again, right? Characteristic, I'll tell you. It is a deep and dull pain, dull and diffuse pain. And if it is diffuse, of course, it is going to be poorly localized. Poorly localized, A delta, wonderful. A delta is going to carry the fast pain and C fibers are going to carry the slow pain. Main neurotransmitter over here, S for slow, S for substance. Right, pain, P for pain and P for substance, P, right? Example, any abdominal pain, any visceral pain for that matter. Abdominal pain, gallbladder ka pain, then appendix ka pain, any pain, etc. I'm writing MI, right? All these are going to come under the slow pain. Now coming on to the ascending tracts, we have discussed the receptor. We are going to talk about the tracts. Anterior, right? Anterior spinothalamic tract carries which sensations, Zara batana? If the ant is crawling onto your body, if the ant is crawling onto your skin, which sensations you're going to have? You're going to have crude touch, and if it is secreting something, you're going to have itching. I don't know how to correlate, but I know you will remember this. That is sexual sensation also is carried by the anterior spinothalamic tract. Then coming on to the next one, that is lateral spinothalamic tract. What about lateral spinothalamic tract? Who is going to get carried by the lateral? Lat mara. If somebody kicks you, you're going to feel the pain and you will be red hot in anger. That is, your body temperature is going to increase. And rest all sensations will be carried by posterior column. All right, so these are the things which will be carried by specific this tracts. Tactile discrimination, kuch bhi puche. If it is not the pain temperature, if it is not the crude touch, itching or sexual sensation, rest all the information will be carried by posterior column. Remember that. Okay, option B. Now there is something known as Brown-Sequard syndrome, in which what is going to happen, there will be hemisection of the spinal cord. See over here, first thing first, spinothalamic tract means anterior and lateral, both spinothalamic tract are going to have the exact same pathway. All right, so see over here, first order neuron comes and ends in the spinal cord itself. In the spinal cord, it is going to crossover. Why? Because the second order neuron is going to start here, and the property of second order neuron is that it crosses over in the spinal cord and crosses over to the other side, and it is going to go towards the thalamus. That's why it is known as spinothalamic tract. Spinothalamic starts in the spinal cord, ends in the thalamus. Third order neuron is going to start in the thalamus, end in the cortex, that is somatosensory cortex. Look over here on the other hand of the dorsal column. Dorsal column is going to enter and go right till the medulla. It is not going to cross over, because crossing over is the property of second order neuron. The first order neuron is going to go till the medulla. It depends whether it is coming from the lower limb, the sensation. The sensation, if it is coming from the lower limb, it is going to go to the nucleus gracilis. If it is coming from upper limb, it is going to go towards the cuneatus, right? So nucleus gracilis and nucleus cuneatus, they are going to have the second order neuron started. Property of second order neuron, crosses over to the other side, go till the thalamus, right? Next, the third order neuron starts and go till the somatosensory cortex. Simple as that. Now, there is something known as the Brown-Sequard syndrome, which is going to be there. Now, what happens in the Brown-Sequard syndrome? In the Brown-Sequard syndrome, there is going to be hemisection of the spinal cord. What happens in the hemisection of the spinal cord? Since the crossing over of the anterior and lateral spinothalamic tract occurs, Brown-Sequard syndrome is nothing but hemisection of the spinal cord. hemisection of the spinal cord. So please remember, there will be ipsilateral loss of dorsal column sensation, ipsilateral loss of dorsal column sensation, and motor segmental paralysis. Motor tract में and this dorsal column में there are two similarities. First similarity is if it is a Brown-Sequard syndrome, both of the things, dorsal column as well as the motor sensations or motor paralysis is going to occur in the ipsilateral side, that means on the same side, right? Another thing, both of them cross over, they cross over in the medulla, right? Cross over to the opposite side. That means decussate in the lower medulla. Both of them decussate in the lower medulla. That is the another common thing between the motor tract and dorsal column, right? And then you have contralateral loss of sensation from two things, that is the anterior spinothalamic tract and lateral spinothalamic tract. All right, so this is nothing but the patient will come to you with the loss of temperature, pain and temperature, because he is not going to tell me ki doctor sahab itching nahi ho rahi, right? So he's not going to come to you with the complaint of that, right? But over here that what they have asked, what is false? Ipsilateral loss of fine touch. Iska answer kya hoga zara batana. Ipsilateral loss of fine touch, that's true. Contralateral loss of crude touch, that is also true. Ipsilateral loss of pain, kya? The lateral will be gone on the contralateral side. So this is false. This should go on the contralateral side with the temperature, right? So answer over here is option C. If you have the map, if you draw the map of the upside down body map, which is going to be there in the cortex of the motor, you can say activities, that means specific part of the cortex is given for the processing of specific part of the body. All right, so there is going to be upside down distorted map will be there. What they are going to ask you, first thing, what is it? It is known as homunculus, right? This is known as homunculus. Maximum area will be given to the hands and the face. If that is not there in the option, you have to search for a specific thing, that is thumb and lips, right? Minimum area will be given to trunk and hips. Remember that. It depends on how much, you can say, complexity of how much complex movement you are going to do, right? And how much precision, complexity and precision involved. It depends on how much of the use you have of that body part and how much complexity and precision is involved in that movement. Depending on that, you're going to give the area for the processing or neurons for the processing. All right. If they ask about phantom limb pain, if you do the amputation of the limb, that is known as phantom limb, which is going to have the pain because your body will not be adapted. If the cortical plasticity is there, you are going to mark it as cortical plasticity because your neurons are plastic, they are not elastic. What I mean by that, they're not, only do sensation of, let's say, from the thumb, or only do or process on the sensation of the eye. They can take over another part's function also, or processing of the another organ also. So that means they can modulate their function, isn't it? So that means they're not elastic, they do not resist the change, they are plastic. So phantom limb pain is because of that only. If someone's leg is cut, the leg wala neurons, that means the neurons which are working on the legs, let's say leg is cut, so these neurons are going to form the connection with the neighboring areas, right? And if the sensation comes from those areas, they are going to feel as if it is coming from the leg. So if they ask phantom limb, if the cortical plasticity is there in the option, mark it as cortical plasticity. If that is not there in the option, then you are going to mark it as law of projection. No matter wherever, irrespective of site of stimulation of the nerve is going to go continuously like this from the receptor till the brain, right? No matter where I stimulate it, here, the brain is going to project it towards the receptor. It feels as if it is coming from the receptor. So because of the law of projection also, you can have the patient of the phantom limb pain. Coming on to the special sensation, rods and cons, you're going to have dark phase and light phase. Dark phase may you're going to have these two combined, which is nothing but rhodopsin. They're going to ask you dark phase may which form of the vitamin A is important. That is going to be 11-cis retinal. Please remember, al means aldehyde. So you have aldehyde in your eyes, not alcohol. Please remember that. Nashili aankhein seems fine in the Bollywood songs, but not in the real life. You do not have alcohol in your eyes. You do not have retinol. You have retinal, because the question has come, right? So remember that. As soon as the stimulus falls, light falls, what is going to happen? Light. As soon as light is going to fall, the cis form is going to get converted into transform. So you can remember, in the dark phase, C is going to come before D, right? D comes after C. So remember, cis form in the dark phase, light may you have transretinal, opsin will be separated. All right, remember that. Okay, next, auditory cortex में two things which are important. क्या था? रेटिनाल्डिहाइड होगा पक्का, रेटिनाल नहीं होगा तो रेटिनाल्डिहाइड दिया होगा. सुपीरियर टेम्पोरल लोब and inferior frontal lobe. Superior temporal lobe is important for understanding, which is also known as comprehension of the speech, area number 22, known as Wernicke's area, right, which is important for understanding or comprehension of the speech, which is known as sensory area. So if it is defective, sensory aphasia will be there, or fluent aphasia will be there, which is also known as nonsense aphasia, right? Patient can speak because the Broca's is normal. Broca's is for bolna. B for B. So please remember, bolna is intact. So area number 44 is going to give you the Broca's area, which is intact in the lesion of the Wernicke's area. So he can talk, but he cannot understand. So this is known as fluent speech. Can talk fluently, but doesn't have any meaning. So nonsense aphasia or sensory aphasia. If the Broca's is having the lesion, so he can understand, but cannot talk, right? So it is nothing but non-fluent aphasia. There is going to be stuttering, which is going to come, or slurring of the speech, which is going to come, right? Yes. So this is nothing but the non-fluent aphasia or motor aphasia. Remember that. Okay. Chalo. So this is about the aphasias. Now let's talk about human and element lesions and reflexes. So see over here, first thing first. Reflexes. First thing, element and human. Human is going to control. It is going to stimulate the alpha motor neuron, acha bachas, and inhibit the ganda bachas. Gamma motor neuron ko it inhibits, right? So this is nothing but lower motor neuron. These two are lower motors. Now, alpha motor neuron, if it is stimulated, it causes voluntary contraction. And whenever you cannot cause the contraction, you're going to cause the patient is having paralysis, right? Gamma motor neuron is important for mohol banana, right? That is tone ke liye important. If let's say there is a lesion, in the lower motor neuron, that means alpha is gone, gamma is gone. There will be no tone and no voluntary contraction. No voluntary contraction, I'm going to call it as paralysis for sure, right? And no tone means I'm going to call it as flaccid paralysis. Right. So please remember, in the lower motor neuron lesion, you're going to have L, lower motor mein, you're going to have flaccid paralysis. If it is upper motor neuron lesion, upper mein lower motor neurons, that is alpha motor and gamma motor, are intact. But please remember, the stimulation on the alpha is gone. That means voluntary contraction is gone. Whenever voluntary contraction is gone, I'm going to call this patient is going to have the paralysis again. But paralysis again. And if I ask you that what type of paralysis is going to be, it is going to be having higher tone, because it cannot inhibit the this gamma motor neuron. So tone will be very, very high. So that is going to be your spastic paralysis. कुछ भी याद नहीं रहे तो भगवान के लिए याद रखना, upper में P आता है. Upper motor neuron में you have double P. So upper motor neuron is going to have spastic paralysis. Lower motor neuron are going to have flaccid paralysis. Help me to solve this table, right? So tone is going to be higher. In case of UMN, it is going to be lower. Hypertonia, hypo or atonia. On the tone, the deep tendon reflexes are, you can say, dependent, right? So deep tendon reflexes are going to be higher. So it is going to be exaggerated over here, right? Very, very high reflexes, brisk reflexes will be there. And either they are decreased hyporeflexia or they are absent, right? Muscle atrophy and fibrillation will be seen in the lower motor neuron because they are the ones which are going to supply the muscles. But this is not going to be present in the UMN lesion. This is absent, but instead of this, you're going to have sign known as Babinski's sign positive. What is Babinski's sign positive? Zara batana. It is seen in the infants before below the 1 year of age. Babinski's sign positive. Babinski's sign positive may, whenever, let's say, this is the foot of the person. If you give stroke like this, what is going to happen? There will be dorsiflexion of the thumb. Or I should say great toe. Thumb to हाथ का होता है. Let's say of the great toe. And the fanning of other toes, right? Other toes will fan out. Fanning out of the other toes, that will be seen. Right? So that is known as Babinski's sign. How to remember? Babinski's sign, first thing first, is seen in the upper motor neuron lesion. And when there are quacks, kahan bhejte hain? Dhongi baba ko seedha bhejo upar, right? So upper motor neuron lesion mein you have Babinski's sign positive. See, dorsiflexion will be seen, right? Coming on to the reflexes, first thing is the stretch reflex. When you have passive stretch, passive means somebody else is stretching your arm, the length of your muscle is increasing. You did not want to increase it, but it has increased. So somebody should be there to sense that length. Who is there? Length sensors. Spindle is going to be there. Muscle spindle is going to act as a length sensors, which are going to carry the information with the help of afferent nerves. Which are the afferent nerve? 1A and 2 afferent nerves are going to carry the information, stimulate the alpha motor neuron, and causes the contraction. Right? How many synapses are there? Only one synapse I can see. Synapse means communication between two neurons which are going to be there, right? So only one synapse which is going to be seen over here, and that's why this is known as monosynaptic reflex or loading reflex, DTR myotic or segmental reflex. Inverse stage reflex, my opposite is going to happen over here. It is going to be the relaxation which is going to take place, and that's why you call it as loading reflex, in which if the muscle has stretched excessively, the tension will be increased instead of length. Which are the tension sensors? Tensions will be sensed by tendon, and so as they are activated, 1B through the 1B afferent nerve, it is going to go towards the inhibitory interneuron, right? So inhibitory interneuron is going to come. So of course, as the name suggests, what it is going to do, it is going to cause inhibition to the alpha motor neuron. As soon as alpha motor is inhibited, the muscles are going to be relaxed. How many you can say synapses are there? Tell me. First synapse is here, second synapse is here. So I'm going to call it as either loading reflex, lengthening reflex, or I'm going to call it as disynaptic reflex. Disynaptic reflex. All right. Next. You have intrafusal muscle fiber, extrafusal muscle fiber. In the intrafusal muscle fiber, two types of fibers are there, nuclear back fiber and nuclear chain fibers. Back fiber contains static and dynamic both. Chain fiber contains only static fibers. Please remember, if you contain only static fibers, then resting length will be told by this, that is initial and final length. That means before the muscle started to contract, what was the length? And after it has finished contracting, what is the length? But if I ask you, length per unit time is going to be sensed by, it is going to be dynamic, which is going to give you the velocity and motion. So that means whenever my muscle is moving during the movement or while the muscle is contracting. Or during the contraction. If they ask this question, then the answer is going to be nuclear bag fiber, because I require all the information per unit time, right? So that is going to be nuclear bag fiber. This was your PYQ. If they ask present continuous tense, ing लगा हुआ है, contracting, तो nuclear bag fiber mark कर देना. Okay, next, bat dance. When the bat dances in the night. So please remember beta, alpha, theta, delta. So if you have 0 to 3 hertz, it is going to be delta wave, 4 to 7 hertz, theta wave, 8 to 13 alpha, and 14 to 30 beta wave, right? Beta wave will be there when the brain is alert and active. Alpha wave is there when the person is alert, awake, but eyes are closed. Eyes closed, person awake. Awake but eyes closed. That means meditation position. Remember meditation position. Whenever you have meditation position, it is going to be the alpha wave which are going to come, right? Light sleep mein you have theta wave mostly, but deep sleep mein pucha, pakka. In the deep sleep, which you can say wave you are going to get? Deep sleep mein you are going to have delta wave. As and when the brain frequency, brain activity increases, the frequency of these EEG waves are also going to increase. But what they have asked, they marked this beta wave and they have asked you that in which type of sleep you are going to have this wave, then it is going to be what, right? So you have to remember that. All right, so this one question which has come over here, EEG wave ke bare mein hi, let's solve that question. Eyes are closed, a person is relaxed, awake hai, but eyes are closed. So which waves are going to come? It is going to be the alpha meditation condition wala. All right, there are two types of sleep, NREM and REM sleep. All the parasomnias, altered events such as sleep talking, sleepwalking, which is known as somnambulism, or teeth grinding, clenching of the teeth, bruxism, nocturnal enuresis, that is nothing but bedwetting. Bedwetting is normal till 5 years of age. Normal till 5 years of age, right? And night terrors which are going to come. If I ask you dream comes in NREM or REM, in both. If you do not remember it, NREM को कैसे याद रखोगे? Not remembered. If the scary dream comes, but they do not remember, you do not remember them, so you are going to call them as night terrors, right? If you remember, you have the memory formation of these dreams, then you're going to call it as nightmares, which you remember, and that's why in the REM sleep you remember, right? You remember the dreams in the REM sleep. So please remember, memory is formed, right? And see over here, you are actually sleeping, but you are having high brain activity because memory is formed. So alpha and beta waves are seen. So just now I asked you the question, beta wave pe arrow was marked and they have asked which type of sleep it is. Then the answer is going to be REM sleep. All right. And brain is active. You do not want to act out of the dream. So that's why muscle atonia occurs, but you want to survive. That's why respiratory muscles and extraocular muscles will be spared. There are hallmarks of the REM and NREM too. Hallmark of the REM sleep is PGO spike, that is pontogeniculo-occipital spike. And please remember NREM2 ka two hallmarks are there. NREM2 ka hallmarks kya kya hai? K complex and sleep spindles. K complex and sleep spindles are going to be the hallmarks of these. Circadian rhythm, you have to remember the nuclei, right, of the hypothalamus, suprachiasmatic nucleus. Sleep wake up cycle will be maintained by this. I told you paraventricular is going to release oxytocin. With that, it controls the autonomic nervous system. Sexual behavior will be regulated by anterior hypothalamus or preoptic nucleus. All right, and control thirst. All right. Control thirst, lateral hypothalamus, and temperature regulation. Somebody saying that mute the chat if possible. You can mute it on your side or just ignore. Okay, lateral hypothalamus is for the thirst, and The hunger also, hunger, anger. So there is actual a terminology hungry, right? So it is there. All right. So hunger and anger. Tech team, Praveen ji, if you're there, just block the people who are distracting the class and not paying attention. Okay, that is the only thing which we can do to help the actual sincere students. है ना, फालतू की chat जो कर रहा है, you can block them. Anterior and ventromedial. Anyhow, they are not studying, है ना. Chalo. So temperature regulation. Remember, anterior side of the AC is helping you in the hot adaptation. Posterior side helps you in the cold adaptation. All right. So remember like that. All right. AC से हम control temperature regulation maintain करते हैं, or we can remember that. So if the person is exposed to the high temperature while exercising vigorously to maintain the internal body, which physiological response is most likely occur? Sweating and vasodilation, is it going to occur? Yes, it can occur. Shivering, vasoconstriction, say even more the temperature can increase. So I'm not going to do that. Increase production of heat by liver, already the heat is increased. So I'm not going to do that. And heart rate will be increased because he's increasing the vigorousness or the severity of exercise. So answer over here is option A. And heart rate increment or reduction is not going to help me in the temperature maintenance anyhow. Appetite regulation में satiety center is ventromedial nucleus and hunger center is lateral nucleus. Remember that, right? There are hormones which are going to control the or increase the hunger. Hunger hormones कौन से होते हैं? It is mango. M is MCH, right? A is AGRP. Then neuropeptide Y, then ghrelin, then orexin. And please remember, there is the hormones which are going to cause satiety, that is decrease in the hunger, that is alpha MSH. S for S, remember that. Then comes the leptin. Leptin is the one which is going to have dual regulation. Why dual? I'm saying so because leptin is going to stimulate MSH, but it inhibits the AGRP and neuropeptide Y, right? And all the intestinal hormones, including the insulin, intestinal hormones such as VIP, VLP, GIP, secretin, all these intestinal hormones. I'll just write intestinal hormones. They're also going to cause satiety. All right. Remember leptin. Remember leptin, very, very important. Okay, coming on to the last topic of the memory. Short-term memory is going to last for, it is going to last for seconds to minutes. Remember that. But over here, the answer is not given. It is not there for hours and it will last till seconds to minutes. So answer over here is option C. I'm going to choose. Right, associative memory pe question has been asked. Pavlov ka doggy. Just remember, if you ring a bell in the first go, if you bought a new puppy and ring a bell, he is not going to respond to you, right? He doesn't understand it. But if you give the food, he starts to salivate. Is there anybody to teach him that after looking at the food you start to salivate? No, it is the natural response. In science or in physiology, you call natural response as unconditioned response. Nobody conditioned your brain. It is naturally present. So unconditioned stimulus, which is going to be food, which is going to activate the unconditioned response, that is salivation. But if you pair them together after a few days, what is going to happen? When you ring a bell, yes, the conditioned response will come, salivation will come, right? So only after ringing of the bell, if the doggy starts to salivate, that means this is not natural, right? You have conditioned his brain. So please remember, conditioned stimulus will give conditioned response. That's how we completed the CNS. Let's start with the renal system. We all know that this is the cortex and this is the medulla, right? Whatever nephrons are present deeper into medulla, you call it as juxtamedullary, right? Vasa recta cannot, the peritubular capillaries cannot reach to the deeper medulla, inner medulla, right? So they give the branches, that is nothing but vasa recta. And look over here at the arrangement. As you have the loop of Henle, the DCT is going to come near the glomerulus, and that's why it is going to be helping us in the formation of juxtaglomerular apparatus, JG apparatus, right? Structural and functional unit is going to be the nephron. Let's talk about the first, that is filtration. going to happen in the Bowman's capsule, right? There are 3 layers. What question they are going to ask? One question that will be asked. See, if they ask negatively charged proteins are present in which layer? In all the layer. Endothelial cells also, food processes of podocyte also, they contain the proteins, right? Everything contains the protein, but please, please, please remember that if they ask maximum negatively charged protein present kahan par hai, then it is going to be basement membrane. Maximum pucha, answer is going to be basement membrane. But all of them have this, you can say, the proteins, right? What is the benefit of having negatively charged proteins in the filtration? That they repel the negatively charged protein, because similar charges will be repelling each other and opposite charges they attract each other, right? Remember that. So the protein urea will never occur. Albumin urea will never occur normally, because albumin is, first thing, it is very, very large. Second thing is negative charges of the proteins in the glomerular filtration membrane repels the negatively charged protein, that is nothing but albumin. Repulsion is going to be there. And if you see over here in this graph, let's solve that only. If I take any radius ka molecule, let's say 26 over here, so if I extrapolate that graph, so see, C graph is showing very, very less filterability. X and Y axis always check. Radius is given, that means molecular size of the substance is given, and filterability is given. I'm not changing the size. I'm going to change its filterability on the basis of charge. So what is happening? See over here, first thing first, C molecule is filtered very, very less. B molecule will be more than C but less than A, and A molecule is maximum. So if it is a neutral molecule, it is going to come in between. If it is a negatively charged molecule, which is known as anions, it will be repelled by the negatively charged protein in the glomerular filtration membrane. So it will be filtered very, very less. But if it is a positively charged ion, which is known as cations, what is going to happen? The negatively charged protein present on the glomerular filtration membrane, they are going to attract those positively charged protein and they are going to filter it. So that's why their filterability is going to be much, much more. So cation more than neutral, more than anion molecule, that is going to be the filterability. If the effective, see, criteria of filtration is size and charge. Charge we have already discussed, right? So what about the size? If the size is less than 2 nanometers, they will be freely filtered. If the substance size is less than 2 nanometer, the substances will be freely filtered, such as water le lo, urea le lo, or even the electrolytes or glucose or amino acids. All of them will be filtered very, very easily, very, very nicely, because the size is very, very less, right? If the size is more than 4.5 nanometer, then what is going to happen? If the size is more than 4.5 nanometer, of course, they will never be filtered. They will never be filtered, such as macroglobulin, big, big proteins, right? RBCs, WBCs, platelets, they will never, ever, ever, ever be filtered. Why? Because the size is very, very big, bigger than the filtration size or filtration pore. Pore se zyada bada hai, of course, it is not going to get filtered, right? So that is the criteria for filtration, okay? Shivani, you can take the break, beta. I'm not saying that you cannot take the break, and you are getting oxygen without the break also. Don't worry. Trust your lung and trust your, oxygenation system. Next, tubular transport. In the PCT, everything is going to be reabsorbed maximally. And a maximum reabsorption happens of all substances except. See, I can give the break also, right, of 2 minutes, but it is going to break the flow and it is going to disrupt my speed. That is the thing. All right. So exceptions are always there. So magnesium. It is going to be reabsorbed in the ascending limb of loop of Henle. Maximum secretion of all substances also occur in the Ananya, it feels like that in the exam. है ना? I can go slow. See, I can decrease my speed. But what will be happening? Then we have to postpone the class till, let's say, 9:40 or 9:50. है ना? Then you are going to do what thing? उसके लिए भी problem होगा. है ना? You are going to make a ruckus. Some students will. है ना? So all substances. Right? All right. Whomsoever wants the break, please take a break. And tomorrow, whenever this recording will be uploaded, just watch that part. Okay? Don't worry. Or just listen to me. Hai na? Maximum secretion of all the substances occur in the PCT except two things, that is potassium and urea. So please remember, potassium is going to be reabsorbed in the DT. Distal tubule consists of CD more than DCT. Both of them are going to cause the secretion of the potassium. Urea, on the other hand, is going to be again in the loop of Henle. It will be secreted. See, if I ask you maximum reabsorption of the potassium, then the answer is going to be, agar maine pucha maximum potassium reabsorption, then it is going to be PCT only. Unless and until I say maximum potassium secretion, you are not going to mark it as DT. All right. So unless and until I ask you as maximum potassium secretion, you're not going to mark it as DT. Urea ka bhi reabsorption, 52% of the urea is going to get reabsorbed in the PCT. Reabsorption पूछा इसका, urea का और potassium का, the answer is going to be PCT. Secretion पूछा, then the answer will change to DT or loop of Henle, depending on whether they have asked about potassium or urea respectively. All right. Next, SGLT. About SGLT, which SGLTs are present? SGLT2 more than SGLT1. Both are present. 90% SGLT2 is present and 10% SGLT1 are present. So in the kidney, both the SGLTs are present in the PCT itself, right? Kidney में PCT में दोनों होता है. But if I ask you about intestine, it is only SGLT1 which is present. SGLT1 which is present. All right. Chronic alcoholic depression, dehydration, weakness, it is there, right? What they have asked is maximum water reabsorption occurs in presence पूछे, in absence of ADH पूछे, doesn't matter. पढ़ा आपने maximum water reabsorption, that's all you want. Maximum water जैसे ही पढ़ा, you're going to mark it as proximal tubule PCT, right? You are not going to think anything else. Coming on to the loop of Henle, counter current mechanism present in the kidney, skin, GIT, testes, even in the lungs and retina. Right? In the kidney, what is its aim? Aim is water conservation for concentration of urine. Two parts are there, countercurrent multiplier. They are going to ask who are going to form the countercurrent multiplier. Your answer is going to be LOH and MCD, that is loop of Henle and medullary collecting duct. What they are going to do, they are going to create the medullary hypertonicity. Exchanger, we are going to write one V like this, one V like this, it becomes X. So vasa recta, remember, it is going to maintain. Vasa recta maintains the hypertonic medullary interstitium. That's all you need to remember. Kaun hai multiplier and what is its function? Who is the exchanger? What is its function? That's all. Just remember that straightforward question they are going to ask. Hypertonic medullary interstitium will be formed by, created by multiplier, maintained by vasa recta via reabsorbing all the water. Okay. Next. Coming on to the thick ascending limb of loop of Henle, I already told you that it is going to be helping me in the countercurrent mechanism with the help of one important pump, that is sodium potassium 2 chloride. If I say that there is a mutation of sodium potassium 2 chloride, it is going to cause Bartter syndrome. Sodium potassium 2 chloride ka mutation is going to cause Bartter syndrome. Another question, magnesium, calcium, divalent cations will be reabsorbed in the ascending limb of loop of Henle via which transport mechanism? Wonderful, Dhwani. It is going to be paracellular transport. Yes, Pranay, wonderful. So it is going to be paracellular because this is one cell, this is another cell. Between the two cells it is coming, right? So it is nothing but paracellular transport. I'll write it here itself. Paracellular transport say magnesium more than calcium. Wonderful, right? That is going to happen over here. Next, coming on to the CD and DCT, two cells are going to be there. What are the two cells? P cells and I cells. How to remember क्या function है P cell का and I cell का? P cells are known as principal cells. Principal cells का क्या functions होता है? Just remember. Principal ion का movement it is going to do. It is going to cause sodium reabsorption and potassium secretion. Sodium reabsorption and potassium secretion. Sodium reabsorption with the help of ENaC channel and potassium secretion via renal outer medullary potassium channel, that is ROMK channel, right? And intercalated cells. Eye cells are nothing but intercalated cells. Alpha intercalated are more important. I is there in the acid. So remember, and we have to maintain the pH, which is slightly alkaline. So we are going to secrete the acid. We do not want much of the acid in the body. So alpha intercalated cells are going to cause acid secretion. Just remember that. Aldosterone is the hormone which is going to cause stimulation of both, right? So aldosterone is the hormone which is going to stimulate both the cells. P cell as well as I cell. It is going to stimulate P cell as well as I cells, right? Next, see over here that if I ask about ADH, ADH is going to allow the water. What is its function? ADH, especially if it acts on V2 receptor, it is going to cause the opening of aquaporin 2. And it causes the absorption of or reabsorption of H2O. Reabsorption means what? Reabsorption means it is going to take the blood, this water from the tubules, put it into the blood. Take the water from the tubule and put it into the blood. So, if the ADH is high, that is syndrome of inappropriate ADH secretion. Inappropriate, what I can do is I can remember it as increased. Hai to ye inappropriate, but I am going to remember it as increased ADH secretion. Very high ADH, it is going to take excessive water from the tubule, put it into the plasma. What will happen to the urine concentration? The urine will be very concentrated. More solutes are there, water is not there much. So urine osmolarity is going to be increased and plasma osmolarity is going to be decreased because of this. So urine will be hypertonic, low volume and concentrated. Maximum osmolarity possible, 1200 milliosmol. Reverse is going to happen in the plasma. Plasma will be diluted here because more water I'm taking from the urine, put it into the plasma. Exact reverse is going to happen if the ADH is either decreased or absent completely. What is going to happen? The permeability has been decreased now. So there is no one to take the water from the tubule and put it into the plasma. Now what is going to happen? If there is no one to take the water from the urine, so more water will remain into the urine. The urine will be diluted and the plasma will be concentrated because I'm not getting any water over here. So plasma osmolarity increases, urine will be diluted, hypotonic and high volume. Bucket भर के urine होगा उसको, right? 10% even it is decreased. So 180 liters का 10% is going to be how much? 18 liters का urine per day he is going to form, right? So please remember high volume. Polyuria, polydipsia will be there, and 50 to 100 milliosmol. What is the minimum osmolarity possible? Your answer is going to be 50 milliosmol per liter. There is something known as TMG and renal threshold. What is the renal threshold? There is expected renal threshold and actual renal threshold. Expected is 300 mg per deciliter, but what is the actual value? 180 to 200, right? I expect you to get 300 out of 300, but some what happens and you get 200 plus marks, right? 250, 220 like that, right? So there is a difference between the expectation and reality, right? So there is a difference between the expectation and reality known as splay. This type of splay occurs in the renal system, so we call this as renal splay and a renal splay. Why this happens? Because all the nephrons are not reabsorbing glucose all the time, and all does not have that maximum capacity, right? So maximum transport rate of a substance, if it is a glucose, you call it as TMG, right? Per minute पूछा तो 375, per deciliter पूछा तो it is going to be 300. They are going to give you some graphs like this, and what they can do, they can give you the actual and ideal means expected and actual value, and there will be difference between these two, right? So that is going to be what? That is going to be renal splay, and now so that is going to be renal splay. Next, glut present in the skeletal muscle, adipose tissue. इसका आंसर दो फटाफट. Even in the heart, same type of, even in the heart, You have same type of GLUT, that is GLUT4 insulin dependent. D is the fourth question, right? D question. D, that is insulin dependent. Clearance, UV by P, urinary concentration of the substance, plasma concentration of the substance, and urinary volume or the urinary flow rate, one and the same thing. Urinary concentration is U, P is plasma concentration, V is the flow rate or volume, right? Now, if I say, this is the Bowman's capsule, afferent arteriole glomerulus, efferent arteriole peritubular capillary, afferent glomerulus, efferent peritubular capillary, right? And ultimately, via the tubules, you're going to have the urine, okay? Now, 100 molecules came, out of which 20 got filtered and 80 went into the peritubular capillary, and there is no reabsorption, no secretion, means I'm going to get only whatever is filtered, that is 20 molecule into the urine. So if it is only filtration, which substance is that? That is going to be inulin. And please remember, it is the most accurate for GFR estimation. GFR estimation के लिए most accurate पूछा, it is going to be inulin, right? Now, if but you have to give it exogenously because it is not produced in the body. But there is one more thing which is going to happen like this, that 100 molecule of that substance is going to come. 20 molecules will be filtered, 80 will go in the peritubular capillary, but one molecule, let's say, is going to get secreted. There is a slight secretion which is going to occur, right? So slight secretion which is going to occur at 20 plus 1, that means 21 molecules are going to come. But if I still ask, out of these 21 molecules, how many molecules or maximum molecules come from the filtration or secretion, what will be your answer? Please remember that even though there are 21 molecules, 20 out of 21 molecule came from filtration. So there is maximum filtration and very slight secretion. Such molecule is nothing but creatinine. But creatinine is beneficial. Why? Because it is endogenously produced by the muscle metabolism, right? It is endogenous. So it is better to measure the GFR via this, right? So most common agar pucha for GFR estimation is going to be creatinine. Most accurate pucha, answer is going to be inulin. All right, next. Filtration plus complete secretion. Who is completely secreted? That means there is going to be 80 molecules. They are also going to come into the tubules via the secretion from the peritubular capillaries, right? And that is going to be your PAH, para-aminohippuric acid, which is going to be utilized for renal plasma flow or renal blood flow estimation. याद कैसे रखोगे? Para-aminohippuric acid. P for P, remember that. Para-aminohippuric acid is measured the renal plasma flow, right? Estimation is going to be done by this PAH. Filtration plus complete reabsorption. That means 100% reabsorption will be there of the glucose and amino acid. So normally their clearance is going to be 0. Normally the clearance of the glucose and amino acid is going to be 0. All right, remember that. Yes, till the physiological limit. After that, it is going to either increased or decreased. All right, this question has come. The formula UV by P represents which one of the following renal function? क्या है? Clearance का formula है UV by P, urinary concentration, P for plasma concentration, V for urinary flow rate or volume. Okay. Next, JG apparatus में 3 things are going to come. First is JG cells, which is going to be releasing the renin, and they contain the renin ka granules. That's why they are called as granular cells. So they are called as granular cells, and they are going to activate the RAS and maintain the GFR. Macula densa cells, on the other hand, are present onto the distal tubule, which is going to act as a chemosensors, which are going to sense the sodium and chloride levels, right? So if the GFR is increased, let's say more will be the GFR, what is going to happen? More will be the filtration of sodium and chloride. More sodium chloride is going to come to the distal tubule. More will be the reabsorption of the sodium chloride from here. Now, Please remember that macula densa is present in the distal tubule, and distal tubule mainly the DCT is going to have sodium chloride pump, which is going to utilize the energy, active transport, right? If the active transport is utilizing the energy, ATP will be broken down, right? ATP will be broken down to reabsorb them, get converted into ADP and PI, get converted into AMP, cyclic AMP. If that is also not sufficient, it is going to finally cause the adenosine production, right? So adenosine will be increased, which is going to cause increase in the calcium in the smooth muscle, right? And increase in the smooth calcium in any muscle for that matter is going to cause constriction. So via causing efferent or afferent constriction, it is going to cause maintenance of the GFR. Over here, the GFR will be decreased, right? So please remember that ATP, ADP, AMP, and adenosine. What you have to remember? This is known as tubuloglomerular feedback, that is TG feedback. We have discussed this TG feedback. Whenever the GFR is high, कुछ भी याद नहीं रहा है तो इतना याद रख लो. Whenever the GFR is high, what happens is, whenever the GFR is high, you are going to decrease the GFR. How? The tubules are going to, via producing the adenosine, it is going to give the feedback onto the arteriole. So arterioles are a part of the glomerulus, right? So the tubules are going to give the feedback to the arterioles. So please remember, it is tubuloglomerular feedback. GFR will be maintained. Then there are third cells which are known as Lassus cells. Lassus cells are also known as extraglomerular. Mesangial cells. Extraglomerular mesangial cells, please remember that. Now, see over here. The diagram is very, very important because they have asked as a biopsy question also. They are going to give you the biopsy like this, right? And if you see, there are three phases. Afferent arteriole pe, if the cells are shown, that is nothing but your renin-mala cells, granular cells, or the JG cells. If they show the tubule like this, inside the round structural tubule, if you see some cells, so that is going to be your macula densa cells. Outside of this tubule, if they give the cells like this is going to be extraglomerular mesangial cells or Lassus cell. Remember that, okay? And they have given the diagram based image based question also. Calculation. If I say there are two types of stalling forces which are going to be present in the Bowman's capsule and the glomerulus. If you increase the hydrostatic pressure anywhere, right? If you increase the hydrostatic pressure over here, it acts as a pushing pressure. So it is going to increase the GFR, increase the filtration. If you increase the hydrostatic pressure here, it is going to push away the water here. That means it decreases the GFR, opposes the filtration to occur. On the other hand, oncotic pressure, they love the water, they pull the water towards them. That is nothing but because of the proteins, right? So they love the water, they are going to pull the water over here. So the GFR is going to decrease if you increase the glomerular oncotic pressure. But if somehow the proteins get filtered and you increase the oncotic pressure over here in the Bowman's capsule, you're going to have more and more GFR. So they can ask you which are the things which are going to increase and decrease the GFR. I have given the slide in the mission book, right, or mission classes. So just go through that, very, very important, right? How to calculate net filtration pressure. I told you, net filtration pressure, they can ask you to calculate also. Simple formula use karo, HP minus OP minus HP minus OP. The second one, put it in the bracket wale ko likho BB and bahar wale ko likho GG. That means hydrostatic pressure in the glomerulus minus oncotic pressure in the glomerulus minus hydrostatic pressure in the Bowman's capsule minus oncotic pressure in the Bowman's capsule. If I write all the pressures, it is going to be like this. So that is going to be 28 minus 18. That is going to be 10, right? So please remember, if I ask you why the oncotic pressure in the Bowman's capsule is 0, because the oncotic pressure is due to the proteins. Proteins will not be filtered normally, and that's why the oncotic pressure in the Bowman's capsule is usually 0. What causes the GFR to be increased? See over here, afferent arteriole ka constriction. Afferent arteriole, if it is constricted, the inlet is constricted, that means the GFR is going to decrease. Efferent arteriole ka dilatation, that means less resistance is present towards the efferent arteriole. So the more blood is going to go towards the efferent arteriole instead of going towards the Bowman's capsule. That means again the GFR is going to be reduced. Increase Bowman's capsule hydrostatic pressure. Bowman's capsule will not allow the fluid to come and get filtered. So this is also going to decrease the GFR. Mind you, this is a pushing pressure, does not allow the filtration to occur. But if you increase the renal perfusion, that means renal blood flow, if you increase, of course, that is going to increase the hydrostatic pressure in the Bowman's capsule, which is going to increase or push the water into the Bowman's capsule. Increase the GFR, the answer over here is going to be option D, right? Option D. Acid secretion, acidification. Acid secretion occurs maximum in the PCT because there is a possibility and there is no acidification. Acidification means pH will not decrease of the solution in the PCT. Why? Because maximum buffers are also available here. Maximum buffers are available. Right? Now, if I ask you, acidification means a decreased pH of the solution. That is going to happen CD in the DCT because less buffers are available to neutralize the pH. Less secretion occurs, I agree, but the acidification mainly occurs in the DT, that is CD more than DCT. What is the normal pH? Normal pH is 6 to 7, but minimum pH possible is going to be 4.5. This is the minimum limit, right? And that's why it is known as limiting pH. This is known as limiting pH. What is the most common buffer over here? Most common buffer, urinary buffer, is again bicarbonate, which is inducible. Inducible means new production possible. It is nothing but ammonia. New possibility, new production ka possibility. Only titrable means I can measure this buffer, and the main buffer at the CD, main buffer at the CD is going to be phosphate. Main buffer at the CD pucha, it is going to be phosphate. What is this? This is cystometrogram. Cystometrogram mein what two questions they are going to ask you? Simple two question, that this phase in which the volume is increasing but the pressure is not increasing much is because of which property? It is because of, very good, plasticity. Plasticity option में नहीं है तो क्या लगाओगे? If plasticity is not there, you're going to mark it as adaptability. Right? And adaptability. If I ask you which law is applicable over there, Laplace law. It says that the distending pressure is depending on the wall tension and the R. That is nothing but radius. First of all, what you do, you are going to increase the radius. So if you increase the radius, you're going to increase the wall tension via stretching the wall. So pressure increases. Later on, the urinary bladder adapts to the new high radius. So it is going to increase the radius also. So that's why it is going to decrease the pressure back to normal. All right. So please remember that via increasing the T and R, both, the pressure remains constant. The pressure remains constant. Okay. Next question. If such question comes, so what you're going to do? You are going to mark, first of all, look at the, Hanji, ये कैसे solve करोगे बताओ? You are going to look at the pH first. Always look at the pH first, है ना? So हमारा role क्या है? हमारा फंडा क्या है? I'm writing it over here. Okay, metabolic acidosis, ABG. I'll write ABG over here. Acid gas analysis. First of all, always look at the pH first. Always check the pH first. If the pH is between 7.35 to 7.45, it is normal. If the pH is less than 7.35, you're going to call it as acidosis. Right? If the pH is more than 7.45, you call it as alkalosis, right? Now, you're going to check the buffers and acids, right? First thing, you're going to check the Respica acid. PCO2, what is the CO2 ka value? It is going to be your 35 to 45 mmHg. If it is increase, acid is increase, acidosis. Acid is decrease, alkalosis. Right? Then you are going to talk about the buffers. There is a metabolic buffer. That is nothing but bicarbonate. What is the value of bicarbonate? Physiology book says till 26, so medicine book says 28, doesn't matter, write down 28 because the value will be either given less than 22. If it is less than 22, it is going to cause acidosis. If it is more than 28, it is going to cause the alkalosis. It is going to cause alkalosis, right? Please remember that. But see over here, what is the value? pH. I'm going to decide on the pH whether it is acidosis or alkalosis. So this is a case of acidosis for sure, right? pH is 7.1, very less than 7.35. So I'm not going to mark it as alkalosis for sure. Two options are out. PCO2 value is 22. Is it normal kya? No, it has been decreased. Please remember, it has been decreased. But this is the case of acidosis. What should have happened to the CO2? See over here, what I have written. CO2 would have been increased. CO2 should increase when it is the acidosis. But over here, the contrast situation is taking place. That means the opposite thing is happening. The CO2 is actually decreasing and the pH is also decreasing. If such contrasting happens, that means this system is not having the problem. Rather, it is trying to compensate. So this change is contrast to the pH. This change is contrast to the pH change. So actually this is compensating, remember that, right? And decreased bicarbonate, can it cause acidosis? Yes. So this is matching. So that's why I'm going to mark it as metabolic acidosis. With respiratory compensation. Please remember, pH के साथ साथ change आ रहा है, you're going to mark that as the problematic system. If it is going to the contrast, you're going to say that this system is actually trying to compensate. And कोई भी diagram आए, कोई भी chart आए, don't get scared, right? You just have to check all these three things only, no matter how many things they give. Just check the pH first, right? It is 7.2, means I'm sure that this is the case of acidosis. Then I'm going to check the PCO2. It is within the normal range, a little bit towards the lower side, but almost in the normal range. And then I'm going to check the bicarbonate. It is decreased significantly, and that's why this is also a case of metabolic acidosis. Again, right? It's often the small steps, not the giant leaps, that brings about the most lasting changes. So let's change the system. Only few slides are left, right? फटाफट से वो भी खत्म कर लेते हैं. Nuclear receptors, which hormones are going to act? Thyroid and vitamin A I'm going to write. Usually I used to talk about vitamin D also, but vitamin D में controversy है, so let's not go there, right? They have asked about levothyroxine, so don't worry about that. Cytoaldo, याद रखना, cytoplasm, aldosterone, okay? And both means nuclear also and cytoplasmic, but both option में नहीं है. You are going to mark it as nuclear more than cytoplasmic. Which are the two things which have been left? Aldosterone is a mineralocorticoid. तो aldosterone गया तो कौन बचा? Sex steroids and glucocorticoids. Glucocorticoid में main is going to be your cortisol, है ना? This is your estrogen, progesterone and testosterone. Estrogen, progesterone and testosterone. Then, if it is not the lipid soluble hormone, then you are going to check whether it is coming in the dirty pig or not, right? What is dirty pig now? Dirty pig is the mnemonic. I'm going to give you a mnemonic, that is dirty piglet, right? So let's say it is a piglet. All right. Now, if it is insulin or it is growth factor, if it is insulin or growth factor means nerve growth factor or the fibroblast growth factor, PDGF, that is platelet derived growth factor, VEGF, that is vascular endothelial growth factor, all the GF, GF, GF. It is not your girlfriend. It is the GF means growth factors. They are going to act through what? Tyrosine kinase. If they have given prolactin, growth hormone, and leptin. Piglet. So prolactin, growth hormone, and leptin, they are going to act via the cytokine receptor. Cytokine receptor is not there, then receptor ki jagah they can give you the pathway, that is JAK-STAT pathway. Receptor is different and the receptor is different and the pathway is different. Pathway diya hua hai to JAK-STAT aayega. If it is not the piglet, if it is not the lipid soluble hormone, rest all are going to act through. Rest all are going to act through GPCR protein, that is G protein coupled receptor. G protein coupled receptor. Okay. It is also known as 7-pass receptor or transmembrane receptor. It looks like a snake, so it is known as serpentine receptor also. Why it is called as 7-pass receptor? Because it crosses the membrane 7 times. So serpentine receptor bolo, transmembrane bolo, one and the same thing. Cyclic GMP में just remember ANP or NO. If they have given ANP or NO, nitric oxide or natriuretic peptide. Natri जहां पर भी आता है, nitric oxide or natriuretic peptides, ANP, BNP, CNP, sub, it is going to act through cyclic GMP. But if it is IP3-DAG, you require IP3-DAG for the contraction of the smooth muscle mainly. So smooth muscle contraction agar pucha hua hai, you're going to go with the IP3-DAG. Can you name some contractile hormone? Name some contractile hormone. One contractile hormone which causes the contraction during delivery as well as during the breastfeeding, that is lactation. Myoepithelial cells ka contraction. Yes, wonderful. It is oxytocin. Then you have vasopressin, nothing but the ADH. But ADH, if it is acting via V1 receptor, it will act through the IP3-DAG. V2 के through act किया, it causes the water reabsorption, not contraction, so it will act via cyclic AMP. Adrenaline का alpha-1 receptor, beta-2 हुआ, so it is going to act via cyclic AMP. Then acetylcholine का M1, 3 and 5. Right, M2 हुआ, M4 हुआ, it is going to act via cyclic AMP. Then angiotensin 2, potent vasoconstriction, CCKPZ, that is cholecystokinin pancreatozymin. Right, now there are some exceptions over here. What I mean by exceptions? They are not contractile hormone. Usually I say that the contractile hormones, that means the ones which are going to cause contraction, are going to act through the the IP3-DAG. But there are some hormones which doesn't cause contraction per se, but still they act through IP3-DAG. So what are such hormones? Such hormones are going to be GnRH, GHRH, gastrin. Remember, GHRH, GnRH, GG wale sare gastrin, and TRH, RH. Okay. If they give TSH, it is going to be cyclic AMP. If they give T3, T4, it is going to be new. Question is here, cyclic AMP as a second messenger, except. What is the answer? Remember, cyclic AMP I haven't discussed. Remember, rest all are going to act via cyclic AMP, right? So if we do not discuss corticotropin, dopamine, or glucagon, that means they are acting via cyclic AMP, but we have discussed that piglet is going to act via either cytokine or the tyrosine receptor, right? Remember that. Coming on to the oxytocin and prolactin, I told you during delivery and during the milk letdown reflex, oxytocin works. That is in the females. What it is going to do in the males? In the males, it is going to cause the vas deferens ka contraction during sperm ejaculation and helps the sperm to come out of the epididymis and go to the urethra. So in the males, it's going to cause vas deferens ka constriction or contraction. Prolactin. There is a fun fact about the prolactin, that prolactin is actually under the inhibitory regulation, right? There is something known as prolactin inhibitory factor. Right, which is going to be released by hypothalamus. So let's say this is hypothalamus and this is anterior pituitary or pituitary. Now, पिट्यूटरी में क्या हो रहा है यहाँ पर देखो, you are going to be having release of prolactin here, and PIF, which is also known as dopamine, is going to inhibit it. Now, if there is a pituitary stalk which is gone, what is going to happen? If there is a lesion here, pituitary stalk is gone, there is inhibition which is going to be gone from the prolactin, and the patient will land up into galactorrhea. That means lactation will start without the pregnancy also, right? So galactorrhea will come. Why? Because the PIF is not acting upon the prolactin. Remember that. Coming on to the growth hormone, what are the substances which are, or what are the things which are going to increase and decrease the growth hormone, right? Hypoglycemia. Right now you are having hypoglycemia, such as fasting है या starvation condition है, fasting है, starvation है, या फिर you are doing the exercise. In all these conditions, hypoglycemia takes place. Please remember the relationship between the growth hormone and the glucose. Glucose, when it is less, it stimulates the growth hormone. Growth hormone increases the glucose, but then the glucose gives the negative feedback. Remember like that, right? So glucose, hyperglycemia gives the negative feedback. Okay, then protein meal amino acid is going to increase the growth hormone. Psychological stress and pyrogens, they also increase it. Hormones such as estrogen, which causes the growth, of course, in the pubertal age. Estrogen, testosterone, or let's write androgens. Estrogen, androgens. Even the glucagon, which looks like growth hormone. Why it's a brother of growth hormone? Because yes, it is going to increase the glucose again, like a growth hormone. And then you have ADH. So estrogen, androgen, and glucagon, ADH, all these hormones are going to cause increase in the growth hormone. Alpha-1 adrenergic agonist and dopamine agonist. They're going to increase the growth hormone. Growth hormone itself and IGF-1, they give the negative feedback to the growth hormone and decrease it. NREM sleep decrease the growth hormone. NREM sleep increase the growth hormone. REM sleep decreases growth hormone. So how I used to remember, REM में memory is formed. Either you have to choose the memory or the growth. है ना, memory choose करो या growth choose करो. And the answer, the option is there for you, right? क्योंकि REM sleep में, deep sleep में memory is formed, but the growth hormone has been decreased. Cortisol and somatostatin. Somatostatin is nothing but GHIH. Is going to decrease the growth hormone, right? So you can just remember what are the things which are going to decrease the growth hormone, and then you can just mark increase or decrease the growth hormone accordingly. Growth hormone will be released by pituitary, so they have given the options and they have asked you to label it. So C is the growth hormone. A and B, they are going to have the stimulatory and inhibitory control from the hypothalamus. The B must be GHRH, growth hormone releasing hormone. This must be GHIH, which is not there in the option. Rather, they have given the somatomedins, no, somatostatin. Right? Now, identify the D. See, the growth hormone can act directly on the tissue. Let's say this is the tissue or cells, right? Directly on the cells, or it is going to go to the liver, releases something known as IGF-1. That is insulin-like growth factor, and then it acts indirectly on the cells. So either they are going to act directly on the cells, direct action, indirectly via the IGF, indirect action, right? So IGF-1, insulin-like growth factor, is also there, which is going to get stimulated via the growth hormone, right? Insulin-like growth factor is going to have insulin-like activity. Just remember that. Okay. Coming on to the thyroid. See, thyroid ka samajh lo, and then we can just make the basic discussion over here. First thing first, there is going to be trapping on the iodine. I told you the mnemonic TOBSER. Just remember the mnemonic TOBSER. First is going to be the trapping of iodine, but iodine cannot be trapped. You have to trap the iodide, right? Iodide is a negatively charged molecule. With the sodium, it will be trapped. Secondary active transport. sodium iodide symbiote, present in the ear also. So it is present in the thyroid gland, it is present in the mammary gland, this placenta, it is present in the parotid gland, which is salivary gland, GIT, right? In all these places, this NIS is going to be present. It will never be present in the pituitary. That was the question, so remember that. Next, now if you trap it in the this cell, follicular cell is not going to have TPO, na? TPO किसमें होगा? TPO is going to be present in the colloid, right? So you have to send the iodide into the colloid. So what you're going to do, you're going to do the chloride and iodide ka exchange over here. So iodide will be going into the colloid and the chloride will come into the follicular cell. Chloride channels are there, so it is going to keep on moving there. Doesn't matter. First of all, you have done the trapping. Then O for O, top sir mein O is going to be oxidation. Oxidation means what? You have trapped iodide molecule, no? You have to make it iodine. So iodine will be formed, 2I molecules with the help of TPU. As soon as you come into the colloid, TPO can be acting upon your processes, right? So iodine will be formed, oxidation. Oxidation is then the binding will come. So one molecule of tyrosine is there, you attach one tyrosine to it, it will become MIT, right? One molecule of tyrosine, two molecules of iodines are attached, that is going to be DIT. So monoiodotyrosine, diiodotyrosine, known as binding. Then comes the this coupling. Coupling में क्या करोगे? If one tyrosine with the that is one MIT is there and one DIT is there, and then they combine, it is going to form triiodo. I cannot call it as tyrosine. I have to call it as thyronine because two molecules of tyrosine they are coming together, right? And DIT will be combining with the DIT, that is going to form T4. So that's how the T3 and T4 are going to be formed, right? T3 and T4 is going to be formed, all right? Coupling is going to be done, then the release and this secretion that needs to be happen, but for that I need to keep it into the follicular cell. So as soon as the stimulation comes, I will be able to release the thyroid into the blood, right? So please remember that T3 and T4 क्या होगा? पहले trapping होगा iodine का, then there will be oxidation, binding, coupling, right? And then there will be endocytosis. I'm going to cause the endocytosis and keep it stored into the cells, right? And then whenever it is required, it will be released, okay? So please remember that into the cells, top cell, remember that, okay? Then insulin secretion, beta cells of pancreas may remember that there are cells पे, beta cells पे you have the GLUT, that is nothing but GLUT2. Insulin independent, in दो बार आया, insulin independent, that means it is going to be your beta cells of pancreas, right? Or where else you have this GLUT2, GLUT4 तो हमने लिख लिया था, GLUT2 लिख लो, बीटा सेल्स ऑफ पैनक्रियास तो है ही, राइट? पैनक्रियास में है प्लस लिवर एंड किडनी एंड GIT. In all four places, you have this insulin independent GLUT, right? You have ATP dependent potassium channel. Potassium channel pe they can ask you the question, right? If you close this channel, causes more insulin release. So you can give the potassium channel blockers such as sulfonylureas in the diabetes mellitus, right? And you can give the potassium channel openers such as digoxide into what thing? Digoxides into the insulinomas, right? Remember that. So what are the insulin like? If you have to measure the insulin, right? There is a chain, connecting chain of the A chain and B chain. Insulin is formed of A and B chain. There is a connecting chain which is also present in the vesicle, right? Which is going to be released in the equimolar concentration of insulin and C-peptide. That means if one molecule of insulin is released, one molecule of C-peptide will be released too, right? So please remember that. So that means 1:1 concentration में this will be released, and that's why if I have to measure how much insulin is released by the pancreas of the person, that means endogenous insulin release. So that is going to be the C-peptide assay in which we are going to know this. Why? Because outside insulin looks similar to this, right? Plus insulin have very short lifespan, right? So that's why you're going to do C-peptide assay. Adrenal gland mein, you're going to remember that cortex is divided into the zones, that is GFR, that's how you can remember. Glomerulosa, fasciculata, reticularis, everybody knows sex steroids, that is androgen will be released from the reticularis. Precursor basically, that is a DHEA, dihydroepiandrosterone will be released from here, right? G never goes with G, that means glomerulosa never releases glucocorticoids, it releases mineralocorticoid. Glucocorticoid will be released by the fasciculata, mainly it is going to be the cortisol. Then coming on to the medulla part of the this adrenal gland, medulla part is going to have colorful cells, and color is known as chroma. So please remember, chromaffin cells are there into the medulla, which are going to release, yes please, epinephrine, norepinephrine. When the metabolism occurs, they are going to be converted into metanephrines, I agree, but metanephrines are not very stable. They quickly get converted into something known as vanillyl mandelic acid. Vanillide mandelic acid, right? Vanillyl mandelic acid, that is nothing but VMA. So if there is a tumor of this colorful cells, so we call it as pheochromocytoma. OVA means tumor. The VMA levels will be very high. Just do the concentration, measure the concentration of the VMA into the urine, right? And that's how you can know whether you can diagnose whether the patient is suffering from pheochromocytoma or not. Catecholamines ka metabolite is going to be VMA. They have asked this question like this. They have not given the D, that is nothing but they have not given the chromophil cell ka layer. They have just given the adrenal cortex, that means capsule ke taraf is going to be the outermost, GFR, like this. So they have asked about reticularis, this is the reticularis layer, so I'm going to mark it as androgen, right? If they would have given the adrenaline, chromaffin cells, colorful cells, then I would have marked it as adrenaline, remember that. Coming on to the zona reticularis, please remember testosterone is released by Leydig cells. Just remove the lay from here. DIG ke jagah karo DICK, which is present in the males. You will never ever forget this, that the Leydig cells are going to secrete what thing? Testosterone. Testosterone, multiple times this question has come. Gynae ka question le lo, physio ka le lo, ya kisi cheez ka, surgery ka le lo. It doesn't matter. Just mark it correct. Okay. Estrogen. See, androgen are also produced in the females also, but do we require androgen? No, otherwise our voice is going to be hoarse, right? And then the feminine features will not be there. So what we are going to do with the help of aromatase, we are going to convert the androstenedione into the estrogen, right? So please remember, this is converted by the aromatase. This is converted by aromatase. Next, calcium homeostasis. Just remember that PTH is going to increase the calcium, but it has the phosphaturic effect. What do you mean by phosphaturic effect? Phosphate excretion, phosphaturic effect. It causes the phosphate excretion from the urine, and that's why the phosphate in the blood, the serum, is going to decrease. And what is the major action via which it is going to do it? It is going to cause bone resorption to be started, and that's how. Bone resorption to be started, and that's how it is going to increase the serum calcium. Calcitonin is going to decrease both, and it is going to inhibit the bone resorption. It is going to inhibit the bone resorption because it is going to send the calcium back It causes modulation, so it is going to inhibit the bone resorption. Vitamin D is going to increase both the calcium as well as phosphate, and it helps in the bone mineralization. Bone mineralization. Sertoli cells are not going to release androgen beta. Androgen is nothing but testosterone. Sertoli cells are going to release inhibin. Remember, Sertoli cells are going to release inhibin. Zoom user. Okay, चलो आगे बढ़ते हैं towards the last thing. 15-20 minutes में खत्म करते हैं. Serosize outermost layer. If I ask you, GIT में serosize outermost layer, serosize absent in, what will be the answer? Absent in, yes please, esophagus, and that's why you do myotomy, not seromyotomy. Esophagus में it is absent. Then you have muscularis layer, inner circular, outer longitudinal. You're going to have one plexus over here in the muscularis known as a myenteric plexus, because this is present in the muscle layer. So you're going to call this as myenteric plexus. Then you have submucosa layer, mucosa layer. In the submucosa also you're going to have plexus, which is known as submucosal plexus. Now there is an intrinsic and extrinsic system that is of the plexus, known as enteric nervous system, which is the brain of your GIT, right? You're going to have first thing first, you're going to have the submucosal plexus, let's say, which is also known as Meissner's plexus, right? And then there is a myenteric plexus, which is also known as Orbach's plexus, because Orbach has discovered it. But what they are going to cause, S for S. So remember SSS, that is, it is going to increase the secretion. SSS is there, so it is going to increase the secretion, and this is going to increase the motility. Now, which system is going to increase the motility? Sympathetic or parasympathetic? Extrinsic is going to be extrinsic nervous system control is there, that is via the autonomic nervous system. First is going to be your sympathetic nervous system. Please pay attention over here. Sympathetic system goes, and it is going to cause what? It is going to cause the inhibition of both. And parasympathetic system, that is rest and digest, as the name suggests, you have to rest and digest. Now parasympathetic system goes and stimulate both of them. It is going to stimulate both of them. So increased in the motility and secretion can be seen when there is activation of parasympathetic system. This question will be shown to you, or you have to identify it. What has happened? As soon as you added the drug, the motility has been decreased. So what are the 4 things which are going to decrease the motility? If I ask you, what will be your answer? Tell me, fatafat say. What are the 4 things I told you to remember in the mission classes? So, pehla, sympathetic wala 2 things, that is epinephrine and norepinephrine. You can call it as adrenaline and noradrenaline. NORAD, right? And then you have the atropine, which is parasympatholytic. Atropine, and one hormone is there, that is enterogastron. Atropine and enterogastron. Just remember these 4 things which are going to decrease the motility. Rest all are going to increase the motility, right? So answer over here is going to be adrenaline. Yes, barium, serotonin, acetylcholine, all of them are going to increase the motility. Slow wave in the GIT will be generated by the pacemaker cells, which are nothing but the Cajal cells. Yes, I'm calling it as Cajal because it's a Spanish name. J is pronounced at her there, right? Like mojito, right? Next, if I show you this, what is this? Membrane potential is shown. That means electrical activity is shown, right? As soon as I added the cholinergic drug, what has happened? The spike potential started to come, right? So these are nothing but spike potential. They started to come. This is nothing but action potentials which are generated, and the contraction will take place. But as soon as I added the adrenergic drugs, see over here, whatever spike potential was just developed, it started to decrease. Even the tension started to decrease. Muscle tension is nothing but force of the muscle started to decrease. That means muscle started to relax. Muscle started to relax. Remember that. Okay. So that's how we prove that the sympathetic system causes motility to decrease. Parasympathetic increases the motility. Coming on to the migrating motor complex, so what is it which is developing right now in your stomach? That is the hunger pangs, which is also known as migrating motor complex. It starts with the empty stomach. If you already had your dinner, right, because the camera is closed, right, so then you're not going to have MMCs, right, and it is right away going to the distal ileum, right. It is present in the interdigestive phase, not after eating. Why you need to contract your stomach and the distal the intestine? Why it is going to contract? Because the brain knows that you are hungry. It is going to welcome the new food whenever you are going to have that after the class, right? So it clears the GIT. It is known as a jhadu of the GIT and sweeper of the GIT, right? Broomstick or sweeper of the GIT is nothing but MMC. Question has already come on to this, that 90 to 110 minutes, 1.5 घंटे के लिए it is going to go on, right? 3 phases are there. Third is going to be the active phase. Just remember that 3 phases. First is question phase, then the irregular activity, and then the active phase. That's all. Activity increases as the phases go forward. All right. It is stimulated by motilin. Motilin will be released by MO cells, not M cells. M cells are there, which are going to be microfold cells. M cells, they are going to give immunity by acting as Galton malt. What is Galton malt? A GIT associated lymphoid tissue or mucosa associated lymphoid tissue. Gastric acid secretion में cephalic phase of gastric acid secretion, we have already talked about that. In the feed forward mechanism, not only the salivary but also the gastric acid secretion increases, right? What they can ask you, see over here, 3 phases are there. Cephalic phase, 20 to 30% of the gastric acid will be released via thought, smell, sight, right? Maximum will be released via in the gastric phase. The food enters via the stomach and vagus nerve and distension. Distension is the most common stimulus, most potent, right? Intestinal phase, as soon as the food goes, you're going to decrease the acid, increase the bicarbonate. See over here, right from the 60 to 70%, the acid secretion has decreased to 10%. Who is going to help us out? All the GI hormone. Secretin is going to release a pancreatic more maximum pancreatic bicarbonate secretion is going to occur with the help of secretin. On the other hand, CCKPZ, Z is there, so pancreatic enzymes pucha, enzymes are going to be released by CCKPZ, that is the cholecystokinin pancreatozymin. All right. Next, coming on to the iron reabsorption. Iron, you are going to take the iron in the dietary format. Most commonly, dietary format में हम कौन से form में लेते हैं? Fe3+. 3+ is nothing but ferric form of the iron. But it will not be reabsorbed in the ferric form. You require ferrous form. You and me, 2 of us. याद रखना, ferrous means 2 of us. Still, it is a polar molecule. It is a charged molecule. It requires the transporter, that is DMT1. Via the DMT1, the intestinal iron is going to go in the enterocyte. 3 questions will be asked. Pay attention over here. First, iron reabsorption occurs via which transporter? Answer is going to be DMT1. Iron reabsorption from the intestinal lumen into the enterocyte occurs via, again the answer is going to be DMT1. But if they ask the specific question that the iron reabsorption from the enterocyte into the blood occurs via or into the capillary goes via, then the answer will change to ferroportin 1. Remember, please read up the question carefully. Okay, what is the store form of this iron? I do not require the iron right now, so I'm going to store it in the ferritin form, right? It is the storage form. All right. Then what is the transfer form, or how it is going to get transferred into the blood? Via the transferrin. Via the transferrin, you are going to transfer it into the blood. Next, there are 2 things. One is going to inhibit this ferroportin. There is hepcidin. 2 I's are coming, so hepcidin is going to inhibit the this ferroportin. But there is one more thing that is known as hephaestin. What is hephaestin which is going to do? Hephaestin is going to be, there are two H, no, they're going to help the ferroportin. How? To convert it from the Fe2 plus into Fe3 plus, so that it can get transported into the blood, right? So it helps us. So it is going to help us to convert the Fe2 plus into Fe3 plus. So transfer form is transferrin. Hepcidin is going to be the liver ka protein, which is going to inhibit the ferroportin. Hepcidin help us in the conversion of Fe2 plus to Fe3 plus. All right. So they have asked, iron is transported from the enterocyte into the capillary. That means into the blood is going to be ferroportin. The autocorrect has done it protein, but it is ferroportin. The last concept, vitamin B12 ka concept. First of all, where the vitamin B12 will be absorbed, terminal ileum mein. Vitamin B12 will be reabsorbed in the terminal ileum. If I ask you, duodenum में maximum reabsorption occurs of and jejunum में, duodenum में iron and jejunum में folic acid. Remember that. Okay. Now, vitamin B12 is a very chui-mui vitamin, right? It's very delicate vitamin. It requires the protection. The protection into the stomach is done by heptocorin release from the salivary gland, right? Heptocorin keeps the vitamin B12 protected in the this stomach. Stomach may, I agree that the intrinsic factor is released, but it is not going to protect it from the gastric juices. Why? Because heptocorin is still attached. This heptocorin vitamin B12 complex come into the duodenum. What is going to happen? That in the duodenum, heptocorin will be released, and now the intrinsic factor is going to start protecting vitamin B12 into the intestine. Yes, it is going to protect it, and terminal ileum mein reabsorption is going to occur, right? So the question, next question, this is the question, gastric acid secretion. Gastric acid secretion is going to occur via, please remember, yes, acetylcholine is going to do the gastric acid secretion via the vagus. Histamine also increases, and gastrin. All these three things stimulates the proton pump and increase the gastric acid secretion. This is, secretin is what? Secretin is the intestinal hormone which is going to increase the bicarbonate the secretion, not the gastric acid secretion. Answer over here is option A, right? Anterograde peristalsis is because of NO and VIP. Just really remember, they are going to cause relaxation in the front. And these are going to cause constriction at the back. Constriction at the back of the foot. All right, so that is all from my side, right? A little progress each day adds up to big results, right? So that is all from my side. If you have any doubts, you can ask. You can ask that on the Telegram group. Till the exam I'll be available, right? You just can do this PN, or you can write Dr. Pooja Nigde. This is my Telegram ID. Instagram ID pay if you want to reach me. That is going to be physio by Dr. Pooja. _by_ Dr. Pooja. PDF will be available, right? I'm going to send it right away as soon as the class is finished, right? I'm going to send the PDF abhi, right? In 2 minutes. As soon as class is finished, my first thing is going to be sending the PDF to the team, ask the team, and team is going to, send it into the group. Don't worry about that, okay? So that is there. Ferroportin and this DMT wala, last I'm taking it. Remember, if they ask 3 questions, just asked iron reabsorption from where to where they have not mentioned. So you are going to mark it as DMT1. Iron reabsorption pucha, DMT1. Iron reabsorption from the intestine lumen into the enterocyte pucha, then also the answer is going to be DMT1, right? From diya hua hai, from the intestinal lumen into the enterocyte, how it is reabsorbed? Via DMT1. But if they ask the question that from the enterocyte into the blood, which we already solved the question here, see, enterocyte se capillary mein kaun leke jata hai, then the answer is going to be ferroportin. Okay, then the answer will change to ferroportin. That's all. Okay, previous page, this one. All right. I am not allowed, Rohit, I'm not the admin, so I cannot send it. I tried it already, so I cannot send it. Okay. So, yes, I'll ask the team or request the team to send you this PDF. All right. Chalo. So that is all from my side, guys. So, see you on the other side of the exam, right? I want you all to come in the cerebellum. So, read up, don't give up, no matter how much anxiety occurs. My mantra, just remember, convert all the anxious time, all the worry time into study time. That's all I want to say. Whatever worry time you have, just try to convert it into the study time. That's all. Just write on your desk that concentrate here, right now, in the present, right? Just read up however is possible. Don't worry, your brain will give you that feeling because you will be fearful, right? Your amygdala will create that fear, right, and anxiety that you might not be able to remember. But please remember, as soon as you see the options, you will get to the answers correct, right? It is going to be there in front of you. So don't worry. Convert your worry time into the study time. Thoda yahan par relax raho. Everything is going to be fine. All right. Chalo. So that is all from my side, guys. Bye bye. Take care. Yes, this is enough, right? Yes. So bye bye. Take care and all the very best. See you on the other side.